Committee into the 2022-23 supplementary budget estimates. I begin by acknowledging the traditional custodians of the land on which we meet today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people here today. The committee has fixed Friday, 31 March 2023 as the date for the return of answers to questions taken on notice. The committee would appreciate if senators could provide any written questions on notice to the Secretariat by Friday, 24 February 2023. The committee's proceedings today will begin with the whole of portfolio and corporate matters outcomes of the health and aged care portfolio. The committee will be conducting today's hearing in person and via video conference. Under Standing Order 26, the committee must take all evidence in public session. This includes answers to questions on notice. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. The Senate has endorsed the following test of relevance of questions at estimates hearings. Any questions going to the operations or financial positions of the departments and agencies which are seeking funds in estimates are relevant questions for the purpose of estimates hearings. I remind officers that the Senate has resolved that there are no areas in connection with the expenditure of public funds where any person has a discretion to withhold details or explanations from the Parliament or its committees unless the Parliament has expressly provided otherwise. The Senate has resolved also that an officer of a department of the Commonwealth shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. Witnesses are reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. I incorporate the public immunity statement into the Hansard. I remind all senators that as we continue our work implementing the Set the Standard report, as Chair, I will ensure that proceedings are conducted in an orderly, respectful and courteous way. An officer called to answer a question for the first time should state their full name and the capacity in which they appear. I remind committee members and witnesses who are appearing via video conference and who are not speaking to please mute their microphones. Before I welcome the Minister and the officials to the table, just a note that yesterday the committee did agree on a change to the program before us. That change does not affect the total amount of time allocated to various outcomes. All it does is shift the location of the lunch break. This is to allow parliamentarians to attend a specific event with members of the House of Representatives. So you'll notice on the program that we will be coming to outcome one slightly earlier than we were originally expected to. That's to facilitate the change in lunch break. But I would now like to welcome Senator the Honourable Malarndirri McCarthy, Assistant Minister for Indigenous Australians and Assistant Minister for Indigenous Health, representing the Minister for Health and Aged Care. Minister, do you have an opening statement this morning?
No, I don't. I'd just like to also pay my respects to the traditional owners of this land, the Ngunnawal and Ngambri people and their elders past, present and emerging, and thank all who've attended this morning with me.
Thank you, Minister. I also welcome Secretary of the Department of Health and Aged Care, Professor Brendan Murphy, AC. Professor Murphy, do you wish to make an opening statement today?
No, thank you, Chair.
Okay. I now call on officers from the department in relation to whole of portfolio and corporate matters, and I invite questions. We'll begin with Senator Ruston.
I apologise for being a little bit late. Just to
Senator Brockman, you have the call.
Just a very general question, I guess, both to Professor Murphy and Professor Kelly. Professor Murphy, particularly in the previous role you held. I guess, you know, COVID is still out there, it's still floating around, but I guess we are through the emergency response phase of the pandemic. What is the process from, I guess, an organisational sense within the department, within the medical community, from the government to assess what occurred over the last 3 years and particularly the health learnings we can take from it?
Thank you, Senator. Brendan Murphy, Secretary of Department. I think Minister Butler and the Prime Minister made it quite clear that they do intend to do a deep inquiry into the national COVID response. They have not yet determined the timing or the nature of that inquiry. Their view was that they would like to see how we settle a little bit in this new, as you say, different phase where COVID is not having quite the impact that it used to have. But I imagine that will be a decision for government in the not too distant future about the timing and nature of that inquiry.
And so that's the government process. What about within the medical community itself,
Well, I think,
or within the department? I mean,
sure.
Are there processes underway?
Professor Kelly can talk to the fact that AHPPC has done its own sort of internal review, and many of the states and territories have looked at their own response. So we're obviously continuously evaluating all of our programs, such as the vaccine rollout, the antiviral administration and usage. But in terms of the broader public health response, Professor Kelly can talk to. AHPPC has been looking internally at their internal review of their response. So do you want to take over?
Yeah, thank you, Secretary. Professor Paul Kelly, I'm the Chief Medical Officer. Thank you, Senator, for your inquiry. I think your preface of your remarks there, we're still in a pandemic. The WHO continues to meet regularly with member states to look at the global situation, and they've decided that COVID-19 fairly recently in most recent discussions remains a public health threat to the world. And we've seen what's happened in China recently in terms of very large rates of infection and deaths in that country as they've opened up and accepted the living with COVID situation. Here in Australia, we've gone through a number of waves in the last 12 months, or 14 months in fact, with Omicron. The most recent one is now settling, but there will be more waves into the future. I predict there will be at least another couple this year, so we need to be ready for those. In terms of looking back, I think it's useful to look back so that we can learn lessons for the coming years, not only in relation to COVID, but other disease threats, and the government commitment to starting a Centre for Disease Control has allowed us to think through that, and many of the consultations we did towards the end of last year really was part of a review of what's happened in the last couple of years. What have we learnt? What could we do differently? And so that will be part of that process. Professor Murphy mentioned that the AHPPC met to talk about their own, how we worked as a committee during that period and what we can learn from that into the future. And so that's an exercise we've undertaken. There have been a range of audits of work that's been done during the pandemic, particularly in relation to the National Medical Stockpile and rollouts of personal protective equipment, rapid antigen tests and the like. So they're on the public record and have been published. So there's a range of lessons there. We have to learn lessons from this extraordinary time so that we can be more prepared for the future. And I look forward to whatever the review process may be from the government perspective. Just your other part of the question about the medical profession or health professions more broadly, I think there's a real realisation that firstly COVID hasn't fully gone away. There's much more interest in post-COVID conditions, so-called long COVID. That's something that we are continuing to look at, and the parliamentary inquiry, Professor Murphy and I and others will be working with members of the House Committee in relation to that tomorrow, actually, and we're looking forward to their what they've gathered and advice to go into a national policy in relation to that, because I think there will be a long tail to this pandemic, even once the acute phase is slowing down.
Has the medical community yet grappled with the fact that the Commonwealth, and Professor Murphy was intimately involved with this, its mandate in terms of vaccination was very narrow, but the state mandates were much broader. Whether that had a counterproductive effect in terms of the take-up, because we have seen a reduction in take-up of the boosters I mean, is that just the general public getting more quote-unquote comfortable with the current situation, or has the medical community yet looked at whether some of those state-based mandates are actually counterproductive in terms of take-up?
I'm not aware of any specific studies that have been done to answer that particular question. I think, to put it the other way, when you look at the first 2 doses of vaccine, Western Australia had probably the widest widest mandates, as you're aware from your own experience, had the highest uptake of the first 2 doses, but then it dropped off a little bit after that. So, cause and effect in relation to that is hard to measure, of course, but. Look, there were reasons that the various states made their own decisions in relation to mandates, and really they have to be the ones that need to talk to that. Where we're at now,
I'm
though,
not asking you to talk to it, but I mean, I think my view is that vaccines, along with antibiotics, are the single most positive health advance in the last 100 years. And we don't want a distrust to build up. So I just wonder if the medical community had confronted that issue at all.
It was certainly an issue which was considered at that time. What are the potential downsides of going too hard on a COVID vaccine compared with all of the other vaccines that we have? And there is some evidence around the world that childhood vaccinations, particularly measles vaccine, has decreased in its uptake, not only in Australia but elsewhere. Whether that's due to a trust issue, hard to tell. But these again, is one of the long-term effects of the pandemic, is about trust in medical decision making, trust in government decision making. All of those things are very important, and without that, things become difficult.
I'll pass over to Senator Ruston. If
Okay
that's
with you,
okay, Chair.
Finish the time.
Yeah, that's okay. Ruston, and then I'll come to you, Senator St John.
Thank you. Good morning, everyone. Just quickly on unanswered questions. Secretary, currently there's 17 unanswered questions left over from the last estimate. So I was just wondering whether they're with you.
I'll get Mr. Wong to respond to that.
So from the last estimates, we received in November, 10 November, 358, and we responded to 92 of those. They've been tabled. I'll just pull up the specific where they're currently situated. So of the 358, 242 were tabled by the due date, 330 were tabled in full, 28 are outstanding, 16 currently with the Minister's Office for noting, 10 with the department, and 2 with other agencies.
Could you maybe give, what would be the reason why these would still be with the department?
I haven't got the details of that, but we can find out.
To get some more data or more information. Sometimes they come to me and I say that I don't think that question's been answered fulsomely enough, and we want to go back and have another go and get more data. So often that it's generally a complex issue where we obviously strive to answer in as much detail as possible, and sometimes the initial response doesn't meet adequacy. But we can provide a bit more information for you later, Senator, if you like. But I think our response rate, I think, certainly has improved over the last few years, but I acknowledge it would be ideal to have everything tabled in time.
Yeah, I mean, it'd be interesting to know what the subject matter was, whether they're all on the same subject matter. Minister, would it be possible for you to see from the Minister's office today as to why the ones that are in her or his office, whichever it happens to be,
I'll take that on, Senator.
haven't been tabled, and if we could get an answer today as to when they would be tabled, and same thing, Professor Murphy, if we could get an idea of when we might be able to see the answers. Is it here that I can just ask generally about COVID deaths?
Professor Kelly is here and is across COVID deaths.
They're pretty simple questions. I'm not going to...
It's generally seen as as an outcome on health protection thing, but if it suits
Yeah.
you, Professor Kelly is the man.
Yeah, I was just interested, like we were very fixated for a period of time on the number of deaths that were happening, almost, on a real-time basis. So, Professor Kelly, have you or any of the agency staff got before you the actual number of, what is the total number of Australians who have died since the beginning of the pandemic?
Thank you, Senator, for your question. I'll just find that number. We are still reporting on deaths from COVID-19, and we are moving very much towards using the Australian Bureau of Statistics as the gold standard in terms of deaths. And so that is not a timely number, but I'll be able to talk about that if I can find the number.
Maybe while you're looking, you just said that you're moving to an ABS-style reporting. When was the decision made to move away from your internal reporting to the ABS, and what was the basis of the decision to do that?
So the ABS is the way that we report on, the deaths are reported on in Australia, and the reason why we use that is because it's based on the state-based birth, deaths and marriages register. And they use very, very specific and clear reporting metrics in terms of the medical certificates and coroner's reports. So some of those things, particularly the coroner's reports, can take quite some time. We have other ways of looking at death. We have the National Notifiable Diseases data, which is held by the states and shared with the Commonwealth, thanks. And also other mechanisms. But the ABS is the way that, as we move towards living with COVID and away from COVID exceptionalism, we went to the way we report on cancer deaths, for example, or other types of
So,
other deaths.
Professor, I was actually, and I'm sure that's absolutely true and factual, I was just understanding what was the determinant of the decision to change how we were reporting on COVID deaths. Have you got the COVID deaths there yet?
Yes.
Well,
yeah.
just while Professor Kelly's getting up, can I say that was the department was strongly pushing that change. We did originally use a fairly unverified death certificate, that was death statistic, which was calculated from the various reports of states and territories when they were reporting every day. They used to report their deaths every day, and they were not verified, and often when the ABS analysis happened some weeks later, we had to revise them down. And given in the early phase of the pandemic, when there was huge public interest in the daily death numbers and they were driving, vaccine uptake and all that sort of stuff, it was quite important to get something that was seen by the community to be real time. But in being real time, it compromised accuracy, and many of those deaths were then revised down, found not to be due to COVID. And so, as Professor Kelly said, the gold standard has always been the ABS. And so we, the department, put to government late last year that we thought it was time to move to the gold standard method that would provide accurate time-to-time comparison. So it was very much our desire to move away from what was an inherently inaccurate system. So, sorry, Professor Kelly.
Yeah, thanks, Secretary. However, we still are reporting on the National Notifiable Diseases Surveillance System data every week rather than daily. So it does have every day's data in there, but it is less liable to those fluctuations that the Secretary has said. So the number is 18,190. That's as at the 8th of February.
Okay. And have you got them broken down into years, so 2020, 2021, 22, and obviously to date this year?
I have the data for 2022 is 14,855.
14,855 for 22.
For 2022,
Yep.
892 so far this year.
For 23, and what about 20 and 21?
I'll just take that on notice for the moment, if I may, and we'll look back on that and get it back to you later.
So do we have the figures of how many aged care residents are accounted for in that 18,190 number?
I do. In residential aged care homes there have been 5,075 deaths during that, since the beginning of 2020, and I do have that by year.
Yep.
686 in 2020, 226 in 2021, 3,855 in 2022, and 308 up to the 9th of February this year.
Okay. And so at what point, what was the date at which the data change in terms of reporting occurred?
So this reporting is no change. This is based on the National Notifiable Diseases Surveillance System.
But separate question, sorry, I jumped around a bit there, my apologies. So the decision was made on your advice to move to the ABS data reporting methodology. When was the first report released using that? When was the last report released under your previous scheme, and when did it move to the ABS?
So just to be clear, Senator, this is using the same mechanism we've used throughout, which is that National Notifiable Diseases data. It's just being done weekly rather than daily. There's been no change in relation to that weekly report. That number is comparable right throughout.
But didn't you just say that you were reconciling back and off and having to change them?
Yeah, but this data is what we're reporting every week, and that hasn't changed.
No, maybe I'm not being clear. You said that you originally were reporting on data that you said was not as accurate as you'd have liked it to have been.
Correct.
So you moved to the data reporting from the ABS data reporting. I'm just seeking to understand, when did you cease providing data that was not ABS data to the general public and move to only reporting on ABS data?
We haven't ceased, Senator. Sorry if I said something differently earlier. This is the same as we've been reporting all throughout. But then a lot of the other work we're doing in relation to linking up and understanding more about death data and other data related to COVID is using the ABS figures. But this weekly reporting is the same as we've been doing throughout.
Okay, sorry, I misunderstood you. So in terms of the review around data, I mean, is this something that it's just a comparison between what you are collecting on a weekly basis, and then do you every week or every time you report then reconcile? I mean, I'm trying to understand what the reconciliation process is here.
So I think the Secretary sort of mentioned at the start, but at the time where all states and territories were reporting daily figures, and again, to be clear, these data are owned by the states and shared with the Commonwealth. When they were doing that, most states were reporting on date of notification. So I remember one particular day in one state where they reported, I think, 157 deaths on one day, of which only 17 of them were on that day. The rest were from up to 6 months before. So that explained why there was a lot of fluctuation on a daily basis, which was misleading, really, because actually you want to know when people are actually dying, because that's the thing that's helpful in terms of charting the pandemic. So we do go back and look at that when further information comes, for example, from a coroner's report to the ABS, and we reconcile those figures every week. So that if you look back historically, those numbers on a particular day might be slightly different to what was reported, but that is just for the accuracy.
So is it possible to get, say, the reconciled data on a weekly basis from, say, the 1st of January till now? Because in going and having a look at the data as it's currently provided, it's really difficult to make any comparison, or is there somewhere I can go to get better information? Because there seemed to be an increase in the number of deaths in some areas, unexplained, so we don't know whether they were COVID-related deaths or not. We're assuming they are, but we don't know from what period they are likely to be applied to. So is there somewhere that you can go and actually get your fully reconciled data on a week-by-week basis so that you can make some sort of sense out of what these numbers are?
I just to make sure I've got your question exactly in my mind, Senator. So you're looking to see what was reported on a particular day, and
No,
then
not
if it
a day,
was
no, week is fine.
Okay. I'd have to take that on notice, but what I can say is that the data which is publicly available on the health website is the most accurate data on that day, which includes the reconciled data going back. The other issue, and recognising that 2023 is still relatively new year, there is a delay, usually of sometimes weeks before the accurate death data comes in. Even through this process, as I mentioned, sometimes that can be even longer if we're waiting for a coroner's report. Just on that, the other important thing of why we're very interested in using the ABS data is that they have a much more accurate way of looking at deaths with COVID, deaths from COVID, and the underlying illnesses that might have contributed. It also allows us to look specifically at aged care residents, at people with a disability, at First Nations people, and so on. And those things are really important for policy.
I suppose, to be honest, my interest sits around the fact that we had 686 deaths in 2020 when we were in a state of great uncertainty and terror. We went into 21 and, with the great work that you guys did, and I acknowledge that extraordinary work in aged care facilities that were done by the Department of Health and Aged Care, we managed to get that number down to 226, which was a phenomenal effort. We then saw in 2022 3,855, with a significant escalation towards the end of last year. I think it was sort of like less than 1,000 in the first half of the year, and 2,000 in the second part of the year, and we were still seeing significant deaths in aged care now. Sort of trying to understand what happened that resulted in the phenomenal success that you'd had in aged care to have deteriorated so significantly by the end of 2022 that we saw, I think, nearly 3,000 deaths in the second half of 2022 in aged care. Was there something we should have done that we didn't do? Was there some circumstance that we can put this down to? And clearly, what were the lessons learnt from that to ensure that we don't see the horrific figures that we saw in the last 6 months of last year?
So, Senator, I'll just talk about deaths in aged care, and there's others that might want to chip in on that from the aged care area themselves. But look, death from any cause, of course, is a sad but unfortunately inevitable event. It's a very common daily event in aged care. In fact, since the start of the pandemic, 175,513 residents of aged care have died of all causes. Just very specifically to your comment there about the second half of last year, that figure I gave you was for the full year. The highest death rate was actually in January of last year, not the second half of the year. But the reality is people die in aged care, and some of those have died from COVID.
Take you back there. So you're saying more people died in the first half of last year, not the second half of last year?
There were 3,855 deaths in aged care related to COVID in 2022. There were, as you know, several waves of Omicron related COVID during the year. The highest rate and the biggest effect on aged care was actually the first one, which was in December of 21 and peaked in January of 22 and then into February. But there were other waves. There was another wave in winter which also affected aged care, and there was another wave towards the end of the year as well. I don't have the breakdown in front of me, but I'll take that on notice about when those deaths occurred. But there were deaths in aged care throughout 2022.
Just for your information, I mean, as best I could extrapolate from the data that was made available, it appeared as if there were 912 people in aged care died in the first part of 2022. and on that basis, that leaves nearly 3,000 that died subsequent to that. So I'm just sort of understanding that, I mean, yes, we certainly knew that the Omicron wave that hit us in January 2022, was, the time when we opened up, and it was a very tragic time. But it seems like, there was a lot of focus on that and a lot of activity. I know you put a lot of effort into trying to deal with that, but it seems like at the end of 2022, I mean, despite the fact the focus on the tragic deaths in the early 2022, there have been massively increased numbers of people who've died in aged care from COVID at the end of 2022. But I don't think I've heard what you're doing to try and deal with that. It almost seems like no one's really taken much notice of the fact that so many people died in aged care at the end of 2022, and no one's really talking about it. No one seems to be placing any urgency or any importance on it.
I don't think I would accept that
I hope
comment,
you don't.
Senator. But the reason why there have been more deaths during 2022 has been because we are living with COVID. There is a large number of infections that have occurred, millions of infections that have occurred in the community. We know from when we were charting this very carefully early in the pandemic that even 10 or 50 cases in the community leads to aged care outbreaks. We've learned a lot about how to deal with aged care outbreaks over this period, and there's been a lot of work done, and perhaps Mr. Lyon might want to talk to the work that's been done in aged care through that period. But there have been a lot of cases. The case fatality rate, even though the number of people dying is higher, the case fatality rate has dramatically dropped in those dark days you mentioned in 2020. There was a 1 in 3 chance of dying from COVID if you were an aged care resident at that time. The most recent wave we've had, it's down below 3%. So that is a dramatic change in the protection we're giving. But the more cases we have in people over the age of 80, there is a very high rate of death from any cause. As I said, 175,000 people have died in aged care during that period, and the average time that people are in aged care is just over 3 years. And the reason why people leave, unfortunately, is because mostly they pass away. So this is in no way a suggestion that we're ignoring that issue, and we're doing a lot of work in terms of protection of people in aged care.
I was going to say,
Senator Ruston, I do need to move the call around. I'll come back to you on this, but we've had the call for 20 minutes, so I'm just going to go to Senator Steele-John for a block, and then we'll return.
I only had 2 more questions if you want me to get rid of those, or otherwise,
No,
well, it's fine. Go.
Including Senator Brockman, it's been sort
No,
of
that's fine.
almost 30.
That's
So
fine.
Senator Steele-John,
Thank you very
we'll come back to you.
Thanks, Chair. In October last year, the Australian ADHD Professionals Association published new evidence-based guidelines for diagnosis and support in relation to ADHD, including 132 recommendations to government. How has the department been engaged with these recommendations?
Senator, that would normally be a question related to outcome 1. I'm not sure whether we have
We've
the
got
right
people in the room that can take it now.
I'm not. I doubt if we would have the officials in the room who would be across that. That's on this afternoon. Outcome 1.
All right.
We might return to that.
Yeah.
Steele-John,
All right.
if you've got others, you can go.
Yeah, yep. I will shift to other questions. So LGBTIQ people are a priority population across a range of federal strategies. There is a concern that I've heard from the community that many of these strategies lack specific goals, actions and related funding. I'm just wondering, first of all, will the government be investing in the development and funding implementation of a 10-year national LGBTIQ health and wellbeing action plan?
So, Senator, again, that's outcome 1, and we will have officials who have been working very closely on LGBTQI issues with Assistant Minister Carney, and who'd be very happy to talk about the the work they're doing, but that is in outcome one.
Okay. All right. Well, then it seems that my question for whole of portfolio are probably actually better addressed there.
Okay, we'll
So
make sure
back
we
to
come back to
Senator
the
Ruston.
outcome one. Senator Ruston, you've got the call.
Okay, look, in December last year, in relation to aged care deaths, the minister, Minister Wells, said that you were keeping a watching brief on the number of deaths in residential aged care. I'm sort of keen to understand what the department, what is a watching brief, and what are the kind of sort of level of activities that one does under a watching brief.
Senator Michael Lyde, Deputy Secretary Ageing and Aged Care Group. I think watching brief doesn't mean just watching. It means the department has a range of settings in place in relation to management of COVID in aged care. The settings have largely been consistent across the calendar year 2022 and through to the current time. So I think the Minister Wells was, of course, at each point we've briefed her interested in and actively seeking briefing to say, are we doing everything we can? Is there anything more we should be doing to upgrade our response in aged care? And so the department, has come back with, with the current settings we've got being maintained. We think that it's important that they're maintained. So, and as I said, those have been relatively consistent across 2022. The primary kind of work we're doing in aged care revolves around making sure that the vaccination rates are very, very high. Obviously, they're very protective. So I think currently in the residential aged care population, the vaccination rate is around 85%.
How many doses?
We can get that for you, Senator. That's for having had, I think, 4 doses. And obviously there's a commitment now to roll out a booster. And so that'll be a very important kind of additional activity that we undertake over the coming weeks and months. I'm in the second strand of activity is the making sure that antivirals are available to residents in aged care where there's COVID. They have obviously been very protective of that population, and we've administered a very large number of doses either through pharmacies or at earlier stages in the pandemic directly to residential aged care facilities. I think the third aspect is that ongoing communication that we have with our providers of residential aged care to make sure that they continue to uplift their capacity in terms of core skill sets like their infection prevention control work in facilities, and then through the lead clinical residential nurses, registered nurses, and the like. And we obviously continue to support facilities through outbreaks with reimbursement of provision of PPE and rapid antigen tests, and also then reimbursement of costs that they may have in relation to outbreaks.
Thanks, Mr. Lyon. I'll come back to reimbursement of costs. So there's a heads up that you're getting questions on that. So what I'd be interested to know if you could provide, you said you had settings that related to a status of watching brief, if you were able to provide some advice on notice about what those settings were, and at what point in time did the department change its setting to a watching brief setting, as opposed to obviously a level of greater urgency, which I'm assuming was in place before you moved to a watching brief? I mean,
Senator, we didn't change our settings to a watching brief from another setting. What I'm saying to you is that we have maintained the same footing, which includes those strategies I mentioned over the course of the last calendar year and into the current time, and that includes obviously preparations for making sure that we provide that new booster into residential aged care. So certainly not, settings haven't changed. We can provide you with the the advice that we've provided directly to aged care facilities, which probably give you an indication of that setting we remain very anxious about doing everything we possibly can to protect residents in aged care.
Senator Ruston, I can answer the question about the fourth doses in aged care. It's 85.7% at the moment for eligible fourth doses in aged care. The other point I'd add to Mr. Lyons is the really important increase in antiviral medication use, the oral antivirals. He did mention that. Okay, thank you.
So, I suppose I'm just thinking that watching brief suggests sort of like a level of, sort of an amber alert, as opposed to, I'm sure you didn't go through the pandemic on a sort of an amber light. I'm assuming you went through with a much higher level of sort of alertness to aged care activities. But the other thing, in February 2022, the Prime Minister, now Prime Minister, said that deaths in aged care was a measure of performance. Minister, I'm just wondering whether the fact that we have had more deaths in the last 8.5 months in aged care settings, sadly, than in the first 2.5 years of the pandemic, whether you believe that there has been a failure in the system on the basis of the comments made by your Prime Minister, Mr Albanese, that deaths in aged care was a measure of performance.
I'm sure the Prime Minister says a lot of things, Senator, and firstly his concern always is for all Australians, and there's no doubt, as we've said on numerous occasions in the Parliament, that any death in COVID, especially to our elders, is a serious matter. And we've just heard Professor Kelly speaking about the statistics and how the statistics have also been looked at in terms of COVID, with the collation of figures that look back on different days and weeks. So we know that those figures that Professor Kelly spoke about are important for us to learn in terms of data. You asked from the outset whether we're going to look at an inquiry into how COVID occurred and the collation of material and data. I think this is an ongoing conversation. I think to pick and choose what the Prime Minister says in terms of the deaths of people is your choice to do, but I wouldn't misrepresent the fact that there is concern by both our Health Minister and the Prime Minister for the care of all Australians.
So, just to be clear, do you, as a Minister in the health portfolio area, believe that deaths in aged care are a measure of performance?
I believe that any death anywhere is one where we always should ask questions about, Senator.
So you do think it is a measure of performance?
I'm not saying that. I'm just saying that we always need to be clear within the systems, in particular in the health system, as to why people pass away. I mean, we do it with First Nations people who have low health, kidney failure, who die from rheumatic heart disease. We've put in incredible amounts towards the budget to deal with these issues, and obviously conscious of the fact that the Coalition cut that budget in health because of the rates of deaths that we see across Australia. I would not agree that we're not doing the right thing here.
I don't think anybody was suggesting that. I think you've just put that on the record yourself, Senator McCarthy.
I think we put on the record that in terms of health budgets and funding cuts over the years, your previous government has shown a huge record of the cuts in the health system for all Australians, and I'm saying that we have to look at the system and try and improve it, and that's what we're doing under Prime Minister Albanese.
Just for the interest of clarity and accuracy, I would put on the record that under the Coalition government we saw increases across the board in every area of healthcare.
Direct it as a question to the Minister or the officials, please.
Look, thank you very much, but thank you very much. Clearly, we were not going to get an answer to the point that the Prime Minister said that deaths in aged care are a measure of performance. So thank you.
Question for whole of portfolio?
I'm done there. Yep.
Okay, Senator Brockman, did you have more under
Just
whole
really
of portfolio?
quickly, and this come up during the week in the media, Professor Kelly. There was a significant increase in the all-death mortality. I mean, depending on how you report it, apparently it varies from 13 to 16%, but I think everyone would agree that's significant. When we all became health statistic experts in 2020, you know, one of the ways of looking at the impact of the pandemic was deaths above baseline. I mean, so if I put my head back where I was a few years ago, I would say, oh, but I mean, what are you saying when you see that number, that 13 to 16%? I mean, what is the explanation that you feel explains it? Because it does seem significant, statistically significant.
So there are others in the room that might be able to talk to the work we're doing in relation to what you're describing there as excess deaths. Just in terms of our international comparisons, though, Australia has done extremely well throughout the pandemic in relation to excess deaths. We continue to have lower death rates related to COVID and more generally than most other similar countries. So I'd say that in the first. But it's an issue that has come through in 2022 particularly, and requires more detailed analysis, which we're doing. There's whether it's related to the disruptions that happened in terms of other health matters during the pandemic. That's one of the theories. So, for example, there's been an increase in cancer deaths. But you know, is that due to delayed diagnosis, for example, people for whatever reason not getting screening or deciding to delay those sort of matters? There are other theories in relation to COVID itself and the long-term effects of COVID, whether that has changed other diseases like cardiovascular disease, respiratory diseases and the like. So there's a lot of work being done internationally and here in Australia in relation to working through that work. But Phil Gould is in the...
Mr Gould is here.
He's at the end of the table, yes.
Apologies, I don't have my name tag. Dr Philip Gould. I'm the First Assistant Secretary for the Health Economics and Research Division. The ABS statistics that you're referring to are a really important gauge of the effect of a number of health conditions in terms of mortality. So the basic approach to excess mortality is to take a baseline figure of what we would expect deaths to be during normal conditions, and we look at a regular basis then on how much deaths over a particular period have been above or below that. During the early stages of the pandemic, we actually saw negative excess deaths, so deaths were actually below normal. And indeed, over time, if you look at the statistics over the course of a decade or even 2 decades, you see periods where we have positive excess deaths and negative excess deaths. So the numbers do naturally fluctuate. In terms of the numbers that we've seen most recently from the ABS, clearly COVID has been a contributor as a cause of death in Australia during that period. We've talked about those numbers, so that's clear. But as Professor Kelly referred to, we have other causes of death which have been higher than average. So dementia is an example, as is heart disease and diabetes. So again, these may or may not be related to each other. But we do expect to see fluctuations in these numbers.
Do we compare, because again, this excess deaths was one of the few tools that policymakers had to compare various nations, and as you say, during that 20 to 21 period, Australia actually had a positive excess death, if that makes sense. You know, we actually had less people dying than would normally be the case. But you know, obviously now, you know, that situation has reversed. Are we looking at the international experience? Because again, we could see in other nations, COVID deaths in 2020, 2021 caused significant spikes in excess mortality compared to Australia. So are we monitoring what's happening in those countries?
Yes, look, I don't have those numbers at hand. There are a number of websites, for example, the Economist produces estimates.
I know there are a number of websites, but does the government,
we do look
department?
at that, and broadly speaking, our experience is not out of line with international experience during the pandemic. I think our early performance was we had lower deaths. As I said, we had a period of negative excess deaths. And now what we're seeing is more in line with other countries. Without having the numbers at hand, I can say, though, that the performance is still generally good on an international level.
Okay. I'm happy to leave it there.
Okay. Thank you, Senator Brockman. We were expecting some other senators for whole of portfolio, but they've not arrived. So I suggest we move on and...
Is that from our team? Or?
Yes. Yes, we have called them and messaged them a number of times.
We need to move on.
So we will head on. So we'll be calling officials from Outcome 2 now, please. Just give officials a moment to do the shuffle. Senator Steele-John, you have a number of questions for me? Yes. Yeah.
And also perhaps on one, but I know
Yeah, well, yeah. Okay. Senator Steele-John, you have the call.
Thank you. Thank you, Chair. One of the recommendations of the Aged Care Royal Commission was the establishment of a seniors dental benefit scheme. Has the department been given any directions to investigate how to implement the SDBS?
Dental is, in fact, we do have an official who can help, but it is actually in Outcome 1 2 dental. But
Dental's
Outcome 2, yeah, sorry.
Hello.
Yeah.
Would you like me to repeat the question?
Yes, please, Senator. Thank you.
Okay, so the Aged Care Royal Commission, one of its key recommendations was the establishment of a seniors dental benefit scheme. My first question to you is, has the department been given any directions to investigate how to implement an SDBS?
So Tanya Ishnew, Deputy Secretary Primary and Community Care, Senator. I think obviously a dental scheme for senior Australians is a big undertaking. We haven't been given any specific direction, but we have been looking at it in the context of the response to the Royal Commission. Actually implementing such a scheme is complex and expensive, so, you know, rolling something like that out would be a decision for government.
Okay, so just to be clear, you said you haven't been given any specific direction, but you have been investigating the area?
We have, and in the light of the Royal Commission, Senator, we've been looking at it in terms of what would a response look like to that particular recommendation.
Okay, and when did that work commence?
I would need to call on my officials. I might take that on notice if I can, Senator.
You've got one of your people coming up now.
Simon Cottrell, First
Assistant
Secretary, Primary Care Division. Apologies, I was coming into the room as you were asking your first question.
Yes.
But there's currently a review of the Child Dental Benefits Scheme underway, and in that context, we're exploring options for how to improve access for children with disability to dental services.
Yes.
So that's one aspect of how we're examining this issue.
Yes, I think you I may have not quite heard which commission I was referring to. So I was referring to the recommendation of the Aged Care Royal Commission in relation to the creation of a seniors dental benefit scheme. And I'd asked whether the department had been given any directives to explore how to implement that scheme. Your colleague just informed us that some work is being done. And my question was, when did that work commence?
The department started undertaking exploratory work on this issue as soon as the Royal Commission made its recommendations. I don't think we've provided advice to this government about it.
Okay, so when did you begin? So when did you begin that exploratory work? I'm just trying to find out when you started.
So,
First of all.
Senator, can I take that on notice in terms of actual dates? Obviously, it was when we were looking at the response to the Royal Commission, so after the Royal Commission report came out. But we'll try and come back to you with specific timing.
Okay, and who has been leading that work in the department?
Dental health is the responsibility of my division.
So your division. So is it just yourself working on this topic, or is it the team underneath you that are working
So
on
we
it?
have a section that looks after dental health issues.
Okay. So are you able to give us a kind of update on where that particular piece of work is up to?
So as I said previously, Senator, it's exploratory work.
Yes.
We haven't advised the government on it.
I understand you haven't made a recommendation. So where's the exploratory work up to?
So, Senator, we'll need to, obviously we would need to look at the exploratory work and brief government and ministers before we could actually share anything.
Okay. So the Royal Commission's recommendations have been out for a long time now. There were horrific stories shared with that investigation in relation to the treatment of older people in aged care generally, and particularly in relation to the state of the dental health of older Australians in aged care. What you're saying to me is that you have done exploratory work, but you haven't made a recommendation. You aren't able to tell me when you are going to make a recommendation to government. Minister, we've also heard that no directive has been given to the department to kind of advance this work any further. My understanding was that your government supported this recommendation. Where's the urgency?
Look, Senator, thank you for your question, and I am aware that in November the 21st, our government offered states and territories a 12-month $107.8 million Federation funding agreement for adult public dental services. Yes. So please do not say that we don't see urgency in this. We certainly do. To date, the Northern Territory, South Australian, Western Australian governments have signed the FFA. So we are clearly working through the need for public dental access across the country.
Senator Steele-John, apologies for interrupting. I've just noticed we have media in the room, so I just need to go through the script. The media have requested permission to film and take photographs of proceedings, and the committee has agreed to do this with some nods. Yep, thanks. I remind the media that this permission can be revoked at any time, and the media must follow the direction of Secretariat staff. If a witness objects to filming, the committee will consider this request. The media are also reminded that they are not able to take images of senators or witnesses' documents or of the audience. Media activity may not occur during suspensions or after the adjournment of proceedings. Copies of Resolution 3 concerning the broadcasting of committee proceedings are available from the Secretariat. Senator Steele-John.
Thank you, Chair. Minister, the recommendation of the Royal Commission was really clear. What is needed here is a seniors dental benefit scheme. Your minister has not made a direction to the department to investigate the setting up of this scheme so long after the recommendation was made. Is it the intention of the government to make a commitment to such a scheme in the coming budget?
Can I just correct you there, Senator? We've had the passage of 2 new acts through Parliament in 2022, combined with measures from the October 22 to 23 budget, which will address in full or in part a total of those 37 recommendations. And as at the 27th of January this year, the department, as we've heard, 19 recommendations are completed, 107 recommendations are in progress, and for the remaining 22 recommendations, the department is working with governments on its reform priorities and to determine if further action is required. So we are working on it, Senator. I cannot stress enough that this body of work is being done.
So specifically on the seniors dental benefit scheme, are you saying that there is work being done and the government is expecting a recommendation to be made to them in relation to the setting up of that scheme?
Well, certainly the Minister and the Department are working on it, Senator, and I'm happy to get the most latest updated information for you in terms of that specific question.
Please do, thank you. Mr Cottrell, you mentioned that the government's undertaking a review in relation to the provision of dental care to disabled children, I think was your...
It's at the Child Dental Benefits Schedule, which provides benefits to all family tax benefit eligible
children. So you're
children.
reviewing it particularly in the context of disabled children?
That's one aspect of the review. So
okay. When is remind me of the completion date of the review?
It's early this year. I'll have to come back on notice with the exact date.
Okay. I'll come now to the National Oral Health Plan, 2015 to 2024. From what I understand, the last reporting against the KPIs in the plan was released in 2020, using data from reporting in 2016 to 2018. Can I check that it's correct that no public data has been released since that which was collected in 2018, about 3 years ago?
Senator, there's no longitudinal data set on dental health. From time to time, the department and government sponsor research studies. That would have been one of them. That latest available data, we're considering when the next one will be undertaken.
So you're considering it now?
Yes.
And when did that consideration process commence?
Senator, I will need to take that on notice, but we'd expect an answer in the middle of the year.
Okay, because your plan, as noted in the kind of headline name, is 2015 to 2024. It's very hard to see how you will track against those KPIs if you're using a data set that's 3 years old.
Yes, so we're as I say, we're considering undertaking the next study to update that data.
Okay. Is there an intention to take that recommendation to the National Cabinet space to enlist the states in the gathering of that data?
Our Minister is discussing long-term dental health reforms with the states in the context of the Health Ministers' meeting.
Right.
So that's a live discussion. There's a working group on long-term dental reform that is looking at these issues, the funding of the adult public dental schemes, funding that's currently provided through outpatients departments and a range of other mechanisms, and looking at how we can make that more sustainable in the long run.
And just in relation to the plan, is there an intention to report against the KPIs in the plan?
I think we've got a commitment to do that, yes, Senator.
Okay. Could you just come back to us with a clear yes or no with that? All right. I'd also note that the report is available online. Beyond the plan, I should say, there is a report that's available online titled "The Oral Health and Dental Care in Australia," which includes some key reporting, including how many people have been assessed, how many people have accessed dental services, for instance, and hospitalisations that may have been prevented had they have received earlier treatment. The report was last updated online in about March of 2022, from what I've been able to see, and it includes data from 2019 to 21 period. If there's data for this report, then why is there no public data to complete an updated report against the National Oral Health Plan? It seems that we've got a serious problem when you've got one report over here with a more recent data set than the National Oral Health Plan.
So I'm not familiar with the precise data set you're referring to, Senator. So we'll need to have a look at that. But you know, as I've said, we have a commitment to update the data. We're working on doing that, and we have a commitment to report at the end of the oral health plan.
Okay.
Senator, if I may, we'll take the details of that particular report, but as I'm sure you would be aware, data sets vary depending on kind of the particular slice that we take. So it may be that it's reliant on hospital data and AIHW data rather than a much more comprehensive set.
Yes.
But if we take that detail, we'll be able to provide a comprehensive answer.
Okay. Thank you. I've got some other questions for outcome 2, Chair.
I might
you
share the
wanna
call
share the
over and
call?
I'll come back
Yeah,
to you,
thank
Senator
you.
Steele-John. Senator Ruston.
Thank you very much. Can I just get a bit of an update in relation to medicine shortages? Is that the right place to be doing it?
Outcome 1 officers are probably from the TGA in a better position to answer those questions. Sorry, Penny Shakespeare, Deputy Secretary, Health Resourcing Group.
Okay, will you'll still be around at the same time? Those
Yes.
TGAs here? Because I'm sort of keen to understand what action is being put in place to ensure that we do everything we can in Australia to secure supply that may not necessarily come through normal processes if there are international supply chain issues.
will be here for when
So-
the TGA's here.
We can certainly
fine, I can wait.
talk about some of the work under the Pharmaceutical Benefits Scheme that we're doing to try and reduce the impact of medicine shortages, but I think the information about actual shortages experienced at the moment is probably best answered by officers from the TGA.
Okay, all right, well, we can leave that till then. What about MSAC processes? That's you?
Yes.
Fabulous. So just keen to understand, once you've got a positive recommendation from MSAC, what's the process that has got undertaken to then translate that into a new MBS item?
So MSAC does make recommendations across a range of schemes, but if it's around the medical benefit schedule and including an item on the MBS as a result of an MSAC application, the advice is transmitted to government. Then we will look at any implementation arrangements that we need to settle with potentially impacted providers or patients. So, for instance, at the moment we've been working on implementation of an MSAC recommendation to include carrier screening testing for certain conditions, Fragile X, cystic fibrosis and spinal muscular atrophy. We've needed some time to work with the pathology sector to make sure that their storage of genetic data from people who potentially do not have conditions is adequate to ensure that that data isn't, able to be taken by others through cybersecurity breaches and those sorts of things. So that's a particular example of some work we've had to do to support the effective rollout of a new item through the Medicare benefit schedule. If it's a fairly straightforward thing, then it's really just a matter of agreeing costs through the government budget processes and then having that added to the MBS at the next available update. So
tell me if I'm verbling you. So you're saying that the process after the MSAC approval before the MBS addition is sort of more around logistics and the practicalities of the deliverability of the approval, more so necessarily than additional consultation?
So I don't think I'd characterise MSAC advice as approval. MSAC makes recommendations about listings on the Medicare benefit schedule to governments. The approval is actually done through government processes, which can include things like what logistical arrangements do we need to make to support the effective rollout of a new service or technology through the medical benefit schedule.
So what is the purpose of the action that exists between the MSAC recommendation and the MBS approval, and what matters are taken into account that would determine whether the recommendation was accepted or not?
So I suppose things like the ability of the service to be provided in Australia through providers. Now, MSAC will look at part of that, but we also need to confirm that with, the clinical providers. That example I gave earlier about ensuring that we've got adequate protection of broad community-based genetic data for testing purposes, it really can vary depending on what the item is.
Yeah. And is the assumption then that if in the process of assessing that if you get the green light on everything and there is no, there's nothing preventing that particular recommendation from being able to be practically applied, then it would automatically be approved, or is there another
There's also
process?
legislative processes. So MBS items are actually given effect through legislative instruments. So we just go through a process of working with providers.
So that's only, they're not disallowable though, are they?
Yes. So the general medical services table, the pathology services table, they're all legislative instruments.
So every time you list a new MBS item, it's a disallowable legislative instrument.
Yes, that's so. But in terms of developing the legislative instrument, we need to look at conditions, and we do check those with providers to make sure that they're as clear as possible, that we don't end up with any unintended impacts on delivery of services or patients in the way that the legislative instruments are drafted.
Mm-hmm. So on average, how long does it take from an MSAC recommendation to those instruments being tabled?
I need to go and check that data. I'm sorry, I don't have that with me, Senator.
So you have any idea? Are we talking weeks, months, years?
So there are generally 3 updates to the medical benefit schedule each year.
Mm-hmm.
There can be things done through determinations in between those updates. So it's probably in the order of months, but there would be some more complex services that would take a lot longer.
Yeah, it'd be great if you just an average and then maybe the outliers on either. I mean, how quickly it can be done, and obviously the potential for long times. What would be the comparison, say, for instance, with our process and from a recommendation to approval or application even, in terms of the whole assessment process in Australia in comparison to other similar countries, Canada, New Zealand, France, UK, whatever? I mean, are we fast, slow, average?
So there are international comparisons done by some organisations which look at health technology assessment processes. I don't have that here with me. We may be able to find some other officers that have got information, but I understand Australia generally compares fairly well.
Okay, and it'd be interesting to understand whether the comparisons in relation to the MSAC process or the if other jurisdictions have a similar time frame in relation to recommendation to final approval. So once you've had a positive recommendation to approval, whether those times were comparable as well. I'm just interested, are there any plans afoot at the moment within the agency to try and accelerate the process such that, you know, and it's only anecdotally, there is often conversation in Australia about how Australian patients are not receiving the kind of fast access to new technologies that many other patients around the world are receiving because of the slowness of the process, which obviously we'll be able to assess once you've provided that information. But just wondering, is it of a concern to the department that is a comment that is quite often heard, and is there anything on foot at the moment to try and see if we can accelerate the process to enable Australian patients to get the fastest possible access to new technologies?
Yes, so I might ask my colleague, Ms Platona, to come to the table, because we've been consulting about potentially introducing cost-recovered pathways for assessment through MSAC. So there's been no decision on that, but we have certainly been consulting about that and whether or not that might be able to provide faster assessment timeframes for certain types of applications.
Thank you, Senator. Adriana Platana, Technology Assessment and Access Division. So MSAC processes are quite different from the ones that you'll be more familiar with on the Pharmaceutical Benefits Advisory Committee, because they consider a range of products. It is not medicines like with the PBS. As Ms Shakespeare said, there are MBS items, there are gene technologies, for example, that are coming through. There are other types of genetics and genomics tests. So the scope of the MSAC work is a lot broader. Also, the types of applicants that MSAC receives requests are quite broad. Some, for example, are commercial organizations, some are colleges, clinical colleges, specialist colleges. So in trying to streamline the assessment processes leading into MSAC and its subcommittee, we have to give consideration of the type of applications and the type of applicants and the nature of those applicants. So we have been looking into introducing cost recovery into the MSAC processes to give us more opportunities to streamline the processes there. Clearly can't do that for every applicant. There are commercial interests for which we are looking at in terms of putting more resources and bringing more resources into this process. And we are continuing to consult. We have done an early consultation piece last year, have received feedback. We're considering that feedback, modifying our approach as necessary. And I think we are going to go soon for a new round of consultation with stakeholders. There's a great deal of interest in the work of MSAC, and we are responding to that.
Sure. Just finally, the 2021 report, the New Frontier report, in there was a recommendation that was contained particularly in relation to it, and I'll just read it so I don't muck it up. Improving coordination between MSAC and the Prostheses List Advisory Committee to provide faster access to patients to these technologies. I'm just wondering whether that is occurring and whether you've got any updates about how the interaction between MSAC and the Prostheses List Advisory Committee is occurring.
So it's definitely occurring because the prosthesis list area is undergoing a 4 years reform, and part of that work is about establishing new tailor and fit for purpose assessment processes. Ms. Flynn has all the details on the prosthesis list.
Thank you, Senator. Elizabeth Flynn, Assistant Secretary, Prosthesis List Reform Task Force, Technology Assessment and Access Division. Senator, we've been designing 3 new listing pathways. We just call them Tier 1, Tier 2, Tier 3, and the Tier 3 pathway is the one for medical devices that need to be assessed by MSAC. So I think one of the blocks at the moment is that there is no clearly defined pathway for medical devices, and so these 3 new listing pathways should clarify that.
Yep. So to the clinical implementation reference group, can I go straight to that? Is that yes, a good segue for you? Great. So just wondering in relation to that group and the decision around I think it's how many, was it 400 or so items have been recommended for no longer to be included on the list. So I was interested to understand the process about that decision making. Was it simply as much as implantable versus implantable? I mean, what was the decision making process around why that particular 400 are no longer on the list?
Senator, there's been quite a long process to deal with these items. So just to backtrack a bit, the main purpose of the prosthesis list, which is a very large list of about 11,500 items in now 4 parts, it includes medical devices in Part A, human tissue products in Part B, exceptional circumstance type devices in Part C, and the items you're talking about are all grouped together in Part D now, and I think they're close to 500 items in Part D. We commissioned some independent work, I think it was in 2019-20, to identify these items that had somehow got onto the list and they didn't really fit the criteria. So for medical devices, Part A is all about implantable medical devices or systems that support that implantable medical device. And historically, we'd found ourselves with items in there such as skin glues, which are not clearly not medical, implantable medical devices. So we commissioned that work, which was published in 2020, and that had about 400. It had identified about 400 items across the prosthesis list that didn't fit the criteria to be there. So that was our starting point. We did a consultation paper asking stakeholders, what they thought of this grouping. We proposed a new definition that should clarify and prevent that situation from happening in the future. On the basis of the feedback on that consultation, that's what we took to the Clinical Implementation Reference Group several times over, and we also used independent clinicians to support that advice. So essentially it's whether the device is a single-purpose device or supports an implantable medical device, and it doesn't meet those types of criteria, it fell into that Part D category.
So those I won't call them devices because clearly you don't think they are devices, that's why
They're
you're taking them out of the
devices,
list.
they're just not implantable devices.
So can you give me a bit of an update around what the alternative funding mechanism for those items is going to be going forward?
Yes, so a number of stakeholders were quite concerned if they were taken off the list and there was no clear funding arrangement going forward. So we've just released a consultation paper this week which proposes that when we take them off of the prosthesis list on the 1st of July this year, that they will fall under a different category under the Private Health Insurance Act, which is about default benefits, and they will be bundled so that for an episode of care, we've looked historically at what types of these items you would use in an episode of care. So what I mean is in orthopaedic surgery, you might use some skin glue and a drug delivery device for pain management while you're in the hospital, that kind of thing. So they're now a bundle for, sort of orthopaedic episodes of care with a price associated with it, which was determined by the Independent Health and Aged Care Pricing Authority based on the historical records. So the concept would be that those bundles, and there are essentially 24 different bundles for different episodes of care, would be listed in the default benefit area of the Private Health Insurance Act and still be mandated as a bundled price.
Okay, so they will be mandated?
Yep.
But that's assuming following the consultation that that's the decision that's made?
Yes.
Or is there a guarantee of that they will be mandated already? Because I think if I recall correctly, the Minister did make some comment in December about the mandating of the payment of these particular...
Yes.
So
yes,
is that correct?
The Minister did decide to mandate them, for a period of time and see how it's working, and then, we might tweak the system, I suppose.
Okay, so how long is that mandate likely to be?
I think it would be likely to be 2 years. We'd be tracking how it's working for all of the stakeholders.
And how is it proposed that mandate be put into place? Is it a legislative mandate or a regulatory process? How is that proposed?
It's a legislative instrument, and so the consultation is really about what that looks like, what that legislative instrument looks like.
The Department has also recently done a broader review or funded a broader review of default benefit arrangements under the private health insurance legislation, so it would be considered with that review.
Okay. All right, so most likely a legislative instrument that will mandate the payment mechanism for 2 years. The payment mechanism is already established, or is that part of the consultation as well?
So there are already payment mechanisms for, consumable items used in surgeries between private health insurers and hospitals.
So these will be just put into those 24 bundles that you've just referred to?
Yes.
And there will be a mandating mechanism through legislative instrument to ensure that these particular items are adequately covered or are unable to be adequately covered through the private health insurance mechanism under the defined.
They're probably better characterised as minimum or default benefits, so that's what insurers are required to pay in the case of an episode. But the payment mechanisms themselves are between the insurers and hospitals and patients.
And I should also note that there's part of what we're consulting on is an opt-out option where if a hospital comes to its own terms with an insurer that are different from the bundle, they're able to opt out if they come to a better arrangement.
Sure. Okay, so in the changes, for all of these 400 items and the change in how they're now to be dealt with, Has any assessment been made around the likely impact, like a regional assessment impact, to see whether there is any different impact in rural and regional hospitals as opposed to metropolitan hospitals?
We don't anticipate any impact because they will remain, mandated as a funding mechanism.
But we are consulting on the proposed arrangements that the Independent Hospital and Aged Care Pricing Authority have developed, and I think part of that consultation will identify if there are any particular impacts that...
So in a sense, you're not doing an assessment, you're just using the consultation process to see if anything gets thrown up via that mechanism.
Many of the people that we work with in this sector, such as private hospitals, have much more granular data than we do about the particular impacts on hospitals or patient groups or regional areas, and they will be able to assist us in that analysis.
Senator Ruston, I do need to share the call around,
Sure.
but I'll come back to you. Senator Urquhart.
Thanks very much. I've just got a few questions around the changes to the PBS. So I think Ms Shakespeare probably, is that you? To you, thank you. So we know that the government changes commenced on the 1st of January. Can you tell me what do these changes to the PBS actually deliver?
So from the 1st of January this year, the general patient co-payment for PBS medicines was reduced from $42.50 maximum down to $30. So for general co-payment patients, there are a large number of medicines which are now less expensive.
Can you tell me how many, what you say a large number, do you have sort of, it doesn't have to be exact, but some sort of,
so we can
idea
probably,
of...
talk in general terms about the numbers of
great.
general patients. It really depends on what has
What
been
the type,
prescribed
of
for an
course.
individual patient
Yeah.
and what it's priced at on the PBS, but
Yeah.
I'm not sure if my colleagues have any additional data they can share.
So we estimated that around 3.6 million Australians per year would have, that had prescriptions over the $30 would be benefiting from this policy.
Sorry, I didn't quite catch that last. There's a bit of conversation going on the other side of the room that I'm finding it a bit difficult to hear. Sorry. It's just, sorry.
Around
I caught the 3.6 million.
Australians per year
Yeah.
who have prescriptions over $30 would
Right.
be benefiting from this initiative.
Okay, great. So 3.6 million, yeah. And can you outline to me how much an individual patient and a family is likely to save per month with this change?
So, good morning, Senator. Nikolai Tsiganov, PBS Pricing and Policy Branch. Per month, it really depends on how many prescriptions a patient requires. So for a medicine that was prior to 1 January costed above $42, a patient would save per script the $12, which is the reduction, the maximum reduction in the co-payment for general patients.
Yeah. Have you done any sort of averaging across what that might look like for an individual or a family?
So again, it will vary greatly depending on whether that's a chronic condition or whether that's something that's a one-off treatment. There's great sort of variety between.
But I guess, sorry to interrupt. I guess the the bit I'm interested around, yes, there are one-off prescriptions that people get, but there are also a large number of Australians, and maybe it's that 3.6 million that are on a more regular sort of series of prescriptions over a period of a week or a month.
So, for example, if someone was receiving 13 scripts, so if they had a chronic condition and they were receiving a script every single month, a pack of medicine might be 28 tablets in a pack, and so they might need 13 scripts in a year for their chronic condition. So previously, under the previous maximum co-payment of $42.50, for a medicine that costs above $42.50, they were paying $552.50 per year. That same patient would now be paying $390. So that's a saving of $162.50 per year.
Yeah, okay. And can you...
Concessional, that's somebody who's not eligible for a concession, isn't it?
This is only for patients without a
Yeah,
concession.
I'm just getting to my next
Senator,
question. Yeah, thank you.
I'm just being helpful.
Well, I'm fine at the moment, thank you, Senator
Call out if
Ruston.
you need help.
Can you tell me the effect of what the recent changes are in the safety net for particularly pensioners and concession card holders who fill their prescription?
So in terms of the safety net changes, there were safety net changes in July 2022. So the
Senator Urquhart has already indicated she finds it difficult to hear when there's others talking or interjecting, so perhaps we can let her ask her questions and hear her answers. Thank you.
Thank you, Senator. So previously, under the PBS safety net arrangements for concessional patients, patients would need to fill 48 scripts per year before they got their scripts for free. Under current arrangements, that's been reduced to 36 scripts. So patients now need to spend $262.80 per year if they're a concessional patient, and after that they can get all their PBS prescriptions for free for the rest of the year.
Okay, so that's sort of the limit.
That's the safety net cap.
Once they get to that, then the rest are free from that. So.
That's correct.
And what would be the number of concession card holders that would reach that threshold over the period of a year? How many people are we talking about?
Well, we have estimated in the past that about 23% of all PBS beneficiaries would reach the concessional safety
Sorry,
net.
Ms Platano, I'm having a really hard time.
23%. My husband will be very pleased of me that nobody can hear me. About 23% of PBS prescriptions would reach that concessional safety net and would therefore be free.
Right, okay, thank you. Can you tell me how many new listings have been made to the PBS since the 1st of July 2022?
Been 67 new listings with additional funding that have been added since July.
Can you, so 67?
That have had additional funding committed by government.
And there are a further 83 items that were also approved where budget funding was already provided, and also 3 price increases. So altogether there were 153 PBS listings from 1st of July 2022 to 1st of March 2023.
So can you step me through and outline some of what the more significant new medicines that have been listed on the PBS?
Apologies for that, Senator.
That's all right. When you've got a lot of tabs, it's hard to find the correct one.
So from 1 February 2023, so this is the most recent listing month, a drug called Opicapone was listed as an additional therapy for Parkinson's disease. That's for 1,300 patients that have previously accessed a comparable type of treatment through the PBS. And without subsidy, patients could pay around $1,800 a year for that particular medicine if it wasn't PBS listed.
Do we know, and I don't know whether you can answer this, but do we know, since that's been listed on the, or how many people have benefited from it from that date, from the 1st of February compared to previously? How many people would have used it before? Because I guess the cost would have been prohibitive before.
So I think the only number we have available is the estimate of the 1,300 patients that have previously accessed similar treatments.
So there was about 1,300 before?
That have accessed similar medicines through the PBS, and this would be a new treatment option for them.
Okay, right. So this is a different medicine to what that 1,300
That's
would
correct.
have taken. Yep.
For the same condition.
Yep.
Also in January, 1 January 2023, a new medicine called faricimab, brand name is Vabysmo, was listed for the treatment of both diabetic macular edema and neovascular wet age-related macular degeneration, so they're conditions that can cause blindness. And in previous years, more than 18,000 people have accessed treatments for those conditions. For the diabetic macular edema condition.
Yep.
And as many as 62,000 people have had treatment for neovascular age-related macular degeneration as well.
Right.
And so that particular treatment on the private market could cost as much as $4,000 a year.
Wow, okay. And that cost now is a general prescription cost?
So that would be the PBS maximum general co-payment of $30 now for general patients and $7.30 for concessionals.
Yep.
Additionally, daratumumab on 1 January was also expanded to treat amyloid light chain amyloidosis in combination with other PBS-listed medicines. And that's quite a rare condition. Around 160 patients per year are expected to be treated with that. But it is a very high-cost medicine. Privately, it would cost as much as $243,000 per course of treatment. And again, now that's just a PBS co-payment amount.
Yeah, wow.
Evolocumab, brand name Repatha, was also extended to include more patients with high cholesterol, hypercholesterolemia, and expected around 9,900 patients each year will benefit from this expansion of the listing. And patients would otherwise pay as much as $3,700 per year.
Is that, I know I've been reading a bit of stuff about high cholesterol drugs and, or maybe it's a dieting drug that is a diabetic drug that's a shortage of that. None of these are linked to that shortage.
The drug that you are referring to is made by Novo Nordisk, goes by the name of semaglutide, and it's been in social media and a lot of media about not having adequate supply to treat the diabetes patients, which are the only indication that is registered for this drug and on the PBS full. But I think the company has since updated both us and the TGA that supply is becoming available and they are moving to normal supply situation. So hopefully the company has taken all actions to rectify that.
Great, thank you. But there's no connection between this one and that? No, okay.
And the other medicine that I would also mention that was listed on 1 December is the drug called vericiguat, and it's for chronic heart failure, and more than 10,000 people are expected to benefit from being able to access that particular treatment, and then would have paid more than $1,900 per treatment on the private market for that one as well.
$1,900 per year?
That's a per course of treatment, sorry.
Oh, per course. And how long is the course for?
So I think it's a single course of treatment, I think, that you get prescribed, and so it would be $1,900, $1,900 per that course.
Okay, terrific, thank you. And can you tell me, is it the case that since the 1st of January this year, the maximum co-payment is $30?
That's right. So the maximum co-payment for general patients is $30. Of course, some medicines cost less than that.
Yes.
So for general patients, medicines that cost less than $30, that's right.
Terrific. Okay, thank you. Thanks, Chair.
Thank you. I'm going to go back to Senator Ruston and then I'll come to you, Senator Steele-John, straight after Senator Ruston. We have a break at 11, so in the interest of sharing the time around, if we can do about a 10-minute block and then I can share the call. Thanks, Anne.
Just following, just finishing up on the prosthesis list reforms, there were concerns, quite significant concerns raised by the Catholic Hospitals Association in relation to the proposed changes to the prosthesis list. Subsequent to your process of the to the consultation in relation to the mandating of the payment of these particular items. Have you had any consultation with Catholic Health Australia and are there concerns around rural and regional and around the disproportionate potential impact of the removal of these from the prostheses list had they not been mandated to be able to be paid by the Private Hospital Association? Have you had consulted with them and are they satisfied that what you're proposing is going to deal with the issues that they raised?
So, Senator, we're meeting with all stakeholder groups on a frequent basis, and we have a lot of conversations with Catholic Healthcare Australia. They haven't raised that particular issue with me. However, I would say just last week the Independent Health and Aged Care Pricing Authority released a calculator which will enable individual hospitals to put in their data and see, whether they'll be receiving similar reimbursement between the two situations, the one where they're on the PL at the prosthesis list at the moment versus the new bundled items. And so I think that we will probably hear from all of the hospital groups once they've, done the numbers for themselves, and we'll see where that takes us.
Okay, so you're not sure whether the concerns that were raised in their press release of the 14th of September 2022 have been allayed?
I think consultations are continuing, and we're consulting with the hospital groups. We're also looking at the interests of those who have private health insurance and ensuring that costs and affordability is considered there, as well as the impact on providers of health services. So we're balancing these across a range of different stakeholder interest groups, and consultation is continuing.
Senator, can I just also add that press release in September predates the release of the bundles by the Pricing Authority. It predates the Minister's announcement that they would be mandated through a new mechanism.
That was my point. My point was that it does predate it, and what has happened, have you had consultation with these people to find out whether the concerns that they raised here have been allayed by the changes that you have outlined this morning?
Well, as I said, I would expect that we would hear about that shortly, now that they can use the calculator and factor in how it's going to impact individual hospitals.
Yep. So on the back of that, have you done any assessment around those concerns? Because one of the ones that was particularly obvious was that 70% of the procedures that were likely to be impacted were for women, and have what you've subsequently put in or proposing to put in place, are they addressing that and so on? Have you done any assessment on that, or are you just waiting on the feedback from the sector?
Well, a couple of things. I think the concerns were predicated on the fact that the items would no longer be funded, full stop, and so the situation has changed fundamentally.
I get that, and with the greatest amount of respect, I absolutely get that. What I'm trying to understand is whether what is being proposed has actually dealt with the issues that have been put forward, or do you still believe that there is potential for there to be a detrimental impact on rural and regional Australia, or a detrimental subsequent impact on women? Have you assessed whether that's the case, or do you believe that what you've done has dealt with the issue?
I believe we've dealt with the issue, but our next meeting with the key stakeholders is at the end of February, so they will have an opportunity to raise that with us in that meeting.
Okay, sure. So when the proposal to put the legislative instrument in that mandates the payment mechanism to address with this issue, is that proposed to be put in consequential with the legislation or subsequent to it?
They're proposed to occur at the same time.
So are the instruments, the legislation, as far as I'm aware, is, well, we thought we were going to see it last week, as you very kindly briefed me on it. When is this legislation then? It's in the Parliament at the moment. When are we going to see the instrument? Because you said you were still consulting on the instrument.
There's a couple of different things. The legislation in the Parliament at the moment, the removal of the general use items is not dependent on the legislation that is in the Parliament at the moment. And the mandating of the bundles is a legislative instrument which can be set up in time for the 1st of July.
Okay, so when are we likely to see the instrument that deals with the items for removal?
Well, as I said, we're consulting on the concepts at the moment, so I would anticipate probably April, May.
And when will we see the instruments in relation to the mandating of the payments?
Sorry, Senator, I thought that was what you were just asking me.
So it's the same, so you're saying it's the same instrument that says this is what's coming off and this is how we're mandating it to be paid into the future, will be the same instrument?
The items that are mandated will be listed in that instrument.
Okay.
So, yeah.
And that instrument will also mandate the requirement for how they're paid into the future?
Yes.
Okay. So when will we be seeing the cost recovery framework details for that legislation?
Right. I believe that cost recovery, the CRIS, the Cost Recovery Impact Statement, will be consulted on around May.
When does the cost recovery framework come into effect?
Theoretically 1st of July, but nobody will be charged a fee on the 1st of July for a number of reasons which I can explain. This year, the prosthesis list is transitioning from the current IT online application system to a new one. And the new cost recovery fees will be embedded in the new system, which is called the Health Products Portal.
Mm-hmm.
That will start receiving applications in September. So there will be a hiatus. We won't be able to receive applications between May and September this year while we do the transition. And when it opens for business on the 8th of September, anyone submitting an application then would be required to pay the relevant fee.
Okay, so up until that point in time, the cost recovery framework will not be activated.
Well, there is a cost recovery arrangement in place with the prostheses list at the moment.
Yes.
This is updating that to
Okay.
reflect new pathways and up-to-date costs.
But as you can understand, certainty is one of the great friends of any business, and I'm just trying to get some understanding about the certainty. So the existing cost recovery framework will remain in operation until such time as the new framework comes into place.
Correct.
When is the sector likely to understand what changes are going to be made to the cost recovery framework? Well, sorry, it's not just the framework, but their charges themselves. When will they become evident?
So, Senator, I think it's important to note that there's been a multi-phase consultation on cost recovery. The sector was provided with indicative fees, I think, like September last year in a consultation paper. The firmed up fees will be coming out in the cost recovery impact statement, as I said, in May.
And I'm assuming that you can give me an absolute guarantee that they'll be within the government's cost recovery framework guidelines?
Absolutely. That's the whole purpose of this revision of the cost recovery regime.
Senator Ruston, are you...
Yeah, sure. No, please. Senator Steele-John.
Senator Steele-John.
Thank you very much. So my first question in this slot is what percentage of MRI machines are licensed machines in Australia?
I'm not sure I'm going to give you the percentages, but I can give you numbers.
Okay.
So we have 429 MRI machines across Australia that are eligible for MBS rebates. 302 of those are in modified Monash 1 locations, so those would be the ones that are required to be licensed now, because for modified Monash 2 to 7 locations, the requirement for licensing was removed as of the 1st of November 2022. So there are 127 MRI eligible machines in those areas without licences.
127 that do not have them, the rest do.
Yes, so in metropolitan areas, we
Yep.
still require
Yep.
machines to be licensed in order to bill Medicare services.
Yep.
But there's been a removal of that licensing requirement for regional, rural and remote locations.
Okay. So, and sorry, just so that I'm clear, so how many, what was the number again for that do still require licences?
302, so 146 of those are fully MRI eligible, and 156 are partially eligible for a more limited range of services under the MBS.
Okay, thank you. In May, Minister, ahead of the election, Labor committed to invest in an extra $80 million to deliver some 20 licences. How many of these have been issued?
I can probably provide some more details.
Yes, thank you.
So I think that there was the commitment to remove the licensing requirement for rural, regional and remote areas, and then there were 3 commitments for specific MRI licences.
Yep.
One was at the Maitland Hospital. That machine is operational, so it's got its deed executed from November last year. Hawkesbury Hospital, deed executed December last year, and that's also, I think it's about to be operational in early March. And the Wyong Hospital. We're still negotiating the deed there. Advice from the hospital is the MRI will not be operational until late March, but it's very far advanced.
Okay, so of the 20 that were committed to, 3 have been delivered so far?
Well, there were 3 specific commitments. I think the commitment was for the removal of licences in modified Monash 2 to 7 locations, which has resulted in an increase in 40 MRI machines, eligible machines.
Okay. Could you remind me of the average rebate that people receive when using a licensed MRI machine?
I'm going to have to get some other officers to help me with that one.
Thank you.
I think we may be able to provide information about diagnostic imaging services, but breaking that out into particular modalities might be something we have to take on notice.
If you could, that would be really useful.
Okay, could you just repeat the question?
Yeah, so if you'd be able to tell us what the average rebate is for people when they are using an MRI machine that they receive when they utilise the machine.
All right, so for the average rebate for MRI, we will have to take on notice.
Yep. Okay, thank you. Would you be able to tell us? You mentioned the change in area that are required to be licensed. Now, I'm aware that sometimes there is a mismatch between the technical boundaries of what is considered a rural and regional location and where the community actually consider themselves to be living rural and regionally. So can you tell me a bit more about those boundary changes and if there are any rural and regional communities that are outside of those changes that still live in areas that require a licensed machine?
So for the purposes of health programs, including this policy around MRI licensing, we use the modified Monash classification system, which was based on research done by rural health experts at the Monash University some time ago. It's modified because their research developed this system of classification based on town size. But in Australia, we have some larger towns, so like Alice Springs, for instance, which are very remote and need special consideration in our classification system. So even though they have larger town sizes in some very remote locations, they're still considered remote and very remote under our classification system. But based on that classification system, all large regional centres, all small rural towns, all remote locations, all very remote locations do not have a requirement for an MRI licence.
Okay. Could you tell me, and you might have to take it on notice, what the out-of-pocket costs are for people who need to access an MRI, but that they are unable to do so? They are unable to access a licensed machine. Because what I'm trying to get from you is the cost differential between when you were able to access a licensed machine and when you were not able to access a licensed machine.
So I'm not sure we're even going to be able to get that for you on notice because, I mean, we have data about Medicare eligible services that we collect. So for non-licensed machines that are not Medicare eligible, we may have some information from industry that we could look for and come back to you on notice.
That would be good. The reason I ask is that I've heard from many members of the community who are having to travel long distances to access imaging equipment, particularly MRI, and they cannot afford these services because they are not able to access a licensed machine for which they were able to claim a rebate. and it has caused me to question the entire basis of the licensing system for MRI, given how basic a need it is to access these technologies in many healthcare-based circumstances. When was the last time the current MRI licensing system itself was reviewed?
I think that we significantly reviewed it from 1 November last year. So I think we'd probably need to look into the people that were having to travel longer long distances, because really the changes that were made from the 1st of November last year were specifically aimed at addressing access issues for people in rural and remote areas, because there weren't the same level of MRI machine licence in those locations. So having freed up those licensing requirements, we've had a big increase in the number of machines that are available.
Yes.
So I think that may have been addressing some of the issues that you raised.
Yes, it addresses, sorry to cut in, it addresses the question of geography. What is still with us, and it is good to hear that, but what is still with us is question of cost. So somebody might live very geographically close to a facility with a machine, but again, if it's not licensed and you can't claim the rebate, it's a massive cost barrier to being able to access those services.
So, I mean, we can certainly have a look to see what information we can provide about non-eligible machines. We do have bulk billing statistics for services provided on Medicare eligible machines.
Because I'm just wondering, if you reviewed it so recently, did you consider in the review process scrapping the licensing regime altogether?
So, you know, we consider a lot of different policy options within the department as we're looking at these issues, but the decisions that have been made by government and now implemented by government have removed licensing requirements for regional, rural and remote areas.
But why retain them at all?
So I think in geographic proximity to Medicare eligible machines in metropolitan areas is much less of an issue.
Okay, all right, well, we'll continue to talk about this issue in the future. Thank you. That'll do me for outcome 2.
Yeah, we will go to a break at 11, but you've got 4 minutes. 3 minutes.
This one relates to the Shepherd Centre's commitment that was made in the federal election. She's coming forward.
The other outcome, I think, I have a feeling that would be outcome 1, wouldn't it?
But no,
it is ours. It's hearing, of course.
I just realised it was outcome 2. I
forget about hearing.
I was waiting for outcome 1, then I realised
about hearing.
it was 2.
It's the only one it's a bit of an outlier. Yeah.
So the government committed $10.4 million to establish 3 new Shepherd Centres, and 2 of which are in my home state of Tasmania. So I'm just wondering if you could provide me with an update of if a location has been found for each of them, especially the 2, but all 3, including Oran Park, and when they're likely to be open.
Thanks, Senator. So the commitment of $6.5 million over 3 years from 2022 was in the budget. Oran Park in New South Wales, Launceston and Hobart in Tasmania identified. We're expecting a grant agreement to be in place by February, March this year, and we expect the centres coming online, you know, proceeding from that. So I can't give you an exact timeline of when they're going to come online, but certainly everything is proceeding.
So is the expectation that they will be a independently standalone organisation in each of those spaces, like they are in New South Wales?
That's right.
So
and that's why the funding is going to the Shepherd Centre to establish.
So I understand they are doing some outreach at the moment in Tasmania, but I was just looking forward to actually being able to see the centres opening and providing the service, because it's a wonderful service to our children. That's all I needed to know. Thank you.
Great. I'll give everyone an extra minute. So we will be suspending now and returning at 11:15 for the tea break. We'll now resume. Welcome back, everybody. Senator Pratt, over to you.
Thank you very much, Chair. I've got some questions now, please, about the true state of bulk billing.
Okay, we'll just get the Shakespeare's team back in. bulk billing, Ms Shakespeare.
So my first question is to get an explanation, please, of how the bulk billing rate has been reported historically to the public by the previous government.
So the bulk billing rate has been reported as the total number of services divided by the number that were bulk billed.
Okay, and what percentage is that?
So for the most recent quarter, which is September 2022, the non-referred attendances bulk billing rate, which is generally the one that most people are interested in rather than total Medicare, but I can also provide that, was 83.4%.
Okay, and what was it kind of during COVID when we were getting lots of vaccinations, for example?
So the bulk billing rate did go up during the last few years. So we had mandatory bulk billing requirements for telehealth services between March and 30 September 2020. So that sort of affected the bulk billing numbers in 2019-20 financial year and 2020-21 financial year. And then, as you mentioned, we also had a large range of vaccination items provided, which were also had to be bulk billed.
So what's the proportion of people during that time period that were bulk billed for a straight up GP appointment or specialist appointment, for example?
So there's different bulk billing rates for GPs compared to specialists. And it depends on whether you're talking about the service bulk billing rate or if you want us to provide information about patients that received all of their services bulk billed.
Yes, I am going to ask also that. How many people did receive all of their services bulk billed?
Okay, so I might get my colleague to go through these rates.
In general terms also, what's the bulk billing rate for seeing a GP, not online?
So Renee Lucchese, Assistant Secretary, Technology Assessment and Access Division. So Senator, if we start with your question around the proportion of patients that were fully bulk billed, and I can give that to you by financial year. And so nationally, in 21-22, which is the most recent full financial year, the proportion of patients that were fully bulk billed was 65.8. And then if we compare that to the previous year, 2020-21, it was 67.6.
Okay, and what can you tell me about the kind of services that were included in there? In particular, what proportion would have vaccinations and those face-to-face telehealth have made up versus a face-to-face GP appointment?
So I think all of those numbers related to non-referred attendances, so including all of those things, as long as they weren't referred specialist services or operations or whatever.
Yeah, that's
and I'm not sure that we can break that out by the number of all patients, or I'm not sure if you can actually break that out.
So total number of patients.
What's the bulk billing rate for, you know, a 15-minute GP appointment?
So you're talking about a level B consultation?
Yeah.
That's something we'd have to take on notice. What I've got with me today, Senator, relates to all GP non-referred attendances.
Yeah. What changes have we seen in the proportion of patients who are always bulk billed over the past 3 financial years? Based on the data you've just given me, it's gone up, not down. Can you give me that specific data? I think you just touched on 21, 22. Are you able to
I
give me
did.
the 3 financial years, please?
Yep, I can give you the 3 financial years. So I'm just, so as you said, I've given you the 2 most recent financial years.
Yeah.
So I'm going to give
Maybe
you...
perhaps just for my brain today, can you repeat each year?
Yep, I can.
And the figure, please.
Okay, so let's start with 21-22, and the figure was 65.8. 2020-21, the figure 67.6, and for 2019-20, 67.1.
67.1. So, what impact would have the COVID measures that were introduced and rolled out, including vaccination, have had on the proportion of patients who are always bulk billed?
So I think, I mean, at that macro level, it's not jumped around a lot. But I mean, there was a significant change in the makeup of services provided to patients under Medicare during the pandemic, because we had lockdowns and people unable to access services in the normal way. So I think it is actually a bit difficult for us to use what's happened in the last couple of years to make assessments of you know, what normal practice and normal bulk billing looks like at the moment. So, you know, there certainly would have been an impact driving up bulk billing rates with those COVID vaccination items, because some patients may have only been to see their doctor for a COVID vaccine. They may not have had any other services, so they'll now be counted as a patient that's had all of their Medicare services bulk billed.
So it looked like bulk billing rates were going up to that kind of 83% rate. People would assume when we talk about bulk billing that we're talking about going to see the GP. To be honest, I had not even really reflected on the fact that, you know, my vaccinations, when I had them at the GP, were included as a bulk billing item. I would have had no idea that, you know, it's great that they were paid for. They needed to be paid for. They needed to be mandated so that people would go and get them. But from the point of view of doing a public policy analysis about whether people find it affordable to go to their doctor, the previous way of it being reported is somewhat, well, it doesn't tell you anything about how much it costs to see a GP, which is how we would normally interpret that kind of data as a layperson, I guess. So the Minister's spoken about his desire for a new methodology to be publicly reported. Can I ask what's going on in that space and why transparency is important? I guess I've just given you my little analysis of it, but I'd like to, you know, hear from the officials about what that really means.
What that means is that there'll be additional statistics reported. So the bulk billing rate calculated on a service basis, which has been reported regularly for a long time, will continue. But there'll be additional context also reported. So some of those figures around the number of patients that always have their services bulk billed, or non-referred attendances, GP-like attendances bulk billed, will be published. And also further breakdowns. So the headline national statistic, I think we've published on occasion, usually on request from the Senate, information by electorate or information by state and territory, but we'll be regularly publishing.
Would you like me to run through what we've published?
Yeah, so can I ask in that context why that you've said you've always collected it, why has that information not previously been published?
So the headline bulk billing rate has been the figure that's always been published and focused on.
The headline But it was a somewhat misleading headline figure if people expect that it is a reflection of how much it costs to go and see a doctor. So this will get us a better reflection of what it costs to see a certain type of specialist or your GP.
Well, we've also published the total Medicare bulk billing rates, and we've published specialist bulk billing rates. You know, so it is just providing additional data.
Yeah.
And I think if I can just get my colleague to run through the complete list of additional data that will be published from the 20th of February.
Thank you. So the additional data that will be published from the 20th of this month. So as Ms Shakespeare reflected, we're going to be reporting patient bulk billing figures, so that will help people to understand the proportion of patients who are always, usually, sometimes and never bulk billed. So you'll have those 4 categories, and that will be provided by Primary Health Network.
Yeah, great.
We're also going to provide some additional information at the PHN level. So we'll also include the standard bulk billing rate and do that for each broad type of service. So we've been talking about GP non-referred attendances, but there'll also be information about, for example, specialist services. And then the final thing I'll mention is there'll also be some information provided by age groups. So 0 to 15, 16 to 64 and 65 plus. So that's a sense of the additional data that will be made available.
Great. So we won't get a misleading headline figure of what the bulk billing rate looks like, because there'll be more emphasis on the always bulk billed and the different components of the broader services that have a rebate but might have a gap fee attached to it. You'll be able to see those in the data more readily as part of the headline figure.
So we'll be expanding the range of data regularly reported by the department. So it does provide greater context.
So it does mean that if we were to do this, have done this previously, it would have been much easier to unpack the fact that bulk billing rates to see a GP were not in fact going up. They were in fact going down because they were masked by all of those COVID measures. Is that correct?
Well, I think, as I said, it's very hard to work out what, you know, would have been bulk billed if normal service provision had continued during the COVID pandemic.
Yeah,
we had a significant change in service delivery modality.
That's right.
We had different policy approaches as to whether those services had to be bulk billed or not over time. So, you know, it's not possible, I think, for us to reach a conclusion like that. I mean, we're happy to continue doing analysis, and but we'd need to look at all of the mandatory bulk billing items and what proportion of services they make up.
Yeah. And I guess what you're outlining as the new approach for transparency will enable us to see what happens to the data once, for example, those mandated vaccinations, for example, are excluded from the data. Thank you, Chair.
Thank you, Senator Pratt. Senator Pocock.
Thank you, Chair. Thank you for your time here today. I was just keen to get an update on the progress towards tabling a new legislative instrument for the opiate dependence treatment program.
Hi, Senator.
Mr.
David
Laffan.
Laffan, Assistant Secretary, Technology Assessment and Access Division. Senator, the amendments to the National Health Act, that require the instrument to be registered in July. So at this point in time, the post-market review is still underway. The reference group, we are working with the reference group to make suggestions, who are making suggestions rather for the finalisation of that report, which will go to the PBAC in March. And then as part of that process, there's also some consultation and some work going on with the working group with states and territories to ensure we're in a position to bring forward that legislative instrument in July.
Okay. And the post-market review was announced on the 24th of March 2021, so that's a year and 10 months. How far away from completion is it? That's a fair length of time.
So it has been a very complex review, and that's not unusual for these post-market reviews to take that length of time. Some of them will take 2 to 3 years. So the report that's been working on at the moment, which we're engaged with the reference group, acknowledges the complexities that are part of the opioid dependence work, so that particularly some of the public consultation which has gone to talking to people who are actually a part of the opioid dependence treatment program and what their experiences have been. It's been really quite clear from that consultation that the issues with opioid dependence treatment are broader than just issues that relate to the PBS, and so that's why we're engaged in conversations with the jurisdictions at this time.
Great. And do you see it being on track for 30th of June, having something ready?
Some of that, may depend on the conversations with jurisdictions, but we should be in a position to put forward an instrument for the 1st of July.
Okay. And can you confirm the dates for any meetings the Commonwealth has had with states and territories to discuss this?
I can tell you the most recent, I'm not sure if I have the date specifically, but the most recent meeting with the jurisdictions was in December last year.
Okay. And are there more planned for 2023?
There will be more meetings in 2023, yes, but nothing specifically in people's diaries at the moment.
Okay.
Sorry, Senator, 16th of December. Sorry, the 14th of December was the first meeting of the working group with jurisdictions.
Okay. But none others in the diary?
Not in the diary at the moment, but absolutely planned to happen.
Okay. And given coronial inquiries have found that cost is sort of the big factor, would the proposed updated regulation deal with that, to remove that barrier for people to get off opioids?
So we said that was a very strong theme that has come through as part of the post-market review, that the cost to consumers does represent a significant barrier, and we've heard that that loud and clear. I think it's too early to preempt what will actually be in that legislative instrument that goes forward. We still have the outcome, or we still have the report of the post-market review to be tabled, with the PBAC and for their consideration of that.
Okay. But you're confident, even though the post-market review hasn't happened, and you're saying this is very complex, in 4 months we'll be good to go with a very good update that's going to remove these barriers?
Well, we'll be ready with an instrument for 1 July.
An instrument that addresses these problems, or just an instrument?
Well, Senator, again, it's a complex matter. There are a number of different ways of addressing the cost pressures within this, so it doesn't necessarily have to take place as part of that legislative instrument. The legislative instrument will deal with matters as they relate under the National Health Act to the PBS. That doesn't necessarily provide a specific pathway for the out-of-pocket costs that you're talking about. That might be achieved through some other mechanism.
So that's one of the issues that we're discussing with the states and territories through this working group we've set up. So PBS has a pathway, for funding the medications at the moment. We need to look at whether or not the cost barriers and issues will be addressed. by making changes to the PBS, or if there needs to be public programs for people that couldn't afford, for instance, PBS co-payments. So affordability is at the centre of the discussions that we're having to make sure that all people who need to access opioid dependency treatment can get access to it.
Okay. Thank you. I'd urge you to push on this. We've known about this for years. It's been almost 2 years for the post-market review, and at the moment it's 3 people die a day unnecessarily. So I think this is something to really put some effort into, and I look forward to sort of being kept up to date with how that goes. Thank you.
Senator Pocock, are you finished for outcome 2? Great. Senator Ruston.
Thank you. Thank you for the 4 questions that were uploaded since I last spoke to you about questions on notice. But still remains in my area of 14 that are outstanding. So I've got a list of the 14 here. I'm happy to table them, but if you'd like me to leave till the end of the day and see how far we get with them, and then see how many are left in your department and how many are left on the Minister's office desk, and then we can prosecute it from there. But thank you for the 4. Can I just take you to an election commitment program in relation to the Centre for Community Driven Research, the Telehealth Nurse Program? Hi, Mr Cottrell. There was an amount committed in the election campaign for $2.47 million to the Centre for Community Driven Research Telehealth Nurse Program. And then in the budget, in 22-23 budget, the commitment was upheld with a $3 million over 3 years commitment. At a forum on the 1st of March 2022, I'll just quote the current Minister for Health, Labor has decided, I'm pleased to announce, that if we're elected at the election that takes place probably in May this year, then we will adopt the case that's argued in the pre-budget submission and ensure that Patient Pathways is funded for another 3 years in the manner and to the amount that is set out in the pre-budget submission, which is, I understand, a little less than 2.5 million, which is where the 2.47 million comes from. Has that happened?
Senator, the government confirmed its election commitments in the budget process, so there was a gap in time between the 30 June ending of the pilot program and the October budget. We offered the Centre for Community Driven Research funding to extend its program for 6 months. It was $150,000 because
$150,000.
Yes.
What was their so their annual budget ask was about 800. It was operating at 800,000, and you offered them $150,000 for what period of time?
For 6 months.
6 months.
For 6 months, while we confirmed the funding, the full funding in the budget.
So what was your expectation that had happened to the people that were working on this project when that sort of period would have normally attracted a funding of around $400,000 and you provided them with $150,000? Was that a decision of the department or a decision of the minister that they would only get $150,000 over a 6-month period?
That was the amount of money that was available to support this program from
I'm not sure I actually
relevant...
asked that question. Thank you. The commitment by the minister was that the amount that is set out in the pre-budget submission, another 3 years in the manner and to the amount. So in the manner and to the amount, so which adds up to about $800,000 a year, a decision was made in that interim period that you would provide $150,000 over 6 months. I'm just understanding how that decision was made.
So, Senator, as I said, the government decided it was confirming its election commitments in the October budget.
Mm-hmm.
There was There was an iterative conversation between the department and the minister about what to do in the interim. The department had $150,000 available to support an extension of the program while the commitment was confirmed in the budget. That was offered to the Centre for Community Driven Research. They decided to withdraw from the program in July.
Did they give you a reason for that?
They made the communication to the minister, Senator.
Minister, would you possibly take on notice to see if you could secure the communication that went to the minister as to why they felt the need not to accept the reduced funding?
Yes, I can take that question on notice.
Thank you, Minister. So obviously they have received no funding from you since that time?
That's correct.
Yeah, okay. So was there any discussion between the department or, to your knowledge, the minister, that the reason that the decision was to do this was because they were fearful that they were going to have to cut their patient care? So instead of, cutting patients, and they decided that it was preferable to their patients not to continue in any way, shape or form, or to continue with the uncertainty that was obviously created with a broken promise of the funding to going on in the manner that it was promised, to the amount that it was promised, and then having that reduced amount. Were there any discussions around that at the time that you're aware of, Mr Cottrell?
So there were discussions with the organisation about whether $150,000 was sufficient to extend for the 6 months. There were discussions in parallel with the organisation about its acquittal of the previous pilot grant. Those things happened rapidly and in parallel, and the organisation decided to withdraw from the process.
Okay. So in the commitment, the budget commitment that obviously has been subsequently reaffirmed in the budget, was there any mention at the time that there would be a review or waiting for the budget process?
So that the evaluation that was undertaken of the pilot program was initiated well before the end of the program, so it was not related.
Okay. So the minister made the decision that he was going to continue the program for 3 years in the manner set out in the pre-budget submission of $2.47 million over the 3 years. The review had no bearing on it whatsoever. So I suppose, what is your understanding in relation to the CCDR at the moment in relation to the delivery of that commitment?
The commitment will be delivered. There's a grant opportunity that's been forecast.
Sorry, take a step back. This was promised to Patient Pathways, and now you're saying it's not promised to Patient Pathways.
Well, Patient Pathways withdrew from the program. We had a conversation with the minister. He
They
asked
said they
us
didn't want to go on with the program. Not that they were unable to continue for the time being because of the lack of funding. They said they never wanted to have anything to do with it again.
They didn't want to be the recipient of the funding that was announced in the budget for the election commitment, but that, we were seeking to confirm in the budget. So they didn't want to be the recipient of the funding. The minister asked us for advice about how best to deliver the program in the absence of CCDR being the funding recipient. We had discussions with the participating organisations about how that could happen.
Okay, can I just take a step back? Can you provide me with some evidence to suggest that that they chose, or that where they have indicated to you or to the minister that they did not wish to take the full grant when it became available through the budget process, as opposed to merely saying they didn't want the 150 in the time through that time frame? Have you got that in writing?
Yes, we do. So we can take that on notice. It's part of the question that the minister's taken on notice.
Okay, well, if we could get that back as soon as possible, because I can assure you that is not my understanding. So has the grant process opened that you're referring to for the program?
it's been forecast. The guidelines are with the Department of Finance for approval.
So if I said to you that those guidelines were publicly available in January, what would you say?
That's part of the forecast process. So when the grant's forecast, because there's a lot of process involved in these grant opportunities, when it's forecast, draft guidelines are put in the public domain. The final guidelines are subject to approval
So
from the
they're all
department.
publicly available to everybody, not just to some?
That's my understanding. If you've registered on Grant Connect, you can get access to draft guidelines.
Okay, all right. So I'm just trying to understand then, so it was nobody was sent them particularly, it was just you had to go onto the website, the Grant Guidelines website, and if you were particularly looking for that grant program, you'd go in there and find it as you would normally do on a grant program. Was there any communication from the department to any of the potential applicants that might have considered, who would be eligible for a program of this nature? Were any of them contacted by the department proactively, or was it just an access through the?
I'll have to check that on notice.
Senator, can I also just say we have had a number of discussions with the various organisations because you'll appreciate this particular service is for complex and rare diseases. So we've had consultations with the 14 patient organisations, peak bodies, around how to best craft this particular commitment and how to best craft this opportunity, given that CCDR chose not to continue with delivering that program. Okay, well, so we've had consultations with those patient organisations.
Okay. So were all organisations that would be potentially eligible to be able to apply for this contacted by you, or only some?
So we would not normally contact organisations in terms of grant opportunities. We would consult with them in the development of those grants, and then we would, the forecast is to signal to the market that this opportunity will be coming through as soon as those grant guidelines are finalised.
Okay. Well, I'd be really keen if you could get as soon as possible an understanding as to whether, where your evidence around CCDR having sought not to continue with this, because that is certainly not my advice, and also to get some sort of understanding if there was any direct and in contact between your agency and potential recipients of the grant, because there seems to be a very clear understanding out there in the marketplace that Rare Voices Australia is going to be the grant recipient, which concerns me as if the process hasn't been under control. So I don't say that with any accusation, but that is certainly what is being speculated more widely, that the grant has already been determined, and that would be a very unfortunate situation.
So that's certainly not the case. We can give you a list of the organisations that we talk to about the future of the program and how we might approach it, but there's certainly no decision being taken.
But first and foremost, that evidence in relation to CCDR. Can I then move on to another commitment that related to a question on notice that you took last year. For your reference, it's the PDR number is SQ22 000476. And it's in relation to the funding of the implementation of the Regional Cancer Treatment Centres for Radiation Therapy Program in Victoria and South Australia.
Yeah, I think it's outcome one.
It's outcome one.
That's outcome one?
Yeah,
yep.
so,
okay.
Yeah.
All right, well, you can look forward to that at outcome one. So I've given you a heads up, so no excuses for not having the information, and I look forward to hearing back from you as soon as possible, Mr Cottrell. Thank you.
Are you finished for outcome two, Senator Ruston?
I think so. But I get so confused about
I just did
where
want to give
everything
Senator
goes.
Waters a chance to clarify where her questions are placed before we let outcome two go.
Thank you. I've got some questions that I'll also direct to the TGA about advertising for medical abortions and the rules that...
One would be, so after the next outcome.
Okay, great. So as long as we're not sending people home that can...
The TGA are ready and willing.
Okay, plus the departmental folk that go along with them?
Sorry?
Plus the departmental folk that go along with
Yes.
them? Yeah,
yeah,
great.
yeah.
Thank you. Thanks, Chair.
Okay. Well, we're running slightly ahead of schedule. So we will be moving now to outcome one. My intention, Senators, is to call APRA first up in outcome one.
Right. I'm not sure whether Mr Fletcher's arrived yet. I asked him to come earlier because he...
I might just... do you want to just check if they're there? I've made an indication to a number of senators the order of calling. So
Mr Fletcher was planning to come, but I asked him to come earlier if he could, so we'll just see if he's here. I advised him to be no later than 12:15 because that was the start.
No, I appreciate that. We might just take a brief suspension while we see if those officials are here, and then we can...
Yeah.
So the committee will just suspend... Do you have the names of the... All right, I would now like to welcome officials from APRA. Thank you for your consideration of the committee's request to join us today. Did you have anything you wanted to start with, or are you happy for us to kick into questions?
Thank you very much, Senator. What we thought may be helpful to provide to the committee, and I can table this, is we've done a diagrammatic representation of the way that professional regulation works in Australia, because there are a lot of moving parts, and we just thought it might be helpful for the committee to have the benefit of what we hope is a clear explanation of the roles and responsibilities of the different entities involved.
Thank you. Well, we might get that distributed, and we'll make a consideration about tabling if you could just get some copies of that.
Thank you.
Now, I understand, Senator Waters, you have some questions for APRA, so if you want to kick us off, and then I'll come to opposition.
Thank you. Hi, folks, and thanks, Mr Fletcher, for joining us today. APRA announced earlier this week a plan to review the way that you deal with the criminal history of health practitioners and how to expand support services for victims of sexual misconduct within the healthcare system. The Four Corners and Age investigation identified a number of doctors who've been allowed to return to practice after losing their registration for serious wrongdoing, including convictions for rape and having sex with minors. Will the review that you've announced this week investigate how that was able to happen?
Thank you, Senator. So just a couple of things to sort of unpack there in terms of the question. So we have a criminal history standard which has been approved by all health ministers, which we apply when somebody is applying for registration for the first time, because we check criminal history. And there are also obligations on health practitioners to disclose to us both at annual renewal and also when they are charged or convicted of an offence that could lead to imprisonment. They're obliged to tell us that, and so that would be another circumstance in which we would apply the criminal history standard, either to those declarations at renewal or that declaration when a charge or conviction has occurred. What we've said in what we've announced is that we would like to review that criminal history standard. So it sets out a set of principles that are considered by the relevant national board when looking at an application for registration or considering a declaration or a disclosure that's made by a practitioner. That will involve public consultation, and we've also said that we want to look particularly at its application to this question of practitioners where there is a concern about sexual misconduct. And what we will do, subject to that consultation, is then provide advice to ministers, to all of the Australian health ministers, about whether there is any amendment to that standard that may require them to consider and then ultimately to approve that change. In terms of support for victims, what we've done over the past 2 years is that we've run a pilot social work-led service focused on victim survivors who have made allegations about sexual misconduct on the part of health practitioners, and particularly those that are going through to tribunal, which is the most serious outcome open to us in terms of these sort of concerns. We absolutely recognise how re-traumatising it can be for those people to go through that process. So this service basically aims to provide navigation support, if you like, for people, similar to like a court support service, if you like, to help people through that process. We've also started to look at things like making available victim impact statements to tribunals when they are looking at what the appropriate sanction might be in relation to these practitioners. And what we've announced is our intention, our view is that the pilot has been successful. We intend to maintain that program and in fact extend it because some of the feedback that we've had from the evaluation is the importance of trying to link people into that service as early as possible when they first raise the concern.
Yes. Thank you. That's really helpful. Just staying with that victim support service, how big was the pilot? Did you find that there was, how much demand were you not able to service? Because definitely agree that survivors need that support and agree that that needs to happen as early as possible. But can you let me know, were there survivors that were not able to access that pilot? And is your intention to make sure that everyone going through that process is able to access that support? And do you need more resources to do so if that's the case?
So our goal is to increase the resourcing of that program and, as I say, to be able to offer it earlier in the process.
To everyone?
To everyone.
Yep.
And to everyone who raises an allegation in relation to sexual misconduct. What we've found is people have a lot of, we've got to be respectful of people's preference around what they want. So some people, the offer's made and they say, not now, but I might need it later.
Sure.
Some people do want it. So, obviously we need to be very respectful of the individual, what the individual wants. What we've probably found, Senator, is that initially we found the focus, we saw the focus as being very much on the victim survivors. In fact, what we've found is that we've needed to also extend that support to the witnesses as well. And so that's been where we've broadened out the focus. And as I say, why we think we need to put additional resources in. We're very grateful that the Psychology Board of Australia has been providing support for this program through their funding.
Okay, so sorry, just to elaborate on the funding, are you receiving any federal funding for that pilot and for your plans to extend it out and make it a permanent program? Who funds it?
So the scheme is funded by the registration fees that health practitioners pay. So we're not receiving government funding for that program.
Okay, and is that appropriate in your view? Are you comfortable with that as the funding source?
So the scheme has been set up as a self-funded scheme. So essentially each of the 16 health professions pay their own way in terms of how much it costs to regulate that profession within the national scheme. And to the extent that we may need more resources, what we have to look to is increases in those fees.
Yes, okay. All right, thank you. You mentioned that there would be public consultation on the review of the existing criminal history standards. Firstly, what's the time frame for that review and when are you hoping to then provide advice to the relevant ministers about potentially strengthening those standards?
So our expectation is to commence that review within the next few weeks. So, and basically our normal approach to doing a review like this would be, first of all, to make it available to targeted stakeholders, jurisdictions and key people, just to make sure that we haven't missed anything in terms of what we're proposing. And then we would go to full public consultation, and we would normally allow probably at least 4 weeks, maybe a little bit longer, depending on what the interest is. We're doing things now with our consultations, such as running webinars, to try and make sure that people are aware, obviously getting it out through things like our social media platforms. And we have a community advisory council, so we'll also work very closely with our council to make sure that we get it out through the networks of community groups and the like, because we want to make sure there is a strong community voice coming into the consultation. And then what we'll need to do is obviously consider the outcomes of that consultation feedback, and it's probably a little bit hard to say how long that will take. It probably depends on how much feedback we'll get, but I suspect we'll get a lot on this one. And then what we would do is put advice initially through the Health Chief Executives Forum, so the CEOs of the jurisdictional and Commonwealth Health Department on advice that would then ultimately go to the Health Ministers' meeting. So we're probably talking about a process to give it, to really make sure people know about it and have input of several months, but it's our intention to kick that off within the next few weeks.
Okay, will you be specifically ensuring that survivors are invited to be involved in that consultation?
Yes, so what we often do with consultations is really try to look at, who are the particular groups and individuals who may want to have a say on these sort of things, and certainly look to create opportunities for that to happen.
Okay. Now, you've talked about how that review will be of the existing criminal history standards. Is there anything else that will be covered in that review?
Well, that review will look at the criminal history
Just the
standard.
standards.
I've talked about our support service. More widely, we have said to health ministers that we would be very keen to have a discussion with ministers about some wider options for reform that we think would support the work we've done. We've done a lot of work in this area over the past 5 years. So it's not like nothing's been happening. There's a strong foundation on which to build. But for example, one of the areas that we know is of great interest to the community is whether there should be more information published on the National Register about, if you like, proven sexual misconduct findings.
Yes.
We do publish links to tribunal outcomes at the moment. They're on the register unless the tribunal suppresses that in some way. And the other area that there's certainly been some discussion about is the question of whether the public should know more about the reasons why restrictions are placed on a practitioner. So if you go on the register,
Yes.
you can see a restriction. It might say that they're restricted to a certain location or a certain, they have to work under supervision, or they can only see certain groups of patients. And I think the debate will be around should there be more about the reasons for those decisions. So we're very keen, and I have an opportunity to meet with health ministers when they meet next week to really just set out what we think some of those options are around some greater transparency in this area.
Okay, well, that sounds positive. I think patients have the right to know. So it's great that you're doing the review, but can I confirm, clarify rather, that the existing criminal history standards actually permit practitioners who have lost their registration for serious wrongdoing to be subsequently re-registered and then able to provide healthcare again?
So the existing criminal history standard is principle-based, so it doesn't say that there are certain offences that mean you can never practice again, and there's no algorithm, so each case is considered by the national board, so it's actually a decision of the board on a case-by-case basis. I would also make the point that often tribunals will make a decision that will allow someone to come back into registration. And looking at some of the recent cases of concern, I looked at 10 cases. Of those 10 cases, 7 of those cases were a decision by a tribunal, so the independent tribunals that exist in each state and territory, to actually allow a person to come back into registration.
And do they use those same principles that you referred to, or have they got just carte blanche to decide what they like?
Different tribunals work in different ways, essentially, but they are subject to the national law in how they, in how they consider the issues. But we certainly think. I mean, one of the other areas that we think is an area for ministers to consider, and this would require an amendment to the national law, is to probably have a greater role for tribunals around some of these reinstatement decisions, because unless the tribunal suppresses it or anonymises it, it actually then means that the decision is in the public domain. Because I think one of the commentaries out of, for example, the Four Corners program was that it's often hard to know what the reasoning was behind the decision. Well, that issue is addressed if it's a tribunal decision, because tribunal decisions are in the public domain, as I say, unless they make a decision to suppress or anonymise a decision.
Okay, thank you. So is it consistent with current AHPRA policy that doctors who've been subject to serious disciplinary action regarding sexual misconduct are able to return to work? And what is the threshold for when a doctor can return to practice?
So the threshold is the criminal history standard, which is applied on a case-by-case basis. I'd be happy to share a copy of that standard so that you could see that, the committee could see that.
Yes, please, thank you. If you could table
and
that,
as I say, it's a principle-based approach on a case-by-case basis. Often what boards will do, and indeed tribunals, will say, OK, if we let you come back into practice, there will be restrictions on your practice. So again, when I looked at some of those ones where there's been some recent coverage, most of those had conditions on their practice around additional supervision or restrictions on the sort of patients that they could see. And where we place those restrictions, or where a board places those restrictions on a practitioner or a tribunal, we then monitor that to ensure compliance and actually require reporting. We look at things like Medicare data, for example, logbooks that are kept and the like in the practice, to make sure there's compliance with those restrictions. And of course, if there isn't, that is then a grounds for taking further regulatory action.
Yes. Is there any misconduct which is a barrier to re-registration? Is there anything that you just consider should disbar someone from future
Well, I think
medical
that's
practice?
the debate that we need to have in the context
So there
of this
isn't at the moment,
At the
but-
moment, the standard is principle-based.
Mm.
These are all the considerations. So we would look at things like the seriousness of the conduct, the length of time since it occurred, what the practitioner's done. There's a whole range of factors that take into consideration. But at the moment, the standard does not specify certain offences that are sort of, one
barrier
strike and
to
you're out. But
re-registration.
I think that's what we want to hear in this consultation. I probably should add, Senator, there are examples of where tribunals, so again, as I say, independent tribunal in each state and territory, have made cancellation decisions that are tantamount to you'll never be able to practice again. There was a recent one in Western Australia where the cancellation was 25 years, for example.
Yes, okay.
So you do see those sort of examples, but not, as I say, the standard is principle-based. And as I say, we think this will be some of the feedback and debate that we'll need to have in the consultation, and ultimately that will need to go to health ministers, because I think there's a public interest judgment that will need to be made here about where that balance lies.
And do you have a view as at the present time whether there should be a permanent cancellation?
Well, our view is around a couple of things. We think there should we think there should be greater transparency around this. We think that there is we would support a greater role for tribunals, as I said, in any decision for a practitioner to come back into registration. And we think that we need and want to do more to support, the victim survivors of these, because obviously it's deeply concerning. I think we reflect in our annual report. We talk about the notion of boundary violations, so it does cover a wide range of things, but we're certainly seeing an increase, which we think
in boundary violations?
In boundary violations being reported to us, yes. We'd had just over 900 reported to us last year. The other area, Senator, that we're quite keen to do more work in is to get closer collaboration with police as well. So for example, in Queensland, we've got a role embedded in QPS along with the Ombudsman there that actually gives us real-time data feeds on any health practitioner who is charged with a criminal offence, and we'd really like to look at that sort of model rolling out more widely as well. So one of the things I'll also be saying to health ministers is we'd be very keen to get the support of ministers in helping us look at how we can strengthen that collaboration with police around the country.
Yes, that sounds sensible. Of the 900 boundary violations, I just don't know what a boundary violation means. I obviously understand the common meaning of the term, but would that include serious misconduct?
So I'll give you the range. So a boundary violation could, for example, be a health practitioner inappropriately texting a patient or making some sort of inappropriate sort of sexualised comment in the context of a consultation. It could be a sexual relationship with a patient in the guise of a consensual relationship. It could be an allegation of inappropriate touching in the context of an intimate examination, and that indeed may potentially be criminal conduct. It could be sexual assault.
Yes, okay, so it's the full gamut.
But it could also be, and we certainly see this, the behaviour of the practitioner outside their clinical practice. So. Child exploitation, possession of child exploitation material, for example.
Was 900 an increase on previous years?
900 is an increase, yes, that's correct.
Could you, on notice, or if you've got the figures to hand, just let me know what the numbers of boundary violations have been in, say, the last 10 years? And are you seeing a trend? Is it a trend upwards, or was there just a spike?
No, it's a trend upwards. I'll look to see whether we can go back 10 years, but I'll certainly see how far we can go back in giving you a trend in relation to boundary violations.
Why do you think it's trending upwards?
Look, I think we've seen much, I think a welcome light shone on this area much more widely in society, and people being more willing to speak up.
Okay.
So, what we're also seeing at times is historical allegations, so people speaking up. Certainly whenever we get media coverage of this, so we've certainly had additional reports in the wake of the Four Corners report, for example, and we always provide an identified person which we give to the program so that people can follow up if they've got a concern. So, I think that wider whole movement, I think, has rightly shone a light on this area.
Yes, so it's not so much that the incidences have increased, but that the reporting of them has.
That would be our view. And,
yes.
I think, having said that, though, I think our view is there's probably still under-reporting going on as well. So
of course.
I think we've got to work on that area.
Yes.
And make it as safe as possible for people
yes.
to come
Well, what
forward.
work... And
I do need to share the call around shortly.
Okay, thank you. Well, could you please take on notice to let me know what work you will do around underreporting? Because as
Certainly.
for all sexual assaults and harassments, that is always the issue, and women always feel like we'll get the blame, and that it just is better to say nothing, which is not the sort of message that should be being sent. So I'd love to know how you're proposing to tackle that in the medical arena. And I do have a few other questions, so Chair, I might cede the call, and if you can come back to me.
Yeah,
thank you.
Absolutely. Just to give the committee an indication of the order, I'm going to go to Senator Ruston next, and Senator Tyrrell, Senator Roberts, Senator Rennick, and then I'm happy to come back to you, Senator Waters, and then back to you again. There is a number. You've got questions as well? I will add you on the list. There's a number of senators to get through, so I just would encourage efficiency and brevity. Senator Ruston.
Mr Fletcher. On the 14th of November, AMC started a public consultation process in relation to surgeries and particularly in relation to medical practitioners that undertake cosmetic surgeries. And in that, there was a proposal for, I think they were for registration standards. So I'm just keen to understand, in your terms, does are registration standards an endorsement or an additional marker on the registrant's application or registration to indicate that they've got additional skills in a particular area of practice? I mean, how does a registration standard or an endorsement actually work?
Thank you, Senator. And perhaps it might be helpful if I just explain the process, and then hopefully that will address the question you're asking there. I think the first point to say is I do want to say again that we absolutely share the concerns that I know many senators have had about the cosmetic surgery industry. We've seen that rapid growth. We've got this mix of a lot of money at stake and patient vulnerability, and of course we've got this very huge role for social media, often highlighting benefits and downplaying risks. So I think there's no doubt that all of us have had to step up to address that from a regulatory point of view, both from the professional side and the facilities licensing side. And everyone, our only goal is to ensure that patients who choose cosmetic surgery are safe in making that choice. So in terms of the endorsement process, so that the independent review that we commissioned that reported in September last year made a recommendation that we should develop an endorsement for cosmetic surgery. And that recommendation was part of the package that we said to ministers that we would do to all health ministers, and that was supported by health ministers. So essentially an endorsement is, if you like, a regulatory tool that would end up on the public register for those practitioners who had met the requirements for that endorsement. And essentially what the endorsement does will set a training standard for cosmetic surgery, because that doesn't currently exist, and the review called that out. There are no current training standards for people doing cosmetic surgery. And because it's on the register, patients will be able to see who meets that standard. And I think it's really important to say we want and expect that to be a high standard. So basically, as you say, endorsement is in addition to being a fully qualified medical practitioner, and the process essentially is the same process that the Australian Medical Council use for accrediting specialist training by all specialist medical colleges. So the Australian Medical Council, the independent accrediting authority, are leading a process to actually develop and currently, as you say, consult on what that standard might be and the sort of outcomes that you'd expect of anybody undertaking a qualification that met that standard. Their recommendation will then need to go to the Medical Board of Australia, who will ultimately need to accept the recommendation of the AMC about that standard. And then that whole package of the endorsement needs to go to the Health Ministers meeting because it has to be accompanied by a registration standard to make it all possible, which ministers will have to approve. So, AHPRA isn't making the decision about what that standard is, although AHPRA and the Medical Board of Australia will have a role in administering and enforcing that standard once it's in place.
Yep. So I'm just keen to understand, I suppose in terms of the definition, you've got a registration standard, which is what's the public consultation proposal came out with. So the endorsement of cosmetic surgery for registered medical practitioners, so there's a registration standard, and then in your sort of nomenclature or terms, we're talking about an endorsement, and then we're talking about that endorsement or that registration standard would show that the person had additional skills in a discrete area of practice. So I'm just trying to understand where each of those, I mean, is there a formalised determination about what is a, what is required from an endorsement? I mean, are you saying that there has to be training standards? Where do those training standards sit? Because, I mean, training standards sit within the colleges when it comes to other surgical procedures. So where would the training standards for cosmetic procedures sit under the mechanism that you're describing?
So, Senator, again, sorry if I haven't been clear on the process, and there are a few moving parts. So, the full name of the endorsement is an area of practice endorsement. So,
okay, so we've got an area of practice endorsement. Yep.
Which is in addition to the basic registration standards that all medical practitioners have to meet.
So you've got an MBBS.
Yep.
And then you have areas of practice endorsement.
Well, you have registration standards you have to meet to be registered. You have to have a qualification.
Yep. So you're registered.
You then have to meet our registration standards.
Yep.
And then what we're talking about is an area of practice endorsement that would be in addition to your registration. Excuse me. And essentially what that sets out is, well, what that would say in the public register is you have the endorsement, but in order to get the endorsement, you would have to have met the requirements for the training and qualification that are set in the standards, the accreditation standards set by the Australian Medical Council.
So who's delivering those?
The AMC develops those standards. It recommends to the Medical Board of Australia what those standards should be. The Medical Board of Australia says yes or no, depending. They essentially approve those standards. And then, as well as the endorsement, there has to be a registration standard to enliven the endorsement.
But what are those standards? I mean,
and sorry, just to finish, that registration standard with the package then goes to Health Ministers for approval.
Okay. So just to be really clear, we've got a person here who's registered and they meet the base standard.
Yes.
And you're now saying that for an endorsement they will be required to have an additional scope of experience, training, standards that meet within this endorsement. Where are they delivered from? Who is delivering those additional? I mean, if you were talking about somebody who was being a plastic surgeon or an orthopaedic surgeon or a gastroenterologist, there is quite clearly a process within their colleges about how they achieve those additional standards that mean that they have the stamp of approval from their college via the process that you've described to say you are a plastic surgeon. I'm trying to again understand under what you're proposing here, why you're going through this different process around endorsement that's different to why you would not seek to do that. I mean, what are you trying to make cosmetic surgeons through this process?
Well, I think it's important to restate what we're doing is what the review recommended and what ministers have supported us doing. So we haven't made it up. It came from somewhere.
No, I'm not saying you made it up. I'm just trying to work out like, how it actually physically is delivered.
But once the let's assume the standards developed by the AMC have been approved. So what that would then mean is that an existing college could say, okay, we've got a training program that already meets these standards, and so the AMC would say, okay, to the medical board, anybody who's done this meets the standard for an endorsement. The other colleges could say, we're going to develop some sort of training product or qualification that we think will meet the standard, and if that was something, then the AMC would review that to ensure that it meets the required standards and ultimately make a recommendation to the medical board. And what the medical board has is a set of what are called approved programs of study, which would essentially say, okay, if you have a qualification from this approved program of study, because it meets the accreditation standards set by the AMC, that would make you eligible for an endorsement if you chose to apply for one.
Okay. We'll leave that there for a minute. We might come back to it. So going back to the public consultation process, submissions are closed in mid-December?
For this?
Yes.
For the endorsement? Yesterday.
Yep.
Yesterday.
Oh, yesterday?
Yes.
Okay. So in terms of the actual area of practice endorsement, they closed yesterday?
Yes.
Oh, okay. No worries. Have you had an opportunity to even look at any of them? I mean, obviously they didn't all come in yesterday.
Well, they're going to the Australian Medical Council, not to us.
Okay, so you have no idea
So-
whether what's being proposed has been supported?
No, I spoke to the AMC yesterday. My understanding is that they'll be moving fairly quickly to make a recommendation to the medical board on the back of the work they've done and the consultation outcome. And they've set up a couple of expert advisory groups that are assisting them with this work.
Yep. So did you, so have you asked AMC to start work on the area of practice endorsement?
So the Australian Medical Council is the accreditation authority for medicine. This is entirely consistent with what they do for all specialist training and indeed undergraduate medical programs as well. So they are doing this as part of their role as the assigned accreditation authority.
So they don't take into account the public consultation?
Well, they've initiated the public consultation.
Okay,
So it's
but they've already said, but I mean, like, has work already commenced on this?
they're consulting on a draft. That's the consultation that closed yesterday. So they've done a draft of what they think the standards should be and what the expected graduate outcomes should be. They've put that out for public consultation.
So how long was public consultation for that?
4 weeks.
4 weeks. And closed?
Yesterday.
Has
I
it-
understand from the AMC they've had a couple of approaches to have a little bit longer, and they've agreed to accommodate those approaches.
Okay. Was the same sort of... I'll come back to that. I'll follow this train of thought first. So health ministers have agreed that in the interest of public safety, that the title of surgeon should be reserved for only those who have gained specialist registration through AMC and the necessary training.
Yep.
So are you of the view that only people with surgical training should be able to undertake surgery?
So-
in the sense of the scope of practice outside of MBBS?
So 2 comments, just so that, as you say, health ministers have agreed to amend the national law to protect the title surgeon, and on the advice of the Medical Board of Australia, that will be restricted to people who hold specialist registration in surgery, obstetrics and gynaecology and ophthalmology. That would mean it would be an offence to call yourself a surgeon once it's in the law if you didn't have specialist registration in those specialty areas. So this endorsement will not allow yourself to call yourself a cosmetic surgeon if you are not otherwise entitled through specialist registration. It would be an endorsement in cosmetic surgery.
So you can use the term surgeon if you are accredited in surgery.
If you have
appropriate
specialist
accreditation.
registration in those 3 colleges that I mentioned. Yep.
You confuse me then. So you can't call yourself a surgeon, but you can undertake cosmetic surgery without calling yourself a cosmetic surgeon as long as you've got your area of practice endorsement.
So you can't call yourself a surgeon
No.
if you don't have specialist registration
So nobody can call
in
themselves a
surgery,
cosmetic surgeon
obstetrics and
again.
gynaecology or ophthalmology once the law's changed.
Okay, so
and
the
that's
law
an
will-
offence.
Yep, okay. So, but you made some comment before, and maybe I misunderstood you, that you could undertake cosmetic surgery even if you're not a cosmetic surgeon.
So it would be an endorsement in cosmetic surgery. So depending on where the standard is...
But what do you call yourself if you've got an endorsement in cosmetic surgery? What can you call yourself?
You would say that you're a medical practitioner with an endorsement in cosmetic surgery, or depending if you're a specialist.
So you've reserved the word surgeon but not the word surgery?
It's not... The word surgery is not reserved. The word surgeon would be the protected title.
There are other non-surgeons who do surgery, Senator. I mean,
Well, I know MBBS.
there are rural generalists,
lumps and
GPs
bumps.
do some surgery, and normally this area is highly specialised because of the nature of these practitioners. We don't normally need to have this level of highly specific practice endorsement. This is a special case required to control this group of professionals because of the issues that have occurred. So it is a really complex issue. If you said only someone who was at FRCS could do surgery, that would stop a lot of the surgery that's happening in a lot of our rural hospitals, a lot of GPs doing, skin cancer surgery and the like. So it's a complex and tricky area, but I think what's very clear is that we don't think anybody should call themselves a surgeon unless they have that surgical qualification, but it doesn't mean that some people with the appropriate training, I think you mentioned that, you shouldn't be doing any surgery unless you've had appropriate training, and most doctors would never do that. The challenge is that a small proportion of the people doing cosmetic procedures, we don't believe have had sufficient training to do what they've been doing, and that's why this group needs a special and different means of regulation.
And Senator, we want it to be a high standard. This is not about a race to the bottom. This is about having a high standard, because at the end of the day, this is about keeping people safe who choose to have
And there are
cosmetic
many
surgery.
people with fellowships of the College of Surgeons who would be unlikely to meet this standard. So just because you've got a surgical fellowship does not mean that you can get this endorsement.
Yeah. Look, to be honest, it just looks tricky to me.
It is tricky. It's a very tricky area.
Yeah, but I think I'm using the word tricky in a different context than you're using the word tricky, Secretary. It just looks like it's a way to get around it, because, you can stick cosmetic surgery on the front of your window, but you just can't call yourself a cosmetic surgeon. So was it the intention of AHPRA and the AMC when you worked together to come up with this endorsement model that you would have a situation where non-surgeons would be able to apply for this endorsement? In a sense, it sort of strikes me as you're sort of legitimising their surgery by allowing them to continue to get an endorsement that lets them do what they're doing without going through a process that you would otherwise expect of a surgeon.
Well, Senator, I think I can only really reiterate all medical practitioners have basic training in medicine and surgery. As the Secretary said, the reality is there are many examples of non-surgeons who already do surgery inside and outside of cosmetics, and the intention is to have a high standard that would be met, that would need to be met if people were to have this endorsement on their registration. I really can't comment on what that standard will be, because, as I say, quite literally, the consultation only closed yesterday. But I think it is important to say it's not an AHPRA decision. It will ultimately be a recommendation to the Medical Board of Australia, and then, as I say, accompanied with the registration standard for the consideration of all health ministers.
Senator Ruston, I will be seeking to move the call around shortly.
Okay. So I suppose my concern is that there are a set of standards that have been around and adhered to in relation to, design, continuous professional training and the like. And it seems to me that we have, sort of worked to circumvent that by this means, notwithstanding what you said, and I certainly hear you loud and clear. So is it true that you, AHPRA, are able to put practice restrictions on, IMGs as an example, and you do so?
So again, that's a decision for IMGs of the Medical Board of Australia, but certainly registration can be granted with requirements around additional supervision, for example, or requirements around particular places that you can practice and needing to get authorisation if you change. And we also have different categories of registration. So we use a category called limited registration, for example, in some cases as well.
Yeah. So was the idea of using a scope of practice sort of constraints model in terms of the cosmetic procedures challenge that we have before us considered?
So the way that the national scheme is set up is we don't regulate scope of practice, we regulate title. So with the requirements to use the title.
Did you say you don't place scope of practice restrictions on IMGs, or scope of practice restrictions aren't placed on IMGs?
We place restrictions on registration, sometimes
Are they
because-
scope of practice restrictions?
Well, they limit, for example, where they can practice.
Yeah.
They limit potentially, set requirements around supervision, for example.
Yep.
But just
Not what they can do. They can do whatever they like if someone's watching or they're doing it in the right place.
Well, we may, so I'm talking on the registration side. If you go to the notification side, which is where there are concerns, for example, about the performance of a practitioner, a board may also place restrictions on that practitioner around what they can and can't do, because there is a concern about the safety of their practice.
I'm going to pass the call to Senator Tyrrell now.
Some questions about last week's Four Corners episode on disciplinary decisions. When will the investigations into the sexual misconduct complaints be finalised? Do you know?
Sorry, could you repeat the question?
When will the investigations into the sexual misconduct complaints be finalised?
Senator, we have at the moment about 900 open notifications about what we call boundary violations, so a full spectrum ranging from an inappropriate comment through to potentially an allegation of sexual assault. And all of those, so we seek to move those investigations along in a timely way. Sometimes it is complex because we may have the involvement of police. Obviously, we need to be very sensitive to the victim survivors in some of these cases as well, because it can be quite re-traumatising. But the thing we always do, the first decision that is always made, is whether there needs to be any restriction placed on that practitioner while we investigate further the allegation, and that's always with a focus on public safety, and in some cases that may be complete suspension of their registration so they can't practice, or in other cases it may be limiting them to being able to only practice with a certain age group or with a certain gender. So that's always the first decision. What's the fence, if you like, that needs to be put around the practitioner for patient safety while we investigate further?
Okay. Is there a threshold when it comes to referring to the police?
We would always encourage people to go to the police, and we sometimes get referrals from the police as well, and sometimes we may initiate contact with the police as well. So, obviously when we're talking about allegations of sexual assault, or I gave the example before of potentially inappropriate touching in the context of a clinical examination, those sort of things, yes.
So it still comes back to the person who feels that they've been violated or...
Well, it can be partly about what they want to do. It can partly be about whether police are already involved. It can partly be about whether we want to involve police. But one of the things we think is important is we want closer working relationships with police in these areas.
Fair. There's some reforms that APRA are putting into place. Are they on a sliding scale of introduction, or are they going to be completed by a holistic date?
So there are some reforms we can do now without any need to change the legislation that we work within. So the example of reviewing our criminal history standard, extending our Notify support program are two examples. But there are others that would require amendment to our legislation. So, for example, a greater role for tribunals in decisions to reinstate people to registration after a period of cancellation or disqualification, and we'll be discussing those with health ministers when they meet shortly, because ultimately ministers would need to agree to those amendments going forward.
Because there'd be financial implications and resourcing attached?
Well, yes, although we're not funded by government, we're funded by practitioner fees, but it would require our national law, which is state and territory legislation, not Commonwealth legislation, to be amended.
Thank you for that clarity. Have all practitioners currently under investigation been stood down pending the findings, or are there still some still practising?
So the risk assessment that's done at the front end, as I was saying, so we call it immediate action. Okay. There's a certain threshold that we need to meet in terms of being able to take immediate action under the national law. So all practitioners where we have a view that threshold is being met, we've taken action in relation to. I would make the point, though, it is an appellable decision. So sometimes what we find is that practitioners will go to a tribunal and appeal will seek to have a stay on the restriction that we've placed on that temporary basis while we're investigating. And there are certainly examples of where tribunals have diluted, if you like, the restriction that we thought was necessary for patient safety. So they might, for example, replace a suspension with a restriction around gender.
Does that get restricted between crossing boundaries, as in like states and territories, or is that across the board?
Any restriction that's placed by bodies is national. So if you're suspended, you can't work anywhere in Australia as that practitioner.
Is there a certain period by which investigations must be finalised? From what you've just said, no.
There's no statutory period within the national law, no.
Yeah. Is there a period of time that it can be played out in, like a month, a year, 2 years?
So on our current, if I just talk about all of the complaints we deal with, we get about 10,000 complaints a year across the 16 professions, 850,000 registered health practitioners. We do a risk assessment of all of those complaints. We have clinical advisors who work with us on those as well, and we aim to close those that don't need investigation within 3 to 6 months, and we're currently closing those about 70% of matters in that period. Where we need to investigate, it does take longer. And it would not be unusual perhaps to have a 12-month period and sometimes longer. Some of that is, as I say, because they can be very complex matters. They can, involve police and coroners, where we've got to sort of sequence our work with what they're doing. Sometimes we have practitioners who are very unwell and who can't sort of participate in the process. But we are really conscious of timeframes because it's incredibly stressful for the practitioners involved. It's very stressful for the person raising the concern. And one of the areas we've put quite a lot of additional resources in this year is our whole what we call notifications, or our complaints team, to really try and both reduce caseloads for those people and improve those timelines.
Is there any way that we could get, without personal information, the data in relation to incidents and the timeframes associated? Yeah, so we do publish data like that in our annual report, and be happy to sort of share that with you, yes. Perfect, that'd be amazing. The Four Corners program also went into like the Launceston Hospital in Tasmania in regards to child safety concerns and around an 11-year-old little girl who was raped by an emergency doctor in 2001, I'm sure you're aware. The alleged offender was recently struck off but can soon apply to be reinstated. Is it possible that this doctor would be reinstated?
Well, it is possible, yes, although obviously there would need to be very careful consideration of the circumstances. I mean, whilst there are doctors who do come back into registration, there are also doctors that and other health practitioners that we refuse registration to. So I can't really comment on an individual case, but it is on a case-by-case basis, based on our criminal history standard. But the level of the crime, so to speak, would determine whether they were reinstated. The severity of the offending would certainly be a very important consideration. Yes. Do you have data or figures on, like, practitioners that are accused of rape or pedophilia and that are practising or have been reinstated? We've got some data, yes. Yeah. Would that be available to us? We could certainly, I understand privacy. Yeah, one of the things we could do is we've certainly done our own investigation into a number of the practitioners that have been in the media recently. We'd be happy on notice to provide information. I mean, we're a bit constrained in some cases in what we can say, but we can certainly provide the public domain information to you. Yeah. I'm not after specific names and stuff like that, that's fine. But it is being monitored regularly, obviously. When did APRA investigate the practitioner in question? Are you aware? And have they been investigated previously? Which practitioner are you referring to? The one that, in regards to the little girl in Launceston. So that occurred prior to the establishment of APRA. It came into existence in 2010, so that was a matter dealt with by the medical board that was in place at the time. Okay. In the Four Corners program, APRA publicly endorsed legislative change to address the way accusations of sexual misconduct are dealt with.
Since then, we've heard APRA has written to all state and territory health ministers jointly responsible for the laws governing APRA to lay out a blueprint for reform. What exactly would APRA like to see changed, like big picture?
So there are a number of areas. As I say, there are some things we can do immediately, and the review of our criminal history standard, and in particular how it's applied to sexual misconduct, the expansion of our support service for victim survivors who come forward. But in terms of areas that we'd be very keen to have the consideration of ministers, one would be the question of publishing more on the public register about, if you like, the proven history of a practitioner and possibly some of the reasons behind the restrictions that are in place around these sexual misconduct matters. We already publish links to tribunal decisions unless they're suppressed, but we think there's scope to look at publishing more.
Yeah.
Secondly, we would like, we are supportive of an amendment to our national law that would see a greater role for tribunals in relation to a decision to reinstate a practitioner into registration after a period of cancellation or disqualification. So they're probably two examples of where we... there is also, I think, a discussion that we're keen to have with ministers about the question of how we might have a stronger community voice in the regulatory decision-making work of the scheme and more widely. We already have community members. For example, the committee that looks at this for medicine is chaired by a community member, but we think there is scope to look at greater involvement of community members. And I guess the other point more widely is, and perhaps goes to the diagram that I referred to earlier, is it's quite a complex, I don't know what you'd call it, landscape of different entities who are involved in this. And so I think anything that ministers might be willing to look at to simplify and streamline that is something we'd be very keen to be part of as well.
So basically you are there to protect the industry and medical practices. So you're doing everything that you can to make sure that it's safe for people in the real time as well, yeah?
Yeah, 100%. I mean, our absolute focus is public protection and patient safety. Yeah. That is our paramount principle.
Yeah, so preventing the re-registration of practitioners in another state or territory is exactly what APRA is there to do.
So we manage the registration of health practitioners across Australia. Yep. The thing that we have in one state currently is that if you were a cancelled practitioner or disqualified, before you could come back into registration, you have to go back to the tribunal and get their okay to apply to us to be registered. And the big advantage of that is it puts it in the public domain. So we think that's a reform that ministers might like to consider applying in every state and territory in Australia, because that would give much greater transparency for the public about these decisions.
I love the sound of that, and I think that's my time. But thank you so much.
Thank you, Senator Tyrrell. Senator Roberts, and then I'll be coming to you, Senator Rennick.
Thank you, Chair, and thank you for being here this morning or this afternoon.
Thank you.
How many medical professionals has AHPRA contacted directly to lay down the law regarding AHPRA's rules around authorised speech in connection with COVID-19?
Thank you, Senator. I've got quite a bit of data on our work in the COVID space, and do you...
I can take that on notice.
All right, I'm very happy
Please,
to
but
notice.
could I have an answer to the question I just asked? How many have you contacted directly to lay down the law regarding AHPRA's rules around authorised speech in connection with COVID-19?
Well, let me just set the context and try and answer the question as best I can. So, as of pretty much this month, we've received 1,450 notifications about registered health practitioners in Australia.
To do with COVID?
To do with COVID. And if I just give you an example of the range of issues, it's things like concerns being expressed by patients about the clinical care they've received when seeking or receiving COVID-19 advice, vaccination or treatment.
What about just those around authorised speech?
What do you mean by authorised speech?
Well, I think you know what I mean.
Well, perhaps if you could clarify what you mean.
Well, let's continue with the other questions. Is it necessary for AHPRA to receive a complaint regarding a medical professional offending your standard of speech from a third party? Or is AHPRA monitoring social media and taking it upon yourself to police the opinions being expressed by medical professionals?
The vast majority of notifications or complaints that we receive are received from the public or other practitioners. We're not actively surveying social media for
So the vast
complaints.
majority? That means some aren't that way?
Well, I'd probably have to take on notice whether, I mean, there is a power under the national law for a board to take what's called own motion.
What's own motion?
Well, that means we don't need a complaint. The board can take an own motion and act. I'd probably have to take on notice whether we've done any own motion in relation to COVID-19.
Thank you, or your staff. How many medical practitioners have you formally warned for wrong speak based only on their expressed opinion of COVID? Whether that be COVID itself, related health measures, including COVID injections?
So I'm going to have to give you the figure for all registered health practitioners, so I'll have to take on notice for doctors only. Boards have cautioned 108 registered health practitioners for a range of issues, and I was starting to tell you the sort of things, because it's not just about what people are saying, it can also be about aspects of their practice as well.
Okay. Has AHPRA terminated the licence of a medical professional as a result of comments made publicly by that medical professional rather than on the basis of medical malpractice?
So we have no power to, in our terminology, cancel the registration of a practitioner. That has to go to a tribunal, and that's a decision of a tribunal. However, we do have a power to suspend practitioners while we're undertaking an investigation. So there are currently 33 practitioners who are subject to what we call immediate action. So 16 of those relate to the spread of misinformation about COVID-19 or vaccination, so claims about a fake pandemic. The vaccine program is government-led mind control. Vaccination will lead to cancer. 11 of those 33 relate to a failure to comply with public health orders that were in place at the time, possibly fraudulent conduct, possibly around things like fake vaccination certificates and fake exemptions. Again, obviously at a time when this was the required rules. And then we have 7 practitioners subject to immediate action where they haven't been suspended, but there have been conditions or limitations placed on their practice. So they may be conditions related to supervision, or there may be limitations about not in fact being able to issue vaccination certificates.
A number of doctors, and many, many more, have backed it up. A number of doctors have told me personally they are under threat from AHPRA and that they must comply with what do you call it, government health advice, or the government health message. Isn't that bullying and intimidation?
Well, Senator, I don't accept that that is what we're saying. Essentially, the code of conduct for medical practitioners, let's just talk about medical practitioners, has always said that in providing care, a medical practitioner has to draw on the best available evidence and use their clinical judgment. The guidance that we provided in relation to COVID-19 was simply about how those pre-existing requirements applied in the COVID context, and that was at the request of practitioners for clarification. And I don't believe health practitioners have any reason to be fearful if they are able to demonstrate how they're using evidence and how they're using their clinical judgment. And as I say, every case is looked at on a case-by-case basis. There's no algorithm here.
So before we move to the next topic, has AHPRA received any direction to behave in the manner I've just indicated from any Minister for Health or a senior health bureaucrat?
No.
Thank you. Let's move to intellectual freedom. In the Reid versus James Cook University case, the High Court of our country found that intellectual freedom plays, quote, an important ethical role not just in the lives of the few people it protects, but in the life of the community more generally. The primacy of individual conviction relies on the right to, quote, profess what one believes to be false and, end of quote, and, quote again, the duty to speak out for what one believes to be true, end of quote, for what one believes to be true. This is the opposite of your actions. Do you know better than the High Court of Australia?
Well, Senator, what I've said is that the requirement on registered health practitioners predates COVID. It is a requirement to use best available evidence and clinical judgment. I should also note there is a conscientious objection element of all the codes, so that if you don't feel able, for example, to give advice on a particular issue. There is a way, providing you appropriately refer your patient, that can be dealt with. So I don't accept that these are long-standing expectations and obligations on registered medical practitioners and indeed on all registered health practitioners.
I'll quote a letter from AHPRA to Ms Hart. It's dated the 20th of September 2021. When providing care in person or sharing information online, registered health practitioners have a professional obligation to only share information that is evidence-based, in line with the best available health advice, and is consistent with public health campaigns such as the COVID-19 vaccination policy. If a doctor does not believe that is good, the latter, health campaigns, public health campaigns, is good advice or good procedure, you're forcing them to adopt it against their will or lose their job.
Well, we don't employ doctors for a start, but in terms of
you are forcing them to lose their job.
Senator Roberts, if we could allow Mr Fletcher to finish his answer to you, please.
I'm just going to go back to what I've said. What we expect is that you, as the letter says, you use the best available evidence and your clinical judgment in providing your care to patients. And if we received a complaint about you or if we received a complaint about a doctor, Senator, we would provide that person with the opportunity to explain how they have met that requirement in the way that they have delivered care. So there is always procedural fairness for the practitioner to be able to put their side of what they believe they've done.
I've circulated a letter from the Australian Medical Professionals Society that is growing rapidly because of the actions of health bureaucrats in the last 3 years. AMPS, the letter is most troubling, and I'll ask your response to it. This letter has been widely circulated in the profession.
Mr Roberts, the letter's just being circulated now, so the Secretariat
Thank you.
should be placing it to you. Senator Roberts.
Have you seen that letter?
I have seen letters from this society. I'm not sure whether I've seen this specific one. I'd have to check that.
AMPS discusses the indemnity scheme for medical professionals that was promised by the Morrison government to indemnify medical professionals for injecting the COVID products for which the manufacturers were given indemnity. The letter and attached document from the Department of Health and Aged Care clearly indicates the indemnity scheme was never implemented. Mr Fletcher, have you allowed your members to be hung out to dry on COVID product liability?
The COVID-19 vaccine scheme is not a question for AHPRA. It has been implemented, and Ms Shakespeare...
No, I'm not asking about the COVID.
That's the indemnity
I'm saying the letter and attached document from the Department of Health and Aged Care clearly indicates the indemnity scheme was never implemented. I want to know from Mr Fletcher, has he allowed his members or the doctors to be hung out to dry on COVID product liability? Because you're forcing the doctors to comply with it.
Clarification as
I don't
Chair.
think that's a question for Mr Fletcher to answer.
Okay. Apologies, Senator Roberts. We'll have to come back to that.
Can we
give Senator Roberts an
this
indication
correspondence, and we'll be prepared to answer your question.
So who will I ask the question to?
Well, let's have a look at it, and we'll come
If you
back
could
to
provide some advice after the lunch break on perhaps where it is best asked. Senator Roberts.
Thank you. Let's go to informed consent. From your announcement on 9th of March 2021, quoting Mr Fletcher, there is no place for anti-vaccination messages in professional health practice, and any promotion of anti-vaccination claims, including on social media and advertising, may be subject to regulatory action, end of quote. This is the definition now of informed consent from the High Court's decision in Rogers versus Whittaker. Quote from the High Court, "For consent to be legally valid, it must be given voluntarily in the absence of undue pressure or manipulation. It can only be given after the potential risks and benefits of the relevant vaccine, the risk of not having it, and any alternative options have been explained to the person." End of quote. That is settled law. AHPRA is encouraging doctors to break it.
Sorry, Senator Roberts, could you please direct your comments as a question to Mr Fletcher?
It seems to me that AHPRA is encouraging doctors to break what the High Court is saying is settled law?
So, Senator, I've got the March statement in front of me that was released by all national boards and AHPRA. And what it says is national boards expect all health practitioners to use their professional judgment and the best available evidence in practice. This includes when providing information to the public about public health issues such as COVID-19 and vaccination. And then I'll just jump a sentence to go to any promotion of anti-vaccination statements or health advice which contradicts the best available scientific evidence or seeks to actively undermine the national immunisation campaign is not supported by national boards and may be in breach of the codes of conduct and subject to investigation and possible regulatory action. So there's a may in there. And as I say, if we have a concern, if we receive a complaint, we look at that on a case-by-case basis, and there is always an opportunity for that practitioner to set forth how they believe they've met the requirements of the code of conduct. Because again, I want to state this reflects what has always been in place in relation to the expectations of the behaviour of registered doctors and other health practitioners. And the statement also makes clear if they, in the case of conscientious objection, for example, a practitioner's personal beliefs, they should inform their patient and they should create referral options for that patient.
Mr Fletcher, have you or any members of your board obtained personal legal advice on this issue?
No.
You haven't? Okay. I'd like to just go on with the last question.
Last question.
Yeah, I've got... AHPRA have made it clear that repeating the government's talking points without question is a condition of working as a medical practitioner. Are you protecting the government and big pharmaceutical companies' interests over the interests of your members? And by your brazen and in what I consider immoral actions, haven't you and others in health, are you confident in your control of the medical system?
Senator, our only focus is on public protection and patient safety, and as I say, our expectation, which has been there for many, many years, is, as I've said, around use of professional judgment and best available evidence.
I suggest you talk to a few doctors.
This works, this process works if we pose questions are listened to, and then opportunity is given for answers to be made, Senator Roberts. But given it is at the coming to the lunch break, I will be shortly seeking to suspend. I just want to give the committee an indication of what we will do next. So AHPRA will be asking you to return after the lunch break, please. We have a number of questions to work through from other senators. Senator Rennick, I will be coming to you after the lunch break, if you can please be here at the commencement of it. And then we also have questions at this stage from Senators Pratt, Ruston and Waters. After AHPRA, it is our intention at this stage to move to questions to the TGA. So if those officials could just be aware that we will likely call them shortly after AHPRA. We will now suspend and the committee will resume at 1 p.m. Thank you. Sorry, we will resume at 2 p.m, not in 1 minute, at 1 p.m. Sorry. Eat fast. Being 2 p.m. and not 1 p.m, I would like to welcome everyone back, and we can resume the proceedings of the committee, please. We are returning to questions to Mr Fletcher from AHPRA. But before we do, I understand the department had an update on a request for information from Senator Ruston.
That's right. Charles Vaughan, Deputy Secretary, Corporate Operations Group. So we provided some information earlier on the status of our questions on notice, and we endeavoured to come back with an update on where we were at. Just to states 358 questions on notice since the November hearing. 94% of these have been tabled by the department. Of the 6% outstanding, and that represents 21 questions on notice, 9 were received by the department in mid-January this year. We expect that all the quans currently with the Minister's Office, so that's 13, for noting with the Minister's Office, will be tabled in the coming days. That's right, and they'll be tabled in the coming days.
That's 13 out of the 21?
Yes, that's right. Yep. Of the quants submitted by Senator Ruston, she mentioned 14. On our books, it's 13. So what we're suggesting there is just my team will work with Senator Ruston's office just to reconcile those two lists. Some of the senators' quants were tabled this morning, but we'll work on getting the remainder processed as quickly as possible.
So does the 20, sorry, Chair, but does the 21 include the ones that were tabled this morning, or is that
No, that's net of that. So it was 26 when I reported. It's now 21 because of those that have been tabled this morning.
All right, I will pass that on to...
Yeah, thank you. Pass that on to Senator Ruston. Might just assist the committee as well. Are we able to get some similar figures going back the last 5 years? Just
Oh, absolutely,
that'd
yes.
be great. If you could take that on notice for the committee, that would be wonderful.
Okay.
I'd now like to introduce Senator the Honourable Katie Gallagher, Minister for Finance, Minister for Women and Minister for the Public Service, representing the Minister for Health and Aged Care. Minister, do you have an opening statement for the committee?
Thank you, Chair.
Okay. I'm going to pass the call to Senator Rennick. Just before you start, Senator Rennick, we have a number of senators with questions for APRA, so we'll be encouraging shorter blocks just to allow us to get through the material. Senator Rennick.
Okay. Hi, guys. My question is to Mr Fletcher. Just in regards to your prior statement on the 9th of March in 2021, when you advised health practitioners to follow the government advice, I just want to run some of the government advice by you. In August 21, Professor Skerritt, head of the TGA, came out and said Moderna is, even after 6 months, it's proving to be 93% efficient against any infection, 98% against severe disease and 100% against death. Now, given that we know that it didn't stop infection at all and that we've had a reported death as recognised by the TGA from Moderna, do you, and I should note as well that the general health advice was always that the vaccines were safe and effective, and no missing information such as use in immunocompromised patients, use in frail patients with comorbidities, use in patients with autoimmune or inflammatory disorders, interaction with other vaccines, long-term safety data was ever mentioned as being untested. So this was missing information in the Australian Public Assessment that came out in January 2021. That was for Pfizer, by the way. Why wasn't, do you regret saying that doctors should follow the public health advice when it was clearly misleading?
So, Senator, the statement that you're referring to from March 2021, which reflects obligations on registered health practitioners that have been in place way before COVID, indicates that those health practitioners must use their professional judgment and their best available evidence. In terms of the reference points for the evidence, if we were to get a concern expressed to us, we would certainly look to bodies like ATAGI, the TGA and the public health authorities in states and territories in the Commonwealth for that advice.
Yeah, and that's the problem. The advice never actually gave a list of all the stuff that wasn't tested. And I should also note that they noted as a potential risk vaccine-associated enhanced disease, okay, which obviously comes with the more shots you get, the greater chance of having your immune system weakened. Now that we're up to the 5th dose, are you advising doctors to warn patients of the risks of vaccine-associated enhanced disease, given that even it was recognised as a potential risk as far back as January 2021?
We're advising doctors and all registered health practitioners to use their professional judgment and the best available evidence in their practice.
So given that that's a noted potential risk, would you act, given that you put out a statement when the vaccine was originally rolled out, are you going to put out another statement advising doctors of the risk of immune imprinting?
We have no plans to put out any further statements.
So you're not going to help raise awareness of this potential risk from multiple vaccine shots?
Well, at this stage, as I say, we have no plans to put out any further statements. The statement we put out in March 2021 was in response to requests that we were getting from health practitioners for clarification about how their existing obligations under Code of Conducts apply.
Well, in other professions, you have to outline the risks of any product. Don't you think that the sensible thing to do would be to outline the risks from this particular
That's not a role for
product,
a
as
target,
noted.
Senator, that's not a role for
So I'm not speaking to you.
APRA, sorry, it's not a role for APRA. It's a role. Yeah.
Senator Rennick, if we could just let
I'm
Professor
just
Murphy
saying
clarify.
APRA is not a source of public health advice. What Mr Fletcher is saying that APRA requires practitioners to use the best available advice at that time, and that will change.
And that's
over
my
time.
point. The best available advice at the time was clearly misleading. It didn't provide 100% protection against death. And I'll get to you later, Mr Murphy. You'll have your time. Okay, but we'll leave that. And the last question I had for you, are doctors being told to advise patients on how to lodge an adverse event claim if they have an injury from the vaccine? I've spoken to many constituents when I've said to them, if they, when they come to me and say they've been injured by the vaccine, have you lodged an adverse event report with the TGA? And many people haven't even heard of the TGA, never heard of the Therapeutic Goods Association. So are doctors making patients aware of what to do if they become injured by the vaccine?
Well, we would always expect, Senator, that health practitioners meet their reporting obligations appropriately, and if appropriate, advise patients of that as well.
Okay, thank you.
Thank you, Senator Rennick. Senator Waters.
Again, just to continue on the theme that we were discussing before about sexual misconduct by doctors and the deregistration and sometimes re-registration process, can you just clarify for me, please, what is the policy on conditions for returning to practice? Is that, as you mentioned before, just sort of up to the tribunal and you consider various factors, or is there a policy about things like mandatory education or exclusion periods or disclosure obligations?
So, Senator, it's really considered on a case-by-case basis by the relevant board that's looking at it. And essentially what the board is focusing on is, are there steps that are required around restrictions or additional requirements on registration in order to ensure patient safety. So that could take the form of additional supervision. It could take the form in some cases of requirements around education. It could take the form around restrictions on the patients that people are able to see or the practice locations they work on. It really just depends on the circumstances of the case.
Understand. And that's just within the discretion of the board. There's no sort of guiding document or...
Well, we have a regulatory guide that's set, and which is on our website, which sets out some of the way that we deal with these matters and the considerations. I mean, across all of the notifications that we deal with.
All right, thanks. I'll take a look at that. When we spoke last time, you mentioned that when doctors had been allowed to return to practice after sexual misconduct, that you did monitor for compliance with any of the restrictions that had been imposed. Can you just tell me whether or not there is any regular review conducted to make sure that behaviour has changed?
So, Senator, what we do is we have a team within APRA who monitor compliance with any restrictions, and that would include reporting that the practitioner might need to do to us about their compliance with those restrictions. We might look at Medicare data, for example, if we wanted to get a sort of additional source of information to confirm compliance. And if we see that there is non-compliance, we would then look at whether that is something that required additional regulatory action, either to tighten up those restrictions or indeed to look at further regulatory steps that might need to be taken.
Okay, thank you. In the review of the criminal standards that we discussed earlier, are you just looking at the process for future decision making, or is it within scope to review doctors who have been previously banned and then allowed back into practice?
So the review of the criminal history standard would be looking at the future application of that standard once it was approved by health ministers, if it is indeed amended as a result of the consultation.
Now, we spoke earlier about the 900-odd boundary violations. I've got here that you're currently investigating 933 sexual misconduct complaints, over 400 of which are against practising doctors. Can you just confirm that they're the right figures for me? And along the lines of some earlier questions, what is the average time frame for completing an investigation? I think you said earlier that it was between 3 and 6 months when no investigation was required, and it could take about 12 months when there was an investigation. Do you have an average length of time that an investigation takes?
So just in terms of the 900 or so matters, I'll take that on notice and confirm the breakdown by profession.
Yes.
But essentially, just to again make the point that when we talk about boundary violations, we're talking about a wide range of behaviour. None of it is acceptable.
Yes.
And we take all of it seriously. But it could,
Yes.
as I say, range from inappropriate texting or inappropriate
Yes,
comments
right
to a
through to
patient, right through to
criminal
potentially something
behaviour.
that is sexual assault.
Yes. Okay.
And sorry, the second part of your question was.
When you do judge that an investigation is required, what's the average time frame for that?
I'm happy to take that on notice and come back to you on that.
Thank you. Do you expedite investigations where there are multiple complaints made against the same doctor?
So what we do when we first get a notification or a complaint is we do a risk assessment. And as I say, the first decision we have to make is whether there's immediate steps that need to be taken to protect the safety of the public. So as I say, the notion that what's the fence that we need to put around that practitioner in terms of perhaps additional supervision or even a suspension. And certainly the fact that there are multiple complaints would increase the risk rating on that practitioner.
Okay,
yes.
thank you. And is it yourself your organisation that conducts the investigations, or do you engage? Who does the investigations?
AHPRA conducts the investigations in the jurisdictions for which we have responsibility.
Yes.
In New South Wales, it's dealt with through a separate system, and in Queensland, some of them are done by us, some of them are done by the Office of the Health Ombudsman.
Okay.
We do sometimes engage additional expert opinion, for example, but the bulk of the investigations in those jurisdictions that we're responsible for are done by investigators employed by AHPRA.
Okay, thank you. Are there currently any KPIs for dealing with complaints, or any proposed?
Yes, there are. So we look at KPIs around timeliness, and we're very conscious that lengthy timeframes, are in themselves
Not
can be very
great.
stressful
Yes.
for both the practitioner and the notifier. We also regularly survey practitioners and notifiers and invite them to provide feedback on their experience around things like how well we communicated, whether they felt that they understood what was involved in the process, their perceptions of the fairness of the process, if you like. We have published on that, so very happy to share that if you'd like to read that. And we also publicly report on a quarterly basis by jurisdiction on some of these performance measures across all of our regulatory work, so also in registration. And of course, we produce an annual report every year, which includes a lot of data, and that's tabled in all of the parliaments in Australia, including the federal parliament.
Okay, do you have any KPIs specifically around dealing with complaints? You've mentioned timeliness and communication. Is there any sort of numbers or targets that you've set?
Yeah, so we have KPIs around assessment timeframes. So they're the matters that we look to try and close at the assessment phase. Sometimes we just need a little bit of additional information from the notifier or the practitioner. And then we look at timeframes around investigations.
Yes.
And also we look at things like once we get a notification, how quickly we move to do the risk assessment and as I say, make sure that there's that we're clear on the need to take immediate action to address any current risk while we look at the case more closely.
Okay. Is there a risk that any of those KPIs, or are you concerned that any of those KPIs might encourage compliance officers to focus on the more readily resolved issues rather than some of the more complex harassment or more serious offences? I mean, obviously all complaints need to be taken seriously, but is there a concern that having those KPIs might favour resolving the easy ones ahead of the more complex ones or serious ones?
We're very attentive to those sort of unintended consequences, if you like, of some of the measurement systems we've put in place. And our focus is really probably in two major areas. One is where we're looking at the lower risk areas in terms of concerns that are raised with us, certainly aiming to resolve those as quickly as possible in the assessment phase. And often it might also involve a referral to another entity, and then really making sure for those that we investigate that they are ones where there is potentially a more serious risk that needs to be looked at, and actually then making sure that they progress in a timely way. One of the things that we're doing more and more is actually looking at more specialist investigation teams. So, for example, we do have specialist investigators in relation to any of the sexual misconduct We have a specialist stream in relation to concerns we've got about health and impairment, which often needs quite a different approach to, say, a concern about the conduct of a practitioner.
Yes.
And we also have specialist teams that relate to cosmetic surgery through our cosmetic surgery enforcement unit. So I think that, you know, that sort of specialist focus in some of those high-risk areas is also designed to make sure that that there is timely action in relation to those those sorts of things as
In
well.
relation to the sexual misconduct complaints, are those specialist officers trauma informed and trained?
Yes, so they've had specialist training. We've worked with survivor services. They've had training in trauma, and we've also done that training with the regulatory decision makers particularly on the medical
Oh,
board
I'm
as
pleased
well.
to hear that. Okay. I'm almost finished, Chair. AHPRA has proposed increasing patient representation on key decision-making boards. What boards would that include, and how will the patient reps be selected?
So there are two issues here. One would be the national boards. So there are 15 national boards for the 16 regulated health professions. At the moment in the national law, the mix is 2/3 practitioner member, 1/3 community member. So in fact that would ultimately be a question for health ministers about whether they wanted to amend the national law to change that. And then we have a whole series of regulatory decision-making committees that are convened, and that would be something that we would look at internally about how we make sure we've got a strong consumer voice and community voice in those. We also have for nursing and midwifery and medicine state boards that are delegates of the national board, and they're certainly open to state health ministers who appoint to those boards to increase the number of community members. And wherever we've got vacancies on boards, they are publicly advertised, and we have attributes, and we are particularly keen to have applications from Aboriginal and Torres Strait Islander peoples, because we have a commitment to increasing participation across all of our boards from First Nations peoples, and we are also very keen to get people who in a sense are connected community as well, so really genuinely bring that community voice to regulatory decision making.
Great, that sounds positive. And lastly from me, the newly appointed Women's Health Advisory Council, who will be coming on at some point this afternoon, has been established amongst other things to examine medical misogyny. Will AHPRA work with this council in responding to the issues raised in the Four Corners report?
We would be very happy to work with them, and I'd also highlight to the Senator the medical training survey, which we undertake with the Medical Board on an annual basis, which is just published for this year, where we survey all doctors in training. And although I think most doctors in training rate their training experience very highly, there continues to be quite a worrying percentage of people who either have witnessed or experienced bullying, harassment and discrimination in the workplace. So we are very keen to work with others around building a culture of respect in medicine, but also in all the health professions more widely.
All right, thanks very much for your time. Thanks, Chair.
Thanks, Senator Waters. I'm going to pass to Senator Ruston. I'm aware there's a number of senators here for the TGA. If you're here for the TGA, can you just grab me for a quick chat whilst Senator Ruston is doing her question? Senator Ruston.
Thank you. Just finally following up on the last part of what I was talking with you, Mr Fletcher, about before the lunch break. Just wondering if you can confirm whether there's any plan, any intention, any desire by any of the players that have been involved in this process of endorsement around cosmetic medical practitioners and cosmetic procedures in relation to grandfathering existing operators into the new model?
There are no plans to have grandfathering.
Okay. So, no plans, no intention, no desire?
No plans.
Ministers were pretty clear that they did not want that.
No plans, no intentions, no desires.
That's great. Thank you very much for confirmation on that. Can I just now move to text-based or asynchronous care? Is that something that you've been involved in terms of the determination as to the efficacy of it as a medical tool?
What are you referring to there, Senator?
When somebody goes on and enters data initially, for instance, as an example, with their not actually speaking to someone, they may just be providing data in a digital manner before they actually progress to speaking to a doctor.
Are you talking about telehealth?
Well, it's telehealth, but not telehealth as in I'm talking to you on the phone, but the precursor to that, which is, following, like a text-based initial approach? Which is part, I assume, of the telehealth review.
I mean, I'm going to say not specifically, although I would note that the Medical Board of Australia is currently consulting on revised guidelines for telehealth. But that really is about the question of, virtual consultations that are occurring between medical practitioners and patients.
So in terms of that, Secretary, who would I need to speak to?
In respect of the safety aspect or
Well, I'm
billing
just trying
aspect
to,
or-
I'm trying to understand how it's being viewed as part of a model that may be considered to try and deal with the broader issues of the primary care model, and what is the process to assess whether text-based, I think it's called asynchronous, but text-based is probably easier to understand, as a part of that overall model of going through telehealth and obviously through to general practice and face-to-face. So is there what's the process in terms of considering that component of telehealth?
I don't believe, Senator, others might correct me, I don't believe we're specifically looking at that. It could certainly be something that we could look at as we develop the primary care model that the Strengthening Medicare Task Force has been working on, but I don't believe we have a specific body of work looking at non-face-to-face contact other than telehealth, where there is a doctor involved.
Yeah, there was newspaper reports earlier on this week or last week, I lose track of time, in relation to accusations of, bots or whatever they call them, not real people prescribing prescriptions.
Well, that would be an offence if a registered practitioner didn't prescribe. It would be a misuse of the prescriber number. So that would be an illegal action if a computer somehow generated a prescription without the active involvement of a practitioner.
Yeah. I suppose what I'm trying to understand is that there's these accusations of what is clearly inappropriate conduct by, if that's what's happening, but also that there are legitimate models where you're able to get online prescriptions by a telehealth mechanism, and just how that is factoring into the determination around, the broader, innovative models of care.
Sure, we'd be happy to take on notice any intel or any work we're doing on that, but I'm not aware of anything specific we're doing on. I don't know whether anyone else is.
Could I just comment, Senator, perhaps just going back to the consultation the Medical Board is doing on telehealth. One of, so there's a range of, generally supportive of telehealth as a mode of care delivery, but some of the concerns are things like the requirements around not having to consult or see a prescriber before a prescription is given, not getting a relevant medical history, and then, to pick up, I think, on your point, prescribing processes that are managed by an algorithm or an AI process, as opposed to being undertaken by the prescriber. So there is an element of that in what the Medical Board of Australia is consulting on at the moment around revised guidelines.
Okay, so what's the time frame on that review?
It's out for consultation at the moment. I'd probably have to come back to you on exactly. Again, it partly depends on. I'd have to come back to you on the exact date on that, so I don't have it in front of me. Again, it partly depends on what sort of response there is. My understanding is there's been quite a lot of interest in this.
Sure.
Yes.
Yeah, and I'm sort of interested to understand if there's been any data that's been collected that's in relation to the difference in the outcomes of face-to-face or a blended model, because clearly understand no one's suggesting that you do telehealth and only telehealth. So what sort of data there is and how that's been collected, and what is the outcome ratio, and what the impact would be relative to location, because clearly rural, regional and remote, the further you get away from the capital city, the greater dependence you have on alternative models. So I'm happy to put the rest of that on notice. It may not necessarily be to you, but to you. But I'm
the department properly, I think.
Yeah, but coming from rural and regional Australia, I am very interested in how you're developing non-one-size-fits-all models of care. Thank you, Chair.
Thank you, Senator Ruston. Senator Tyrrell.
Thank you. Sorry, I came back. Apologies. I did miss one question in regards to the little girl that was raped in Launceston and the doctor was struck off. My secondary question to that was, why didn't APRA decide to reinvestigate in light of the concession by Child Safety that on the balance of probabilities that the child had been raped, even though it happened prior to APRA's creation? So historically, can you go back?
So I think the first point to make is that this practitioner is not able to practice at the moment because their registration is cancelled.
Yep.
The only way that we could reopen a matter from 20 years ago is if there was any new information.
Okay.
That's obviously very difficult in this situation because tragically that person has deceased.
Yep. I appreciate that answer. And that's it, sorry.
Senator Tyrrell. Senator Pratt has kindly agreed to put her questions on notice to assist the committee. Can I just confirm we are finished with APRA and we can dismiss these witnesses? Great, thank you. Thank you, Mr Fletcher, for your appearance today.
Thank you very much.
Okay, we're now continuing on in this outcome, but as foreshadowed, I will be calling the TGA in the first instance. We have a number of senators at the table with questions for you, Professor Skerritt. As informally agreed with senators, we'll be moving through these in shorter blocks of 5 minutes. Senators, if you require another block after your 5 minute, please let me know and I'll put you on the list again. Oh, you want to be on this? Yeah, okay. And just to give you an indication of order, I'm going to Senator Rice, then Antic, then Rennick, then McGrath, then Hughes, then Waters, then Reynolds. So Senator Rice, you have the call.
Thank you. And look, I'll start. I'm not sure whether I'm in the right place, so I'll check. I want to ask some questions about gay blood donation.
Thanks, Senator. You're always in the right place. And should I just apologise to senators that Minister Butler has asked to see me at 4:45, just for a bit over half an hour. So I'll duck out for 15 minutes of this session, but I will be back after the break if there's further questions. You never know, you may be done with me by then. But that's about an hour and a bit, but hopefully we're done. So certainly, please go ahead.
Okay, so look, according to the Kirby Institute, there were 333 new HIV cases in Australia in 2021 through male-to-male sex. And even if these individuals were to choose to donate blood in similar numbers to the general population, around 3%, this would equate to only 10 individuals. And the chances of these 10 individuals donating blood during the period in which HIV infection may go undetected through blood schemes next to none. So given that the risk of HIV transmissions from men who have sex with men, blood donation is no longer statistically meaningful, why keep the existing requirement for a 3-month abstinence period?
So we're always open. First of all, we can't unilaterally change this. It requires an application from Lifeblood. Now, there's two broad approaches looking at population risk for donations from men who have sex with men and indeed from any community. One are what they call population-based approaches, and that is what Lifeblood, or what used to be known as the Australian Red Cross Blood Service, uses in Australia. The other approach, as is used in the UK and some other countries, is what they call individual risk assessment.
Mm-hmm.
Now, we have been discussing with them. In fact, coincidentally, we're meeting with them tomorrow afternoon, and that will be on the agenda. But in many ways, in many areas of our regulatory practice, we are responsive to a submission from them. We've also been discussing the potential of removing all controls on plasma donations, irrespective of sexual history or sexual practice.
So can I just ask, I mean, we've asked these questions before, and it's been, yep, it's up to Lifeblood to make an application. I've had meetings with Lifeblood in the past. What role does the TGA play in basically encouraging Lifeblood to be taking this approach?
We explain what other regulators are doing. For example, the US is currently, they haven't made a final decision, but they're currently considering this individual risk assessment approach, which comes down to individuals. One of the reasons why Lifeblood has said to us that they're a bit hesitant to apply individual risk assessment in Australia is that one of the questions that is asked by blood services, you do a donor questionnaire before you donate blood, is do you or how often do you practice anal sex? And they're actually worried that in an Australian context that there would be a number of people offended by that question and it would actually negatively affect their number of blood donations. But these are discussions that are ongoing.
Mm-hmm.
So it is something we put on the agenda, blood donor deferrals for men who have sex with men and indeed other forms of identification with, with gender and sex every time we meet with them, Senator.
So on that issue of reducing those other donations, you're aware of the recent Canadian research showing individual risk assessment would not reduce the amount of blood available. Is there any reason why that research wouldn't apply to Australia, which is very similar?
I'm aware the Canadian government a few years ago commissioned a range of research projects, including the one you mentioned. And that is the sort of thing that the Red Cross Blood Service, who have people working on this thing full time, will take into account. I don't know whether or not individual risk assessment would reduce blood donations or not. It's really for Lifeblood to determine that. And when we and if we receive an application to move to individual risk assessment, we'll review it as a priority.
I suppose it goes to the point in terms of the TGA and government, in fact, of having a policy that is non-discriminatory, and the fact that it seems that we're being held to ransom by the attitudes of Lifeblood, who aren't accountable to us like the government and the TGA.
Well, they manage, in Australia, as you know, unlike countries like the US where it's actually a fee-for-service thing, blood donation, in Australia blood donation is a gift. So I realise you used the word in general terms, but in legal terms it is not discriminatory. That's been tested in the courts and in various forums. But the way the system is currently structured, Lifeblood have responsibility for managing the blood service. We have the responsibility for responding to an application for them. But every time we meet with them, and we meet with them quite regularly, as I said, including tomorrow, we discuss this issue, Senator.
Well, can I ask then that you...
I'll raise it again tomorrow.
Raise it again tomorrow and put the position very strongly that this would be an appropriate direction for them to go in, given that research, given that it shows that, in fact, the number of increase in donations from men who have sex with men is more, the Canadian research shows, more is going to offset any reduction in donations for anybody.
Yes, and really the final thing should be on safety, but they also obviously do not want to limit their donor numbers because it is a donation in Australia.
But you're opening up a whole new pool of donor numbers by doing it. Thank you. Thanks, Chair.
Thank you, Senator Rice.
John Cowell, Chief Executive, National Blood Authority. I do need to add something to Professor Skerritt's answer because I wouldn't want it left on the basis that Lifeblood has any reluctance to expand the donor base. They're continuously looking for opportunities to do that from everyone in the population. So the opportunities to explore changes in deferral arrangements for sexual activity issues is a matter of constant consideration. And I also just want to make clear that they're not detached from government because they work under a deed of agreement that the National Blood Authority manages on behalf of all governments, both Commonwealth states and territories. So there is a capacity to engage in addition to the engagement with the TGA. We would speak to them every day, I suppose, often about these sorts of matters. So they're very enthusiastic about expanding the donor base and to do so in an appropriate and risk-based way.
So Thank you, Mr. Cahill. We can pick it up on your next block if you like. Senator Antic has sought to table a document. The committee needs to consider that, but can we have that document distributed for the benefit of witnesses? Two documents, sorry. Yep. But the committee will make a decision, Senator Antic, on tabling it at a private meeting.
Happy for those to be distributed.
Senator Antic.
Thank you, Chair. Professor Skerritt, when did it first come to the attention of the TGA that 2 Australian children, one aged 7 and one aged 9 years of age, died of cardiac arrests directly after receiving a COVID vaccination?
So, Senator, we have a number of reports of deaths of people of all ages, including children, temporarily related to adverse events from vaccination, or not related to adverse events from vaccination, just related in time. So these two reports were received in our database of adverse event notifications. Unfortunately, we were unable to get sufficient information on these particular cases to assess them in detail, but they were associated, the information we did have is that they were associated with heart attack, which is not a known adverse event of any of the COVID vaccines.
I'm sorry. Did you just say that cardiac arrest is not an associated
adverse event
as
of
event?
COVID
But
vaccine.
myocarditis, which leads to heart attacks, is
No,
it
no,
not?
but the two are different. Myocarditis is an inflammation of the heart muscle.
Sure, I understand that.
Yeah.
Please finish your answer, and then Senator Antic, I'll allow your questions to be asked in
Good.
silence.
Thank you
as
for
well.
that. So myocarditis is an inflammation of the heart muscle. Pericarditis is inflammation of a lining of a heart, and heart attack is a different clinical entity. Some people with myocarditis do have an increased propensity for heart attack, but they are different from a myocardial infarction.
Sure. So, but at the end of the day, the question was, when did the TGA become aware of the deaths of a 7-year-old and a 9-year-old from cardiac arrest, which in a short time frame from having a COVID vaccination?
I'd have to take on notice the dates that they were reported, those individual cases, to the database of adverse event notifications. As I've said before, we have almost 1,000 reports of deaths temporarily around the same time as COVID vaccination, of which 14 have been determined to be related to COVID vaccination.
These are
So there are probably many more people under 20, 30, whatever age you care to call, that have been reported to us. But these reports do not indicate causality, and quite often they come with very limited information. Sometimes they come with very detailed information. We do try to get more information when we can, but we can't always.
You do have in front of you two notes for file which relate to both of the incidents which have been obtained on freedom of information, both of which I think do draw a conclusion that they were as a result of the COVID vaccination.
No, that is incorrect, Senator. If they were as a result of vaccination, we would have put an announcement. They were not concluded to be associated with the vaccination.
So these were just
Senator.
a 7 and a 9-year-old who just died of... How often do 7 and 9-year-olds die of cardiac arrests?
Unfortunately, it's not as uncommon as you think.
Really?
So, yes. So, in fact, if you look, especially in associated with sporting events, somewhere between 1 and 200 Australians die of what we call sudden cardiac death, under 30, so admittedly they're often people in their teenage and 20s, but sometimes they do go younger. They are rare, but they're not unknown. You have over 100 people, often they're football players on the football field.
So why is it then, or in fact, were the death of these two children relayed to ATAGI at any time thereafter? Because I believe these happened very early on in the vaccine rollout.
It's TGA's responsibility, again using an external vaccine safety investigation group, to determine causality. The external group is when there's questions around the case. So as we've indicated in this place before, there is, in each of these, we're looked at by 3 separate doctors, including a senior doctor, as you'll see from the redaction. The words MO mean medical officer, and this is someone who's trained and registered in Australia, but reviewed each of these. They were not seen as being associated with vaccination. That is incorrect, Senator.
Can I follow up on Senator Antic, Chair?
He's got 37 seconds left.
He can,
so it's up to Senator Antic.
yes, Senator Roberts.
Freedom of Information request 3727 from Queensland. Dr McCann requested causality assessments for all of the reported deaths in the Dane database, which on negotiation was reduced to 11 documents, of which 10 related to Dane death reports. These documents showed the TGA had assessed as causally linked to COVID vaccines deaths that are not included in the 14 deaths from COVID injections, including the 9-year-old and the 7-year-old.
Senator, the statement you've just made is false. Absolutely false.
It's in a Freedom of Information request.
Yes, and it's absolutely false. Go and read the Freedom of Information and see what it actually says. We have reported every death that has been associated with these vaccines. Why on earth would we hide a 7 and 9-year-old?
That is the question.
That is the question.
We are not. We have not.
You're sounding very defensive about it, Professor.
No, I'm not very defensive. I actually have the FOI in front of me.
Senators,
and we're deliberately
We'll come back to it in a
okay.
minute.
The committee suspends. Broadcasting is off.
A causality page, assessment, causality determination, causality for the 7 and 9-year-old.
Senator, you're misunderstanding basic English. So causality is...
Senators, I'm about to... The committee suspends. The committee suspends. Resumes. Senator Rennick has the call.
It does say causality here at the bottom of these two statements. Okay, so my question is, okay, so at some point the AEFI assessment team has said causality. Now, the other assessment, can I just finish? Just finish my statement?
Sorry, Professor Skerritt. Senator Rennick is entitled to ask his question in silence, and then you will give your answer in silence.
Of the 10 that we've seen, some say awaiting causality, and some say it's not causality, right? There's 4 that say, one's got a question mark, but the other 3 say causality. So my question is, why did these particular ones with causality have causality, and then who has overruled that and why?
Senator, causality is a heading. That's why I was trying to explain the way it's used on the form. So you have a decision. And so let's use the example that you've quoted at me, because I have the form in my hand. And it says causality. And then the next dot point under causality is WHO unable to be determined, unclassifiable, because of lack of information. So causality is the heading, Senator. It is not the conclusion.
It actually says decision, causality.
It says decision, dot point 1, and I can table this with the chair. I have the document in front of me. Decisions, dot point 1, causality, then WHO, unclassifiable, unable to be determined. That's what it says, in black and white.
Okay, you previously described cardiac arrest as a heart attack. They're 2 separate things. Do you know the difference between a cardiac arrest and a heart attack?
But look, there's a range of different conditions.
Yeah,
Sorry, Senator Rennick. Professor Skerritt.
Yes, so thank you. So this was a cardiac arrest, but it is not. It was not determined with the information given to be related to a vaccination, as I've said again. And so what I feel is absolutely wrong that you're saying is that somehow this form said that it was causally, 2 L's, causally related. The form did not say that, I swear on my mother's grave, right?
Okay. You've got your point across.
Thank you.
So you just said myocarditis doesn't lead to heart attacks. Does myocarditis lead to cardiac arrest?
There are cases where people who have had myocarditis have an increased prevalence of a range of other cardiac conditions, but to say it leads to cardiac arrest is misleading, especially given that most myocarditis associated with vaccination, and indeed there's a recent publication from in a top medical journal by Nordic scientists, is much milder than myocarditis after COVID infection or other forms of viral myocarditis.
I'll dispute that, but that's not what I'll dispute right now. My next question is, there's a 21-year-old female who died from the Moderna vaccine. She had an antiphospholipid syndrome, which is an autoimmune disease. Now, the vaccine was never tested on people with autoimmune diseases. Why haven't you put a warning label on the actual vaccine to warn people that if they have an antiphospholipid syndrome, which is 1 in 2,000 people, higher than the rate of multi-inflammatory disease that you've said 1 in 3,000, why haven't you put a warning label on the vaccine to warn people about that?
Senator, again, I've got to pick you up on your science. First of all, antiphospholipid syndrome is actually even a bit more common than that. It might be 1% of people. So it's a considerably common condition. And because it was a common condition, early in the rollout of the vaccines, it was indeed studied whether people with antiphospholipid syndrome had an increased risk after vaccination. And there were international studies carried out, published in the world's top medical journals. A study using Italian patients, a study using Turkish patients, and I believe the 3rd study was done in British patients. And let me just quote from one of them. The COVID vaccine does not increase the risk of thrombolytic events among patients with antiphospholipid syndromes, according to study results published in Rheumatology. Rheumatology is a top journal which would cover people with antiphospholipid syndromes. I then go to the patient group. There's actually a patient support group in the UK for people who have antiphospholipid syndrome. And I will read from their web advice to patients. There is no evidence to suggest that patients with antiphospholipid syndrome were at increased risk of complications from the available COVID vaccines.
Okay, thank you. So you said in a press conference that Moderna would provide 100% protection from death. Well, in this particular case, it didn't.
Senator,
you said it would provide... I haven't finished my question. Don't interrupt.
Well,
you said it would provide...
Excuse me.
Sorry.
Senator Rennick is entitled to ask his question in silence. Professor Skerritt, I will give you an opportunity to respond in full.
You said it would provide protection from infection for 93% of the people for up to 6 months. You were wrong. Will you retract that statement?
No, Senator, I will not retract that statement because at the time, once again, you've quoted me out of context, and I would suggest deliberately, Senator. If you go back to the record of that press conference, Senator, it was quoting the clinical trial results as published in the New England Journal of Medicine as I stood up with your former colleague, Minister Hunt. And when I stated that, I stated, here are the results from the New England Journal of Medicine from a clinical trial that showed 100% protection against death in that clinical trial. So I stand by that statement because that paper stands in the New England Journal of Medicine, which is one of the world's top 3 medical journals. So I stand by that statement. But you have somehow reworded it, Senator.
Excuse me.
I'm quoting your own words.
Senators, Senator Antic on a point of order.
I want to raise a point of order. The Professor has clearly impugned Senator Rennick's motives for this from saying he deliberately misquoted something or misled him.
Well, I think that's a fact.
Sorry, point of order for you as well, Minister.
To raise awareness of the risks of the Moderna vaccine.
Senator Rennick.
You are projecting misinformation and then challenging it when it's met with factual answers. That's what's going on here.
This is on the record.
Make no mistake, we're all aware of what's going on. The evidence and facts doesn't suit your narrative. It doesn't suit your narrative. I've been watching you. I've been watching you scoff. I've been watching you roll your eyes.
Senators and Minister, I will suspend the committee again if I cannot bring the committee to order. This will take a very long time if every few minutes I have to suspend. The committee suspends. Broadcasting can be turned off, please.
Thank you. Is this your last appearance, Professor Skerritt, before estimates? I was going to...
I believe one of the senators said, let's hope so.
Well, no, I was just going to say, I'm sure you're going to miss us. So, like, anyway...
Senators.
Professor, I have some questions in relation to the issue of vaping, which I've raised previously with you. At the last estimates, the TGA took on notice the membership of the Ministers' Roundtable on the review into the regulatory regime around nicotine vaping products. And I've looked at the list, and most of the organisations on that roundtable were formerly proponents of the current regime. And it's a regime which has delivered a black market that makes up at least 90% of the vaping products sold in Australia. Why have these same organisations been drafted in to fix a mess of their own making?
Senator, I won't describe it as a mess of their own making, but the particular invitees to the round table were determined by the Minister and Minister's Office, not by the TGA.
Okay. Why was there not a single representative of the retail or pharmacy sector on the round table?
Again, we were not involved. This was a meeting coordinated by the Minister's Office. The TGA was not involved in sending out invitations or whatever. I understand the Ministers had meetings with a range of stakeholders, including the retail sector and so forth, but those questions would be best directed to his office. We didn't organise that meeting at the TGA.
Okay. Well, Minister, I might put the question to you. In relation to the round table, as you're representing the Minister, why wasn't there a single representative of the retail or pharmacy sector?
Thank you, Senator McGrath. I probably have to take that on notice. I wasn't involved in the invites for the round table. I'm sure it's just the first of many consultations that the Minister for Health will be having in this regard. So if there are people that want to engage with the Minister, I'm very happy to facilitate that request. I'll see if I can come back to you, Senator McGrath, with any further information.
Professor Skerritt, what were the recommendations of the round table?
The round table didn't produce a list of recommendations as such. There's not a record of meeting. I was present at the round table. It was mainly researchers and others such as the Australian Medical Association and RACGP, who either talked about their own research experience, particularly with a focus on youth vaping, and also doctors talking about their experience with people with smoking cessation, but there is not a communique from that roundtable to my knowledge.
Okay. Well, I think, Minister, that's probably a good reason why to have representatives of the retail and pharmacy sector there to assist
Look, I
taking
think there
forward.
is, I mean, clearly I've had a number of discussions with the Minister about tobacco and vaping control issues and interest in, particularly in what's happening with vaping. I think anyone who has high school students at the moment knows how prevalent vaping is becoming in schools, and the risk that young people are doing to their health by engaging in vaping. So I would see it as the first of many engagements. Senator McGrath, I think this is obviously an area where there's growing interest, where more research is coming out, so we are more aware of the harms that are caused by vaping and a growing concern in the community. So I would imagine there's going to be many more engagements on this issue, and I'm very happy to make sure that the groups that may have gone to you wanting that engagement are put in contact with the Minister's office.
Now, just referring to question on notice number, I think 124, the TGA submitted that 2.63% of its 2022-23 budget is forecast to be spent on regulating nicotine vaping products. It is also stated that it does not collate resource allocation for any other therapeutic goods except nicotine vaping products. Is that correct?
Yes, we don't sit here and say, well, this year we're going to spend this much on heart pacemakers, this much we're going to spend on anti-diabetes drugs. So we keep a close track on how much we spend on vaping because we've got to resource it through retained earnings and reserves and so forth at the moment.
But I suppose, and this goes to the Minister's contribution before, would you think that Australian parents would accept that $4.5 million to regulate vapes is sufficient when over 90% of them, of 90% of the available vapes come from the black market, and schools are awash with such disposable vapes?
Look, you've asked me for an opinion which I won't give as an official, but I do know that government, and I'm sitting next to the Finance Minister, are currently considering the level of resourcing that government needs to apply to what is probably emerging as one of Australia's most significant public health problems. And so I know that in the weeks and months to come it will get a lot of attention from Government, Minister.
Thank you, Senator McGrath. Minister, did you have a response to that? Or no? Okay.
So, I've got another block coming
I'll come
up.
back to you. I'll
yes,
circle
thank
back
you.
round. Senator Hughes.
You guys consider.
I understand that there's some concerns, and I share those concerns about the product labelling of vaping products. Do you think that vapes that promote fruity flavours may appeal to children?
Again, you've asked for an opinion, but I think...
Well, yes or no?
I think that most commentators would say that fruity flavours do appeal to children.
Okay.
And indeed, there's been some surveys and literature research to that effect.
Yeah, okay. So I've got some fruit-flavoured nicotine gum here. It's a fresh fruit sold in supermarkets, just a couple of aisles down from the confectionery aisles where kids can easily see them. I've got a spray here. That's a fresh mint flavour. There's also raspberry. So are these products from Nicorette also trying to entice children with fruit flavours, considering they're available in a supermarket?
No, for a couple of reasons, Senator. Firstly, and I'll use a scientific term, the pharmacokinetics, for example, in other words, how quickly the nicotine's released into the blood is very different. So people using a vape or a combustible cigarette get a hit of nicotine into the brain. Using your gum, since you brought props in, the one below, using your gum, it slowly releases a low level of nicotine into the blood for a longer period of time. The fruit is there because in the gum, the nicotine does have a bitter taste. That's very different from something that would make a smoking-like behaviour attractive to others, such as children and adolescents to whom it wouldn't. And as I said, there's extensive literature, and in fact, even published work recently on surveys of 14 to 17-year-olds quote the flavour as one of the attractions. I don't think that the flavour is generally rated as an attraction for people as to why they're wanting to give up smoking using Nicorette gum.
Sorry, it's not a flavour.
I think people are using the gum to give up smoking. I don't see hordes of 14-year-olds outside Woolworths raiding the shelves because they really like the flavour of that gum. I think
Okay.
they'd buy Juicy Fruit instead.
Okay, so Nicorette also has a product, and I've brought in some of their pods.
Senator Hughes,
No, I'm entitled to ask questions, and this is...
yes, you absolutely are entitled to ask questions. These are hard things to table.
I'm getting there.
So if you could perhaps provide a descriptor of what you're using, the rest of the committee is...
Okay, Nicorette gum, you can buy it in your supermarket.
Please continue with your question.
We got given one of these mists in from the healthcare products, came round to our office in a bag.
Fruit-flavoured tobacco products were very clearly a marketing tool used until they were banned at children and
so,
young people.
Minister, I'm coming to this.
Well,
I'm
but
coming to this, if you'd let me
very
finish.
commonly known in public health circles.
Senators, people asking questions have a right to be heard in silence. People answering also have the same.
Yeah.
Minister, continue, and then Senator
I just
Hughes.
wanted, because, you know, when you look at tobacco control measures, they've had to respond to the marketing techniques of big tobacco. And it's
Who's
similar, well, the big tobacco companies.
Legal
that have,
tobacco companies, you mean?
Yeah, but we also know that
You don't like
tobacco,
them, make them
consuming
illegal.
tobacco causes harm, and when you're marketing those products directly to young people, remember when they used to put out cigarettes in the shape of an iPod packet as well? I mean,
No, I
these are
don't.
common, well, they did, and they got banned as well, for good reason, because it was targeting a product that causes harm to
Are
young
we
people.
talking about cigarettes or vapes now?
Well, I'm
Because I'm talking about vapes, I'm not talking about cigarettes. I'm talking
but
about
I'm
tobacco
telling you
harm
that,
reduction tools.
that dressing up products to make them attractive to young people is a common, actually outside of public health circles as well, a common marketing tool to pull in young impressionable people to consume and become addicted to products, which is exactly what's happening with vaping as well.
Well, hence Happy Meals, I guess, as well. So, Professor Skerritt, this is a Nicorette inhaler. Now, I bought this inhaler. Quip.org tells me to use it and how to use it. I should take short, shallow and frequent puffs of the inhaler, and then I need to take about, and these are quotes, 8 to 10 times as many puffs on the inhaler as you would for a cigarette. So that's about 60 to 80 puffs. Now, this is my prescription vape that I get. It's an Australian product. It's regulated. It comes in a pod form. To get a similar sense of a cigarette, it's 1 to 2 puffs as opposed to 60 to 80. It suggests these products really, in the way that they operate, are very, very similar. And because actually on Nicorette's website it says that this inhaler replaces the hand-to-mouth action of smoking in the same way a vape
Senator Hughes, I'm
mimics
loath to interrupt.
the act of smoking. So
Senator
would it not be
Hughes,
true that
Senator
vape
Hughes,
actually
Senator
acts-
Hughes, I'm loath to interrupt, but I've received advice that as Senate estimates is effectively a substitute forum for the chamber and props are not appropriate in the chamber, it is not really appropriate for you to be using the props as part of your questioning. I'm asking if you can perhaps adjust your questions to still get the answers you need without referring to a use of props.
Sure. So Nicorette's own website recommends children under the age of 12 don't use this product, considering they're available in a supermarket. Does the TGA, and if you need it, it's highlighted, which I can table, the insert from the Nicorette inhaler, does the TGA support nicotine retailers, implying that it's okay for children who are 12 and above to inhale flavoured nicotine?
Senator, just to respond on something related to that, it is not appropriate or valid to say that a nicotine vape is identical to a
Nicotine inhaler.
TGA-approved nicotine
I've got a
inhaler.
thesaurus.
Have you had a look at the concentrations of nicotines in the products?
I have
in the
had.
total?
Well, you know what? I actually can have a look. I can have a look
Senator
at the.
Hughes, Professor Skerritt.
I got asked a question. I'm happy to answer.
But that's actually not how this forum works. As I've said multiple times over the last 20 years or however long this session of estimates has been going, this forum works really well when people ask questions, the questions are listened to, answers are given and those answers are listened to. The questions need to come from this side.
All right, so
Senator Hughes, this is your last question, then I'm rotating
Yep,
the
and then
call. I will
have
come back
another
to you
block.
if
So
required.
Professor Skerritt,
Senator
to the point
Hughes.
of your question with regards to nicotine concentrations, because I do use an Australian-made regulated vape that I purchased the pods, I actually have all the information with regards to the concentration of the nicotine in it. Now, you and I participated in an inquiry where we recommended, Senator Canavan and myself, a regulated market so that Australian consumers would be able to access vapes as a smoking cessation tool over the age of 18 with clear information, as opposed to the black market that's currently operating at 90% because of the failed prescription model. So, would it not make sense to have a vaping, which to go between vape and inhaler is splitting hairs in the most ridiculous of way, would it not be then more appropriate to have a regulated Australian manufacturing and managed vape market where consumers actually can see the quantity of nicotine that is in the vape, as well as provide protections that they're not being sold to children in formats that I can show you later, I think are more dangerous than the pod that I have if it was to be consumed by a young child.
Senator, the premise of your question, that underpin your question, that the behaviour of a TGA-approved Nicorette inhaler is precisely the same as that of a vape is something...
A regulated vape I'm talking about,
It's
not a
something we
black
do not
market
agree
Senator
with.
Hughes, Professor Skerritt...
I'm being taken out of context.
Senator Hughes, I will suspend the committee. Professor Skerritt has a right to have his answer heard in silence, as I just reminded him that you had the right to ask your question in silence. Professor Skerritt, please continue with
Thank
your
you.
answer. I will return to you, Holly Hughes. Senator Hughes, sorry.
I don't agree with your fundamental premise that the two products are the same. In fact, they're very different. Having said that, nicotine-containing vapes are legally available for the purpose of smoking cessation, and the intent of government is that the products are available through a prescription for smoking cessation, but nobody wants youth and adolescents to take up nicotine addiction. As I've said there, while we're seeing smoking levels dropping in this country, the total nicotine use in this country is doing something it hasn't done for 50 years, and that's going up when you look at the total amount of nicotine that's going into people's lungs.
Thank you, Professor Skerritt. Senator Waters has the
Muddy
call.
waters.
Senator Waters.
Thank you. I've got some questions about advertising for termination medication. In December of 2022, Google rejected an application from MS Health to advertise its clinic and the availability of MS Two-Step. Google considered that the ad was in breach of the Therapeutic Goods Act and that no exemption had been provided by the Secretary of the Department of Health to allow the ad to run. Ultimately, they revised the ad and then it was allowed to run, but MS Health remains concerned that the ad was rejected initially, given that they'd been running similar ads for years. So I'd like to know specifically whether any advice was sought either from the TGA or from the department by either Google or MS Health relating to the ad. And perhaps it would be helpful if you could succinctly provide an overview of the TG Act's restrictions and how they apply.
Well, to answer your first question first, Google was in error. The advertisement, as I saw it, did not breach the requirements of the Therapeutic Goods Act or the Therapeutic Goods Code. Following contact between Google and the Assistant Minister's office, we provided advice which was relayed to Google saying this ad does not breach Therapeutic Goods Code or Act, therefore obviously it's up to them working out whether they want to run it, but there weren't any issues relating to us. I understand that within hours the advertisement was placed again. To answer your second question, essentially when it comes to advertising, prescription medicines and MS Two-Step, or RU486, the medical termination drug, is a prescription medicine. And advertising of, unless if there's very limited exemptions, advertising of prescription medicines is not permitted in Australia. So it would be illegal for anyone, including Murray Stopes, to advertise a named product in social media or in other forms of advertising, but it is not illegal for them to advertise a family planning, a pregnancy termination or sexual health services. Does that answer your question,
Yes,
Senator?
thank you, it does.
Thank you.
So did Google ask for advice, or did MS Health step in and ask for
I don't
assistance?
know the sequence of who asked who. They didn't ask us for advice before they made the initial decision,
Okay.
but we did provide advice that it was not breaching the Act or the Code after we were asked to provide advice. But it was just an unfortunate misunderstanding potentially for someone new at Google.
Okay. Has any application been made to the Secretary to permit the use of otherwise prohibited advertisements relating to MS two-step?
No.
Okay. And has any requests been made to revise the restrictions on advertising to ensure that there are opportunities to inform the public about medical abortion options, given the limited timeframes for when they're available?
No request at this stage. There is, related to that though, we are currently, and this is in the public domain, we have before us an application from Murray Stopes to liberalise the training requirements for dispensers and prescribers.
What timeframe are you operating to on that request?
I may ask our Chief Medical Advisor she's over there, to talk to that. We're currently negotiating with them about the scope of that.
Okay.
Yes, we've not had the... Sorry, I need to turn this on. I just need
That's
to...
fine.
Oh, it's fine. Thank you. It's my first Senate estimate. It's Professor
Welcome.
Skerritt's last.
Welcome.
Thank you.
Yes, sorry about
Fabulous.
all the
Thank you.
kerfuffle. Have a stiff drink when you get home.
Don't you worry. So yes, at the moment we have an application from Murray Stopes with us for amendment of the risk management package that sits alongside the prescribing of the drug and also the product information. We are still in the stages of finalising what that is going to be. We've made ourselves very open to Murray Stopes for conversations about what that will look like ultimately, and we've also offered them a reassurance, very rapid review once that's with us in its final stages.
Okay, I'll come back and ask about that in future estimates.
Sure.
And that's it for me for now, Chair. Thank you.
Senator Waters. Senator Reynolds, you have the call.
Thank you very much, Chair. And good afternoon. Professor Skerritt, it's good to see you in person rather than down there on the screen in front of us. I've got a few questions following up on Lyme disease. So conversation, there was a few of us, and it might actually be for the Secretary. So the numbers were 52 and 406. So I just had a number of follow-up questions on Lyme disease.
Or you can try and put them to Chief Medical Officer.
And if not, I think there's no question most of them will need to go on notice anyway.
Yeah, sure.
But I did get some very comprehensive responses back last time, thank you, and I've just got a few follow-up questions on that now. The first one, which obviously you don't have in front of you, is about the CSIRO tick survey and some additional information you provided. So the first question on notice would be, could I get a more detailed understanding of how the $2.347 million is being spent? It's obviously a very complex and longitudinally time project. So if I could get more information about that. Second question is, they talk about part of the process, the laboratory validating microRNA markers. If I could get some more information about how long that takes. And they also talk about a larger patient cohort, but the response didn't say how many there was in the original part of the review and then what that's expanded to. So if I could get that, pretty much if I can get the project timeline so we can see how long and what's occurring across that. The third one is what methodology has been used to correlate disease severity and duration for tick-borne diseases. Another question is, are RNA biomarkers found only in acutely ill patients or also in chronically ill patients? One of the things that's been put to me by the Lyme Disease Association and people who've still suffering, many years after tick bites, is it possible to get more visibility of that project so that as they go through and have staged findings, rather than waiting 3, 4, 5 years to do anything more, whether there are things that can progressively be implemented. And in terms of medical outcomes this year. And if it's not possible, if they could explain why. Now, as I understand it from the answers I got back, the CSIRO study has already shown in the cohort of patients, again, we don't know how many, that there are a set of microRNA biomarkers present in people who've been bitten by a tick. So if we could get some more information about the nature of those biomarkers. And it was clear from that response also that they're looking at an Australian Borrelia strain. Can we also get, and there's been additional research done overseas, so if we could get some information about how that's being incorporated into this study, and are there some things that have been learnt overseas that rather than waiting several more years, if we can look to, and again maybe that's where perhaps the TGA comes into drugs and therapies, and part of that, are you looking to extend that trial, and if so, how long? And final question, at what point of knowledge will the department consider it appropriate to remove the DSCAT label from people bitten by ticks in Australia?
Well, thank you, Senator. That's quite a long list of questions.
A long list of questions. Well, I thought it might be better to take it on notice.
I will take on notice. The major question you asked, which led to the ones that you mentioned in the replies, was have we completed the task that was set the department was set to in relation to the Senate Community Affairs Reference Committee inquiry on what at the moment we will continue to call debilitating symptom complexes attributable to ticks, and that's what has been agreed.
I think it's easier for us just to say tick bites.
Well, that we have DSCAT is what we've been using, and that's what we will continue to use. The short answer to your question was have we fulfilled all of the various recommendations of that committee, and I can report to this committee that all of them have been completed. You've mentioned a range of things that are ongoing, particularly that CSIRO work, which is fascinating and interesting and will continue, and I'll undertake to bring back further information in relation to your questions.
Thank you. And so thank you for taking all those on notice. And as you know, there's a very large community, there's still arguments between the medical profession and people who absolutely believe they have some form of tick-borne illness. So if you can, so yes, you've delivered on all of those things, which is good, but people who are suffering from those illnesses aren't seeing any benefit. I mean, there's no change to how they're treated by doctors or not treated. In fact, in most cases by doctors here in Australia. So if you can give them a bit of a time, so what questions are really designed, can you give them some hope that through what you're doing here, what CSIRO is doing, what the timeline is, when they might be able to see some benefits and outcomes from that in terms of their own treatment, so they have to stop going overseas and being vilified by doctors here. I know you don't necessarily agree with that, but I've seen plenty of evidence of it. So that's really what it is to make it more visible and to give people hope that there is a pathway forward here in Australia to treating tick bites illnesses.
Well, I wouldn't want to overpromise and under-deliver on that, Senator. This has been going for a long time, as you've mentioned, and all of the issues that have been talked about. Yeah. We've spent the government, or the previous government and this government have spent money in relation to this matter. Over $8 million has been allocated in funding for research into tick-borne disease through CSIRO and others.
I understand that, but for people...
I'm happy to come back to you.
I just wanted to... Thank you, Chair. I'll just finish with this, is that for people who actually have this illness, whatever it's called and how we're diagnosed, despite all of this activity, there's been no tangible change for them in terms of getting recognised and treated here in Australia.
Yeah, no,
and that's really the issue. It's the people at the heart of this.
I understand that, and I certainly acknowledge the people, and we've had a lot of correspondence as well from people that are in this situation. It's in. To be honest, all of that we've done, we really have not found anything very specific that we can grab onto to say there is a clue that we could create a new treatment or even a diagnostic test, unfortunately, in Australia. And the international we have to be cautious of using international evidence because it's a different ecology here in Australia. I know you understand this, and many of the people that you're speaking for also understand that. But we continue to be open to new evidence, and we'll continue to bring back the information through your questions to this committee.
Thank you. Senator Roberts, you have the call.
Thank you, Chair. Thank you for appearing today. Professor Skerritt, the discussion that was involving Senators Antic, Rennick and myself, could you resolve that, please, by giving us an unredacted copy of the document in front of you that you were reading from?
Senator, I believe that we cannot, for reasons of personal privacy. I understand that this issue has been to the Administrative Appeals Tribunal, and the Administrative Appeals Tribunal also confirmed that the documentation released was appropriate. So we take personal privacy very seriously, and also there are specific requirements within the legislation, within the Freedom of Information Act, that, for example, you don't put on a disclosure log information that could prejudice personal privacy. So we follow the requirements of the FOI Act.
So we respect privacy too, and so what about a private briefing with the doctor's name redacted?
It's more than the doctor's name. Given the process that's followed, we would not be able to provide you any more in a private briefing.
Well, we could see the document.
Well, we would not be able to provide any more than we have been able to release because of FOI considerations. If you want a private briefing on other matters, certainly through our Minister's office, it can be requested, Senator.
Sorry?
Well, happy to. Just to be clear here, Professor Skerritt, are you saying you cannot provide information to the Senate because of FOI restrictions?
No, we're talking about privacy restrictions.
I get that.
FOI rules have consideration to privacy issues.
But they don't apply to this committee. That we have separate. We do have rules around privacy, but they are not the FOI rules. I just want to be clear. As a Senate committee, we should maintain that we are not bound by the FOI.
You asked for a private briefing outside that, and again, in committee, we would have to take advice from the chair whether, because these are publicly broadcast proceedings, whether it prejudice privacy considerations.
Professor Skerritt, you're entitled to make a PII claim. So, and if to do that, you need to state the grounds and the harm to public interest, and then if Senator Roberts accepts that.
Thank you. Let's move on then.
Sorry.
Well, I think it should be referred to the Minister to make a public...
If Senator Roberts doesn't accept it, yes.
Medicinal cannabis. Medicinal cannabis has been legal through the Pathways scheme. The idea, I understand, is to keep it under control and therefore enable data. For long enough now to have some good data, can you tell me how many people have been admitted to hospital as a result of harm caused by legally prescribed and legally supplied medicinal cannabis in the last 3 years, please?
Senator, thanks for your question. We don't have the same information on medicinal cannabis adverse events as we have on approved medicines. Remember that the overwhelming majority, probably 98% of the 600,000 patients who have had prescriptions written for them in Australia receive medicinal cannabis through the unapproved pathways. And as a result, they're not a commercial sponsor, and therefore there's not the commercial requirement for a sponsor to report adverse events. So for any unapproved medicine, the level of information on adverse events is less detailed than the amount of information than if it were an approved medicine. So, for example, the data of adverse event notifications do not include reports for medicines that have been accessed under the Special Access Scheme, the Authorised Prescriber Scheme. We do have some information. We've had 178 reports of serious outcomes. Again, in many cases, these were with medicinal cannabis products used in people who are taken for palliative care. And in palliative care, the usual outcome is of course death. But we do not have a comprehensive safety database on medicinal cannabis because it's an unapproved medicine.
I thought that was the idea of putting it on pathways so that they could control the use and then assess it.
So the pathways require the prescriber to take medico-legal responsibility for prescribing it to that patient. It does not mandate the company, but because it's an unapproved medicine, there is not the ability in law through our Act for adverse event reporting to be mandated by the company.
Okay, let's move on then. all-cause mortality should go down after a supposed pandemic, not backfire and go up alarmingly after mass indiscriminate vaccination. What happened? Why?
So that has been looked at closely, mortality statistics within Australia, including by the the professional group, the Australian Society of Actuaries. And they've attributed the increase, I think it's a 13% increase, but Professor Kelly may have the exact figure in his head. 16, thank you.
That's up to the 30th of September.
Yes,
2022.
so that figure has been looked at closely by the actuaries, and they ascertain about half of it to COVID-related effects, COVID infection-related effects. They ascertain the rest to other effects such as I think was said earlier this morning, cardiac disease, perhaps oncology, if people, during the peak of a pandemic didn't go to their GPs early enough for a possible bump, and it's turned out to be a stage 4 cancer and therefore unfortunately led to death. If you don't have access to those statements from the Actuary Society, we're happy to provide them on notice. Now,
Yes,
actuaries are the professionals who work out likelihood and probability and causality for things like deaths, and so they have closely looked at these figures.
I understand.
Thank you. Senator Canavan has the call. I'm coming back around, so Senator Canavan.
Thank you very much, Chair. I just wanted to return to the issue of vaping. I thought I'd use my limited time here to take a quiz. Take a quiz that's available publicly on the New Zealand Health Department website. If anyone wants to.
Senator Canavan, as I've said multiple times during these hearings, this forum works best when questions are asked and listened to and answers are given and listened to. So I would encourage you to present whatever you're about to say as a question.
They're all questions. It's a quiz, that's exactly what a quiz is. But if you want to play along at home, just Google vaping, take the quiz. It'll take you to the New Zealand Health website. So my first question in the quiz is, how harmful do you reckon vaping is compared to smoking?
Sorry, is that a question for me?
Yes.
As I've said in this place before, I believe vaping is less harmful than smoking, but I have also equated it to being hit by a car as less harmful than being hit by a truck. You would not recommend someone who is a non-smoker to take up either vaping or smoking. However, there is evidence that for a proportion of individuals, short-term use of vapes can help them, for a proportion of them, can help them give up smoking.
Well, thank you very much for that. You've passed that one. That's correct, but although maybe partially correct, the New Zealand Health website says it's much less harmful. That's their answer. This is a quiz to help bust myths about vaping. It's very helpful. Thank you, Mr. Skerritt. Can vaping help smokers quit?
Well, that's not question 2.
Yeah, I'm not. I should have said. I've got 5 minutes. I've got 5 minutes.
Okay.
I can't answer all the questions.
Do you have 5 minutes? Let's use them.
If you give me a call back, we'll go through all of them. Great to see you playing too. You'll learn something, Mr. Gallagher. But go for it. Can vaping help smokers quit?
Thank you. Maybe we'll bring in a chocolate wheel next. So, vaping can help some smokers quit. It is debated among health professionals for proportion. There was a recent Cochrane review, which is one of the gold standards, that indicated that depending on the paradigm, it could be 4 to 8 out of 100. There are others who say that figure might be a bit higher, it may be 2 to 4 out of 100. I am happy for anyone quitting smoking, so I think it's great if 4 people, and that's why there is a prescription model for helping doctors with the oversight of their doctor, their family doctor, to give up smoking.
Is second-hand vapour as harmful as second-hand smoke?
I don't believe so.
Thank you. And that might be all I'll ask, because, as I say, I've only got limited time, and the other questions are quite logical. But you have passed with flying colours. I just wonder why then the New Zealand Health Department believes all that you've just said. In New Zealand, they do not have a prescription model. That's true. They have a regulated market for vaping. I've searched New Zealand media and I can't see the same surge in vaping in schools that we seem to be experiencing here in Australia. Have you at all, when's the last time you spoke to your New Zealand health colleagues about their approach to vaping and how it might
Well, we actually invited the New Zealand Ministry of Health and some of their quit smoking groups to provide, we actually hosted a seminar for Australian GPs and other interested people in Australia, sharing the New Zealand experience with them. we're actually criticised for that
Not
because we were
GPs.
seen as
I mean,
advocating.
when have you,
No,
at policy level, I suppose, I'm
So I've spoken with them. I'd have to take on notice the last dates, but I have spoken with them a number of times.
Yeah.
I think it would be worthwhile sharing with you the nicotine numbers within New Zealand. There is, what we're worried about is total nicotine use, and that is going up.
Sorry, I wouldn't normally
Senator
do that. This is
Canavan.
not my question. This is clearly not my question. And I wouldn't normally do it, Professor Skerritt, but I've only got 5 minutes, so if it's helpful, I didn't ask about it. I can go and collect that myself or get them myself. I just asked when you last met with them, and you've taken that on notice, so thank you for that. I note the Health Minister gave a speech last November where he said that, I won't read it all out, but he effectively said there was going to be a Health Ministers meeting sometime in January, and he did say the direct quote is that in terms of vaping, this is a priority area for us for strong action, but it will require coordinated action across a range of portfolios at both Commonwealth and state levels. Has that meeting taken place?
No, I understand it is in about a week's time, Senator.
Right, okay. And is there an agenda for that meeting at this stage?
I haven't seen it, but I assume there is.
You're involved in that meeting?
No, I won't be at that meeting.
Oh, is that because you're retiring or the
No,
TGA is
it's
not
a meeting. It's a meeting between ministers, and generally they may have a small number of officials present, such as secretaries.
But not the TGA?
But not a team of thousands.
They get a briefing from the TGA.
Yeah.
Okay, so some TGA officials will be attending.
Well, no, they'll provide
briefing. Yeah, that would be
briefing for the minister.
Thank you, Senator
Okay, all right,
Canavan.
thank
Just a reminder that Professor Skerritt has indicated he needs to depart for a meeting in 15 minutes. We're at an hour now. We've got a big agenda to get through, so if I could just encourage brevity from the committee to allow us to get to the other items I know you want to come to in terms of other agencies. Senator Antic.
Thank you, Chair. I want to come back to this issue of the 7 and 9-year-old children, Australian children, that died of cardiac arrests following injection with a COVID-19 vaccination. And I want to compare that example to the example of the 10th of June 2021 when the TGA convened an expert external vaccine safety investigation group with representatives to review 2 fatalities that occurred shortly after the immunisation of the AstraZeneca vaccine. Is the TGA, through you, trying to tell me that a group of TGA doctors sat in a room with a report of 2 Australian children aged 7 and 9 dying from cardiac arrest following injections, and the TGA did not feel any obligation to inform the public?
We attempted to get additional information. As I said, we have many reports which are very scant in their information. We do not feel that it's appropriate to inform the public when we have a report with a condition that nowhere else in the world. And you've got to step back and realise that there's been, in messenger RNA vaccinations, about 9 billion of these vaccinations given worldwide, including in Europe, including the US, and countries that have very good safety monitoring systems. And we're nowhere in the world, out of almost 10 billion messenger RNA vaccinations doses, have you seen cardiac arrest as a result of vaccination? And when we were unable to obtain further information on these particular cases, we would have felt it would have been alarmist and misleading to go and say, yes, look, there's children dying from this, because the evidence wasn't there to back that up.
And would have undermined the public confidence and reduced the willingness of people to... Indeed. So is it your position, therefore, that these vaccinations are still safe and effective?
Yes.
How many injections have you had, Professor?
I have had 4. I'll answer that personally. I've had 4, and I will have a 5th soon. I've not had COVID infection.
Would you be prepared to disclose your immunity register records?
I'm happy to. I've had both the AstraZeneca vaccine and I've had the Moderna vaccine, Senator. But,
and Professor Kelly?
I don't know what else.
Can I ask the same question of you?
I'm just electing to share that.
Senator, I think that's private medical information. I'm not going to answer it.
There's a very wide scope for estimates in that you can ask questions which go to government expenditure
well, hang on a second.
or the administration of departments. But
I'm more concerned for you. But
community responsibility
with the vaccine.
My vaccination is about keeping other people safe.
Well, I'm very concerned that the minister at the table doesn't understand the science behind it.
Thank you, Minister. Senators,
very clearly that
Senators, I will suspend the committee again if I cannot call you to order. The committee suspends. Broadcasting will be turned off. Everyone take a deep breath. I was actually making a point of order that there is a very wide scope for estimates, but your questions do need to go to expenditure or operations of government agencies. Could you please find a way to redirect your question in a way which complies with the standing orders? Senator Antic.
Thank you. Professor Kelly, as an employee of the Commonwealth of Australia, would you be prepared to disclose your immunity register to prove how many vaccinations you've had?
It's private medical information, Senator.
Which
but
Australians have been
I
required?
can absolutely disclose that I'm fully up to date.
With?
With COVID-19 vaccinations.
Which is how many?
Senator Antic, I thought I was quite clear that the scope of estimates allows us to go to questions which consider government expenditure, the operation of government agencies. It is a very wide scope, but it does not actually go to the medical history of individual witnesses at the table. Please rephrase your question in a way which complies with the standing orders, or please could we move on to a different topic?
Thank you. Professor Murphy, would you be willing to disclose your...
You're out of order.
I'm not... This is not a question directed to you, Minister.
Senator
I'm
Antic.
the minister at the table.
Senator
A
Antic.
minister at the table would be aware of the fact that transmission is not affected by vaccination.
Senators,
that is a concern.
the committee suspends and broadcasting will be turned off. Could we please have a private meeting, senators? Broadcasting can resume. Senators, we will continue with questions. Do we have Professor Skerritt? Okay.
Because he's had to walk down to the meeting.
But he will be back, Chair.
All right. So what we will do is we will move on with the program. We will resume with the TGA at another point in the program with Senators' agreement. Okay. Senators, we have a number of agencies to get through within this section and also the department. Senator Ruston, I understand, has a number of questions for the department, as does Senator Waters. So I'm seeking an indication from members of the committee as to whether you prefer to go there, or would you like me to work through the agencies individually?
I've got stuff for the department if you want to just...
Okay, let's do that. Senator Waters, I'm going to go to you first and then I'll come to you, Senator Ruston. Sorry, Senator Rennick. We are returning to the TGA later. We're at the department now.
Outcome one. Thanks, Chair, for the call. My questions are about women's health, in particular maternity hospital access in regional areas, the Women's Health Advisory Council, and if we've got time, the Australian National Breastfeeding Strategy. So thanks to the officers for coming to the table for those questions. Can I start off first with the access to the maternity units at Gladstone and Biloela hospitals in my home state of Queensland? As I'm sure you know, they've been on bypass for many months now, forcing pregnant people to travel significant distances to give birth. So I'd like to know whether the Commonwealth Department has any oversight of that situation, and in particular whether the Minister or the Department has been briefed by the Queensland Minister for Health or the Queensland Health Department, and if not, have you sought such a briefing?
Senator, I don't believe, we certainly don't have oversight over the operational aspects of the Queensland Health Department, but I don't know whether the officials have had any particular Chief Nursing Officer, Midwifery Officer is very interested in the midwifery services, but might wish to comment.
Senator Professor Alison McMillan, Chief Nursing and Midwifery Officer. I am in continuous contact with my colleague in Queensland, and as Chair of the Women's Centred Care Senior Officials Oversight Group, I am in regular communication with senior officials across all of the jurisdictions. The actual event occurring currently in Gladstone is predominantly an issue of for the Queensland Health Department, as it is they that are responsible for the service provision, but those systematic issues to which we are all familiar across the country in relation to workforce, we do work together to look for opportunities for resolution.
Thank you. So just specifically, has the Minister or the Department been briefed by the Queensland Minister for Health or the Queensland Health Department?
I'm not aware of whether that briefing has occurred, Senator.
Well, could you take it on notice, please, to ascertain that?
Yep.
Thank you. And has the Minister or the Department met with any of the community advocates working to restore maternity services in Gladstone and Billawheeler?
I haven't had any meetings with consumers.
No. Okay. Again, if you could just double check for me on notice, please. Has the Commonwealth offered any assistance to the Queensland Government to attract and retain staff in regional hospitals, particularly in relation to reproductive health services?
Well,
We
beyond...
have a general rural workforce strategy, Senator, which we're happy to talk about broadly across the rural and regional Australia.
And of course, the National Health Reform Agreement is where the Commonwealth invests, which states and territories then allocate to the hospitals services that they run.
Look, I'm conscious of time, and so I guess I'm specifically asking whether or not to ease the squeeze in maternity wards and to stop the bypasses, has any specific assistance been offered by the Commonwealth, as opposed to what the general structure and federal-state relations are, which I am interested in, but we're on the clock.
Okay, so I think the work we're doing with all of the states and territories, including but not limited to Queensland at the moment, is really about accelerating the international qualified workers, including midwives. Also looking at strategies for building the domestic workforce to address skill shortages. So these do actually operate over whole health workforce. It's not specifically targeted at maternity services in particular locations.
Okay, thank you. I'm interested in the national workforce planning strategies for the health sector again, as it particularly pertains to women's reproductive health. Is there any specific work being done on that, or is that forming part of the broader reforms that you've just outlined?
I think I might ask the Chief Nurse and Midwifery Officer to come back again, because we are actually undertaking work on a national nursing strategy, and I know that the Queensland Government has been looking at whether or not it should be leading development of a national midwifery workforce strategy.
Okay.
So, Senator, there is plans for a national nursing workforce strategy to get underway. We are ready and about to commence that work. We are just finalising agreements with all of the health ministers.
Okay. When will that strategy be finalised and start to see
Our
more
estimation
workers?
is, because of the amount of work required, because it of course is nursing is the largest health workforce in Australia, that it will take us somewhere around 18 months to complete the strategy, but that doesn't mean to say that there aren't, as my colleague has already outlined, a range of work already underway that relates to retention and recruitment, and also international immigration of health professionals, including nurses.
Okay, so I'm hearing that the Commonwealth doesn't really consider it its specific responsibility to address the urgent reproductive health needs of women. Is this an issue that you'll be prioritising through whatever policy means, or is it, again, you consider to be more of a state's issue?
I don't think that we would characterise it that way at all. We're very concerned about ensuring that all health services can be provided. We're working with our colleagues in state and territory governments across a range of health service delivery areas that have been impacted by workforce shortages, particularly following, the reduction in immigration during the pandemic. So, we certainly do think that it's important, and there is a lot of work going on. It's just that the work with our state colleagues is not targeted at particular clinical areas. We've got workers that we're trying to attract and retain to fill a lot of different clinical areas.
Okay. Will the Women's Health Advisory Council be tasked with looking at access to maternity care across Australia?
Hi, Senator. So the National Women's Health Advisory Council will have its first meeting on Monday. It's been, the terms of reference are broad and specify that it will go to kind of looking at 5 areas that are interrelated, but gender equity in healthcare and services, health equity and health literacy for women in priority populations, strengthening and diversifying medical research, health professional training and education, and implementation of the National Women's Health Strategy. So in terms of specific areas, one of the first things that's up for discussion by the council is where does it prioritise action?
Okay, so thank you. And I actually do have some questions for the council, but I want to know whether access to maternity care is specifically on their agenda. Would the answer be yes, because that's part of the implementation of the National Health Strategy?
So the answer would be it's encapsulated in the broad themes. Whether they deal with that issue first and foremost, particularly given the role of states and territories in those areas, I'll need to come back after the first meeting.
Okay, thank you. So I've got some questions for the council. Will you be answering those?
I will.
Yep, great. So just mentioned that their first meeting is next Monday. Has any preparatory work been done prior to that meeting to develop a work plan for the council?
So, Senator, as I've just mentioned, one of the first areas is for the council to determine what its key work plan is and key areas. In terms of preparatory work, one of the key evidence bases that will be used is a presentation on the Women's Longitudinal Study of Health. So that will form the basis of the evidence that informs the council, and members have been specifically selected from key expert groups, but also to include broad experts and inclusion in that advisory council. So I'm sure there will be a robust conversation about exactly what the priorities are. The council's in place for 3 years, but we would expect that the first meeting will determine what the first year's worth of discussions and meetings will cover.
Okay, thank you. So I did hear what you said about what the council's priorities will be: diversifying research, workforce training, health literacy, etc. Can you answer for me, please, specifically whether you know whether that work will include progress towards a national menopause strategy?
Once again, I can't commit to that
Not
at this
sure
point
yet.
in time, Senator,
Yep,
but
okay.
as you would know, it is a keen interest of Assistant Minister Carney and has been raised as one of the gaps in the research.
Yes. And likewise, investigating people's experiences of medical misogyny?
So in terms of gender equity in the healthcare system and services, I'm sure it will touch on people's experiences. The council, as I say, the first meeting will be Monday, but one of the things that I'm sure it will cover is how do we make sure that people have an opportunity to tell their stories in terms of their experiences of the healthcare system.
Okay, will additional funding be set aside in the upcoming budget to support the work of the council?
So the 22-23 budget actually included $1.6 million over 4 years to support the establishment of the Health Advisory Council and evaluation and monitoring of the National Women's Health Strategy.
So that was the allocation. There won't be any further one in the upcoming budget?
That would be a decision for government, but there has been an allocation made to support
Senator
the council.
Waters,
There has
I do
been.
need to move the call around shortly.
Oh, can I just have 2 more and then I'm finished on that topic? Questions? Thank you. Could you just say that last
Sorry,
bit
so
again?
the allocation of $1.6 million has already made to support the work of the council. Any further funding in terms of priorities and actions would be a decision for government.
Okay, thank you. And how will the council interact with the National Cabinet or the COAG health ministers? Will there be a standing agenda for the health ministers to get updates from the Women's Health Advisory Council?
So in part that is a discussion at the council, but I'm sure health ministers will be interested to hear on progress of the council.
Okay.
There's not a formal reporting line.
Okay. And likewise, interaction with the National Rural Health Commissioner, will there be any sort of formalised interaction there?
As you would be aware, the Rural Health Commissioner, Ruth Stewart, is very interested in these areas, so I'm sure she will be staying abreast of all of the issues and we will brief her accordingly.
Okay. And lastly, will the Women's Health Advisory Council be consulted as part of any future MBS review?
That I can't commit to, Senator, but that will depend on any future MBS reviews and anything that the council actually determines.
Okay, thanks for your help. Thank you, Chair.
Thank you, Senator Waters. We're going to Senator Nampijinpa Price and then to Senator Ruston. We'll be breaking it for Thanks.
Thank you very much. My questions are for the department with regard to a budget item. I refer to page 35 of the October budget paper number 3, increasing specialist services for children with harmful sexual behaviours in the Northern Territory. Can you please explain on what basis this funding was allocated?
We have to, can we just
We'll
check
need
with
to
our
check.
officials, make sure it was a health budget item? Was it? Yeah.
So we'll need to check the paper. Sorry, Senator. We'll check.
What
the-
page was it?
the item.
Page 3.
Page 35.
Page 35, paper number 3.
Yeah. We'll just quickly check, and we might be better if we could come back after the break with an answer to that. I'm not aware of it.
Oh, it's in the federal financial relations book,
It's in
is
the,
it?
sorry?
The federal financial relations paper of BP3, is that right? I'm just looking it up, that's all, I'm just trying. 35. Oh, 27, sorry. Do you have other ones while we try and get the relevant officials, Senator?
My questions are only specific.
Oh, sorry.
Secretary, to the questions I was asking before in relation to the Regional Cancer Treatment Centres and Radiation Therapy Program in Victoria and New South Wales.
Regional cancer treatment we can do.
It's a payment to the states, Senator. So it looks like my assessment of that part of the budget paper is that that's outlining programs where we are providing grants to the state and territory governments for particular programs. So look, it's essentially we provide the money, the state or territory under a whole range of those, as you can see in that booklet, then provide the service. But I'll see if there's anything further we can provide.
If you could elaborate on what, I guess, was there a report that suggested this was a requirement? I guess I'm wanting to understand
Where it came, yeah.
how it came about.
Yeah. I would imagine it's in negotiations with the Northern Territory government that they would come outlining programs that they need further support for, because it looks like you can see in the other programs in that booklet where it's payments, say encouraging more clinical trials in Australia, you can see there's payments going to Victoria, Queensland, WA, South Australia, Tasmania, all across all, and that program that you've asked about is specifically to the Northern Territory.
Correct.
Only, yeah.
Yeah.
So we're getting some officials to investigate it, Senator. It just might take a little bit of time.
Can you take on notice, are you able to explain what harmful sexual behaviours is?
We'll have to come back to you, Senator. We'll investigate this.
If
we
you can take
probably
that on.
come back with some answers after the break,
Okay.
if that
Yeah.
suits. Yeah.
If
We
you
just have
could-
to investigate, get the right people to check with the budget process, see what that was.
Yes.
It may be
would
that the program was defined by the territory government and we don't have a lot of details about it, but we will find out what we can and come back.
After the break?
Yep.
Okay.
But it is a health-related payment, so insofar as
Yeah, there
is
would be some.
oversight from the Commonwealth, it would be your
Yeah, we
department.
would have.
There would be some agreement in place for that.
We'll come back.
I'd certainly like to understand, because I guess I'd like to understand why only the Northern Territory is the only jurisdiction where this funding has been made available, and very specified, obviously, as well.
Yeah.
Yeah.
I mean, that in itself is an unusual, like if you look below, the National Coronial Information System is only a payment to Victoria. So there are these special payments that go to particular states for particular things, but I take your point and we will come back
after the break
with information for you. Yeah.
Okay, thank you.
They're usually on the website.
It's the opposition's time up until
So,
4 o'clock.
oh, there you
so-
go. Sorry, did we?
Yeah.
You go, Sarah Royston. Sorry, I thought we'd done.
I think you wanted the TGA, didn't you?
Oh, I can ask questions.
Look, back to the regional cancer treatment centres. Okay, so on a question on notice, and I gave you the number earlier, so hopefully you've got it up. SQ 22 000476, in response to a question that I asked you in relation to the $4.3 million that was for regional cancer treatment centres. I wanted to confirm whether the $4.3 million for South Australia is for the regional cancer centre in Mount Gambier in the limestone coast of my home state. And your answer was that a partnership agreement between the Commonwealth and South Australia is currently being developed under the Federation Funding Agreement framework as scheduled, etc., to deliver a radiation therapy facility at Mount Gambier to provide services for the Mount Gambier and Limestone Coast. The Commonwealth has allocated $4.3 million over 2 financial years to support the project, as reflected in the Federal Financial Relations Budget Paper 3 from the October 22-23 budget. I'm just seeking to understand where that funding agreement is. Is it in place?
Thank you, Senator. I'm Ms Bronwyn Field, First Assistant Secretary of Mental Health Division. We're still negotiating that funding agreement with South Australia at the moment.
Okay. So do you have any understanding about how long that's likely to take?
I don't have quite an understanding of how long it will take. It is advanced. So we're not at the beginning stages, but certainly there are still certain things to be finalised with the South Australian Government.
Okay. So can you confirm that the $4.3 million that's been allocated in your budget, 22-23 budget, is going towards the delivery of a radiation therapy facility at Mount Gambier in the limestone coast of South Australia?
So we're certainly working with the South Australian Government around cancer services for that region. The guidelines that we did for that program were broader than just radiation therapy. So my understanding is the proposal is probably broader than just radiation therapy. And
Can I draw your attention to the answer to the question? I'm sorry to cut you off, but I know that at this time of the week everybody gets a bit frayed. It says here the Commonwealth has allocated $4.3 million to deliver a radiation therapy facility at Mount Gambier. That is the answer to the question on notice that I have in front of me, and as I said, it's question number from 2022 000476. It's quite clear. It doesn't say anything about cancer treatment. It says to deliver, and I quote you, a radiation therapy facility at Mount Gambier. Are you telling me that that is no longer the case?
I certainly want to be very clear, Senator. We are working with the South Australian Government. We're looking at a range of options to ensure that we have a viable service, which will include support for radiation therapy cancer patients, but we are looking at broader services and how we actually can viably deliver the services. So while the Quan, yes, and I certainly need to say that it does say that, certainly see that in black and white, but it is something that we are looking a little bit broader to ensure that we're providing viable services and broader cancer services to that region through this money.
So, I'm sorry, the people of Mount Gambier have been promised a radiation facility as outlined by the information that has been constantly provided to that community. I now hear from you that that's not necessarily what's being delivered. Has anybody told the people of Mount Gambier who have been publicly promised this radiation facility that there seems to be some backpedalling going on here?
I might just go back a step because we actually did do a approach and a competitive approach to market around looking at what services could be delivered. There was a proposal put in for such a facility, however it wasn't assessed as viable and that it would actually be able to be consistently maintained and also connected to other services in that region, which was one of the fundamental criteria to be met in the assessment. When we kind of went back to the drawing board, we decided to work with the South Australian Government to ensure those services would remain viable into the future and had the best chance of success. And the guidelines, as I've said, are broader than just a radiation therapy service, so we are working with South Australian Government about what their proposal is contained in that.
So, and look, I understand the difficult position you find yourself in. This is no criticism of you whatsoever, please. It appears from the correspondence that I also have from the South Australian Government is dictating how this money is being spent, because they're saying that it's actually the Limestone Coast Local Health Network who are suggesting that they can't do this. And I'll tell you why they're saying they can't do it. They can't recruit specialist staff. So I would say that is a fundamental challenge about dealing with recruitment and retention of healthcare staff in rural and regional Australia. We can't just walk away from this because it's too hard. The maintenance of equipment, once again, this is just complete neglect by the South Australian Government of rural and regional South Australia. And, clinical oversight requirements. So I suppose maybe if we could get some more information about what is driving the decision that was previously made to support this radiation facility in Mount Gambier, and the decision for the federal government to not pursue it. It seems to me that there is a level of dictation being given here to the federal government about how this money is being spent. I'm quite happy for you to take it on notice. I understand it's very detailed.
Will. If there's more detail, we can, but I just want to correct you around, I think you saying that, concerns that we're not going to deliver this. I would note that this is something that was promised in April 2019. So there's been quite a lot of time that you had in your last term to sort through this, which didn't happen. We've now come in, we're having a look at it. The approach to deliver as per outlined, I think, under the original commitment was not viable. So it has required further work to be done to work out what is the best way to deliver that service, cancer treatment to the people in Mount Gambier. But I think you would all agree that going ahead with a non-viable proposal just because it had been announced in April 2019 isn't the best way to ensure that communities are getting the services they need. So,
okay. Well, Minister, would it be possible then for the information that has been provided that has deemed this particular service that has been promised to the people of Mount Gambier as to not be viable, is that possible for us?
I'll have a look at what we can provide through that. I mean, it would have been, it was an approach after a competitive funding process, but I mean, I don't think anyone's got the motivation to say it was unviable just without actually having justification for that. But these things are difficult, in my experience from looking at how you put together regional cancer services, they are difficult to put together to make sure that you're providing the services you can to a smaller community, and making sure they are viable and that they can be delivered is pretty fundamental, I would have thought.
Well, first of all, I'd say this is not a smaller community. This is the second largest community in South Australia. But
yeah, I know, but you're talking about a reasonably high level of care.
I appreciate you come back to me with some more information. I don't need a lecture about it.
Well, I'm not trying to lecture you.
All right, Senators, this is a great time to go to an afternoon tea break. We're a few minutes over. Senator Ruston, could I ask, would you be prepared to share that letter from the SA Government with the committee? Are you able to table it, please? We will now go to an afternoon tea break. When we return, I'll be hoping to give officials some guidance on where we're going with the program, but we will suspend and be resuming at 4:20 p.m. I'll just take a moment to give some guidance to those in the room about how the committee has informally agreed to move through the program. We are returning to questions to the department under outcome 1 now. At approximately 6 o'clock, we'll be intending to go to the agencies listed in the same section as outcome 1 in the program, as well as the TGA. But I am going to some senators now. We had some questions for certain agencies which senators have agreed to put on notice, so we'll be able to dismiss those agencies now. So Senator Brockman.
Has the Health Practitioner Regulation Agency already been dismissed, Chair?
Yeah.
It has? Okay. The NH and MRC, I believe we can release. You've got questions? Okay.
You can't put them on notice?
For them that I need to ask him first, I can put the rest on notice.
Okay, the National Health Funding Body?
No.
We can release the National Health Funding Body. National Blood Authority, we can release...
No, I wouldn't say that.
Okay, we have a request for the National Blood Authority. OGTR we can release.
I've got one question for them too. Sorry.
Can't release the OGTR. The Commission on Safety and Quality in Healthcare. Happy to release? Release.
We'll take it. Yep.
The Australian Institute of Health and Welfare. Happy to release. The ARPANZA, we're happy to release. Food standards.
I'm relying on you, Jordan, to say...
No, I can put it on notice.
Food standards.
No.
Happy to release. And we will need the rest.
Okay. Thank you. Senator Ruston, you have the call.
Sorry, Chair.
Could we just respond to...
Yes.
Could we table, this is a matter that Senator Nampijinpa Price raised before. We just table the document, which is the agreement, the federal funding agreement, which does say health. I think that's with Northern Territory Health, for services for children with harmful sexual behaviours. Was an agreement that was entered into in early 2022, and the funding in the budget is for it appears to be 1 year of that funding, but the agreement and the detail of the agreement is here. So
it was an agreement established by the Attorney General's Department to support, so whilst it's a health funding thing, we were not involved in the negotiation discussion on it. So whilst the description is in the document, Senator, we can't respond to any questions about it because it was all negotiated by the Attorney General's Department.
Thank you. I just have one more, two more questions quickly. Would the department, can the department comment on whether it would be beneficial for a Royal Commission to be held into the sexual abuse of Indigenous children?
I think that calls for an opinion, Senator, and I don't think that's an appropriate question for officials.
I'll direct it to the Minister. Minister, would the government be prepared to support a Royal Commission into the sexual abuse of Indigenous children?
that's not the government's policy. As you know from the announcements that the government has been making in recent times, we are putting resources and time into responding to a number of issues, most recently and most particularly in Alice Springs. And the focus is really on getting those resources out and those programs, working with communities and providing the support that's needed in the near term.
Why doesn't the government support a Royal Commission into the sexual abuse of Indigenous children?
Well, it's a matter the government takes very seriously, but as I said, the Minister for Indigenous Affairs, the Prime Minister and the Minister for Health, a number of programs have been announced in recent times to respond to the near-term issues, and our focus is on getting those programs out and on the ground and working with local communities about how that is done to support local communities.
It's a fairly horrendous situation throughout places like the Northern Territory as well as Western Australia, given amongst Indigenous children we do have the highest rates of STIs within our own children. Would you consider one day reversing your decision and upholding the rights of the Indigenous children to live lives free of sexual abuse and establish a Royal Commission into the sexual abuse of Indigenous children?
Well, I mean, it's not the government's policy now. I'm not in a position to rule things out in the future on behalf of the government in any way. Of course, we uphold the rights of Aboriginal and Torres Strait Islander children to live lives free of violence and of sexual assault. But we are approaching this, acknowledging the very complex and years of disadvantage that have led to some of these issues that local communities in the Northern Territory and other places are facing. But our priority is genuinely to work with local communities to respond to local community need and to put resources in. And I know it's not just a matter of resources, money, but money does help. to make sure we're putting in place programs that respond to the needs of local communities. That is the focus. That's what various ministers are working on, and that's what our announcements most recently in relation to Alice Springs are focused on.
Minister, what would it take for the government to change their position to hold a Royal Commission into the sexual abuse of Indigenous children? There's children on our streets at night. My hometown experiences this every single night, day in, day out. There's so many children I know who suffer as a result of sexual abuse. What would take this government to change its mind to hold a Royal Commission into the sexual abuse of Australian children, Indigenous children?
Well, as I said, Senator Namatjinpa Price, and I can see and understand, how difficult watching local communities facing challenges are. I mean, I think everybody in this place most genuinely wants to ensure that we are supporting local communities dealing with varying and complex levels of social disadvantage, like 100%. I don't think there's one person in this place that wouldn't agree with that. Our focus is on making sure that we're doing something in the near term. I mean, that is the decision the government's taken.
I will continue to ask those questions. Thank you.
Yes.
Thank you, Senators. Secretary, before I come to Senator Ruston, if Arpanza hasn't left the building, could they please stay?
Well, we'll just check and see.
Yeah, someone from the Secretariat has gone round there, but
All right,
if they're listening. Senator Ruston.
Lesson 101 of estimates: if you get to leave, you run. Can I just ask some questions around the urgent care clinic program? Okay, just wondering how many of the urgent care clinic locations have been identified?
Senator, there were 50 locations identified at the time of the election. They were confirmed on the 1st of February by the ministers, so there are 50 confirmed locations.
And is that information publicly available?
We're happy to table it.
Is it possible to table it? No. And also the criteria around which those locations were chosen?
So the locations were chosen, as I said, they were identified during the course of the election. They were identified, as we understand it, on the basis of hospital emergency department pressure. And so the locations were identified and clinics established to relieve pressure on EDs.
My list from the election was 26. So were there 50, you're saying there were 50 identified in the election process?
There are 50 confirmed locations.
No, sorry, we're back. I'm just asking, were those 50 locations identified in the election? Because my list only had 26.
That is our understanding. They were all identified at the time of the election.
Okay, and you'll provide that?
We'll provide the confirmed list, and it
Okay.
was confirmed on the 1st of February.
Okay. So in terms of the locations, how specific are those locations in terms of their identification? Is it the clinic on the corner of 6th and 7th Street, or is a clinic that is going to be located in the electorate of Bean, as an example?
So the locations usually specify a suburb or, an area. It's matched to the relevant PHN and the relevant emergency department in that area. So, for example, Bateman's Bay, Lismore, Shepparton.
Okay. And you'll be able to provide that information?
It's about emergency department catchment areas.
Emergency department catchment areas. Okay, great, thank you. So in terms of the process from a geographic location to say that they're going to be in this area because that emergency catchment area is a high demand area, what is the process that happens from there?
So we have been working closely with states and territories, and we set up a senior officials advisory group at the request of the Minister and National Cabinet to work together around identifying and agreeing design principles which have been agreed, operational guidelines which have been agreed, which go to what do those urgent care clinics do, what kind of features do they need to have, what is the relationship with the local hospital need to be. And we've been working closely with states and territories around making sure that we've got a joint approach nationally to make sure that we either roll them out, and different states and territories have chosen a different mechanism for rolling them out. So, for example, some of the states and territories have asked us to make a transfer of payment to them for them to commission them under a federal financial agreement schedule.
They have.
And some of them have agreed that we jointly commission them through the PHNs.
Okay, so how many expressions of interest have been issued in relation to these 50 locations?
So far, there's been expressions of interest issued in Tasmania and in Perth.
Okay, so how many have been issued? So how many of these will be located in Tasmania?
Sorry, Senator Rushton, before we go to that.
Sorry?
Before we go to that, in New South Wales, there was also a joint EOI for urgent care services, which include these clinics, but it was put out by the New South Wales Government for a broader range of services. So 3 jurisdictions, there have been processes. In Tasmania, sorry, I interrupted your question.
No, please, you said Tasmania.
In Tasmania, there are 3 sites. The Tasmanian EOI has closed and the Tasmanian government's considering that.
Okay.
So Tasmania is being funded through a Federation funding agreement schedule.
So when were the EIIs open for Tasmania?
Just before Christmas, so in late December.
So when the Prime Minister said that there were 3 EIIs had been issued in Western Australia and they were the first 3 EIIs, that wasn't correct then, there already had been EIIs?
The first EOI is being issued through the Primary Health Network. So there are 7 sites in Western Australia. Primary Health Network has issued an EOI in respect of the first 3 of those 7.
Okay. What would be really handy, if it's all possible to save us going through it now, if you could give us the list of the 50 locations, a list of, from state by state, how they're intending to go, whether it's going to be through the federal government, through PHNs, or whether it's going to be done as a straight payment to the states and territories. If it would be possible to provide copies of the operational guidelines in terms of how they're intending to operate, the data match on the emergency department catchment areas, the process around obviously the selection of those locations, and given that, as I said, I only had 26 from the election, but clearly you're saying there were 50 from the election, so we've missed 24. So interested to know then, so how many of the 50 sites have got EOIs out at the moment or have got EOIs returned?
We may need to take that on notice in terms of the detail.
Yeah, so Senator, there's the 3 in Tasmania that have had EOIs returned. The New South Wales process, which isn't our process, it's a New South Wales process, but it called for interest in our process, has closed, but we're considering whether a second round is needed for New South Wales.
Well, as in a specific EOI for the purposes of the clinics as opposed to the broader issue? Okay.
Yes.
Yep.
And the Western Australia one is open at the moment for the 3.
3. So we've got 3 closed, 3 open, and some possibility that New South Wales may have moved somewhere. So how many of these clinics will be up and running by the end of May 2023?
So, Senator, in terms of up and running, that will depend on the response to the expressions of interest, which clinics are suitable, arrangements and payments. I think we had said at the last estimates hearing that we were looking to make sure that the rollout had commenced in terms of expressions of interest and, you know, the rollout of getting the urgent care clinics established.
Well, that's not exactly what you said at the last estimate, so I'll quote you, the commencement and rollout will happen this financial year.
The commencement and rollout.
And rollout, yeah. So once you've rolled them out, one accepts they're being operating. So I'm just keen to understand, you've got 3 EOIs in, you've got 3 EOIs out and some stuff around New South Wales. So I'm keen to understand whether you remain confident that, this is quoting you, will be up and running within the first year of this government, whether that's still something that's achievable.
So,
is that to me?
I mean, I don't mind. I mean, that was.
I don't know who you were quoting then, that's all.
Well, I could have been quoting you, but it was also a quote from the estimates as well.
I think you've got the update. We're making very good progress considering this is a new model of care. We're pretty pleased with how it's rolling out and with the very high levels of interest from both primary care and state and territory governments.
So how much money was appropriated in 2022-23 in relation to these clinics?
I think 21.5 I have.
21.5
22 points out of the 135.
Yep.
Yeah.
Okay. And how much of that 21.5 will be spent this year, do you believe, or is it too early to tell?
So I think it's too early to tell. It'll depend on the expressions of interest that we get in. But as we've said before, we're working very hard to make sure that we have the rollout commenced this financial year.
Yeah. So
and that's happening, Senator.
Yeah. So I suppose just to give me some sense of where you think this is likely to land in the next 3 months, you know, given what you know has to occur for these clinics to be rolled out, do you believe that they will, there is some possibility they will all be operational, well, let's say by the end of this financial year as was originally promised, or do you think that's not possible now?
So, Senator, as we've outlined, we are working really closely with the states and territories. We're working really closely with the PHNs. The commitment really focused on existing GP practices to ensure that you could actually look at how do you need to bolster them to become urgent care clinics, but you're not building from the ground up. So, as I said, we are working very hard to make sure that we have urgent care clinics rolling out across the country as quickly as we can with states and territories in partnership.
This is a priority for the government, so there's a huge amount of effort going into making sure we're making good progress against urgent care centres, and I'm sure we will discuss them again in May when we resume.
Well, let's hope you're here to tell me that you've actually got them up and running. But could you maybe tell me how many people, how many patients are you expecting to be seen by these urgent care clinics under their operation as urgent care clinics between now and the end of the financial year?
So, Senator, I can't tell you how many patients, but obviously these clinics are demand driven, and part of the funding is also MBS funding.
These clinics are
demand driven, so they will see patients, and the specifics of making sure the hours of opening, that GPs are on site, and their operating guidelines. We know that, and in working with the states and territories, we're particularly focused on what generally would be referred to as Category 4 and 5 presentations at emergency departments.
Okay, but so how many? I mean,
well,
I get...
It will depend.
It just depends on the... There's going to be different models of care, you know, different arrangements in place. That will become better understood in the negotiations for the agreements that will be reached through the EIO process.
No, I was actually asking how many patients you believe are likely to be seen this financial year.
well, I think we answered that. It
Yeah.
depends, doesn't it, on the final arrangements for what is agreed for each of the urgent care centres, and there's going to be slight difference between them depending on the arrangements.
Do you
that are
believe that
agreed.
any patients will be seen by urgent care?
Do I believe any?
This financial year?
Oh, yes, I would expect so. Yeah.
Okay, well, I look forward to asking you about that in May.
Excellent.
Thank you. I mean, I've got plenty more questions, but that's the end of that particular topic for the moment.
Senator Ruston, we're just going to Senator Pratt for 5 minutes. I'll come to you, Senator Steele-John, and then back to the opposition.
Thank you. I'm going to begin by asking if you're aware of the parliamentary inquiry in the State Parliament of WA into the Esther House Foundation, and if you've considered this in the context of the contract that they were given back in 2019 by the last government. You might need to take this on notice, but I would like to know what milestone payments were made and up until which point. Perhaps you have that information now.
Senator, it's Bronwyn Field, First Assistant Secretary, Mental Health Division. Thank you for that. We are aware of the inquiry that occurred in the WA Parliament about Esther. It was 2019. We put in a funding agreement with Esther. It was $4 million for the running of AOD services and a number of other services. We've paid out $2 million of that funding agreed to Esther, but suspended payments when they went into administration, and we've since terminated that funding agreement when they went into liquidation.
Okay, was that before or after the parliamentary inquiry was called?
I will have to double check on my timeframes, but I'm pretty sure it was before.
What work did the department do, noting that the parliamentary inquiry found serious abuses taking place that would not meet the current national alcohol and drug policy guidelines? What oversight did the department have to ensure that, for example, child safe principles were met and other standards that should be required were being met by Esther in delivering these services?
All of our funding agreements have standard clauses that all grant recipients need to abide by all Commonwealth, state and legislation.
Yes, no, I understand that. What I'm asking is what you did to uphold those, including the Child Safe Organisation principles, which are not just about employees and whether they've got a criminal record, they're actually about the culture within the organisation.
So certainly, when we put the funding agreement in place, they had to show that they would abide by safety checks and all of those things.
And how do you audit that?
The relationship management of the actual grant is through the DSS hub, and so they look at milestone reports to see if an organisation has met those milestones, and certainly keep scanning.
If you could take on notice a question as to what complaints were received either through the Department of Health or the DSS, and an assessment of what access any residents at Esther House or their families might have had to complaints mechanisms. Can I now ask what work the government might look to doing to ensure that funded and unfunded alcohol and other drug services are able to meet the national guidelines? There are many other such organisations still in operation.
So, Senator, in terms of broader alcohol and drug services, as you mentioned, there's the National Quality Framework now, which was released in December 2019.
Yeah.
It is part and parcel of any of our grant agreements.
Okay, and what will happen in the context of ensuring that both funded and unfunded drug and organisations that market themselves as drug and alcohol services, when they're not accredited, can't market themselves in that way unless they have a formal accreditation?
So, Senator, part of that responsibility is obviously a shared one between states and territory governments and the Commonwealth. We have the most direct levers in terms of the funded services that we provide funding for.
Yeah, can I put to you that you might also have a lever in terms of the fact that most of the clients of these services hand over their income via Centrepay, and that Centrepay currently hands over that money, for a residential service, when in actual fact they've marketed themselves to the person entering as, so they might go, they'll tick the clause to say that they're accommodation, when in actual fact that they've been marketed as a drug and alcohol service, and that it's on that basis that someone signs up their Centrepay to that organisation. So in that context, there are many unregulated drug and alcohol services. I can, name half a dozen of them across the country, that while you say we don't fund them, we are still leveraging the participation of people in what's being marketed as a drug and alcohol service in what is a completely unregulated environment.
So, Senator, we can have a conversation with our state and territory colleagues as well. I'd just make the point, most residential alcohol and drug facilities are run by the states and territories, but we'll look into the areas that you've raised.
Okay, well, it's the unregulated ones that I'm most interested in. The national framework is supposed to apply to unfunded and unregulated organisations. So I want to ask for some progress against that, and also really to see how the enforcement of that across both state and territory could be enhanced by having a better view and intersection with the social security component of that and housing component of that as well. Thank you. I wanted to ask...
Senator, can I just answer, sorry, Blair Exel, Deputy Secretary, one of your questions around the timing of the department ceasing its funding versus the report. I can confirm that the report was tabled 1st December 2022 and our funding agreement ceased in May 2022. So yes, that did
not
occur
long
before.
after the inquiry was
held,
called.
but yeah, you asked
And
me
so
to
on
table.
what basis was it withdrawn? It was because they went into voluntary liquidation at that time?
Yes.
Not because any concerns about their performance have come to your attention?
Same time. So at that point, I think there had been no, through the performance agreements, there nothing had come up, but I think it was around the same time that it was terminated.
We were looking at various options with the allegations coming into light.
Yep.
So we were looking at a number of allegations, but they also then went into administration, we were looking at a range of options because we took those allegations very seriously.
Okay, and what were those allegations?
We'll have to take that on notice. I don't have them in front of me, Senator. So
Okay, well, I can tell you they were
we know the
conversion
report.
therapy, they were, restraint, they were not being allowed to leave. It was a horrific set of circumstances, coercive control, a whole range of
I guess I'm referring to the
dynamics.
specific allegations put to the department. That's what I'm referring to.
No, that's all right. Just quickly, I know Senator John had flagged an interest in this earlier in the day, but I've also got some questions lined up. Can I ask what's going on in the space of LGBTIQ plus health, please? I know that there's some activity within government, and I'm keen to get an outline of what that is, both in terms of mental health, sexual health, and health more broadly, the diversity of the LGBTI community and how that's being considered, as well as the participation of community organisations. Thank you.
That's a broad-ranging set of questions, Senator, so we'll try and answer, particularly in terms of engagement with LGBTQI plus communities and people across Australia, both in terms of health and mental health. Obviously, we are hosting, we've got World Pride and the conference starting in the next couple of weeks. Assistant Minister Carney is hosting a health roundtable specifically with LGBTQI peak organisations, but people with lived experience. But I'll ask my colleague, Ms Street, to give you a rundown of that.
Thank you.
Yeah. Celia Street, First Assistant Secretary of Population Health Division. So the government's invested $1.3 million to increase the support and better understand the needs of LGBTIQ Australians, and the measure includes a national consultation in partnership with community-led organisations to understand the unique health needs and issues and barriers to access and support. We have identified LGBTIQ populations as part of a number of our strategies in terms of priority populations in the National Preventive Health Strategy and in other strategies. So it's a key priority population area. We've got the round table for Assistant Minister Carney is hosting, and Assistant Minister McBride is also attending on the 28th of February, which is alongside the Human Rights Conference, and it's very much about listening and hearing the views of LGBTIQ people, their unique health needs, but also their lived experiences. And that round table is bringing together the community-led organisations as well as another experts in the data and the like at that round table.
Great. And just finally, what steps are happening in relation to the bipartisan commitment to eliminate HIV transmission by 2030, including again with community-based organisations?
So that's one for the Chief Medical Officer, but Senator, I could also go on about the investment that we're making in mental health with LGBTQI plus communities.
It would be great to see some of that outlined on notice.
Sure.
Thank you. Thank you.
Yes, so just a quick answer on HIV, please.
I'll be brief, Senator, but the government did commit in the last, in the October budget in 2022, $5.9 million specifically in relation to the commitment to eliminate HIV as a public health problem in Australia by 2030. Very exciting commitment. And that a lot of that was mainly working through well-established peak bodies such as the Australian Federation of AIDS Organisations and the National Association of People with HIV in Australia, and particularly working on peer-led models as well as communication campaigns. But Professor Kidd is with me, and he's been very actively engaged with some of those as well since that funding program was announced.
Yes, just briefly, Professor Michael Kidd, Deputy Chief Medical Officer. As you know, Senator, on the 1st of December, the Minister announced the establishment of an expert advisory group to drive Australia's HIV response and the implementation of the National HIV Strategy. I understand you're a member of that, along with your bipartisan fellow chair of the Parliamentary Friends, which is wonderful, but will also involve community representatives and experts from the medical and research sectors.
Right, thank you. Thank you, Chair.
Thanks, Chair. So LGBTIQ A plus people are a priority population across a number of federal strategies, whether it be the National Preventative Health Strategy, the National Suicide Prevention Strategy, the National Strategy for youth and young people, for instance. One of the commonalities across these federal government strategies is that they often lack specific timeframes, funding allocated to them, or specific actions to be taken in relation to them. That's led to a call from the community for the government to fund and develop a 10-year national LGBTIQA plus health and wellbeing plan. Is the government considering developing such a comprehensive plan?
So, Senator, certainly the government has heard that call, and that is one of the key things that the community has actually asked to be raised at the roundtable that Minister Carney is chairing on the 28th. Obviously, the government would then need to consider its response to that call, but certainly the call is clear and loud.
Okay, thank you. And that was the 28th of which month?
Of February.
Of February, fantastic. In 2021, the Human Rights Commission released its report on protecting the human rights of people born with variations in sex characteristics, particularly in the context of medical interventions. Now, a key recommendation of the report included a convening of all States Attorneys General and Health Ministers to coordinate progress in this area. Have these meetings yet occurred?
I think we might need to take that one on notice, Senator. I'm not aware of a meeting in the last 6 months, so can we take that on notice and come back to you?
You can. Obviously, the Attorney General's part, we can put the Attorney General's office as well. But, Minister, from your perspective, do you know if your colleague is working to bring together a meeting of health ministers to discuss the findings of the report?
I'm not aware, Senator, but I'm happy to take it on notice and see if I can provide any additional information to the committee.
Okay, all right, fantastic. Now, in relation to ascertaining accurate data sets, which can then be used for health planning in the LGBTIQ space, at the moment, the two primary mechanisms for attaining that information are a series of research centre activities run by La Trobe University. One is Private Lives, which is a series of national surveys of the health and well-being of lesbian, gay, bisexual and transgender and queer Australians. And the other is Writing Themselves, which is a project around exploring the health and well-being of LGBTIQ young people in Australia. Without these data sets, there is no current national data on LGBTIQ A+ populations, particularly in relation to health planning. Most of the funding for these projects has been provided by the Victorian Government, and the funding is now not ongoing. So I'm wondering whether the federal government is considering committing to assuring the further funding of the Private Lives and Writing Themselves projects to the tune of the amount that's required, which is about $400,000 for at least the next 6 years, to allow for the collection, analysis and translation of these data sets.
So, Senator, I'm not aware of the government having been approached to continue funding for those studies, and obviously that would be a decision for government if to determine whether the federal government would take over funding for those surveys. Yeah. We do have some data collection that we have also undertaken through the Australian Bureau of Statistics and a national study of mental health and wellbeing that tried to improve data collection, but it's by no means the full answer.
Yep.
I think the question you raise around data is really important, though, and increasingly, the opportunity to use data, use big data to help design programs and support through government is just going to continue to gain momentum. So it's actually something that falls under my portfolio as well as data. Yeah. And the opportunities that are going to be there in the future. So the government is acutely aware of that. We're also aware that government does hold a lot of information. I'm not specifically relating to the area you're referring to, but how we use that information and data, how we share it, how we protect it, all of those things the government is looking at. And I'm happy to look at, like in the gender space, we've just done some gender mapping of data across government and uncovered a whole range of information that is held around data around gender and access to programs and things like that I wasn't aware of. So I'll take some further advice, probably not related to health, but through my portfolios on that. In relation to your question about picking up the invoice or the cost, I mean, as a finance minister, I think it is tough when state governments fund services that are not ongoing for the Commonwealth to step in and take responsibility for them, or there is no shortage of programs that are terminating under the Commonwealth's responsibility that we're currently working through about how we continue funding those. But I mean, if there is a genuine request to consider, I would encourage that organisation to reach out to the Health Minister.
I do understand that, and thank you for that response, Minister. My concern is these two projects are national flagship projects and are, as I say, the only current sources for data in relation to LGBTIQ plus health. Without these data sets ongoing, we're really nationally quite stuck for this information in relation to a critical community. So I would encourage them to reach out to you, but also the other way around as well. Just in relation to one of the key recommendations of the Aged Care Royal Commission, it was the establishment of the Aged Council of Elders, established following the Commission as a kind of consultation point for government. Now, as to this point, the Council does not include a representation of LGBTIQA plus peoples. I'm just wondering, will the government, or does the government have the intention to expand the membership of the Council of Elders to include a visible and specific LGBTIQA plus representative?
Senator, that's a question for outcome 3 for aged care, who unfortunately they're here later on. They run the Council of Elders, and they've worked with the Minister for Aged Care to establish the membership of that. But are you happy
I'll try and get an answer for that when aged care are here.
If you could. My understanding is that the council has acknowledged this as an issue and is seeking a memorandum of understanding with LGBTIQ organisations to fill that gap. But it's very much the firm view that nothing beats an actual representative on the council. So if I'm still here, either myself or Senator Rice will tackle that later. Chair, do you want to rotate the call, or shall I keep going?
I'll rotate the call and come back to you. Senator Ruston.
In relation to some funding that was previously allocated to the state governments, I think it was $70 million to construct residential eating disorder facilities. Is that something that would mean anything to anyone here? Hi, Mr. Short. I'm just wondering where that particular funding expenditure was at. Have these facilities been built, underway, contracted, etc.?
Thank you, Senator. So we have fully committed all those funds. We've got all Federation funding agreements established with states. It's at varying processes and kind of progress in every single state and territory. Some have got land, some have built construction, and some are still kind of looking to acquire land, so they're at different statuses. And because we fund the states to do that, it really is the responsibility of states around kind of getting these up and running and delivering services.
That's great. Would it be possible to get an update on each of the facilities in each of the states, just so we can see where they're up to? And
certainly happy to take that on notice and give that to you, Senator.
Fantastic. Thank you so much. My understanding is that there already is a residential eating disorder facility on the Sunshine Coast. Am I correct? And we did put some funding into that, didn't we?
In Queensland, Senator. So
Yep.
that's run by the Butterfly Foundation. It's called
the
Wandi
Nerida. Yeah, yep. Have you had any representation from the Butterfly Foundation around their ability to continue to their operational viability?
Hi, Senator. Matt Short, Assistant Secretary, Mental Health Division. Yes, we have.
And do we have any indication as to whether any support is likely to be provided, or is that a matter of a separate budget process?
Decision for Government, Minister. Senator, sorry.
Yep, okay. So can I assume, Minister, the answer will be it's a matter for the budget?
Yeah, well, I mean, we're working through a whole range in health of programs that are reaching a funding cliff. so it's not on its own.
Indeed, and I can assure you that those people that rely on this service will be similarly pursuing the Queensland Government. Thank you very much, but be very interested in having a look at that information.
I think that one actually hadn't been, it had been funded largely by philanthropy, hadn't it, the Butterfly Foundation?
So the Wanda Narrator is largely funded by the Commonwealth Government, so
Yeah.
$7.5 million has gone into that.
Yeah. It's the operational funding.
The
that was
operational
challenge.
funding,
Yeah. I'm just wondering where
Which
that
is
was
now
getting to.
And it's now got some co-investment from New
Yeah.
South Wales.
Okay, no worries. Thank you very much. I appreciate that advice. So can we just move on to just more generally GP workforce issues? Okay. I was just wondering, in terms of the data collection that the department undertakes around workforce shortages, does the agency have an estimation broken down into health workforce categories of the kind of shortfall that we're currently experiencing because of the challenges before us with workforce by location and by type?
So, Senator, the department is currently undertaking both general practitioner and nurse workforce data analyses. So that would be a supply and demand study for both. Both of them are being undertaken by the department with some very detailed methodology and some. And is currently being tested in the market. So University of Adelaide is undertaking a review of the methodology, and we'll be going out to the sector to investigate the methodology to make sure that everything is accurate. But yes, we are currently undertaking an analysis of both shortages.
So is what sort of time frame do you think you're likely to get some sort of understanding about the demand? I'm sort of, what I'd like to know is it are these shortages more acute in rural, regional, remote areas? They appear anecdotally to be, but of course without the data to substantiate that. And I just wonder whether your, in the case of GPs as an example, whether your Medicare billing data would provide you with, and your provider numbers would provide you with at least a sense of that.
So, Senator, we do actually undertake an analysis of services provided at the GP catchment level, and that analyses the services provided to community and weighs it against the demographics of the community, and that's where the DPA methodology comes from. Our Heads Up tool, which is a really good data capability the department has, analyses a number of data sets, but primarily the services provided to the community. And I think the DPA assessment indicates where the services are below a certain threshold, and that threshold is MM2, the middle of the MM2.
Yeah. So is that information either publicly available or able to be made available to the committee?
Yes, and so the DPA method, the DPA assessment is done annually, and that is published on the website.
Okay. So how much more granular detail do you have apart from that? Because, I mean, a lot of the information that I've trawled through the departmental website and gone through is not overly informative. I mean, clearly understanding it, I may be looking for something that data is not meant to be looked for. But I mean, is there more data that's available? Because it seems to me that we have been talking quite a lot about workforce shortages, and clearly there's no doubt that they exist, but the ability to actually quantify them in some meaningful way. So are you saying that won't be able to be done until you've undertaken this sort of dedicated and specific survey for that purpose?
Senator, we do have a lot more information around primary care doctors because of Medicare billing statistics. So that's what we use to put the input data into the Heads Up data tool. And we have provided briefings to senators. It's not sort of a static list. It's more of an interactive map of GP catchments, and we've got 5 years worth of data in there. It also looks at flows of services across different practices. So, it takes into account the fact that people who live in a particular area might access their services in surrounding communities as well. So that data is available. We have to be careful in how we publish it though, because of provisions in the Health Insurance Act that make it an obligation on us not to identify individuals, whether that's providers of services or individuals in the community. And because MBS rebates can be quite specific, it's possible sometimes when we publish data that individuals can be identified. So that's why we don't just sort of publish the whole Heads Up data tool, but we do make it available to people in accordance with the Health Insurance Act provisions.
And Senator, we have provided that at the catchment level before on notice, and we're happy to do that.
Okay. So do you have an understanding or sort of an indication at the moment, the kind of GP workforce that we are currently short, and any indication about trends, or are you waiting for the return of the information on this?
So we've got good data on supply, so the current GP numbers, headcount, FTE. The bit that we don't necessarily have a good handle on is demand. So we know, for instance, what GP FTE numbers we've got in different regional rural areas of Australia, and that data already shows us that there are less GP full-time equivalents per head outside metropolitan areas than there are inside, but we don't necessarily have the work to map demand. So while the workforce has been increasing, clearly it hasn't been meeting demands because there is widespread concern about shortages. So the demand for services really needs to be considered as well, and that's not what we've got good data for. We need to map both the demand as well as the supply.
And when do you imagine that you're going to have that information?
Approximately May, Senator.
So reasonably quickly?
Wouldn't it be good if we'd had the previous government had done some of this work?
It's going to be
so
really,
it wasn't
really
just left
helpful.
us to clean up.
Really, really helpful, Minister.
Well, I'm just saying it would be
really helpful.
Well,
if
you're
like
asking for timeframes here. Like who was asking
I think I'm
for them
being
when you're in
amazingly
government?
polite, and I think you're.
Well, you
really...
abolished Health Workforce Australia. I was reminded of.
Well, I
which
don't
did
know.
exactly this work, which was abolished.
Chair, I'm more than happy to be respectful in this discussion.
Senator.
I'll go back into silent mode.
I think that's a very good mode, Minister. Very good mode, unless you've got something constructive to add to the conversation. I wasn't actually provoking you. If you want to be provoked, Minister, I can provoke you. So I'm just wondering, do you collect data around, for instance, how many clinics are taking on new patients? Would you have any idea around that?
No, we don't collect information directly. We do get information from rural workforce agencies that may be working with practices that are struggling to recruit, that might tell them that they are not taking on patients. But it's not something that we collect. If we were to require all GP practices to report that to us, it would be a sort of an additional data reporting burden on them, and we want them to focus on their patients.
Yeah. Okay, but a useful piece of data nonetheless. So, I mean, like as an example, do you have an idea through the data collection of what the average out-of-pocket expense, for instance, for a GP consult, average GP consult would be?
Yes.
Okay. And what's that at the moment?
I don't have my outcome 2 folder with me, which has all of that MBS data in it, I'm sorry.
Okay. Look, I mean,
but we can get it to you unnoticed.
Sure. It'd be really, what I'm really keen to get an understanding is that we've got metropolitan, we've got regional, we've got rural, we've got remote. So, I mean, obviously our modified Monash gives us a nice idea of what they all look like. And I'm just keen to understand what the different trends and responses in each of those areas are, so that we can, understand where we need to solve for and where, because it just as a useful piece of information, and that obviously will dovetail into the bulk billing challenges that I'm clearly sure that
you're looking at closely at the moment as well?
We've got lots of existing interventions to boost rural workforce. We've got higher rural bulk billing incentives available under Medicare
Yeah, I
than in
understand that.
metropolitan areas. There is a range of existing programs and
I'm not sure I was
interventions.
asking that, and absolutely, I understand that there are different levers that get put into different areas, but just how much they're working will clearly be defined by what the differentials are between those particular areas in terms of access to workforce and access to service. So do you have any idea, like at the moment, do you have any idea of the vacancies that currently exist in terms of places trying to recruit GPs?
We could probably get some information for you through our Rural Workforce Agency network, who are the ones that work with practices that are struggling to recruit and need assistance.
Yep.
Those are rural workforce agencies. We won't necessarily have that information about metropolitan practices.
Yep.
Senator, also vacancies are a loose indicator of need, because sometimes practices just start up, sometimes practices expand, and they'll advertise vacancies in those instances as well as when there are replacements required.
Sure.
But you're right.
Over the whole nation, you should get a bit of an idea, I would have thought. I get the point on the specifics, but not on the general. Has the department done any work about the impact of the changes in the redesignation of a number of distribution priority areas that have subsequently been included in the list, and what the impact has been on those areas that previously had the DPA status, and the impact of these additional DPA status areas in terms of IMGs in those areas?
Sorry, Senator, so you're asking what the data shows in terms of movement of doctors?
Well, I'm just keen whether you've got that data.
We do, Senator.
And is that available?
We can put, depends what sort of data set you'd like, Senator, over what period of time.
I'd just be
We can
keen
provide that on
to know, in the last 8 months or 8 months since the changes came into place, how many IMGs or indentured, for want of a better word, medical practitioners who previously had been required to work in the DPAs prior to the changes have subsequently made the decision to move to other areas, the new DPA areas, because there are a number of the new DPA areas that are quite clearly metropolitanly based.
Of course, Senator. We do have that data available. We are tracking. So since the changes came into effect, it was a commitment that we would track closely if there were any impacts of the expansion of the DPA to MM2. Over the last several months, each month we record, so there's 2 categories of restricted doctors that this applies to. So the first category is those that are currently employed in areas outside of deep MM2, and then there's the other category is those that would be recruited to or moved to. So by far the largest category of inflow is new doctors being recruited, both international and domestic. But tracking internationally, there's a statistically nil change in the category of those doctors being newly recruited. Of doctors that are currently located outside of MM2, so MM3 to 5 that have moved to MM2 locations, there has been a slight increase, statistically insignificant at this point in a data sense, but there has been a slight increase in that 1/3 of doctors over the last period, but that is also impacted by a sort of a lack of reduction in restrictions on movement since post-COVID as well. So some doctors in those areas who would naturally have been moving have started moving as well. So there is anecdotal evidence, Senator, but statistically there's quite an insignificant change.
Okay, so is there a number that you can attach to that? You've said 1/3. Is there a number?
This is doctors moving from MM3 to 7 areas into an MM2 location.
I'd be interested to know how many moved,
So that in 2020 and 2021, the percentage was 9%. In 2022, that has slightly increased to 12.9%.
Correct.
12.9%.
It's variable though, like if you look at different months, some months in 2022 have been lower than months in 2021. So I think that there is a seasonal impact there as well.
You said year to year was 9 to 12.9.
Yes.
So the seasonal impacts are irrelevant.
And as my colleague mentioned, we also think that there was an impact in the rate moving in the prior years because of the pandemic.
Okay, well, it'd be really interesting to get those statistics. So you're talking about percentages. Do we have numbers?
Yes, Senator. So in 2020, total movements between MMs in total was 693. From MM2, sorry, just 1 second. To MM2 was 74.
I'm sorry?
No, that's wrong.
I've got different numbers.
I've got different numbers too.
So I'm just going to read out my numbers because that was what the percentages were before. So 2020 total movements between modified Monash categories was 448. The move from more regional MM3 to 7 to MM2 was 40. In 2021, we had 510 movements overall. From MM3 to 7 to MM2 was 46. In 2022, we've had 559 movements overall. From MM3 to 7 to MM2 is 72.
Okay, so you'd have to say that is not statistically insufficient or insignificant, but okay, thank you very much. I look forward to receiving that.
That does.
You got it.
Sorry, Senator, that does apply simply to those doctors who are moving who are currently employed and moving, not the doctors who are the additional doctors who are being recruited into the locations.
Okay.
And on that, I think the important point is the migration numbers have actually returned to pre-pandemic levels as well. So.
Well, I look forward to receiving that data, and then I may put some more questions on notice about information about specific
We can probably
locations.
give you that data now.
Yep.
So the number of practitioners, there's been a 41% increase in international medical graduate registrations in the last financial year, which is 2,985 new doctors entering. 2,985. So that's the increase in the international medical graduate workforce coming into Australia.
The increase in it or the number that have come? That's the new.
Yeah, so that's the new people coming in and being registered to work in
And you said that there
Australia.
has been no change in the number of those that are going to rural and regional areas. Is that what you said? So normally a certain percentage of those.
Yes, so I don't have the breakdown of that number about who's ended up in which MM category. I'm not sure we can get it for you because that's based on AHPRA registration data, but we'll look and see what we can.
Great, thank you. Thank you very much.
Senator
Okay, I was about to say I've finished that block of questions.
Well, I read your mind. We're so in touch, so connected. Senator Steele, John, come back to you soon.
Thank you so much. In October of last year, the Australian ADHD Professionals Association published new evidence-based guidelines for ADHD diagnosis and support, including some 132 recommendations to government. How has the department engaged with these recommendations?
Thanks, Senator. So the guidelines, as you mentioned earlier, are clinical guidelines that are published. The government actually funded the development of those guidelines, and I'll ask Mr Short to just give you a bit of background in terms of the funding, the recommendations, which are predominantly for clinicians, and kind of the next steps.
Yep, thank you. Hi, Senator Matt Short, Assistant Secretary, Mental Health Services Branch. So we funded the Australian ADHD Professionals Association $1.5 million for the development of those guidelines, which were endorsed by the National Health and Medical Research Council and released in October. There's 132 recommendations, 111 of those are for clinicians and for consumers for ADHD. There's 21 recommendations that go to broader issues for governments to consider. Currently, the ADHD Professionals Association is developing a consumer guide that is part of our funding that will help consumers to navigate the guidelines as well, and is undertaking a roadshow to ensure take-up of those guidelines with clinicians.
So particularly in relation to the 21 that went beyond clinicians and in relation to government, how is the department engaging with actioning those recommendations?
So they are, for us, informing future policy development for ADHD and how we treat that in the community and advice that we would give to government.
All right, and in terms of the kind of influence of those recommendations, are they informing funding commitments to the provision of ADHD services, potentially in the May budget?
So, Senator, that's obviously a decision for government. As you mentioned, these guidelines have only really just, been developed recently. The consumer guide is the next step, and obviously we're doing a lot of work with the ADHD Professionals Association to look at what, where to next. But any future funding decisions would be a matter for government.
We're lucky enough to have the Finance Minister with us. Minister, are the 21 recommendations, particularly related to government, informing your department's thinking in relation to the budget submissions?
We're working closely with the Minister for Health on a range of measures, I can assure you, but not in a position to go into anything specifically.
Okay. Can you outline how the ADHD assessment and services particularly fit into the Strengthening Medicare Task Force report and its recommendations?
So, Senator, you won't see them directly referenced, nor will you see any specific guidelines referenced in the Strengthening Medicare Task Force report. The report covers 4 areas of broader primary health reform, and specifically looking at access to the system, increasing multidisciplinary care, ensuring a modern health system and broader cultural change. It does go to issues of equity and access in particular.
Yeah, a massive issue for people with ADHD.
Indeed, but as I mentioned, the report of the task force doesn't go into any specific groups, but does make a comment about what are the reform directions needed to get greater equity and access to primary care for all people, but particularly those who have more specific needs. So obviously ADHD would be one group, but between COLD, LGBTIQA+, a whole range of priority cohorts, the reforms go to increasing equity overall.
Indeed, and this is one group. It is a group of 500,000 Australians who experience significant access barriers, particularly in relation to diagnosis, and particularly one of those barriers is cost. I'm wondering how will the recommendations of the task force report inform funding of commitments around ADHD services in the May budget? Because you've got a task force report which in broad terms talks about access as an issue. You've got a community who one of their primary challenges at the moment is access to Medicare funded diagnosis, for instance, which is currently not available. So how is that informing your thinking?
So, Senator, as mentioned, the report goes to broad areas of primary care reform. The government's response will be in the context of the May budget, and it will go to, addressing the issues in that report.
I've heard from many people who are currently pursuing ADHD assessment and subsequent services throughout the country who experience a very long wait time to access them. It's not unusual for folks that have reached out to me to wait for more than a year to see a psychologist or a psychiatrist as part of that diagnosis process. What measures are the department taking to establish the cause of these wait times?
So, Senator, that I think goes in part to the ability and partly where these clinical guidelines are trying to actually improve the diagnosis and access to effective treatment so that more clinicians can actually have specialised understanding and diagnosis skills for people with ADHD, and similarly the consumer guide to allow for people with ADHD to understand what those clinical guidelines will mean and how they might increase both the availability of clinician services and time. So this is a big first step.
Right, but it is a necessary action that has been taken. Can you point to anything else that your department is doing to either identify the cause of these wait times or to reduce them?
So specifically with ADHD, I don't know that I can go into that detail, and I might need to take that on notice, but obviously there are a broad range of other measures that are trying to increase the workforce, particularly in mental health, increase, the scholarships and psychologists and psychiatrists, but also peer workers, mental health nurses, counsellors, and a whole range of mental health workforce that will be also armed with these guidelines to improve access. So,
well, if you could take it on notice,
I will.
just so that I can kind of get a picture of whether there's the other initiatives that you're hopefully taking to address this important issue.
I think one of the other issues is it takes a long time. It's a lengthy.
Yeah.
When you get in, it's not a simple survey or anything. Having gone through it, so I'd probably declare an interest here. Like it's hours and hours, repeated visits and assessments, and and that creates. It's hard. Like if you have a psychologist that's doing that. It takes time, and it's not a high throughput, high speed kind of throughput that you get, which creates, those lengthy waits.
It does, and one of the other contributing factors, which was my next question, is around the reality of stigma that is faced by people with ADHD. Widely
Not
reported.
in my household, it isn't.
Well, no, and nor in my office all my life. Excellent
Quite
people.
positively
but in the broader community, that's not the case, right?
No, I shouldn't. I'm not trivialising.
We do know that. People in the broader community do experience stigma, and often that stigma is something that they are subjected to at the hands of their healthcare providers.
Yeah. No, it's very good that ADHD is becoming more commonly understood condition at high, with high levels of, diagnosis really compared to a few years ago.
Absolutely. Now, the through impact of this stigma is often that it has a significant impact on people's lives beyond the functional impairment of ADHD itself. So I'm wondering how the department has sought to challenge the systemic issue of stigma towards people with ADHD among medical professionals, where it is, sadly, continually prevalent.
Thank you, Senator. Matt, I would say the clinical guidelines is a first step for us there in making sure we're upskilling the workforce that we have already in how to diagnose, assess and treat people with ADHD. In the broader mental health sector, there's a lot going on about stigma reduction, and a lot of our policies and programs go to that broader approach for mental health more broadly.
Yes, but well. ADHD specifically?
We no, there's nothing specific for stigma reduction. What I would say is that the consumer voice for ADHD is really important and is something the government has recognised as well. And there's funding from the former government that we are looking at, or that we have in place to look at a consumer initiative as well.
All right, thank you. Look, just in the interest of time, Minister, I had a series of questions for the National Mental Health Commission, but I'm aware that we're trying to reach the dinner break and move on. So I'll just put the nub of what my questions were to you, which is ultimately a political question. We see today in the Sydney Morning Herald, former Chair of the National Mental Health Commission, Professor Alan Fels, has stated on the record publicly and in no uncertain terms that he feels and believes that the Commission has, in his words, lost the confidence of the mental health sector, and that urgent change is needed, particularly in relation to the independence of the Commission. Mr Fells is advocating for the Commission to be made structurally independent in the same way as the ACCC and other commissions are. Is the government considering considering changes to the function of the Commission or the structure of the Commission to grant it greater independence and ability to win the confidence of the sector?
Well, I acknowledge Alan Fells, or Mr Fells' long-standing, involvement in this area and respect him enormously. I'm not aware of any plans the government has, but I'm happy to take some advice from the Minister for Health's office, see if I can come back. I'm certainly not aware of any plans.
All right. I'll just leave you with the comment from Professor Fells, having chaired the ACCC for 14 years and then moved to be the chair of the Commission from 2012 to 2018. His observation was that the independence of the Commission, the statutory independence of the ACCC, was one of the key reasons it held the respect of the relevant sector and stakeholders, and did not find that to be the case when he came to be chair of the Mental Health Commission.
Okay.
So I'll leave you with that. Thank you for your time.
Thank you.
Thank you, Senator Steele-John. Senator Ruston.
Senator Hughes had a couple of quick questions.
Oh, so apologies. Sorry, Senator Hughes.
I don't know who in the department might be aware about the Climate Active TIC program that's actually run by the Department of Climate Change and Energy. It will become apparent why I'm asking.
Climate change is under my area, Senator, but I need a little bit more information about what you're referring to.
On Monday or Tuesday this week, Monday morning, we were in another estimates in Environment and Communications, and Senator Hanson-Young was asking some questions about the Climate TIC initiative, which is a TIC provided to companies who have met certain benchmarks around climate and reducing their emissions and participating in a program run by the government to acknowledge companies who are abiding by obligations and going over and above. Senator Hanson-Young asked the question whether or not a company had ever lost its TIC, at which point one of the Deputy Secretaries or Assistant Secretaries proudly declared that after receiving a letter from the Department of Health, British American Tobacco had had its TIC removed. Now, I would like, on notice potentially, since no one seems to know what's happening, to find out whom in the Department of Health wrote a letter to the Department of Climate Change and Energy suggesting that British American Tobacco be removed from a program. This is a legal company who was abiding by standards, and where in both the WHO Charter, because it doesn't exist, but where within the Department of Health they have endorsed themselves as the morality police over what companies they like and don't like when it comes to appointing climate initiatives or any other initiative for that matter within the Australian government.
Well, let's see if we can assist. There's a lot in that.
Well, there's a lot in it because
it's pretty loaded as well.
Well, because I want to know when the Department of Health decides that.
I know. I heard you, but I'm just trying to take it down.
But is it alcohol companies?
Well,
It
sounds like you've started the investigation.
Minister and Senator Hughes.
Let's just start and see if we can provide.
Senator and Minister Hughes, please take a moment. I understand from your answer, Minister, that you agreed to take the questions on notice.
I said I'll see. I was just trying to
see what you could do.
Yeah, and take it down a notch. Like, everyone's been found guilty by Senator Hughes before anyone's even had a chance to make any
The department
statement.
told us the letter came from the Department of Health suggesting that it was that by giving a legal company a tick, just because part of their business is a tobacco business, not even their whole business now, part of their business, tobacco business, regardless of them reaching the emission standards and the climate action, the Department of Health suggested the tick be removed.
Well, Senator, as I said, it's my area of the department which is working with climate change. The one thing I do know is we are involved and engaged with CSIRO and the Department of Energy and Climate Change in relation to assessing our own climate impact as a department. That's what I thought you were referring to.
No.
In terms of writing to private companies and particularly private tobacco companies...
writing to fellow departments.
Sorry?
You're right. It wasn't written to British American Tobacco.
Oh.
It was written to the Climate active tick agency through the Department of Climate Change and Energy, and I would like the letter from the Department of Health that went to DQ telling them to remove the climate active tick from British American tobacco, which has occurred despite them complying with all conditions required for the tick. I would like tabled a copy of the letter, I appreciate you may need to take it on notice, that was sent from the Department of Health to DQ telling them to remove, or advising them it would be beneficial to remove British American tobacco from that program.
I'll take that on notice.
We'll take it on notice,
Yeah.
Senator. We'll look
And
into it.
perhaps take that on notice. Does whichever part of the Department of Health took it upon itself to write this letter, do they plan to further these letters across industries that perhaps the Department of Health does not deem worthy of being endorsed, perhaps fast food,
Senator,
the sugar industry, the alcohol industry?
Senator, we'll take that on notice. Anyway, I'll just say we'll take it on notice.
Yes, I'm very interested to know who put the Health Department in charge of morality over corporate Australia.
Thank you, Senator.
Thanks, Senator Ruston.
Just quickly, one area that has been raised constantly of concern by general practice has been a sort of a threatened decision by the states and territories around payroll tax on practices. And I was just wondering if the department had done any had any consideration modelling or had provided any advice in relation to what the likely impact of the introduction of payroll tax on GP practices are likely to have on the overall viability of general practice and the likely...
That's a state-based tax.
No, it's a state-based tax, but clearly the viability of general practice is something that clearly concerns the federal government.
It does.
Yeah, and I was just wondering if the government, whether the department had done anything around assessing what the likely impact would be of that tax. I mean, if you haven't, and that's fine.
Many, depending on the state, who have different thresholds for payroll tax.
Yep.
I would assume for small GP businesses, most of them would be exempt from payroll tax, but some would, where they've got a higher turnover or more staff. States do it on turnover, I think, threshold of turnover or numbers of staff, I think, in some states. But I think it would be very difficult. I'm not sure Health would be in a position to model that. Might be something the Treasury could do, but...
It was just
I don't know why we would model state-based taxes of which we have no control over.
I'm not modelling state-based taxes. I was just, we are in the middle of a GP crisis, which I think we all acknowledge.
Which you put your head in the sand for years.
You're going to try that game again, are we?
Well, I just want some context put around the conversation.
Was I making any accusations or making any blame? I was just stating a fact.
Senators, this process works best when questions are answered and listened to and answers are given and listened to. Please continue, Senator Ruston.
I'm merely asking if the department has had any consideration or provided any advice about the likely impact of clinics being required to pay payroll tax on their GPs. If you haven't, it's a very simple answer, no. If you have, I would just be keen to understand if you what the results of that advice might have been.
So, Senator, I mean, obviously tax is, as the Minister has pointed out, particularly payroll tax is an issue for state governments, and the Department of Health is not a tax expert, so we don't do tax modelling.
Step
we
back
are
a bit.
aware.
Excuse me, in the interest of time, I'm not asking you to do an analysis of tax. It's a pretty simple concept. If you're going to increase the burden on a business, it's going to have an impact on how that business operates.
We're not increasing the burden.
No, I know you're not increasing the burden. It's that we're a state-based tax. I acknowledge that. But it's likely to have an impact on general practice. We know general practice is under pressure at the moment, and I'm just wondering whether that particular issue has factored into your determination around the pressures around general practice, around the pressures around GP, and also around out-of-pocket costs that are likely to result as a factor of those going up. If you haven't done anything, that's fine.
Well, we're doing a lot of things. We are not putting effort into understanding state-based taxes' impact on primary care. I think it's probably safe to say that.
Okay.
And I would say many of them, including the smaller practices where, and in regional and rural areas, would be exempt of payroll tax under state arrangements.
Well, you wouldn't know that because you're not looking
Well-
into it, Minister. So with the
Well, no,
greatest
I know
amount of
from my
respect...
experience that, like in the ACT, there was a very high threshold before you started paying payroll tax.
That's not necessarily the case in other states and territories.
Well,
and-
they're all around the same, whether they do it at a threshold
But-
level or a number of employees. But
Okay. It's fine if you haven't done anything and you're not intending to do anything. I just thought it was a
Well,
factor that was likely to...
no, I don't accept that.
Well,
We are
Senator,
doing a lot in primary care.
I didn't say you weren't doing anything in
well,
primary care. Do you think I could just ask the questions of the
Well, it's
officials,
just, there's
please,
some
Minister?
generalisations there that I feel like I need to respond to.
I'm not making any generalisation at all. All I'm saying is that one of the most significant issues that has been raised with me in relation to the ongoing viability and the pressures on general practice is the threat of this payroll tax. And I was
Is
just
that from,
interested...
just out of interest, is that from larger practices, like the sort of the more corporate
No,
model?
it has been made to me by a number of
Okay.
practices, as well as the RSCGP and other general practice representative organisations and like the AMA and others. So it has been, there were two issues that were raised with me, and this was one of them as being the most likely to have a significant detrimental impact on general practice. And I just wondered that in the process of the Strengthening Medicare Task Force report and all the changes that are being proposed at the moment, if this particular issue had been taken into account. It's fine, it hasn't been. You may choose to do it into the future. So thank you. I'm finished on that.
Senator, it has been taken into account. The stakeholders have raised this issue with us. The Minister has raised it with his state colleagues. And the Prime Minister, in fact, discussed it with premiers at National Cabinet. I think Premier Perrottet announced the suspension of proposed plans in New South Wales to apply payroll tax to...
So do we have any information, like obviously if the Prime Minister and the Minister has raised this, they must have sought some sort of advice around the potential impact, or are they just...
That they, as Senator Gallagher has said, they've understood that this is a state issue, and the states have expressed concern to them about the state of general practice, and they have raised the issue of payroll tax with the states in that context.
And do we have any feedback as to what... I mean, we know that the Queensland Government, I mean, it's a matter of public record, have put a moratorium for a couple of years. So anyway,
that's
look,
right.
that's fine. I raised it only because it had been raised with me significantly. And I look forward, I mean, maybe in May you might have some more information about it, because it might have become clearer in terms of what the states are actually doing. Thank you, Chair.
Thank you, Senator Ruston. Senator Tyrrell just had a few questions for the agency as well.
Apologies, I forgot to put myself on the roster. I know, I'm a dopey Dora. Thank you. I want to ask some questions about the Better Access Initiative, if that's okay. From March 2020 to the end of last year, we saw a trial take place in response to COVID-19, and people were pretty happy with it. The government decided that not to adopt the recommendations for the additional 10 sessions. So, like, 4-point question. What was the rationale for not adopting the recommendation? Did the department advise the minister not to adopt this recommendation? What other advice did the minister receive about the recommendation? What was the cost to the taxpayer of this scheme for each financial year it was used?
So I can kick off. It was the Better Access was a program that offered 10 sessions. It was elevated during COVID to go to 20 sessions, and then under the former government, it was due to expire at the end of December, I think, was it?
That's right.
End of December. So it expired in the end of December. There was a review into the program, which shows that it's well liked, but that, and whilst it gave extra sessions to people on the program, it didn't actually provide access or better access to people who were off the program, because it's a demand-driven program. So if psychologists are seeing the same person for double the amount of time, they can't double the amount of sessions and see other people. So in a sense, that was, I think, a concern, particularly for people who are not in the program. So it expired on the time that was set under the previous government. We can give you the figures, I think. I'll let you do the figures just in case I get them wrong. But it was also around access as well, making sure that, sessions were there for people who weren't on the program. So you are actually reaching people they're able to get that early intervention and access to care. And I think, wasn't the average utilisation, I read somewhere 5? The average number of sessions per person was 5.4 on the program.
So I should say, Senator, so access to the 10 better access sessions remains for all Australians as intended, and as the Minister has outlined, the COVID additional 10 was always due to expire. It was put in place as a terminating measure, specifically in response to COVID. You asked about the amount spent on the additional 10 sessions. Is that?
What was the cost to the taxpayer of the scheme for each financial year it was used?
So I'll need to take on notice each financial year, but over the period that the additional 10 sessions were in place, so from the 7th of August 2020 to the 31st of December 2022, the expenditure for those additional 10 sessions was $310.8 million.
Look, the few people that did take up the more than 10 sessions obviously were more in need of those sessions. So obviously they were more seriously mentally ill than those people that were only able to take up the 5. And I would, well, so I would say to you, if in the clinical analysis of psychologists, they believe that the people who were taking up the more than 10 sessions were those people that needed that help because their journey to recovery required more assistance. I mean, I suppose I'd liken it to, if you were told by your oncologist that you needed X amount of sessions of chemotherapy to take you on your journey to recovery from your cancer, you wouldn't choose to just cut them in half so that you could spread it around. You actually usually carry through on the journey of care to the conclusion that is appropriate for the condition that you're trying to treat. So I just say, so what do you say to those people who are accessing those 20 sessions? You can only have half of them and you can only be half as well.
So, Senator, can I?
And if that is your argument, why did you not fund it as an ongoing measure?
But I thought it was a demand-driven measure.
It is for the 10 sessions, and you funded the additional 10 to December. So if your argument holds, why was it terminating in December?
But if your argument holds that all you're doing is saying that instead of having 20 sessions, you're having 10 sessions so more people can get access to it, your argument that there's any savings doesn't hold any water.
Well, we're not necessarily saying that.
Well, I think you just did.
No, I'm not saying it was about savings. I've never raised savings.
No, I'm not talking about savings.
You just said savings.
No, I didn't. I said to you, this is a demand-driven scheme.
Oh my God, it is getting to that. You just said
Senator Tyrrell
anyway.
did have the call, so I'll return to Senator Tyrrell.
Look, and I appreciate your question. Look, the evaluation found that they weren't being targeted correctly. Would there have been an opportunity to actually redirect where the sessions went so that they were targeted more appropriately, like mental health, you know what I mean? So like instead of having a holus bolus, more high needs psychological conditions, couldn't it have been redirected back there and maintain the 20 for those?
So, Senator, you actually corrected a point I think that Senator Ruston asserted, which is the evaluation actually found that the additional 10 sessions weren't targeted particularly well. They didn't target those most at need, and in fact...
So target them better.
Yeah. So, well, and
the program that is poorly targeted.
But you're stopping people from getting access to the program. Psychologists can't see, if they're seeing the same patient 20 times, somebody is going to miss out, right? They have to.
No,
It's an early intervention program.
That is not.
And there's a whole range. This is one program, right? So for people with
such a critical program.
I know. I use it, right, for my family. Like I understand the program, but I also understand that within a finite resources. And when you're looking at access and equity, that there is a responsibility to make sure that programs are reaching as many people as possible.
And there are other
this was set up for 10 sessions.
The shortage, you don't end the program.
We didn't end the program. It remains the program. The Better Access program was 10 sessions.
Senator Tyrrell did have the call.
No,
Senator Tyrrell, did you have further questions?
Ceased in December.
That's okay.
Yes, please continue.
I'm glad everyone's passionate, but I will go to my second question. Look, we know that the government recently convened the Mental Health and Equity and Access Forum in Canberra in response to the Better Access evaluation. The forum was meant to provide reform advice on how to improve better access.
So the forum was convened on the 30th of January. It was both in response to the evaluation findings, which found that, and the evaluation made 16 recommendations, and Dr Ruth Mine can go through kind of particularly the fact that those recommendations went to broader system reforms and the fact that better access was one element of a mental health system, and that services can be better targeted and used through different mechanisms within the whole system. So the forum actually looked at how do you improve access and equity to services, because specifically the Better Access evaluation found that services were not well targeted, were not particularly equitable and accessible, particularly for areas of low socioeconomic need or specialist need. So I might ask if Dr Vine would mind.
Could I ask a couple of subsequent questions of
sure.
Dr Vine then?
Sure.
So who are the experts in the forum? Obviously you must have been there. How were all participants in the forum selected? Were there representations from every state and territory? Was it focusing on rural and regional areas specifically, or is it more broader? How often does and will the forum meet? And are there any terms of reference that the public are able to access? And when's the outcome meant to be delivered?
There's a lot of questions there,
I
Senator.
know, I apologise.
And first let me introduce myself. My name's Dr Ruth Vine. I'm the Deputy Chief Medical Officer for Mental Health. So in answer to your question, I guess throughout the, firstly throughout the evaluation, there was quite a lot of consultation through two groups, a clinical group and a stakeholder engagement group. So both of those included clinical experts as well as lived experience people, as well as a range of professionals and others. The forum invited those groups and in addition supplemented those groups with a number of systems experts as well as a much broader representation from lived experience. There were 14 lived experience people in total, a number of across the professions. And there were not state and territory government representatives at that meeting. It was looking at the Commonwealth-funded Better Access, but I'm pretty sure that we had representatives from each state and territory across those professions. I actually think we could provide the list
That'd
of
be amazing.
attendees and along with their professional affiliation and their jurisdictional background, and that might give you the answer to that. In terms of things like terms of reference and outcomes, this forum, which I had the privilege to sort of be the MC for, was really about getting the conversation going and making sure that the findings of the evaluation had that opportunity for a broader conversation. That did mean, I think, that we had to limit it. Not everyone who wanted to come to the forum could come. There were about over 80 people in the room, and it was a pretty active conversation.
A lot of voices.
And I'm sure there will be subsequent meetings, but I'm not sure whether of that group in particular, because that was really to inform the
So
conversation.
at the end of the forum, the Minister actually made a commitment to continue the conversation with the stakeholders and also announced 14 of the participants in the forum were people with lived experience or living experience, including carers and consumers. And there was an announcement about 2 independent lived experience peak bodies as well. So the conversation is ongoing. I think importantly the forum covered a whole range of issues, and it's clear that actually care coordination, reducing fragmentation in the system and ensuring accessible mental health services was the key focus. So Better Access is one program that provides, MBS funded services, but actually the broader system and how PHN commissioned services, digital services, telephony services, adult mental health centres and state and territory services that we're negotiating through the bilateral agreements all come together to provide the appropriate care at the appropriate time for those who need to access it.
Okay. Thank you. Under the Better Access...
Senator Tyrrell, sorry to interrupt you. Just letting you know we were hoping to move to the agency shortly, but please continue, but just...
Shall I do one more and then I will put the
Thank
rest
you.
on notice, because I do appreciate your time. Under the Better Access scheme, only the clients of endorsed clinical psychologists are rebated at a higher level, around $40 more per session. There is a lower rebate for the 8 other endorsement areas in psychology. The lower rebate applies to people who have undertaken the same amount of education and training and psychologists with general registration. First point, why is there a lower rebate? And 2, is the government planning to review the 2-tier system?
So the answer to there are differential rebates for a range of people who are actually able to provide MBS rebatable services, and that differential rebate applies across MBS services more broadly. I don't know whether Ms Raven wants to go into kind of the detail, but as I said, there's a well-known kind of rebate system established under MBS that goes to the level of service, the type of people who are approved and able to provide services under MBS, and a rebate fee that is set. In terms of a review, I'm not aware of a review around the rebate system at this point in time, but MBS reviews happen on a rolling basis, more generally.
Yeah. Do we have sorry, I did ask one question about when the results were due from the forum. Thoughts?
I don't think there are results as such. I mean, there was as I said, a vigorous conversation, and it certainly did cover those areas around equity and access and differences between rural and remote and the whole professional range. So I don't think that there was an undertaking that there would be outcomes as such, but the department will certainly consider the areas raised. I think, as has been mentioned, and I think actually this is the first recommendation of the evaluation is that the acknowledgement of better access sitting within the broader health system, and so it really is a conversation also about those other models, the PHN funded models, or the better access mental health items, which was also raised in the forum, including of course the use of psychiatry, but no particular outcomes planned.
Thank you, Senator Tyrrell.
Can I just ask one follow-up question of the Minister? Singular, just to get a letter from the Health Minister.
Yeah, it cuts into agency time. So
Just very briefly, I just wondered if you could confirm that the Minister has received a letter written jointly to him by the Australian Psychological Society, Rural Health Alliance, Victorian Ambulance Union and Federal Police Association, which is arguing for the retention of the 10 additional sessions because of risk to patient harm or preventative loss of life, and also risk to emergency service personnel created by this decision.
I'll take that on notice, but I also am aware that the AMA, Ian Hickey and Pat McGorry have all publicly supported the government's decision, so I accept there's a range of views on this program.
Thank you, Senators. I understand we're in agreement to dismiss officials related to outcome 1. Yep. Yes, great. So,
if there are officials who should be here with a particular agency,
yes,
perhaps they could remain.
I'm about to read the list of agencies that we'll be moving through, hopefully.
They're outcome 1 agencies. So
yeah, sorry, outcome 1 agencies. So I just mean officials not related to what I'm about to read. We're working through the NHMRC, National Blood Authority, Office of the Gene Technology Regulator, the Australian Digital Health Agency, the Australian Radiation Protection and Nuclear Safety Agency, the National Mental Health Commissioner and the National Rural Mental Health Commissioner. It is the committee's endeavour, and the TGA, it's the committee's endeavour to do this before the dinner break, so we will be powering up and asking our questions quickly. National Health and Medical Research Council, who has questions for them?
TGA.
No, I'm calling the National Health and Medical Research Council.
I can ask very quickly.
Okay. Go.
Oh, hi guys. So, my understanding is that it's your agency that's responsible for reviewing the gain of function research projects and basically providing funding. Who reviews those projects to make sure that the quality control is appropriate so that nothing goes wrong?
I'm Anne Kelso. I'm CEO of the National Health and Medical Research Council. So thank you for the question. The work you're talking about, I think, Senator, is the review that we did for the previous Minister for Health, which was to investigate whether the Australian government had funded or conducted any gain-of-function research over the last 10 years. So we released that report last April, having provided it to the Minister in March. So that was a specific review for a specific purpose, and the report contains the material. Beyond that, research grant proposals come through a normal review process if they're applying for funding from NHMRC or the MRFF, and then it's a question for ethics committees, biosafety committees, sometimes the OGTR, to determine whether the project, if it's funded and happens to be relevant to the issues that you're raising, has appropriate control and whether it should be done.
Okay, thank you.
Senator Roberts.
Thank you. Thank you for appearing. What is the current Australian policy position on Lyme disease being diagnosed in Australia?
That's not a question for NHMRC, Senator, perhaps the CMO.
Chief Medical Officer. Thank you.
Okay. So if there are there any further questions for the NHMRC? No? We're happy to dismiss this agency? Okay. Thank you. We're now moving to the National Blood Authority. Do we have senators with questions for them? Senator Rennick. And officials are in the room, so you can commence your question. Senator Rennick.
Hi guys, how you going? I have a magazine here from 1982, and a gay magazine, and in it there is an advertisement from the Red Cross asking for people to donate blood. Now, I'd like to know why the Red Cross was advertising in the gay community when AIDS was, well, the HIV was prevalent, that's the virus. And then I also have a report here from Charles Mackenzie, whereby the Red Cross refused to actually heat treat blood at that time because it would reduce yield, but it was known in Germany that heat treating that blood would kill the HIV virus. Subsequently, a number of haemophiliacs have caught AIDS and hepatitis C. So my question is, why should we trust the National Blood Authority with spike proteins and managing spike proteins? And I'll come to the 3-day issue in a minute. And will the federal government issue an apology to the sufferers of those people who caught hepatitis C and AIDS from mismanagement of treating the blood in the 1980s and provide proper compensation?
I think there has been conversation. John Carl, Chief Executive, National Blood Authority. There's a lot packed into that question, Senator.
There always is.
The National Blood Authority was created in 2003 with the passing of the legislation that established it. And part of the reason for that was, in fact, to assist in the establishment of national blood arrangements which did not exist prior to that. So they were essentially state-based services prior to that point. And the Red Cross itself, the blood service, had a different setup also. So I can speak about the national blood arrangements, which came into force in 2003, as I said. Prior to that, the issues that arose with HIV in the late 80s and hepatitis C that has been the subject of many representations, petitions to Parliament, an ongoing inquiry into the UK that encountered similar issues, a lot of countries did. There was a 2004 Senate inquiry as well, which was pretty comprehensive, and also other inquiries that occurred about that time. Other developments have occurred in the system, significant developments, and the role of the National Blood Authority in this is to manage on behalf of all governments, Commonwealth, State and Territory, the arrangements for, or the governance of the national blood arrangements. So that includes the Australian Red Cross Lifeblood, as it now is, which works under a deed of agreement to the National Blood Authority.
Okay,
and also commercial arrangements for plasma-derived products through a range of suppliers.
Thank you. So my question is to the Minister, and it's pretty much the same question. Will the federal government look at compensation to those victims who caught hepatitis C and AIDS from mismanagement of managing the blood in the 1980s. And my understanding is that in the UK inquiry they apologised and are compensating the victims. Will the federal government here do the same thing?
Thank you, Senator Rennick. I've been trying to look to see whether there is any information I can provide you. I have some recollection of a response to people who may have been infected during that time from blood donations, but forgive me, the fact that it hasn't really formed part of the last few months of my work. I'll see if there's anything further we can add. I haven't been able to find anything since you've asked.
Okay, thank you. So I'll just follow up with the question that we spoke about last time about vaccinated people can donate blood after 3 days. Now, subsequently, we've found studies where the spike protein remains in the blood as well as lipids. Plenty of studies. Up to 15 or 30 days, you can pick your point, but it's well past 3 days. So my question is, will the National Blood Authority extend the time that people have to wait before they donate blood after they've had a COVID-19 vaccination?
So, Senator, deferral periods that are determined for blood donations are determined and implemented by the Australian Red Cross Lifeblood with regulatory oversight by the TGA. So the National Blood Authority does not directly engage in those sort of considerations on those sort of clinical and related matters. When we spoke last hearing about the 3 days and your concern about that, it's important that, and I think I attempted and perhaps failed at the last hearing to try and draw out a distinction between issues related to transfusion of blood for those that have been vaccinated or had COVID, and issues around the health and safety of blood donors themselves. So in order to donate blood, you need to be healthy and well. And part of the consideration of that, as it is with a range of other vaccinations and other medical conditions, deferrals are put in place for the benefit of the donor, not the recipient of any subsequent transfusion. So in the case in question, the 3 days that you're referring to, that's really about donor health, because one of the potential side effects of vaccination is, some people get fevers and react in different ways. So as a very conservative approach, Lifeblood has a 3-day deferral for donors.
Well, it's interesting because I know Professor Skerritt said on the Today Show 2 years ago that your symptoms could take up to 6 to 8 weeks to appear. So why are you only giving 3 days? That's not very conservative to me.
The 3-day deferral is a requirement, a safety requirement for donors that is implemented by the Australian Red Cross Lifeblood. So if you go into a donor centre, if you're not feeling well, they won't take blood from you. So that's part of the initial process. So what they're saying to donors is, if you've had a vaccination, don't come in for 3 days.
But people can have side effects 2 weeks later after a vaccine.
And if they're unhealthy and unwell, they shouldn't go and donate blood.
But they might feel all right up to 3 days and then suddenly they have a stroke or something else 2 weeks later. So, these things may take time to accumulate.
They might, Senator, but I think you're also conflating issues of donor health, as Mr. Cole has indicated, and things that might appear in the blood that could make other people ill. And as I've explained before in this place, the spike protein, first of all, isn't a freely circulating protein in significant amounts. It's a transmembrane protein. It anchors itself into the membrane.
That's not what the paper said. The TGA paper said
sorry,
it can be
I'm just telling you a
secreted.
scientific fact.
It's in your own documents, page 9, 2389-6, the Pfizer non-clinical report, page 8, top paragraph, said it attaches to the endoplasmic reticulum. It can either be secreted
he should
from
be
the
allowed
cell.
Can I finish?
I
can categorically say that the spike protein has a transmembrane anchor region that makes the protein attached to the cell membrane. You're talking about the stages of messenger RNA, you're confusing messenger RNA and protein. They are different. One is a nucleic acid, one is a protein. We are now talking about the protein. There are small amounts of protein.
It says S antigen protein.
So let me finish. And if you need to on notice, I can send you another 10 scientific
No, you'll not
papers.
lie again, but anyway.
Okay, I'll send you another 20. So there are only vanishingly small amounts of spike protein, and the studies that have gone looking at them show that in most individuals they disappear within a couple of days, hence the 3-day thing. There may be a tiny picogram amounts in a few people for a few days after, but so what?
So what causes the myocarditis in children then if it's not the spike protein?
It's not the spike protein.
Well, what is it then? Is it the lipids?
It is thought to be an autoimmune response largely dominated by the cellular immune system.
So what triggers that autoimmune response in the children's hearts?
It is still unclear, but it is not the spike protein per se floating around. So it is total pseudoscience to suggest that if you're vaccinated somehow or you receive a blood transfusion from someone who had been vaccinated a week earlier, but you're at a higher risk of myocarditis.
I'm asking for caution.
Sorry, let me finish, Senator. Why on earth would any blood service in the world who have been exceptionally cautious, as we heard earlier today, around things like viruses from people who have a very low risk of HIV/AIDS, why would blood services globally allow
because in the 1980s...
Senator, let me finish my
Sorry,
sentence.
senators and witnesses, this is not helpful when it descends into a debate
I'm
across
just trying to answer a scientific question.
I appreciate that, Senator Rennick and Professor Skerritt. You both are actually entitled to ask questions and give answers. It just works better if you do it not at the same time. We do have a number of agencies to get through. Senator Rennick, I know some of them are... No, Senator Rennick, I'm still talking. We have a number of agencies to get through. I know some of them are agencies you've requested, so I'd like to move to them quickly.
Okay, that's fine. Okay, so in the 1980s...
After Professor Skerritt finishes his answer,
Very briefly, blood services worldwide have determined that the vanishingly small amounts of spike protein, 3 days, some of them might have 7, some of them might have 2, but a few days after vaccination... Sorry, Senator, I thought I was able to finish my sentence.
Yes.
But it does not pose a risk, including of increased myocarditis. Thank you, Chair.
Thank you.
Blood services in the 80s, didn't he treat the blood to destroy the HIV
Senator
virus?
Rennick, are we able to...
I think we should acknowledge that Australia's response to the HIV epidemic in the early 80s was world leading.
I'm not asking about that. I'm talking about the victims, the haemophiliacs,
anyway,
who've now
I
got
just wanted that
hepatitis C and AIDS.
Senators,
That's what I'm referring
Senator
to.
Roberts has questions for this agency as well. We're cutting him to his time too.
Senator Rennick
Has asked them. Okay, great. Are we happy then, as a committee, to dismiss the National Blood Authority and keep moving through the agencies? Thank you for your attendance.
Thank you, Chair. I'll consider myself dismissed.
Professor Skerritt, don't you go too far. It's not time yet. Office of the Gene Technology Regulator. Do we have senators at the table with questions? Senator Roberts? Oh, sorry, Senator Rennick. They're in the room, so Senator Rennick, you can go with your question, please. Thank you. Senator Rennick?
Okay, hi. Under Section 30C of the Therapeutics Good Act, the Secretary of the Commonwealth Department of Health must seek advice from the Office of Gene Technology Regulator on the safety and efficiency of any product which uses GMO as defined by the Gene Technology Act. Do you have any evidence where the Secretary has written to you asking for advice on the safety and efficacy of the COVID-19 vaccines?
Thank you for your question, Senator. Dr. Rajbula, Gene Technology Regulator. Rajbula, Gene Technology Regulator. Where the particular vaccine involves a GMO, there's reciprocal arrangement, if you like, for OGTR to seek advice from the TGA in terms of a risk assessment around that GM vaccine and vice versa. So the TGA may also request advice from the OGTR.
And have you got documentation of that?
For GM vaccines, yes.
Where they've written to you for Pfizer?
No,
Pfizer
because
one?
the mRNA vaccines were not regulated. They're not required to be regulated through the OGT.
Did they write to you and actually ask you that question?
No, because they're not required to be regulated through the
But how would they
OGT.
know? Because you're the expert. And by the way, gene technology involves both replication and transcription.
Yes.
Yeah, which is what
But
the mRNA vaccine does.
The mRNA COVID-19 vaccines did not involve any step of genetic modification
They
or
produce
a
proteins.
GMO.
Sorry, Senator Rennick, could we just allow Dr Buller to finish her answer,
Or
please?
GMO, which meant that didn't require regulatory oversight by the OGTR.
Yeah, okay. Well, I dispute that. Look up gene technology. But anyway, thank you.
Senator Rennick, Senator Rennick, is that your last question?
Yeah,
Are we happy to dismiss that agency?
I think the witness, I just don't think we need to patronise witnesses in that way.
Gene technology.
Senator Rennick, to tell the Office of the Gene Technology Regulator to look up gene technology is patronising
It's
and,
both-
and
it's both.
disrespectful.
I would remind all senators.
Anyway,
Replication
I just think it reflects
and
poorly on the
transcription.
Senate. The
Okay,
behaviour.
thank you, Dr Buller, for your attendance today. We appreciate it. I am calling the Australian Digital Health Agency. Senator Brockman. Or Senator Ruston.
Can I just to deal with a matter that Senator Rennick raised?
Sure.
They're clearly, and I'm not sure it's fair to take it on notice, but there were a range of compensation programs run for people who were infected with hepatitis C through the late 80s and 90s. Seems to have been run across governments, state, territory and the Commonwealth, but there is quite a bit of literature if you want to look it up. You can see the compensation arrangements.
What would be good is if I could get Infected Blood Australia to actually meet with the Health Minister, because he won't meet with them, and they're the best people because they're the victims who can explain their situation.
Well, it looks like there were compensation arrangements.
Well, they're telling me something different. I'm not going to argue with you.
Senators, I have called the Australian Digital Health Agency. You probably aren't best to engage on this one. So, Senator Brockman.
Great. Thank you very much for being here. I'll start by saying I wish we had a bit more time with you. Unfortunately, as often happens on a Thursday, we compress things a little bit. The Strengthening Medicare Task Force recommended an overhaul of My Health Record and improvements to better connect clinical IT systems across the health system. What's currently being done with this recommendation? And I hate to say this, but if you could keep the answer relatively short, that would be very helpful.
Ms Amanda Cattermole, Chief Executive Officer, Australian Digital Health Agency. Thank you so much, Senator. So there's probably two kind of elements to the answer, so I will try and be short.
Yep.
The task force recommendations are obviously under consideration by government at the moment, but there are a range of matters that we've been working on that are the sort of the foundation pieces, which include work that we've done to improve the usability and functionality of My Health Record over the last couple of years. We've done quite a significant amount of work in the underlying infrastructure so that it is more contemporary and really provides the kind of platform that we can then use to support the sort of recommendations made by the task force. And then the next work, which is under consideration now, will be going forward from those foundation pieces.
Okay. Do you, or does the department, and only answer this if you are responsible for it. If it's the department, I'll put this on notice.
We shall do.
But do you monitor the usage of telehealth?
That's not.
No, that's all done within the department. Okay, I'll put those
correct,
questions on
Senator.
notice. The other thing I just wanted to cover off on was obviously we've seen some cybersecurity issues in the private sector in the last few months, which have had a significant personal impact on a lot of people, but they've also had a significant commercial impact, including the lessening of trust in digital maintenance of records. I guess, one, how, in light of those cybersecurity incidents, what are you looking at to make sure that our protections in place are as strong as possible? And on the other hand, have you considered how you manage any reputational issues if there was, heaven forbid, an incident?
Yeah, yes, Senator, thank you so much for the question. And I have with me Professor Thatcher, who's our Chief Technology Officer, who can take some additional detail if we need to go there. But I might start, if I may. So absolutely, cybersecurity lies at the very heart of the agency, given the significant responsibility that we have in supporting the My Health Record and associated national health infrastructure. There's a range of ways in which we support the security and protection of the record, and it sits under a risk-based framework which has two key elements, the Protective Security Policy Framework and the Australian Government ISM, which is that essential 8 set of cybersecurity requirements that really drive the protection of the most sensitive systems. Our system is accredited to a protected level, and that is reserved for systems with the highest kind of level of security, like you'd expect from ours. We have a deeply capable and experienced cyber team who report to Professor Thatcher, whose job it is to essentially monitor around the clock all of the systems that we support, including the My Health Record. We do that with deep partnerships with our partners right across the cybersecurity network, and we have a whole range of protective and proactive controls that not only separate information, they keep it encrypted in various ways, they separate people's ability to see various things, and they continuously monitor all of our systems so that even the smallest blip we can detect rapidly. And we can take very proactive steps to manage and monitor any of those risks. So I can go into further detail if you want, or perhaps Professor Thatcher might, but is there anywhere that you'd like to go particularly?
I'm happy to put some more detailed questions on notice, but I guess just very quickly, do you think you're as prepared as you could be in the current circumstances that we face?
So,
I mean, cyber attacks seem to be becoming more common. Targeting personal records, particularly health records, which are obviously deeply personal.
Yes. So Senator, I would say this: no one is immune from this, but this is at the absolute heart of the work we do, and we have such significant controls, protective mechanisms, monitoring, segregation and separation controls. Within a protected environment which is of the highest order, that we are certainly as well placed as you would hope an agency like this to be. And perhaps I can see if Professor Thatcher has anything further to add. But we review this continuously. We have governance frameworks that drive it. We exercise it. We did that as recently as last week, and we do everything that you would hope we do to monitor, check, test and control.
Look, I appreciate Professor Thatcher's probably got a lot to say, but unfortunately we are pretty stretched for time. I'll put the rest of my questions on notice and we'll have more time in the next estimates round. So thank you, Chair.
Thank you, Senator.
Thank you, and thank you for travelling to join us today. We do appreciate your attendance. I'm moving on now to the Australian Radiation Protection and Nuclear Safety Agency. Senator Steele-John.
Anyone want that?
Thank you so much, Chair. Just give them a minute to come to the table.
I reckon you can start asking if they're in the room. Yeah.
Are they in the room even? Yes. Okay. So my question's in relation to the recent incident in Western Australia involving lost Rio Tinto capsule. Deeply concerning to the communities, I'm sure you understand. Can you briefly step me through, first of all, what was ARPANZA's involvement in the incident itself?
Yes, so Gillian Hirth, I'm the Chief Executive Officer of the Australian Radiation Protection and Nuclear Safety Agency. Thank you for your question, Senator. ARPANZA's role in this incident was really in providing support to the Western Australian Government. Western Australia regulate Rio Tinto. We don't have a regulatory role in Western Australia.
So the non-regulatory role, basically.
Yes. ARPANZA was requested I think we were notified on Friday the 27th
Friday the
January,
27th,
and we
yep.
were requested for some support, to provide some support with wide area gamma monitoring, and that activated the Commonwealth Disaster Response Plan, ComDIS plan.
So wide area gamma monitoring was that the sole thing that was requested from WA?
Support in the search for the source, and that is the technology that we apply.
Okay, all right. Was there any other involvement of our Panzer in the incident?
No, that was the
role. Okay, thank you.
Senator, if I may, of course, there's a role for radiation safety in the department, which is beyond the regulatory role of Panzer. And just to assure you that we were involved in the whole of government response from the Commonwealth in support of the WA government's response to this incident.
Thank you. So what process reviews, if any, have been undertaken following this incident by our Panzer?
Our Panzer has done their own review of our processes. As you would with any emergency response, you would do an after-action review.
Yes, of course.
In relation to the Western Australian response, currently we understand that the Western Australian Government will undertake an investigation into the incident. Our Panzer coordinates the Radiation Health Committee. I would have to check when our next meeting is due. I think it's in March sometime.
Could you take that on notice and provide
yes,
that to us?
and we will seek an update on the status of that
the investigation. Absolutely. Is our Panzer looking to use this case to update its regulation of the transporting of nuclear material? Although, taking what you just said about your regulatory role, if not your regulatory role, then the recommendations you might make to states and territories around their regulatory models.
I think it's important to note that the Code of Practice for the Safe Transport of Radioactive Material, which is published by our Panzer through our Radiation Protection Series, does set the standard, and that aligns with the current international best practice recommendations.
Yes.
There are, of course, 9 jurisdictional regulators in radiation safety in Australia, and one of our Panzer's roles is to promote national uniformity, but promote is different to require national uniformity. This is an issue that we have raised and had discussions with our jurisdictional partners about other ways we can ensure that we are regulating in a more consistent manner across all states and territories and jurisdictions in Australia.
Thank you. The existence of 9 separate regulatory models for such a critical area of oversight is really quite concerning. I'm glad to hear that you have raised it. Is there... I might just quickly go to the Minister. Minister, are you aware of the role the Health Minister might be playing in putting this question of different regulatory models on a National Cabinet agenda or a meeting of future health ministers?
I'll take that on notice. I haven't had any discussions with the Health Minister on that.
Can you tell me, Dr Hirth, if just my last 2 questions for you are, could you take on notice for us the ways in which the WA regulatory model differs from that standard? You've said that you use, forget the terminology used, but the standard that you use as best practice.
I should clarify that all states and territories do follow the same code of practice, but in this instance, if the code of practice had been followed, you shouldn't have an incident of that type.
Absolutely, yes. So if you could share that with us, that'd be good. And just finally, you've shared with us, I think, that our Panzer doesn't have a role in communicating directly with the community in relation to incidents such as this?
In relation to the Western Australian incident, the communication with the community in Western Australia is the responsibility of the Western Australian Government. We did provide briefs to the Commonwealth Government and to other partners. We would have those.
First Nations partners,
But we don't have a role in relation to that particular incident for communication during an emergency. That is the responsibility of the, lead,
states and territories.
of the lead agency.
Okay, and I note here that I understand that Rio Tinto have offered to pay all associated costs. What have been the cost to the taxpayer of not only the search to the capsule, as you understand it, but also the work that you had to undertake in supporting WA?
I would have to take that question on notice. I know that we are compiling that information, but I don't have the full detail here.
Could you? The cost to our Panzer and what you estimate the cost to West Australia of that search to be, because the public certainly shouldn't fit the bill for this incident.
Absolutely.
All right. Thank you, Chair.
Senator Steele. John, are we happy to dismiss our Panzer? Yep, great. Thank you so much for travelling to attend and provide evidence today. Senators, we still have 3 more to go, so we'll go as quickly as we can. National Mental Health Commission.
Has TGA been released?
No.
Okay, well, we're breaking at 6:45, aren't we? So we'll be coming back to that after dinner.
Well, our hope was actually to get through everything. We're going to aged care after, was the informal agreement by the committee, but...
Well, you just said that you've got lots more.
Do we have questions for the National Mental Health Commission?
Look, actually, Ms Morgan, I am so sorry to do this to you because I really did want to talk to you, but in the interests of understanding time, if it would be possible to get a brief from you, if that would be okay, Minister.
I'll ask you
to get a brief, a one-on-one, that would probably be a great advantage to me, and it will save some time here. And I'm so sorry you've sat here all afternoon because I really did want to talk to you, but I'm happy to do that.
Thank you.
Thanks very
You're
much.
dismissed. National Rural Health Commissioner.
Got your name tag?
I had questions, but I waived it.
Okay, so you're happy to put yours on notice. Did anyone else have questions for the National Rural Health Commissioner?
I just got, and I can run through them, and I'm happy for them to be taken on notice.
Sorry, we have the Deputy Commissioner here.
Yeah.
Welcome.
Thank you. After making you come. Yes. So look, just to, I was really interested in understanding the broader impact that you think that the current health, general practice, rural and regional sort of health sector workforce shortages are having on rural and regional Australia. But and I haven't got time to prosecute this with you now, but if you could find some time at some stage, I'm keen to understand the differences between regional, rural and remote, and including Indigenous communities, because we seem to have this habit of just chucking them all into one basket, but they are completely different in terms of how they manifest themselves in their challenges. So I would have loved to have gone through with you what those challenges are. I was also keen to understand what your findings or experience has been in relation to how DPAs have been working over time and what the changes have done in relation to that. And just more generally, if you have in your consideration as the Commissioner come up with any ideas or initiatives, measures, etc., that you actually think that could uniquely respond in rural, regional, remote Australia, understanding that a one-size-fits-all model clearly doesn't work, which is the reason that you exist. But I could possibly ask you to try and answer all those now. So you've had a lovely trip to Canberra. So thank you.
Great to be here.
Send them back. So look, I'm so sorry.
That's okay. So Faye McMillan, I'm a Wiradjuri woman, and this is my first time appearing, and I'm appearing on behalf of the Commissioner who is on leave. But to go to some of the questions that you've asked, Senator, around the DPA, I will refer to the department on those. But certainly out of the Medicare task force was the multidisciplinary teams which respond to those uniquenesses that you spoke about that differ from regional, rural, remote and very remote communities. And so putting it back into what do the communities of those regions require and what are the health professionals that are in those communities going to be able to offer as far as primary health care and the opportunity to support continuity of care for all Australians. So that's the first one. DPA, as I said, will pass over.
I mean, once again, Minister, I don't know whether it's possible to ask if it would be an opportunity for me to be actually get briefed by the Rural Health Commissioner.
I'm sure.
I'm sure that.
Yeah,
I'm sure.
because I could sit here for 2 hours with you, but I know that I'll probably not make it out of the room alive.
No.
You've done marvellously well at your first time at estimates.
Thank you. Well done. Thanks for travelling. Lovely to see you. You're dismissed. We are now at the TGA. I understand we've got questions from Senator Roberts and questions from the opposition. We'll go to Senator Roberts and then I'll just grab you, Senator Preston.
Thank you. Professor Skerritt, on notice, could you give me the titles? I won't ask for the names of the people on your committee that reviews doctors' reports attributing deaths to COVID vaccines. And I want their qualifications and whether or not they're registered doctors, please. Albacidin. Recent papers on Albacidin confirm earlier hope it can take over from conventional antibiotics. One recent paper showed Albacidin would not have a problem of antimicrobial resistance. That is a major issue worldwide. Is there anything happening at the TGA on Albacidin? Are you monitoring the science at least?
Thank you for your question, Senator. We are certainly very closely monitoring the science. In fact, I'm keynote speaker next Thursday at the Australian Antimicrobials Congress, which is held every 3 or 4 years in recognition of the importance of regulatory issues and monitoring the science. We haven't had a submission relating to that product because it's still very early days, but we are monitoring. We have guidance to manage antimicrobial resistance because, as you've indicated, it's a serious threat.
Thank you. On 2GB Radio, 16th of March 2021, you said there is no evidence of cause and effect between the AstraZeneca vaccines and thrombosis. That turned out to be false, didn't it? There is cause and effect between AstraZeneca and thrombosis.
Well, if I said that on the 16th of March 2021, and I'd have to see the transcript, it was before I'd confirm whether or not I said that.
Yep.
The evidence developed very much in the days including Easter because many of us, or I think 3 of us sitting at this table, didn't have an Easter in 2021. They were, everyone talks a cliche of 18 nowadays, but I think for the 3 of us and many of our other colleagues, they were.
Were you fit then to go on and make the comments?
Well, first of all, I want to check the date of that statement and what the wording of a statement has, because I have expressed concerns that statements are not always accurately reflected, so I'd like to see that statement. I think the view was that as of early mid-March 2021, there wasn't evidence. And the other thing we need to clarify is thrombosis with thrombocytopenia is a separate condition from potential impacts of medicines and vaccines on thrombosis alone or thrombocytopenia alone. The TTS syndrome, which really was first identified in the last week of March 2021 and therefore was the area of intensive work over Easter and the months that followed, is can't be very unique, is an almost unique condition.
One of the things that's really annoying a lot of people, especially the vaccine relatives of those killed by the vaccines and the vaccine injured, is that there's been no acknowledgement from the federal government or yourself that these injuries are occurring. There's been no empathy for the pain. There's just no, this is the best stuff in the world. The injections were not even tested properly in the United States. And
Senator
yet you
Roberts, if
approved
you
them.
could pose it as a question, please.
The question is, when will you apologise to the people who've been brutally injured by these vaccines? Lives destroyed.
Sorry, Senator, I have actually apologised on national television, together with former Minister Hunt, when the first sad death of a lady in the Central Coast. We apologise in writing in our weekly and now fortnightly vaccine safety reports. So we put out detailed public reports, as well as doing media, detailed public reports on vaccine safety. And in that we acknowledge the pain and distress of those who have been seriously injured. But we also emphasise the extreme rarity of these conditions. The same could be said for any medicine. There are other medicines that have many more deaths and injuries associated with them than COVID vaccines, for example, or higher rates of injury. So any death or any adverse event is is very unfortunate, and we extend our condolences. But unless if you want to live in a cave or under a rock in a world without any medicines or vaccines, go back 300 or 400 or 500 years.
that's not what we want to
we
do.
have modern medicines, and every medicine has risk as well as benefits. By way of indication, since the beginning of the COVID pandemic, more than 10 times as many people have died from paracetamol, from Panadol, than from adverse events due to COVID vaccines.
After you've touched...
Thank you,
And yet we're not
Professor.
banning paracetamol.
Thank you, Professor Skerritt. We are due to go to the dinner break. We can extend by 5 minutes if we can try and get through this, and then we can dismiss the TGA. Senator Roberts, I'd like to share the call around. Are you able to finish up your
Yes, I get one more question.
One more question, thank you.
Referencing a preprint paper from the British Medical Journal dated 9th of February 2023 titled Age-Specific Severity of SARS-CoV-2 in the Netherlands, produced by the Netherlands Ministry of Health. I don't expect you to have read this paper yet, but we can discuss the issue the paper raises. Their conclusion was that in the Netherlands, the risk of hospitalisation from COVID itself grew exponentially across each age group, and this held true across all 3 major COVID outbreaks in the Netherlands. Children under 10 had a hospitalisation rate of 0.37%, with 0 progressing to ICU or death. That means 99.63% of kids getting COVID did not need a hospital visit once infected. This risk grew exponentially across the age groups to 5.1% above 70.
Has there a question?
Yes, there is a
Yeah.
question.
Okay.
Could you summarise, Minister? Sorry, I'm going to summarise. Pfizer product does not stop transmission. Kids have a tiny risk of hospitalisation and a 0 risk of serious harm from COVID. 2 kids we know of have died from Pfizer vaccine on your own assessment. So why are we giving this bloody thing to children?
Well, most of the statements you just made then are wrong, in fact, if not all of them, probably, Senator. So first of all, there are impacts on transmission. The impact on transmission of Omicron is much lower than the impact of transmission on Delta and so forth.
For how long?
Senator, we have provided that information on notice. We can provide it again. Secondly, we do not agree that 2 children have died. And thirdly, there have been examples of Australian children in intensive care following COVID infection. And again, we can provide you with that information that comes from departments such as New South Wales Health.
Thank you, Professor Skerritt. We have a few minutes for the opposition, so Senator Hughes and then Senator Rennick, and we're finishing in a few minutes. Okay, thanks.
Professor Skerritt, on the back of the package for Nicorette's, and it's produced by Johnson & Johnson, and they're represented on the TGA's Advisory Committee on Medicines Scheduling via the Consumer Health Products Group. Are you aware of a Mrs. Julie Viatos?
Yes.
Yes, so Ms. Viatos works for Consumer Healthcare Products, and on their own website and everything else, they stipulate that they represent Johnson & Johnson with regards to Nicorette, my mistake. At any stage throughout the discussions around looking at MVPs or NRTs, has Mrs. Viatos made a claim of conflict of interest or?
So we believe it's important to have some people with practical industry experience on a range of committees, including the Advisory Committee for Medicines Scheduling. We have, or the Chair, through the Chair, we have conflict of interest processes, and indeed my colleague Dr Gilmore Walsh has worked closely on tightening them, communicating them and modernising them. And so before each item is discussed, and also ahead of a meeting before papers go out, there are questions asked about whether there's a potential conflict of interest. That's either self-identified or identified by other members of the committee. Nicorette, I believe, has not been discussed at this committee in Ms Viatos's presence.
Okay, so has vaping and vapes that contain nicotine and flavours of vapes ever been discussed at a meeting where Mrs Viatos was present?
I believe she would have been present at the meetings that discussed prescription-only vaping products, but I also do not believe that there was any view expressed about a comparison by her about a comparison with products such as Nicorette.
That's all right. So latest proposals from the
and we can make the minutes of that meeting available to you.
That would be
if you wish to
appreciated. And if
confirm
there
that.
ever has been a declaration of conflict of interest, that would be helpful. So TGA's latest proposals around the regulation of MVPs include banning all flavours except tobacco, introducing plain packaging and limiting the nicotine level available in MVPs. Is it not the case, and particularly think of it this way, people that are doing the right thing through the pharmaceutical model have started on a vape, which tends to happen, that's tobacco flavour, but then move away from that because that's the whole point of getting away from cigarettes, moving away from the tobacco flavour. Yet, which we could talk about all night, the fact that you would potentially be pushing those vapers who are using the prescription model back to the illicit market for flavours if they were to be banned. I certainly wouldn't go back to a tobacco flavoured vape. But that these were discussed, and Mrs. Viatis was part of this, all while someone she represents is able to continue selling NRTs in colourful branded packaging in a supermarket. So Nicorette's available in green packaging with bright colours, in coolberry, icy mint, fresh mint. So Nicorette would still be able to sell their juicy fruit gum.
Senator, you're conflating two things.
I'm not.
The TGA consultation paper, which has proposals, and our only proposals, was not an agenda item and discussed at the Advisory Committee for Medicine Scheduling. It was a totally separate process.
So did Mrs. Viata have anything to do with having vapes scheduled as prescription-only medicine?
As I said, I believe she was present at those meetings, but you also have to remember that this is an advisory committee. They have no decision-making role whatsoever. You
don't think there's a conflict of interest there between having someone who represents Johnson & Johnson, who makes a considerable profit from their own product, advising on another market?
So if she had advocated that in a comparative way...
Well, I don't know whether she's advocated it.
Sorry, I believe there would have been, and I think that members and the chair would have asked for her to be recused from that meeting. But
Are minutes from those meetings available?
Yes, again, we can make the minutes from those meetings.
If you could table those minutes of any meetings?
Yes, we may have to provide them in confidence.
No, that's fine. Happy in confidence. All good. No, that's all
Keen
good.
to move on. I'm seeking
I'll put the rest on
guidance from the committee. I understand, Senator Roberts, you're happy for us to dismiss the TGA...
Not if you're not supporting a spillover.
Well, no, I'm not supporting a spillover.
Okay, well, I'm not happy to let the TGA go.
Okay.
The committee resolved. The committee has resolved to move on to aged care after the break, Senator Roberts, so that's...
Well, what about Standing Order 26.4 that says we can either you agree to a spillover or we can keep asking questions?
The committee.
So Senators, we're going to suspend the committee for the dinner break.
So I'm not going to get any more questions into the TGA?
I'm not dismissing the TGA. I'm suspending the committee for the dinner break.
Right, okay, thank you.
And if we could have a discussion.
Sorry, I better get...
The TGA is required to stay through
I
the dinner
hope
break.
to be able to provide advice during the dinner break. The committee is suspending for the dinner break.
Okay.
Now resume. I want to start by thanking Senators Roberts and Rennick for their cooperation in assisting the business of the committee this evening. We are returning to the TGA. We'll be doing that for 15 minutes between Senators Roberts and Rennick, and then we'll be moving to aged care and dismissing the remainder of that outcome for health. Senator Roberts, you have the call.
Thank you. Thank you, Chair, and I thank the committee for their consideration. Professor Skerritt, can I reference Freedom of Information Request 2289, and you can take this on notice. The Freedom of Information to the TGA asked for the patient-level anonymised data from the Pfizer's Phase 2-3 study. A simple request. Your response was, quote, "The TGA does not hold any relevant documents. To be clear, the TGA does not hold individual-level patient data in relation to this application for provisional registration." End of quote. What was the manner of examination of these documents if they're not in your physical possession?
Thank you for your question, Senator. As I've previously indicated, there is only one regulator in the world, the US FDA, with a budget of $7 or $8 billion, that actually looks at individual patient data. And the rest of the regulators, including the European Medicines Agency, which regulates for 600 million Europeans, like us, takes statistically validated analyses of patient data, and if there's issues with the individual patient data, the FDA, through teleconferences and video conferences that happen throughout COVID, will raise those issues. So the reason why it was a nil response for the FDA is that we, like every other regulator bar one on this planet, do not get individual patient data. That doesn't mean a medicine submission of thousands and thousands of pages of data does not have extremely extensive analysis of patient data, but it just doesn't have JH from Bethesda, Maryland, received the dose on the 25th of April. FDA get that, and that is why the US FDA has 15,000 staff.
So you did not examine the documents here?
We examine all the documents here in details. As I indicated to you, we receive 5, 10, sometimes 20,000 pages in the old days when it was printed out of information with a vaccine or medicine application, including the provisional ones where we receive many thousands of pages. And we have teams and teams of people who spend hours and hours and weeks assessing that data.
So presumably in that hours and hours and days and weeks, they made a summary on a piece of paper. They didn't just keep it in their heads, I hope.
So hold on. They wrote an evaluation report. They also wrote an Australian Public Assessment report, which was published on the day of approval of the vaccinations. It is a public assessment report. Any member of the public can download it from our website.
So how do you not have the data?
We have the data. What we don't have...
And that data is in the report you just mentioned?
So, no, the data is in the submission to us and the evaluation. Some of that data, really the highlights, the most relevant parts, are in the public assessment report. The public assessment reports are usually 40 to 100 pages.
I'd like your data. What your summaries that led to the public report?
You'd have to request that under Freedom of Information because some of it is commercial and confident, some of it is not, but please submit an FOI application, Senator.
Well, I'd like it on notice. I'm requesting that document.
We'll have to check through ODGA's Senate procedures whether that is equivalent
yes, well,
to
we
an
can do that
FOI
in a minute. We can do that in a minute because I'll take your mind back to earlier today when Senators Antic, Rennick and myself asked about Freedom of Information 3727. I'll read that again. From Queensland, Dr McCann requested causality assessments for all of the reported deaths in the Dane database, which on negotiation was reduced to 11 documents, of which 10 related to Dane death reports. These documents showed the TGA had assessed as causally linked to COVID vaccine deaths that are not included in the 14 deaths from COVID injections. I'm particularly interested in just 2 of them.
Sorry, Senator,
hang on, I'm talking. I'm specifying what I want.
Senator Roberts, can I ask your question in silence?
It's not
and
a
then Professor
speech.
Skerritt, I'll come back to you.
Thank
but
you.
I would encourage you to direct it as a question.
I want the data on the 9-year-old who died and the 7-year-old died. And we were happy to accept the names to be redacted. But
Senator, we have,
detail.
first of all, your assertion that these children died as a result of vaccination is incorrect. Secondly, you have been provided with what is considered appropriate under the Australian law, including the Freedom of Information law and Australian privacy principles, as being appropriate. So you have been given what is appropriate. I do not determine Australian privacy principles, and I'm not the Information Commissioner for Australia. We are working under nationally agreed principles for what we release.
You're required to produce this
Professor,
committee.
excuse me, it may assist. FOI provisions aren't particularly relevant in this forum, but what is relevant is a public interest immunity claim, and if you're seeking to do that, you can do so through
we can do the same for the same information.
And there are standard and accepted grounds upon which that can be made. Senator Roberts,
I'm
please
advised
continue.
that you're required...
Sorry, Chair, I think under that basis the Senator would need to write probably through the presiding Minister in the shape of Minister Gallagher, who would then refer it to...
Yeah, I'm happy to take it on. To take it on as a
I'm not happy yet.
You're seeking the document. I will refer it to the Minister for Public
I'm not
Interest.
happy yet because Professor Skerritt is required to produce to this committee any information or documents that are requested. There is no privacy, security or other legislation that overrides this committee's constitutional powers to gather evidence, and you, Professor Skerritt, are protected from any potential prosecution as a result of your evidence or producing documents to this committee.
Yeah, it's been...
If you wish...
I will take it.
I'm talking, Minister. If you wish to raise a public interest immunity claim, it is up to the committee and the Senate whether to accept that.
Well, that's where it ends up.
If you have any concerns in regard to this, you should raise them with the chair. But I want you to take on notice that I want you to produce that document to the committee or properly raise a public interest immunity claim through the proper channels.
I believe the Minister has undertaken to raise that as a PII claim through the relevant Minister. As she has done that, I think we need to move on to the next question, Senator Roberts.
Can I just make the point that the Senate can also, Senate inquiries, Chair, can have a process for treating confidential documents in confidence and distributing them.
But at this stage, there's not really much more we can do, Senator Roberts, except wait for the PII claim to be made and then consider it.
Yep.
And I think it is important to understand that if information being provided to the TGA under these circumstances was subject to public access through the Senate committee process, you would see it a much more difficult job for the TGA to get the information it needs to do its job. So let's be clear about that.
And I would just remind senators that the estimates process is a public process. We don't have a forum to take confidential information, which is why this claim needs to be made.
Right, so we go back to the PII.
Just we're 7 minutes in, just to give you guys an indication.
Does, Professor Skerritt, does myocarditis cause cardiac arrests?
Not usually.
That's not what two cardiologists and a surgeon with a PhD in genomics has just told me.
I'm sorry, you just need to look at the medical literature and perhaps
that's all I need to know.
My two medically qualified colleagues
I'll take
may
that.
also comment.
I don't want to dwell on it.
Not usually is the answer.
So, thank you. Well, we'll take that. So I just want to refer to page 19 of the Pfizer non-clinical report and a first paragraph below the first table, and I'll quote it for you, is that V8 and V9 have identical amino acid sequences of the encoded antigens and differ only in their codon optimisation sequences, which were designed to improve antigen expression. Why did you originally redact that paragraph in the original Freedom of Information, given that that proved that the vaccine was gain of function that increased the toxicity of the vaccine by increasing the spike protein?
Senator, I don't have the relevant document in front of me, Chair, so I think we'll have to take that on notice.
Take that on notice.
No, I don't, well, OK, so I've just read it out to you. This vaccine increases the antigen expression, right, of the spike protein. It increases the amount of protein made by the vaccine over the virus. OK, a traditional vaccine, is genuinely attenuated, not empowered with a greater expression-making function. So
Senator
do you
Rennick,
accept the vaccine is gain of function?
It's been taken on notice. We don't have.
Do you accept the vaccine is a gain of function because of the codon optimisation?
We don't have the document that you're citing
Will
from.
you not interrupt me, please?
Well, I'm trying to facilitate.
No, don't interrupt me, Minister.
Senators,
we don't have the document.
I was listening carefully.
We do.
Senators, I was listening carefully. Professor Skerritt has taken the first question on notice. If you are directing this as a new question, he said he's not able to answer questions on that document.
Okay, so I'll go to the next question.
Well, he's taken it on notice, apologies. Not that he can't answer it, that he'll come back to you.
Do you agree on page 44, page 35, we have 34, 35, we have an increased transfection rate because of the designed lipid that you said is the lipid that normally goes in a sausage. It's not, so you got that wrong as well. That the vaccine has an increased transfection rate, much higher than the actual original virus that has to enter through the ACE receptor.
Chair, could I please be asked a question without reference to a document that we do not have? Otherwise, I won't answer and I'll take it on notice. If I could be asked a question without reference to a document.
You're avoiding...
Professor, I can't instruct Senator Rennick what to ask, But Senator Regan, I think it would assist in your questioning. I don't believe this witness is going to take any more questions on this document which aren't on notice. So we've got 5 minutes to go.
Okay, so you're avoiding the question. That's all I need to see. The people will see what you like.
Senator,
page 45.
Sorry, Senator.
Page 45.
I think Professor Skerritt has a right to respond to that.
Answer because I think the accusation, and I'm avoiding the question, is quite offensive. It's not the first time you've made that offensive accusation.
Well, you haven't answered the question. Okay, that's a fact.
I will answer the question without reference.
Can I
to
move to the next question?
Excuse me. Let the record state that Professor Skerritt has taken the question on notice and endeavoured to come back to the committee. Senator Rennick.
Okay. All of you have all said that the vaccine has stayed in the shoulder. That was the initial description, and yet the biodistribution table on page 45 of the document that you're well aware of, you don't need the document in front of you, shows that the lipids in the animal trials went throughout all organs, or nearly every organ in the body, and was still increasing after day 2. Why have you said that the lipids only stay, or the vaccine only stays in the shoulder, when the animal trials clearly showed that it was distributed throughout the entire body?
Well, first of all, unless if there's fairies involved, the lipids cannot increase in coming days. A set amount of lipid nanoparticle is injected into the body, like other lipids, and these lipids are, and I'll repeat, very similar to what you and I have in our, well, at least in what I have in my sausages. You may have different sausages, Senator.
They're proteinated.
But these lipids get decreased because they get broken down by the body. They can't spontaneously increase. As far as the issue about where, they're mainly retained at the injection site. They were the wording that we used. There's moderate distribution to the local lymph nodes and spleen, and only a small fraction goes elsewhere in the body.
Have any trials been done on people receiving 5 doses of the vaccine, in particular, with particular note to immune imprinting of repeated vaccination? 5 doses. I asked this question 18 months ago, but I'll ask again.
18 months ago, I don't believe anyone had 5 doses of vaccine.
That's right. You mocked me for asking. Well, here we are. We're at 5 doses now.
So there is experience now, and again on notice, we will provide the references from multiple on the immune response and how it is enhanced following multiple doses of a vaccine, 3, 4 and 5. We will provide results of those studies, including work from the US Centre for Disease Control on notice to you, because we'll provide references to those studies.
So despite the own public assessment report noting that the risk of vaccine enhancement existed, you're denying the fact that risk exists?
So the public assessment report, written 2 years ago, said that in any vaccine you have to watch out for the principle of immune imprinting. And that is something that we're still watching out for, but we're not seeing evidence. If there was evidence of strong immune imprinting, you would see a decreased response. So in other words, subsequent boosts would not raise neutralising antibodies. What we are seeing, and ATAGI also considered this data, as well as TGA recently, that these additional boosts are still raising neutralising antibodies very significantly, particularly BA1 and BA4-5 bivalent vaccine boosters. They are doing a very good job in raising neutralising antibodies.
That's a down-regulating antibody. Last question.
It's not, Senator.
Last question. Why should anyone believe anything that you or Professor Kelly or Professor Murphy? Professor Kelly has said the vaccine would stop transmission. He's given me death rates from the unvaccinated COVID rate that's higher, for Omicron that's higher than the Alpha variant. Professor Murphy said the spike protein doesn't go into the blood, despite the fact that he then admitted he hadn't read the Pfizer document that said that there'd been no distribution and degradation studies of the S antigen protein, and you've misled on the Moderna statement and the lipids. So why should anyone believe anything you three say?
Senator, I think in terms of coming up with factually wrong statements in this place, I think you...
It's not factually wrong.
Well, no, I reject your assertion.
So you can't answer the question...
Well, first of all, I reject your assertion that I've misled. So I've got to start with that premise, that I believe you're not telling the truth.
The witness has a right to have his answer heard.
So first of all, I do not accept your assertion. So secondly, the question then related to the distribution of the spike protein through the body, and as I indicated, it goes to a transmembrane anchor. Only very, very small amounts of spike protein go other than to a membrane
anchor. The body.
The Professor has a right to have his answer finished,
so
please, Senator.
It does not go into for example, red blood cell and white blood cells to significant amounts, circulating cells. Many cells do not float around your body, otherwise you'd be a big
Many
blob.
cells do.
You'd look like SpongeBob SquarePants if all your cells floated around the body.
Distracting.
So whether it's cells that stay in lymph nodes or whether it's other cells, most cells do not go around the body. And
some cells do.
And hold on, there are also not ACE2 receptors on many cells that do go around the body, such as
But with transfection
erythrocytes.
overcomes that.
No, it doesn't.
Yes, it does.
Thank you, Senators. Was your answer concluded, Professor
Yes, thank you.
Skerritt?
Yeah.
Thank you
Thank you,
both. I
Chair.
appreciate
Thanks for your
you
patience. Thank you, Chair,
condensing
and
that.
committee.
I really do. Professor Skerritt, it's time for us to say goodbye.
Thank you.
I understand that this is actually goodbye, and you are retiring. So on behalf of
Thank you.
on behalf of the committee, I want to thank you for your attendance here over many years and for your service as well to the TGA. We do appreciate your presence. It's possible you won't miss us as much as we miss you, but we are grateful for your.
Thanks, Senator.
service.
I'm not leaving the department for a couple of months, and I still will remain active professionally, although not as a public servant.
Well, we wish
But
you
I would
well.
put on record, but I have no commitments to future employment. I don't want that to be taken that I'm about to work for Pfizer tomorrow or anything like that.
I wasn't going to put it to you, but thank you. And Minister, would you like to?
Yes, I just on behalf of the government, and I know that Minister Butler has already made a public acknowledgement of the work of Professor Skerritt, but I would also like to acknowledge his very significant contribution to our nation as a public official who has served with distinction and in extremely challenging circumstances, particularly in the last few years. We wish you well with your next steps, whatever you choose to do, and thank you very much for your service.
Thank you very much, Minister.
Thank you, Professor. And on that,
Thank you, Chair.
on that note, Outcome 1 and associated agencies free to go home. Or back to work or wherever you go. We will now be moving to Outcome 3, Ageing and Aged Care. It's my intention to do with the department, and we can come to the agencies listed under that outcome second. Is that okay? Or would you? Yep. So Senator Ruston, you have the call.
Okay, thank you very much. I just would like to maybe, well, no, I wouldn't maybe. I do want to speak to somebody around the aged care support program extension grants. Is that you, Mr Lai?
Senator Michael Lai, Deputy Secretary Ageing and Aged Care. Are these the COVID grants?
Yep.
Senator?
Yep.
Yep.
Okay. I was just wondering whether that you could give me an idea of what the time frame is for grants to currently be approved. So what quarter are you working on in terms of grant approvals at the moment?
So, Senator,
For
there's not
reimbursement.
a fixed time frame for each grant to be assessed. There's Ms Greenberg's going to explain to you the different categories. We've got some which are relatively simple in nature and lower in cost, right through to some very expensive claims, which, you know, in excess of $1 million, which are very, very complex. So that there's not a so some of those claims are taking much longer to assess, and then we have a category of claims which are for providers who are experiencing particular viability issues, and then we're trying to process those ones in a separate stream and do those as quickly as possible. But I'll let Ms Greenbergs describe the times.
Helen Greenbergs, First Assistant Secretary, Service Delivery Division. Senator, as Mr Lai's outlined, it is highly variable depending on the scale of the application. Other factors that come into play in terms of the timeframes required to assess goes to whether we need to go back to the applicant, and in some instances we do need to go back on a number of occasions for follow-up information and for clarity around some of what's been applied for in terms of the grants. So that can be quite an extensive process. Around 90% of all applications we do need to engage back with the applicant.
We've had advice from the sector that there's over $100 million worth of grant applications that are sitting with the department from last year. Would that number be correct?
Senator, there's a very, very large amount of money associated with these grants. The grants were originally appropriated for a total amount of, I think it might have been just under $30 million, and with the wave that happened at Christmas time last year, well, in 2021-22, there was a very, very large number of claims associated with that COVID wave, and in the budget, the government increased that appropriation. It's been increased a couple of times, but it was increased by a factor of $800 million to deal with the large number of claims associated with that wave and with COVID cases since in aged care. And so we do have a very large number of grant applications. They're continuing to come to us now. And so we are processing those as fast as we can, but there are a number of claims that outstanding that relate to the second half of last calendar year that we are processing.
In terms of, the 90 days, I suppose, would you be able to provide advice on how many claims are currently outstanding for longer than 90 days from receipt of the application?
Yep, Senator, we're not working, I'm not sure that we're working to a 90-day
No, I use that as a sort of like a standard sort of accounting time.
Yeah, we're happy to give you that figure.
We have
to take that on notice.
Yeah, no, absolutely. One provider actually came forward and said that the amount of the claim that they currently have with you amounts to 8% of their annual turnover within their organisation and putting extraordinary pressures on their cash flows. What sort of consideration is being given in the prioritisation of the assessment of these claims to the kind of magnitude of the claim and the likely impact it may well have on the profitability or the operating of the business?
So, Senator, we generally assess applications in line with when they were in the order that they were received. We do make exceptions for providers who indicate they are in financial distress, and we prioritise those applications and the assessment of those applications and work with the providers on those. If there are providers who are under financial pressure, we do ask that they make contact with us, and we will work with them to prioritise those assessments.
Well, given that the Stuart Brown report says 87% of aged care homes are operating unprofitably, I would suggest that just about everybody who would be waiting on these grants is probably operating under some level of financial stress. Another piece of information that we've received was that on contacting the department in relation to an aged care support program grant, quite a big provider was advised that the department is currently processing, and I'm quoting this, currently processing applications with a value of $20,000 or less submitted in November 2022, and other applications of a higher amount submitted in July 2022. Is that correct? I mean, that's what's been said, but I'm just interested as to whether that is the prioritisation. So if it's under $20,000, we'll do it reasonably quickly, but for some of these larger, more complicated and obviously significant sums of money are well over 6 months old.
We're happy to come back, Senator, on notice about where we are at point in time on that. I think the reason that might be would be not that we're deprioritising larger grants. Larger grants are, by their very nature, more complicated to administer, and Ms Grinberg's talked about going back and forth with providers. We have experienced a large number of particularly in the more complex grant space where providers haven't submitted sufficient detail, and we are, if the government is paying out the large amounts of money in excess of $1 million in some of these cases, we need to be able to verify basic facts. And so, providers are doing their very best, but we have had occasions where providers, for example, haven't been able to indicate when the outbreak took place in their facility, provide details about to verify the expenditure on agency staff, justify other claims around PPE and the like. And so we have a test that we have to meet to make sure that for those very large claims that people can verify that. And so in some cases that takes longer to do if people are unable to provide that detail for us. And so we have to strike that balance. We're trying our very best. We've put a large number of extra staff when we were given additional funds in the recent budget. That's enabled us to triple the number of staff who are working on these grants. We are trying to streamline the process as much as we can, but we can't just wave expenditure through. As much as we might want to see money go to providers as quickly as possible, we can't just wave that through without actually being able to verify the claims that are being made.
No, and quite understand that, Mr. Lai, but I'm getting a huge number of calls from providers and operators that I think we would all consider household names. They're providers who are saying that they're not profitable at the moment, even outside of the money that's owed to them, which inevitably you have to audit. But they're saying that they're borrowing money to be able to meet the liabilities on the grants that are not being processed. So I'm keen to understand what level of contact you're having. Are you receiving, as a department, the same level of quite distressing phone calls from
We are
operators?
receiving contact from providers, and they are anxious to make sure those grants are paid out. And we have done some work with the industry around trying to make sure that we push information out based on our experience of the grants process, to say to them, make sure when you put a claim in, you've got these things. These are the common things where we have to come back to you to ask for further detail, and which slow the processing of claims. So we're trying to do that work with them. We also, when providers contact us, take the opportunity to try and make sure that if a provider is experiencing financial difficulties, that we try and stream them into that stream. And in many cases, we're already working with some of these providers, and so we know from other parts of the aged care group where we're doing that work with them that they have a COVID grant, so we're able to expedite that. So we're doing our very, very best, and we do understand that people are anxious to get the proceeds from their grant. I mean, it is a really important initiative that the government has put in place. It's very important in terms of making sure that providers who do experience a COVID outbreak, that we are providing this large level of assistance to them to meet those additional costs that they face when that happens.
So what is your expectation when you will be in a position to be able to provide this extraordinarily large backlog? I mean, how much of this is backlog and how much of this is just business as usual? And also, I mean, can you give us an indication of what some of the larger amounts that are outstanding to these providers? My understanding that we're talking tens of millions of dollars that are owed to a single provider organisation. Can you confirm that?
We would need to take for individual providers on notice. I don't have that data with me in terms of grouping together of providers and their applications. Some providers will have experienced multiple outbreaks and so will have submitted applications, particularly over the course of the last year and including into this year, following outbreaks during the summer period.
Okay, well, it would be great to be able to get an understanding of the whole amount, and also an understanding of if you are considering any other alternative means by which you can alleviate some of the pressure, whether it be a part payment in recognition that clearly a substantial component of the amount that's been claimed is likely to be correct, even though you may require, for the sake of your own governance and accountability measures, to deal with the remaining part. But, you know, for an organisation who we know are already likely to be under severe financial strain, that, you know, $10, $15 million that they have expended in keeping older Australians safe is not being remitted to them in a timely fashion, I think does require some sort of explanation and maybe some alternative arrangements if the timeframes are as long as you're saying they are to assess the applications.
Senator, we are looking at every and frankly talking to the sector about process improvements that we can put in place to expedite claims. But again, the flip side of that amount you quote, $10 to $15 million, you know, that is a very large amount of money to be paying to an organisation, and so we have to balance that risk, taxpayers' money, and make sure that we can assure ourselves that that expenditure has occurred during an outbreak and for the purposes to which the claim refers. So we have that. It's very, very hard to remove that due diligence that we have to do on those very, very large claims.
Absolutely, but I really say that $15 million is an awful lot of money for having been expended by an organisation to be outstanding because the government has not been able to process it. So I'd be keen to get that information as soon as possible and get some sort of understanding that with your current workforce and resources, how quickly you're going to be able to firstly clear any backlog that exists in the last financial year, when you'll be clearing last year's, and when you believe you're in a position to be actually processing these claims in a timely fashion and not creating what appears to be an extraordinary amount of distress to the sector because of the amount of money that is outstanding that has been expended by those agencies in keeping Australians safe, and they're not getting the money returned in a manner which is costing them money. Because maybe I could ask the question, are you paying interest on this? So if somebody has got an outstanding claim of $10 million from 8 months ago, are they wearing the interest bill?
Senator, the program is a, you know, I'm not sure I'm aware of a program which is as thoroughgoing in terms of trying to meet all the costs that an organisation faces in ordinary time, where an aged care facility has some kind of influenza outbreak or the like. And I'm not trying to say that it's exactly the same, but the expectation is with their funding agreements that they meet the costs of responding to those kind of events. And so this program is unprecedented in the sense that we are meeting kind of such a range of costs that the organisation might face, a huge amount of workforce cost, workforce replacement cost, PPE, rapid antigen tests, other equipment which helps them, and so it is a really thoroughgoing program, very important. We are aware at this particular point in time that aged care providers, because of COVID and other factors, have low occupancy, and so there are some financial pressures in the sector. So absolutely understand that's the situation at this point in time. But you know, it is a really, really important initiative. It's been across both, you know, throughout the course of the COVID pandemic. So, you know, I think that it's important to look at it in that context. It's not that the government has withheld money from organisations. It's providing money in response to costs that have been incurred.
Yeah, I'm not sure that I would be describing the aged care sector as incurring some financial pressure at the moment. I think it's probably a little bit more significant than that. As a point of clarification, also, firstly, did you answer me around the interest, yes or no?
There's no interest paid,
Yeah,
Senator.
thank you. So they're incurring the interest. And the other one is that there was somebody suggested to me that in some instances where they've put in an application for the reimbursement, that they've been knocked back on some of their PPE claims because the PPE was older than 30 days. Is that a criteria for being able to be successful in claiming it, that you has to have been purchased within the 30-day period around the outbreak?
Senator, I would have to confirm and look at the grant guidelines for that level of specificity. We do allow some claiming of pre-purchased PPE, but there are some constraints around that are then subsequently used in the course of an outbreak. But I would have to check the guidelines for the details around that.
And Senator, if you were able to give us the...
What did you just call me?
Senator, if you're able to give us the detail of that case, we're happy to have
Can
a
we
look
get
and see.
that recorded and played back?
Did I say Senator?
You called me Senator Hanson.
Oh, no, you missed it. I definitely didn't say that.
Which is a great compliment to my friend Senator Hanson, I'm sure.
We do. I mean, we've also supplied PPE into residential aged care facilities, so it may be that the guidelines are trying to pick up, where we might have already supplied. So, but it would be useful if you do have the specific details.
I do.
We can have a look at it for you.
They said that because it was more than 30 days old, it was not eligible to able to be claimed. And then their response was, we thought we were being proactive in making sure that we had it on site to make sure that we were ready to respond immediately to an outbreak, and feel that they've been penalised for their preparation, was the advice that I got. Could I also maybe, and I don't expect you to have this information now, could you give me some details around the proportion of claims that have been knocked back and the reasons why they've been refused? I mean, obviously that was one small example, but there must be other reasons in terms of the non-compliance, and particularly the period of time from the claim to when that claim was refused by the
Yes, we're happy
department.
to provide that.
Okay, that will be great. So, thank you.
Senator Russell, we're at a 20-minute block. Happy for me to pass the call over? Yep. Senator Rice.
Thank you, Chair. Good to see you all again. I'm going to start with the new where we're at with the development of the new Aged Care Act. You acknowledged at last estimates that the time wasn't going to be as you'd originally hoped, and the Royal Commission's recommended time frame. So just an update on progress, please.
Mel Metz, Assistant Secretary, Quality and Assurance Division. Hello again, Senator. So we're still working on the drafting of the bill for the new Act. At the moment, we're progressing drafting instructions. We're still consulting with the bodies that we've been consulting with that I mentioned last time, particularly the National Aged Care Advisory Council and the Council of Elders, and looking to have an exposure draft ready in the second half of this year.
Okay. So, and has that changed from your last estimates? I can't remember what you said.
I don't think so, Senator.
It's the same.
The same?
Yep.
All right, okay. And so that's the exposure draft in the second half of this year, and any sense then of the introduction to Parliament, Minister?
Can officials help me?
Yes,
here?
I think, Senator, the aim at this stage is to have something in the Parliament to enable the legislation to be passed by the middle of 2024.
Okay, good. Going to the organisations you're consulting with, and given the commitment to having a human rights-centred approach in the new Act, what human rights organisations are you consulting with?
So we have an expert advisory group that has a human rights expert on it that we're consulting with. But
So
the Council of
who is that
Elders
human rights expert?
That's Professor Wendy Lacey.
And is that the only human rights expert that you're consulting?
Well, on that particular group, we also have OPAN and COTA represented, and we deal with them quite a lot.
But they're not human rights organisations.
Well,
Are you consulting specifically with any organisations that have got specific expertise in human rights?
Are there any particular organisations, Senator, that you
Well,
have
I mean,
in
the
mind?
involvement of the Human Rights Commission might be good. The Australian Human Rights Council, I think. The Human Rights Law Centre is another one. A number of key organisations that have got expertise in human rights.
The Age Discrimination Commissioner is actually on the National Aged Care Advisory Council. So.
Okay. But in terms of civil society human rights groups, you're not at the moment. Would you be open to?
Yes, Senator, absolutely.
Okay.
I mean, we have in our consultations with, particularly with the OPAN board, who have links to some of those groups. I know that because they've, talked to me at length about them. We're getting to people that way, but we're more than happy to, extend our remit, because we're very interested in making sure that we have, we really do have a very strong human rights focus in the new legislation.
Okay, well, I look forward to hearing then that you have consulted with those human rights organisations next time we speak. I now want to go to the use of physical restraints and go to the data that came from the Productivity Commission's report on government services that was released recently, which I was pretty shocked by the data that came out of that with physical restraints. That 21.6% of care recipients experience physical restraint, including 17.1% exclusively through the use of a secure area. Do you think that's acceptable?
Senator Amy Laffin, First Assistant Secretary of the Quality and Assurance Division. Obviously, we're concerned about the use of restraint, and inappropriate use of restraint is something that we're working really hard to reduce. I think the benefit is that we now have transparency. We're able to count that. We're able to see that and track those numbers down. Certainly in terms of our quality indicator data, we have seen a downward trend in the use of restraints. I think the secure dementia units, which is counted as an environmental restraint in our statistics, we do hear opposing views about whether they should be counted or not as restraint, but we continue to maintain that as one of the items. But we are concerned, and that's why we continue to have a number of different programs that are focused on, one, understanding the use of restraint and reducing the use of inappropriate restraint as much as possible.
Do we have any other data in terms of other mechanisms, other physical restraint mechanisms that are being used other than the secure area?
Not so. What we have is the count. That's what the quality indicators give us, is the overall count of restraints used. So we don't have. That's an interesting point, because it could range from someone consenting and in fact asking for the use of a bed rail when they sleep at night, to something that's far more restrictive, that a medical practitioner has consented to. So it covers a wide range, a continuum of restraint.
So what work are you doing in trying to address that?
I'm happy to take that one. Katie Holm, Assistant Secretary, Quality and Assurance Division. My colleagues outlined the framework that exists to support the monitoring. So certainly the Commission has a role, the Aged Care Quality and Safety Commission has a role in looking at that material. I'm happy to provide an overview of that, but perhaps I might focus on the department first while the Commission take a seat at the table. So the department does have an ongoing role in closely monitoring the use of restrictive practices. As Ms Laffin indicated, that's through the Quality Indicator program, and they cover the physical restraint aspect and also medication management. Minimising the use of restraints is assessed under the quality standards, and the Australian Atlas of Healthcare Variation Series provides an indicator as well, and some data in that relation to that regular report. The department has a clinical advisory committee which is chaired by Professor Kidd,
with a range of experts who provide advice to the department.
Thank you. Have we seen any meaningful reduction in the use of physical restraint since the Royal Commission?
In terms of physical restraints, there's no actual count of when they are used in accordance with the legislation. Under the SIRS scheme, they have to be recorded if they've been inappropriately
That's not my question.
used.
My question is whether we are seeing a downward trend, given it was identified in the Royal Commission as being a very significant
I'm
issue.
happy to step in there. If we look at quality indicator program reporting from July 21 to June 22, that does show an annual decrease in the use of restrictive practices. So a 1.5% decrease in care recipients who experience physical restraint.
What were the actual figures down from what to what?
I do have that. Sorry, just trying to find the right page. So, physical restraint in... No, I think I've got the same period there. So, for care recipients who are physically restrained in Q2, so October to December 2021, was 37,311. In the next quarter, 37,050. In the next quarter, 35,583. And in the next quarter, 37,631.
37,631?
Yeah, so there has been a...
So it went up again.
Yeah.
So basically, the answer's no then.
No, it has been trending. It has been trending down.
It was trending down for those 2 quarters, and then it's gone up again to 37. It was more than the first quarter that you quoted. So there's been a line fitted through it that hasn't taken account of the uptick.
It's something that we're watching
So
over
it sounds to me
quarter.
that the answer's no, that we haven't had a meaningful reduction in the use of physical restraint since the Royal Commission.
So, Senator, I mean, it's bounced around a little bit, but I think that maybe we need to come back at the next interval and say to you whether we do think... I mean, there is a trend and we've had one... looks like we've got 1 quarter of tick up, but...
And are there earlier figures? I mean, the Royal Commission was pre-21. So when did the Royal Commission report?
So I think it's more about when the quality indicators started to be reported.
All right.
So,
okay. Well, let's leave it, and yes, maybe we'll have to relook at it. Ms. Anderson, quickly, did you have anything that you wish to add on your approach to dealing with and trying to reduce the use of physical restraint?
Janet Anderson, Aged Care Quality and Safety Commissioner. Thank you, Senator. I will be brief. We have a restrictive practices unit that we established specifically to look at these issues. It is a point of contact both for staff within the Commission but also for providers. What we are finding, and I'm getting reliable information back from the unit members, that providers' questions about restrictive practices are far better informed than they were even 18 months ago. So what we do have is a rising level of awareness about what constitutes an appropriate restrictive practice and what may constitute an inappropriate restrictive practice. Now, there is still confusion in the sector, and they're still learning about behaviour support planning and how to implement it effectively in order to avoid the use of restrictive practice. But we are seeing an increasing level of awareness across the sector.
Okay, so what proportion, when you say that there is that increasing awareness, is that across the whole sector? What proportion of the residential aged care facilities would you have be in contact with to see whether that's the case?
I wouldn't be able to hazard a guess, Senator, and I don't think we've measured it in a way which would allow me to quote a figure to you. The Chief Clinical Advisor, Dr Melanie Roth, and her team do have a pharmacy outreach program where they go and visit rural and remote residential services and deliver in-service or on-site education to staff, to the local pharmacist, to the local doctor and so on.
Okay.
And routinely, if I may, routinely what they find is relatively low levels of psychotropic medication prescription, but in many instances, after they have visited that service, there is further deprescribing. So we can see the impact one-on-one, I'm not able to give you sector-wide figures.
Right, for aged care facilities where there has been that direct connection with them, but for other ones, and you don't know how many that sample might be.
It is very difficult to quantify, and of course it is a figure which moves around.
Okay, I better move on. I now want to move on to the star rating system. So. While officials are just shuffling, can I just seek some clarity? It probably makes sense to have the Commissioner come up as appropriate, as opposed to calling her at a separate time. So if you're happy, we'll just... Yep. Great. Okay, so... Sorry, can I just correct something or to provide more detail from something before? My colleague just reminded me that the numbers and percentages have gone down in terms of physical restraint. It's just the population has grown. And likewise, over that same period, we've seen a 2.2% reduction in terms of medical restraint, chemical restraint used. Right, okay, so we've got an increase in population. Yeah,
which has increased the overall count, but not the percentage.
Yeah. Perhaps if you could you get me the figures?
We'll give you a table.
The table on notice would be great. Okay, so the current star rating system, which I think this is our first estimate since the star rating system has come into place, which there's been quite a lot of discussion about, obviously. So first of all, just to give us the baseline, how many providers have we got overall that are being rated?
2,547.
Right, okay. And how many of those, let's go through, how many providers only received a single star rating?
And Senator, you're looking for a count or percentage?
Both.
Okay, 19 with 1 star, which is 1%. Okay. Noting we've got some rounding here, so if things don't add up exactly.
And
two star?
Yep.
187, 7%.
Yep.
3 star, 1,364, 53%. 4 star, 957, 38%. And 5 stars, 20 is 1%.
Okay. And is it right then that, so we've got the half of them being 3 stars and so 61% 3 stars and under. Are you able to provide a list of the 1 and 2 star ones? And it's on the website if you click through to them all, isn't it?
Yep, we're able to provide that. I don't have that on me, but yes.
Yep, on notice, okay. And with those that are 1 and 2 star, how many of those have you taken action with to attempt to improve their ratings? What's happened with those low rating?
Yeah, so there's a number of things that the department's doing. So firstly, just the transparency is enabling services to compare themselves to other services. We've distributed communications and tailored information and support information about improvement. So for example, the Quality Indicator Manual gives advice on how to improve results using a plan, do, check, act continuous improvement model. Our network, our state and territory network colleagues have been engaging in local conversations. We've been developing individualised performance dashboards to be released through the online portal to providers. And we're encouraging providers to have discussions at board level, so both with their CEOs, the new clinical governance committees that we've recently required, to engage with their residents about what residents said about care. And we've also referred all of the 1 and 2 star services to the Aged Care Quality and Safety Commission.
Okay, so hence the Commissioner has come up to the table again. And can you tell me then, Ms Anderson, so what action has then been taken with the 1 and 2 star providers?
Senator, there are certain rules inherent in the star rating system which become apparent in my answer. Of those 19 services that Ms Lapham was referring to that are in that 1 star category, all of them have are subject to enforceable regulatory action. So 8 of them have a notice to agree, 8 of them have a notice to issue sanctions, 3 of them have a non-compliance notice. So in the presence of certain levels of regulatory compliance or enforcement action, they are limited to the maximum number of stars to which they're entitled. And in the case of those 19, all of them are already subject to enforcement action. We already have them under close watch. a number of them have been sanctioned and therefore have limitations on the ability to charge subsidy and to engage in independent
Did you say it was only 3 of them,
all 19.
Yes, but what was the 3 when you went through the 19?
There were 3 notice of non-compliance, but there are 8 notices to agree and 8 sanctions. So that is a very heavy-duty sanction or regulatory compliance enforcement action. Now, that's 19. The next category up, the 2 stars you were also asking about, Ms Laffin talked about 187 services in that category. 141 of those are subject to a non-compliance notice.
And what does that mean? I know we've talked about this before, but just for
we
summary.
have found them, yes, I will explain. Thank you. The quality standards have 42 requirements. We have assessed them against all or some of those requirements and have found them non-compliant. And the level of non-compliance is of an order which creates concerns in our mind that we need to take a regulatory compliance action. We need to serve them a notice which includes certain requirements about actions they are required to take, and then acquit to us in order for us to be confident that they have undertaken the necessary remedial action to address the deficit, the shortcoming.
And what's the timescale that they need to take that action?
It depends on the extent of the non-compliance, Senator. Some services are very keen to turn this around quickly and get
I would
cracking.
hope so, given the
So do
health
we.
and well-being of their residents.
Well, we're very enthusiastic about getting the motivation running the right way there, Senator. But others take longer. Sometimes there is greater complexity in addressing the shortcoming, and they necessarily take longer because it's about working with staff, it's about ensuring they have the training that they need and so on.
I know the Chair's wanting me to finish up, but what actions are you taking to protect the health and well-being of those residents where they're 2-star, they have not meeting the standards, and they're taking longer to take action? It seems to me that if I was a resident there or the family of one of the residents there, I'd be deeply worried about the well-being of my loved one.
By virtue of being subject to a notice from the Commission, they're already on close watch, Senator.
Senator Ruston, I will return to you. Senator Ruston.
Okay, just following on star ratings. I was just wondering if you could give me some indication of what was the methodology that was used to determine the upper and lower limits of the bounds for which 1, 2, 3, 4, 5 stars was determined.
Joshua Malden, Assistant Secretary for the Quality and Assurance Division. So, developed the scoring for the star rating system. We went through a process of research. So, at first we looked at a range of international systems. So, we looked at 20, really focused in on 11 that were really well developed to look at what the work learnings were and the information that could provide us. We then went through a really extensive consultation process. Number of focus groups. We talked with older Australians about the things that were important to them and how they would weight particular things. We then used the expert advice of both University of Queensland and the Australian Institute of Health and Welfare.
So in relation to those questions and the rating of the bands in which each of those stars fell, was the decision that, in relation to the Consumer Experience Index, which is what we're talking about, was the original decision that 45 or more points out of 48 was the original decision in relation to that being the upper bound for 5 stars, or was that subsequently changed after the original decision was made around the banding?
So I believe you're talking about the resident experience surveys, is that correct?
Yeah,
That's the scoring you're talking about?
Consumer Experience Index, I believe you call it.
Absolutely. So the decision was made by consultation with the Australian Institute of Health and Welfare, and effectively what we wanted to achieve through that process was real-world alignment. So if I just elaborate on that, so that would mean a 1-star would be for where consumers generally rated their experience as some of the time or worse.
Sorry, can I just take a step back?
Sure.
And I'd really appreciate that anyway, but if you want to chuck that on notice, what I'm asking you is that my understanding is that there was a banding of those ratings, 1, 2, 3, 4, 5 stars, on the basis of the responses that you got back from the consumer survey, and that originally the bands were set at a particular level and they were subsequently changed to a different set of bands, and I was just interested to understand what the change was when it was originally somewhere in the low 40s up to 48 that gave you a 5-star rating, then all of a sudden it was changed to 45 plus was required to get yourself a 5-star rating in the consumer experience, which I have to say 45 out of 48 is a pretty high benchmark to jump over for, you know, when you're actually asking people about their experiences. So I'm keen to understand why it changed from the low 40s to 45.
Yeah, so Senator, just to clarify, is that those ratings or bands have not changed since the publication of the star ratings. So
No, I
what
didn't say they had.
was an aspect of development.
I didn't say they had. I asked what changed it from when that was first decided to the decision to go to 45.
So I can elaborate on that. So the original banding that you would have seen would have been based on hypothetical data sets that we modelled. When we actually got the real data for the first time, that's when we did the analysis with the Australian Institute of Health and Welfare and then decided on a slightly different banding to make sure that we were making appropriate differentiation across the stars.
Well, could I put it to you that the decision to do that, given what you've just given me as your answer, would suggest that there was a manipulation of that because too many of our homes came back with very high ratings in terms of their consumer experience, and so you chose to make a change so not so many of them were in the higher category, because it's concerning that you'd made a decision based on the theoretical data that this is what you believe to be the appropriate rating or band for somebody who had a superior experience, which would have been a 5-star, and then subsequent to that it was changed after you received the data. I find that concerning.
I think it's about making decisions based on the available evidence that we have. I wouldn't necessarily agree that it's a manipulation. I think we do need to consider what best practice is, and that we had a look at that in the context of the data and we made a decision. Having said that, this data is going to be flowing in. You know, the data in the star ratings is dynamic and will continue to refresh. We are looking at establishing a technical expert group to help us consistently look at the data, because the star rating system that we have landed, we certainly see it as a first step.
And Senator, I don't believe that someone achieving 45 to 48 points, like that is a 5-star performance. That it needs to be at that highest level.
So
because
what is the basis?
5-star to be excellent, not okay.
So what is the basis of you making that decision? I mean, this is a pretty serious analysis of the operation of a pretty important part of Australian society. And I've got to say I'd like a little bit more than you just think it's what the standard should be. I mean, clearly you came up with a standard analysis on the basis of the theory of what you believed, or what the experts believed were going to be the appropriate brands for the allocation of star ratings. They have subsequently changed. I have yet to understand why they've changed, apart from you just felt that that was what should happen. If there's some information you could provide me to allay my concerns that this has been manipulated outside of the robustness of the theoretical analysis that you put in place for the original decision,
Senator,
that would be great.
We certainly don't think that the scores have been manipulated, and I think we can. It's probably hard to do in estimates, but I think we can take you through the rigorous process we've been through to arrive at those ratings. I mean, the feedback that we've had has been surprise from independent commentators that so many people have rated 3 stars or higher in a sector where, you know, we've had a Royal Commission, and so you know, we have critics either side, I suppose, at the moment about the star ratings. I think from our point of view, the importance of it is that it actually is promoting a conversation within residential aged care facilities with boards around particular aspects of their care, which they haven't previously had. So
Yeah, look, with the greatest amount of respect, thank you. And you know how much I enjoy talking about this, but we're a bit short of time. Can I then go to... There was an allegation and accusations made that the department provided detailed information to the media on a table that identified and provided detailed information about each particular home, but then refused to provide that same information to the providers. Is there any truth in that accusation?
Senator, we're not aware of.
Not that I'm aware of. I'd have to go and look at the, potentially inquiries that have been received.
If you're able to provide us
All right,
with.
well, I'll provide you with the concerns that I've received and maybe you can look into them individually. I won't name them here because they clearly don't want to be named. So just in terms of before the star ratings went live last year, was there a process that was gone through to check to make sure that all the data was current at the time of it being uploaded?
Yes, Senator.
Absolutely, Senator. So, effectively, look, star ratings are based on calculations and they were informed by international expert advice, and they do use a minimum of around 356 data points and apply algorithms to every service rating. So we went through a robust process of data validation to ensure it was accurate. So to ensure the rating accuracy, we undertook data validation through a number of different steps.
Yeah, okay, I'm fine, happy, you've done that, great. So, were you contacted by any providers after the star ratings went live with requests?
They were provided to the providers.
Yeah, they were for a
release.
very short period of time, I might say. But nonetheless, they were provided with that. Did you receive, yes, they were provided to providers before they went live. I had advice that many providers tried to contact the department to say that the information that was contained was outdated but were unable to get through, and so they went live before they had the opportunity to actually get access to the department. So notwithstanding that, did you receive many calls from providers to suggest that the information that was contained in their star ratings was outdated?
We received a number of calls, but for a wide range of reasons.
Yeah. Can you just answer the question? Did you receive calls on that particular issue?
We invited them, Senator.
Yep. Okay.
We asked for that feedback.
Yep. And so how many of the ones that you received actually said that the data that had been provided was out of date, inaccurate, and subsequently required to be changed?
I don't have a specific number before me in relation to whether or not the data was inaccurate. The majority of concerns that we received, the majority of them were resolved by explaining to them the criteria on which the star ratings was based on.
And they were resolved to their satisfaction?
Yes.
Well, clearly there's an awful lot of...
What's your concern here? Are you
I
sort of
was-
dancing around it? But
No, not at all.
Is your concern that people weren't given the star rating they should have been given?
No, I was concerned that the data that had been used in determining the star ratings was not, in some cases it wasn't current.
Yeah, so the result of that was they got a lower star rating than they otherwise would have.
Well, I don't
Is that-
imagine they would have been complaining if they've got a higher one.
No, well, that's what I'm trying to elicit from your questions. Is that your concern that people were not, providers were not rated as high as they thought they should be rated?
Yes.
Right.
We were concerned
okay.
that the data was being used, and the other concern.
Senator, some of the issues were that the actual data provided by the facility was not up to date, and so we can give you a breakdown. There will no doubt be cases where the error might have been on our side. That was the purpose of the validation process, but we can give you a breakdown of calls received and how we and reason and how we dealt with those.
Great, thank you.
Senator
And-
Ruston, we're due to go to a tea break. But
I only had half my time.
we're coming back after the tea break.
Oh, dang.
It's the plan.
Can I, actually, just to finish off star ratings, unless anybody else has got...
I've got lots more star ratings.
Okay. I will finish me on star rating then. I was just wondering, one of the other criticisms I had was that because nursing homes knew that they had this 24/7 requirement by July and the care minute requirement by October this year, they were sort of somewhat blindsided by the fact that the star ratings went up on staffing, and so many of them didn't meet their staffing times because the requirements to build up and all the challenges around workforce meant that many facilities were getting 4 and 5 stars and everything else, and they were getting 1 star for staffing. And I think there was a sense of some level of unfairness in that. So I just put that on the record.
Senator,
I'm not asking you to do it.
We actually spoke to the industry association and sector leaders, some of the members of our advisory council, and specifically raised that proposition with them, and they agreed that it would be better to judge people against the standard of care, the staffing levels that would apply from October, rather than to show where everyone needed to get to at that time. So that we specifically consulted the sector about the advisability of doing that versus taking another approach, and they said to us, do it this way.
Well, clearly they're not the ones talking to me.
So we'll go to tea, but I promise we're coming back. It's 9:03, so we will resume at 9:18. Thanks. From the Independent Health and Aged Care Pricing Authority depart. The senators who have questions for you have indicated they're happy to put those on notice, so you may depart. Welcome to stay, enjoy the evening, but you do not have to. Senator Ruston, coming back to you for another 10 minutes. Great.
Okay. I'm just wondering, has the department got any sort of idea now how many homes that it thinks will be unable to meet the 24/7 requirement by the 1st of July and that are unable to get the exemption?
Nick Hartland, First Assistant Secretary, Home and Residential Division. So we are still preparing for people to make applications to us.
No, sorry. How many do you think will be unable to meet the requirements who are not eligible for the exemptions?
We don't have that figure, Senator.
Would it be possible to take it on notice? I mean, or you haven't given that any consideration?
We don't have the data that would allow us to calculate that satisfactorily, so we have given that consideration.
Okay, so on that basis, you've made a determination that's contained in your guidelines, your, whatever we call them here, the guidelines of the requirements, that exemptions from 24/7 for operations of 30 beds and less in modified Monash model 5 to 7. And so, given that you made that determination, what was it? Well, you don't have to give it to me now, but the rationale for the criteria for that, and if that was the case, you must have had some idea that every other nursing home would be able to meet that requirement. Otherwise, I'm assuming you wouldn't have been so tight and restrictive in your exemption determination.
So the exemption was carved out on the basis of we could see that there were a group of providers who would have significant difficulty meeting the requirement, and so we're anticipating that many of those providers actually will meet it, but we thought it prudent to keep those providers in the market, that they have access to an exemption. It's not an unqualified exemption, and we can talk about the conditions that they would need to meet a little while ago. A little while into the future, if you wish.
Back to the future.
Yeah, exactly. Of the others, we think that it is reasonable that they meet that requirement. And others, they've been funded through either ANAC or the supplement to do so. But it is true, Senator, that there are labour market shortages in aged care, so it's possible that there will be some that don't meet it, but we don't have a figure to put on that yet, given that it hasn't started, and our reporting arrangements that would allow us to identify when the criteria is not met haven't started either.
In the requirements, there doesn't seem to be any indication about what action will be taken against providers who are outside of the exemption criteria, who, with or without best endeavours being attempted, who can't meet the requirement. What actions will be taken against them? Where would I find that information?
So there are a couple of things that we do on our side that are in a part of a broad compliance approach to this. So one of them is that we will, of course, be checking their data to make sure that they're informing us correctly.
Yeah, no, sorry, that was my question. I was asking you where I could find that.
Well, you can find it by talking to us at Estimates.
So it's not publicly available, Mr. Harmon?
Do you want to? Mr. Richardson might be able to assist.
Senator Mark Richardson, Assistant Secretary, Home and Residential Care Division. Senator, if a facility doesn't meet 24/7, they'll be subject to, I guess, it'll be one of the quality. It'll be part of the quality principles Not enforcement action, but compliance action could be taken by the Commission. So they'll be subject to those standard processes that are already in place for all the other, I guess, quality principles and quality standards that are out there already.
So what I'd be keen to understand is at what point in time are you going to be taking submission from providers who are outside of the exemption criteria, who genuinely have tried best endeavours and they've provided you with the necessary advice that they're in shallow markets, they can't get access? When are they going to be given some sort of sense of, I suppose, certainty that they're not going to be closed down?
So that goes to, so I did start to talk about the range of regulatory responses that we've got. So one is the monitoring. The other is that if they miss, we're paying a supplement and they don't have full coverage.
So it'd be a financial penalty?
They would not receive the supplement if they don't have that, so that's a compliance issue. Ultimately, as is the case with a lot of things in aged care, there will be a process for us to identify them for the Commission and to consider, and that then gets you to the Commission's approach to dealing with that. Well, I won't speak on behalf of the Commission. I'll let Ms Anderson.
I don't need any more detail. That's great. Thank you very much. Thank you. I appreciate it. I'm just interested in the guidelines. It says further work to develop and refine care minutes and 24/7 requirements, page 11 of the requirement. It refers to the development of alternative models of care, and yet it says that those alternative models of care will be developed over the subsequent 12 months. Does that mean those alternative models of care are only available to the homes that are eligible for the exemption?
That's the current state of play. As we work through that work, there'll be submissions put to us about alternative approaches, and they'll be considered as they're raised with us.
Okay. So in relation to the care minutes that come in October, the model as it currently stands is care minutes are divided between RN minutes and care minutes that are provided by other eligible workers, so ENs, personal care workers, assistants in nursing, etc. Obviously, RNs are designated in terms of their care minutes and are paid higher. And the PCWs and the AINs are paid at lower, with the ENs somewhere in the middle. Given that we've mandated RN times and the viability pressures on home, they're quite clearly known by everybody, has the government given any consideration to the possibility that homes will be forced to employ only PCWs for the delivery of care minutes, other than the RNs, and what that impact's likely to have on enrolled nurses?
This issue's been raised with us. There was a provider that took action in relation to its EN workforce that caused a discussion in the media. As you'd expect, we've been asked for and have provided advice to the government on the situation, and we in the government are working through whether there needs to be a change, and if so, what that change would be.
When's that likely to be? Is it likely to be something that would be changed before the 1st of October?
It depends on the government's wish to make a change and what option it would choose. So depending on where they want to go with addressing this, it could be, the timing could be 1st of October if that was the right timing, or it could be some other time if there was another solution.
So how many homes does the department envisage will fall short of their care minute requirements, both RN and general care minutes, by the 1st of October, or is that something else you don't know?
Our ambition for the sector is that they meet all their targets, but as I said before, in relation to the, I think it's effectively the same answer in relation to the 24/7 requirement. We know there are labour market pressures, and we know that there are some providers, even with best endeavours, won't meet that target. I don't have a figure for what that might be. We think it's small. We think the funding's adequate, but it's a big complex sector with variable labour markets. So, we'll monitor it closely.
Yep.
And if there's a compliance issue, then we can ask Ms Anderson to come to the table again, or we can
leave it. Unless she wants to do it up and down exercise. On page 15 of the requirement guide, it states, and I state this very clearly, no consideration will be given to exemption from care minutes.
No.
So if we have a situation where a home, through best endeavours, is unable to achieve it, and we all know, that there are going to be places, particularly in shallow markets, rural, regional, remote Australia, most particularly impacted, that are likely not to be able to meet these minutes. You have in your guides very clearly stated, absolute quote, word for word, no consideration will be given to exemption of care minutes. I'm just keen to understand that is a pretty black and white statement. We know we've got workforce shortages. We know as we stand here today, and I'm sure, Mr Lai, you're not about to tell me that every single nurse and care worker that we knew that we were going to need to meet these requirements are on standby and ready to go. What is going to happen to these nursing homes, and how many are you going to force to shut down? And the other question is if you take... No, hang on, let me finish. No, of course you're not going to advise them to shut down, but we already know. Well, can you provide me with advice of how many nursing homes have closed in the last 6 months, and how many have indicated to you are likely to close down between now and the 1st of October because of the fear?
Ms Strapp can give you the figures on openings and closings. I mean, these are Royal Commission recommendations around care minutes and 24/7 nursing. They're very, very clear, made for a very clear reason, and I know that you're not suggesting that they're not really important to make sure we guarantee the quality of care for older Australians. And it is very difficult for us to give a free pass to aged care providers and say that we won't effectively regulate the quality of care that they provide, so to suspend the operation of the quality and safety arrangements. So we are in a world where we understand that providers are under pressure in relation to workforce. And Ms Anderson, I know we're not in the business of calling her, you would call her to the table, but you know, her job is to make sure that care is being provided and be a risk proportionate regulator in relation to that. But the Royal Commission recommendations are very, very clear about what is required to provide high quality care to aged care residents. And so we don't have a lot of room to move in that regard.
No, look, indeed, and I do absolutely understand what you're saying, Mr Lai, but at the time the Royal Commission made its recommendations, we were not in the dire situation we are with workforce. And I think even, you know, the Royal Commission would have to acknowledge that whilst, of course, we want to give older Australians the best possible care in their journey of ageing, and I've been on the public record of saying that 100 times myself, and I absolutely believe it, you cannot put a situation where we are going to shut down nursing homes, or we're going to cause them to shut because of the fear that they're not going to be able to comply with these conditions without providing some sort of flexibility around alternative models of care. You say in your document that you're prepared to look at alternative models of care, but at the same time you're saying that there will be no consideration given to being able to put the flexibility into the care minutes to enable us to be able to work through the challenges that are before us at the moment, the challenges that were not before the Royal Commission when they made those recommendations, that we have got to make sure that we do not close down nursing homes and have people move hundreds and hundreds of miles away, or stay in their own homes because they have not got access to a nursing home when we haven't put best endeavours in place to come up with alternative models of care. So I'm just keen to understand whether there is any flexibility for those nursing homes, particularly rural, regional and remote nursing homes, to have alternative models of care that understand their shallow markets, give them some flexibility to be able to work towards the outcomes that we all want, and not be so rigid on their enforcement.
Yeah, there is obviously in relation to 24/7 RN, there is flexibility. There's supplements for smaller providers and there's exemptions for very small providers in the system. So,
and we're funding the care minutes.
Sorry?
Like we're funding the care minutes.
I understand that, but you can fund care minutes till they come out of your ears. But if there's nobody to work in these places, you can't fund no one.
That's why we've had a lead-in time quite significant lead-in time.
Well, I'm asking now.
I don't know what it sounds like you're supporting the extra care minutes, but sort of saying, but you've got to give exemptions. Like,
No. What I'm saying is that you can't close a nursing home down.
Nobody's talking about closing.
Well, they're
nursing
closing
homes
themselves, Minister. They're closing themselves.
This isn't the appropriate forum to have a policy debate, so if you could direct it as a
Senator
question,
Smith, with the
please.
greatest amount of respect, nursing homes are closing themselves down out of fear of what's about to happen to them because they
Senator
do not
Ruston,
believe
Senator
that they have a
Ruston.
viable model. I'm just seeking
Everyone
to
agrees that this
understand-
topic is important. I was calling you to order on the debate happening between tables. It would assist the committee if you could please direct it as a question to witnesses, and I will instruct them to answer when you do.
Thank you. So I'm...
We do we have Dr. Hartland can give you an indication of how we think we're tracking on care minutes, and Ms. Strapp can then give you the openings and closings and the total number of beds in the sector.
I'd be keen on the openings and closings
Yeah.
probably as much as anything
Well,
else.
you're asking very long questions, so I reckon they should be allowed to answer first over here and then over there.
I wasn't actually asking very long questions. I
You
did
were.
give you a bit of a lecture then.
Let's
but
go to
that
the
was-
answer.
Yeah, it was a lecture
Miss
slash...
Strapp,
Senators, let's go to the answer, and
then
then I will be passing the call on, and I'll return to you again, Senator Ruston.
Just on Eliza Strapp, First Assistant Secretary, Market and Workforce Division. So since 1 July 2021, 61 services of 2,704 have closed. And a further 6 services are in the process of closing. In that same period, 39 services have opened, 9 in regional areas. And I think it's also important to note that the number of the number of places that have opened compared to places that have closed have actually increased. So we've had 4,362 places opened. So those are beds opening nationally compared to 3,318.
Well, I think that probably is more of a problem than a good news story. But could you perhaps provide me with a breakdown of where they are? Because it's the little ones that are the problem, not the big ones. So if you break them down, that'd be great.
Yeah, I can. I can also tell you that 24% of the closures are in regional areas. The majority of them are in metropolitan areas.
So if you could break them down by size, location and type. And we're also interested in what their business model is, whether they're privately, commercially operated, whether they're not-for-profit, whether they're state-run, community, etc. And if you could have a look at that, I believe you want the call.
Thank you.
So there's just one bit of information that Mr Richardson can add that would assist the...
Senator, so to just jump backwards a little bit, the ANAC funding does include funding for enrolled nurses as well as registered nurses and personal care workers. Care minutes is trending up. At the time of when the funding was calculated and provided in the 21-22 budget, we were looking at about 177 minutes being delivered by the sector. In the last quarter, they're delivering about 186 minutes.
Right.
In terms of registered nurses in the 21-22 budget, 26 minutes was what was being delivered by, on average across the sector. Now we're at 34 minutes. So it is trending up. Funding is in place right now in order for the sector to ramp up to the 200 minutes and the 40 minutes. So it's all trending in the right direction. In terms of what you're referencing, so what we're looking at is the staff skill mix. That it's consistent with the Royal Commission recommendations. They suggested that we have a look at facilities that provide specialised services, homeless, Indigenous, and whether or not a different mixture of staff could be used to deliver the 200 minutes. The reference that you were talking to, the context is that. So what we were trying to identify was that it wasn't an exemption to the 200 or the 40 minutes. It was an exemption to the staff skill mix that we were looking to investigate.
Thank you. Have officials finished that answer? Okay. Senator Tyrrell, you have the call.
Thank you.
Sorry, I was
zoning out. Appreciate your time. The government has made a number of changes in the space that implement some of the 148 recommendations of the Royal Commission into aged care quality and safety, including Parliament passage last year of the aged care and other legislation amendment. How many of the Royal Commission's recommendations that the government agreed to have been actioned to date?
So, Senator, there's a number of ways you can cut this. we have resourced or enabled, I think, 37 recommendations, but we're obviously working at progressing quite a large number. But Ms Connolly can probably give you a more detailed breakdown if you'd like it.
I am aware that we've got time restrictions too, so.
Thea Connolly, First Assistant Secretary, Reform Implementation Division. Measures at the 22-23 budget combined with two pieces of legislation passed in the second half of last year have enabled or addressed in full or in part 37 recommendations from the Royal Commission.
Beautiful. I was going to ask for a breakdown of those, but I think that would take way too much time. Does it cluster into areas or?
It's across the suite of recommendations. I can give you some examples.
That would be great. And if I could get a breakdown in a spreadsheet or something sent to us, that would be amazing.
Yeah, let's just provide on notice. Yep.
It's late in the day. And also in regards to that, like there's quite a few more recommendations to come. Is there a time frame for release of, or that's probably not worded very well.
I could probably give you some guidance, Senator, but just to say, like, to give you an example of, I think the new aged care legislation will acquit 50 recommendations, a large number of recommendations. So there's some elements of the reform that are responsible for a whole lot of them, others less. But we could give you some indication.
Why don't we see how we can provide you with some information of where, it's not only the ones that have been done, but the progress against the others. I'm sure that information. Yeah,
that would be amazing. Thank you so much. I also have some questions about the review of the aged care quality standards. The department's website says that there was consultation on the updated standards from the 17th of October to the 25th of November. Can you update me on the outcome of the review? He's nimble, isn't he?
Everyone wants to go home.
So in terms of that consultation process, so just to flag, we had focus groups, webinars, 873 survey responses, 119 written responses, so it was quite well received. From that, we were able to kind of gather some findings and provide advice to government, and the next step is the Aged Care Quality and Safety Commission will be piloting those standards, those strengthened standards.
Is that going to be done in any particular area, state, territory, or just?
There's currently an expression of interest out at the moment. Ms Anderson can speak to it, but we're looking for a wide range of services with different characteristics.
Beautiful. She's back at the table.
I think Ms Laffin has actually answered the question. The expression of interest is out now. We're inviting providers to make known their interest to us, and we are looking for a sample size and variety which allows us to test our assessment methodology in a range of different settings.
If you're happy to sit for a minute, I've got a question for you, Anna Mary. Is that okay? When will they be implemented as such? So when appropriate? Or?
Yeah, I think it's a matter of what those pilot findings are, and then giving the sector an appropriate time to engage with the new standards, prepare themselves to meet those standards. We're currently looking at similar timing to the new Aged Care Act, and as Mr Lai said earlier, we're looking around mid.
So we're going to take into account the restrictions and problems that they may have in implementing them quickly and efficiently.
We're hoping the piloting process goes well, but obviously if there are issues in the piloting process, then we may need to go back to the drawing board, redraft some of the standards and then repilot. So it is an iterative process.
I'm assuming my colleague across the hall will tic-tac with me on this question that I've got too. So a couple of weeks ago there was a report of a home in our home state where a resident was bleeding for all night long because there was not a nurse on call because they'd become unwell. The centre said it had complied with the standards. A couple of points with that is, how is it possible that the centre complied with the current standards in that instance?
I think that might be a question for me, Senator. Which service are you talking about?
Yarrandoo in Somerset, northwest coast of Tasmania.
Yes, indeed.
We've heard a rumour that you were there, yeah.
No, it's received very significant coverage. Yarrandoo is one of Southern Cross Care's services, and we certainly have been paying very close attention to it. It is now the subject of a compliance enforcement action by the Commission because we were concerned about the quality of care that was being delivered, and indeed all the residents are aware of that now. So, Senator, I'm sorry, what the particular question was?
I've even forgotten now because I was listening so intently. How is it possible that the centre was compliant with the current standards?
Well, services move from compliance to non-compliance in a long or a shorter period of time. It can be dependent on the expertise of a manager. It can be a temporary staffing problem. It can be something which is emergent over a number of months. There are many, many variations on that theme. The important thing for the public and for the Parliament is to know that the Aged Care Quality and Safety Commission has means of detecting that at an early stage and then ensuring that we protect the safety and well-being of all the residents by moving quickly if that proves to be necessary. And in this instance, the service is subject to that compliance enforcement action.
Thank you, I appreciate that. Would this type of incident be preventable under the revised standards?
Sorry, I missed
Would this type of incident be preventable under the revised standards? Because this nursing home has had quite a few instances in the last year or so.
The revised standards are designed specifically to strengthen the performance of services. They have yet to be implemented, and I think we can all have expectations and aspirations for their impact on the sector. For the moment, and indeed since July 2019, the Commission I lead has been very assiduously monitoring the sector and ensuring compliance against the current standards. And what we are seeing is the emergence of more compliance through our site audit program. We undertake site audits in order to re-accredit aged care services, residential aged care services, and the emerging data over the last 6 months suggests a lower level of non-compliance, so a high level of compliance across services. Now, it's an early trend, but it is a reassuring trend, and if it were to continue, as we hope it will, it does suggest that the services which were new to the standard in July 2019 are becoming more familiar with them, are becoming more competent in implementing them, and more confident that they're looking after their residents well.
Thank you for that. Do you think all facilities will need a general audit to determine whether they will comply with the new standards moving forward?
We have a program of audits for the purposes of reaccreditation. Now, the regulatory model is something which is being reconsidered in the context of the construction of the new Aged Care Act. So accreditation as it's currently operating may in fact change under the new Act. But we fully expect that there will continue to be a need, and we will continue to provide, or rather undertake, site audits on a program basis to ensure that we are keeping close watch on services, and a particularly close watch on services that we identify as being at higher risk of non-compliance. And we have a number of means of assessing a service and creating a risk profile for that service through complaints, through serious incident notifications, through our assessment and monitoring engagements with them. And by that means, we understand them in terms of a level of risk, and we calibrate the intensity of our monitoring in accordance with our understanding of assessed risk.
Beautiful, thank you. We can't have facilities that meet the current standards but don't meet the revised standards shut down immediately. How will the new standards be phased in, and how long will they be given? Because people live there, it's their home.
Senator, the department may assist me in this answer, but can I say at the outset that the introduction of new standards is not in and of itself going to shut down facilities? That is just not going to happen.
Which is what everybody's been saying, and I'm grateful
yes,
for that.
And we collectively need to disabuse people of that myth. It is simply not going to happen. There will be a process, an extensive and rather intensive process of education and capability building across the sector in order to give providers the best chance of complying. Now, when we as a regulator come along and assess their level of compliance against those standards, and we find them non-compliant. If we find that they are not fulfilling the expectations of the standards and we find them non-compliant, then we never ever go to the top tier power of revoking approval to be a provider unless we have moved through another sequence of steps. So in the first instance, they may get a non-compliance notice, or we might go a little further up our regulatory pyramid and issue them with a notice to agree or a sanction. And these are increasingly intensive tools which place more onerous expectations on them to make good the deficit. But it's only where they are willfully non-compliant, they are determined not to comply with the standards, that we deploy the heaviest hitting tools and we ask them to effectively show cause as to why we would not revoke their approval to be a provider.
I have faith
Thank
that
you.
you're strong.
Thank you, Senator Tyrrell.
I do have something else, but I'll put that on notice. Is that okay?
That'd be wonderful. We'd appreciate it. Senators, I'm going to come back to Senator Rice just for a short block, and then I'm coming back to you for another long one. Senator Rice.
Right, okay, and I'm going to continue on some questions about the STAR system. So the STAR system's got 4 domains, correct? So compliance, consumer experience, staffing and quality indicators, and they make up they've got different weightings for how they all add up. But each residential aged care facility, do they receive a number of stars across each of those domains?
Yes, that's correct.
Yes, and then how are they? And then I presume that according to that weighting, they then all added up to an overall star rating.
Yes, that's correct.
So, and it's correct that an award of 3 stars, either across the domain, each domain, or overall, is supposed to reflect an acceptable level of care.
Yes.
Yep, okay. So I want to go to the compliance domain. So is it correct that a home will receive 4 stars for compliance if it hasn't been subject to compliance action for more than 12 months?
1 to 3 years, yes, that's correct.
Sorry, 1 to 3 years?
Yes.
Okay, but so basically if it's more than a year that it's had any compliance action, it'll get 4 stars for compliance?
Yes.
Yep. Is the Productivity Commission report on government service correct in reporting that we had only had 26% of homes underwent a re-accreditation site audit in 21-22 and 20% in 2021? So it's...
I'd have to defer that question to the Commissioner.
Sorry, Senator, what was the question?
The number of homes, the percentage of homes that underwent a re-accreditation site audit.
I don't have that information in front of me, but we certainly provided them with information that they then published.
Right, the information I've got that it was 26% in 21-22 and 20% in 2021. So in terms of re-accreditation audits, it's only, somewhere between a fifth and a quarter of homes that have had a re-accreditation audit.
Senator, if I may, we have significantly increased our field presence in the last 12 months, and we have now done 3 times the number of site audits financial year to date in 22-23 as we had done in the equivalent period in 21-22.
Okay, well that was my next question in terms of how many in a year, what proportion of aged care homes would have had a visit?
Oh, a visit. That's a different question.
Yep.
A site audit is a particular sort of visit. A site audit is where we look at all 42 requirements under the Age standards. A visit may not be that thorough. A visit may take a domain approach and look at a subset of requirements.
But a visit that inspected the quality of care.
Yes,
so that was able to pick up whether there were things that needed,
I don't think I have a
attention.
proportion of the total sector, Senator, but the if you just give me a minute, I might be able to get close. I think. Yeah. My difficulty is I have a number of site visits, but I don't know how many services that equates to, and there would be some services we visited more than once. So in 21-22 we made 1,733 site visits, but I'm not sure what the service number is. I'm sorry, I can probably take that on notice.
Okay, so it was 1,700, but that would be an overestimate because some places would be visited more than once.
Yes, very good chance.
So you've probably got half of homes. How many homes? You know, in a 1 year period, how many homes would be? Well, it's let's say approximately half.
That probably is in the ballpark. I'm certainly happy to take it on notice and give you a more precise
Okay, so
response.
half of homes haven't been visited in the last 12 months. So potentially half of homes could receive non-compliant, because if they've had no other compliance measures, they'd receive a 4-star in compliance.
We also have the opportunity of using our complaints channel as a way of reaching a conclusion on whether a service requires a direction to revise their plan for continuous improvement. And a direction, as I understand it, and Mr Maldon will correct me if I get this wrong, but my understanding is a direction actually limits them to 3 stars. Is that right?
Yes, that's correct.
Yeah, but what I'm getting at, it seems like there's a very large, substantial proportion, ones that either haven't had a visit from you, they haven't had a complaint made about them, which is, you know, in the order of half of all homes that you haven't looked at, no one has looked at in that 12-month period. And this is concerning if that means that they're then going to be they're then going to get a 4-star for compliance on the basis that no one's made a complaint and they haven't been visited in the last 12 months. Because the Productivity Commission data shows that almost 40% of the homes that were subject to reaccreditation didn't meet the standards for personal care and clinical care, and almost 30% didn't meet the standards for human resources. So the default of giving homes 4 stars for compliance, when half of them you're only getting the 4 stars because you haven't been looking, seems not appropriate.
We do not visit homes on a random basis. We visit homes either because they are due for reaccreditation or because we have risk intelligence which suggests that we need to look at them more closely. So we actually prioritise our resources and our effort to those services which are demonstrating higher risk. So the ones we visit are the ones which are more likely to be non-compliant.
But they know you're coming, don't they?
No, they do not.
They don't know you're coming?
Nope.
Okay. So, I mean, I suppose I'm questioning the value of 4 stars for compliance in the absence of data and what that's based on, because that seems to be pretty questionable.
Data, Senator. And I think that's what Ms Anderson was getting at in terms of the risk assessment. How they select those services to go to is informed by a whole lot of data, including serious incident response reporting, complaints, as was mentioned, results of quality indicators. All of those things are taken into account and factored in as part of the Commission's deliberations on where to go.
So,
if a service hasn't come to our attention by any means across 18 months, then they deserve to have that recognised as a high level of compliance.
Have you done some ground truthing of that?
That's a fair question, Senator. This information has been available in star ratings for 9 weeks. We are looking with great interest across the full suite of measures which contribute to star ratings. Obviously, some of them are more familiar to us, but some of them are new. We are very pleased to have access to, for example, the resident experience surveys for the first time, and we have found those to be invaluable. So the short answer to your question, Senator, is this is a work in progress. We now have something which was not available in this way before, and we are determined to use it.
Okay, I mean, my concern is because compliance is 30% of the star rating, so it's the most heavily weighted, and yet you need to do the ground truthing to make sure that the service that hasn't been visited for over 12 months is that you can have some confidence that that's deserving 4 stars, not just 3 stars.
And sorry,
acceptable.
Senator, it isn't the most heavily weighted. The most heavily weighted is the resident experience. And
Sorry.
there are those rules, as Ms Anderson mentioned before, that a service could get whatever sub-ratings and stars they want, but if they've only received a 1 or a 2 star in compliance, that's a maximum they can get for an overall rating.
Senator Russ, I do need to pass the call back to Senator Ruston, and then I will come back to you with Senator Ruston.
Can I just ask one more and then I'll move on, and I'll finish my star ratings, which was basically under the staffing and my concerns about that as well. And is it right that under the system a home gets 3 stars for staffing even if it provides less than 90% of the total care time budget, as long as it's got 115% or more of the RN care time?
Yes, I do believe that's accurate, Senator. I think that's in acknowledgement that a few different things at play here, as my colleagues previously mentioned, and that is that the first quarter that was rated is people were under the ACFI system of funding rather than the ANAC system of funding. And so it's acknowledging that people need to take time to ramp up those resources, and that obviously the workforce challenges are well known in that space.
So that may change then, you're saying?
So certainly something I said before is that the star rating system, this is a first step, and we will look to continuously evaluate it to ensure that the score is set up correctly.
Because it concerns me that 6 extra minutes of RN time would make up for a shortfall of over 20 minutes in total care time, which just doesn't seem right. But I'll leave it there. Thank you.
Senator Ruston, I did give you the call. Oh, sorry, Senator Askew.
Thank you, and I'll just be quick with a few questions that relate to my home state of Tasmania. On the west coast of Tasmania is the town of Queenstown, which has a population of less than 2,000 people and it's classified as M6. Unfortunately, many older Tasmanians that live there are forced to move out and leave the area due to availability of aged care beds in the area. And I know the member for Braddon, Gavin Pearce, has been working tirelessly for regional health and has been working closely with the West Coast Council and the Tasmanian Government to attempt to secure more services. But in a direct response to a letter from the West Coast Council, Minister Butler claims to understand that older Australians in rural and remote communities want equitable access to the care they need, regardless of where they live, so they can stay close to their loved ones and communities as long as possible. That sounds great. However, the only solution this government can offer is a market intelligence and supply gap project, was the answer in his letter. So when in government, the Coalition announced $3 million towards an expansion of the West Coast District Hospital to increase the aged care bed capacity. Labor didn't commit to match this funding. However, some statements made by Labor during the campaign did appear to indicate bipartisan support. So will the Minister commit to this funding to increase aged care beds in remote Tasmania?
Senator, I'll see if we've got the right person here to talk to you about the work we're doing in Tasmania. We are aware of that situation.
It's a pretty dire situation at the moment.
I understand we are working locally with the Tasmanian Government around that. I'd certainly say to you that where we have thin markets, that we certainly the process includes more than just the analysis of the supply gaps. We obviously have a range of programs that we have in place that we can use in these circumstances, and where we don't, we have engaged in discussions with the relevant state governments around how to address them.
Yes, that's right. And I know our local regional coordinators down in Tasmania are working closely with the local health district and providers in the region to address some of the supply gaps in that area. We do, as Mr. Lai mentioned, we do have a range of things that we can assist with, including capital grants. We haven't received a formal proposal from Tasmania on this project, but I believe that correspondence has indicated that we'd be happy to look at proposals of what funding would be required and what bed allocations that we could make. So I do know our state officers are working closely on this matter.
So there is a likelihood that there'll be four extra beds delivered?
I can't give I think we need to look at the proposal in more detail and look at whether it meets our requirements. But I think we are conscious that there is a shortage and that we want to ensure that people in the area are able to access aged care.
Well, Minister, what do you know what the Minister's priorities would be
Yes,
when
look,
it
I
comes to
understand we are
supporting the
working
West
with the
Coast?
Tasmanian Government. I know Senator Urquhart's been liaising with the Minister on this as well. I understand that the money for aged care beds was part of the 2019 election commitments, and my understanding is it was redirected by the state government to other services, but I will check that up. I know people are working with the Tasmanian Government, aware of the issue, and probably something everyone could work together on
Premier's
by the
also
sounds
written
of it.
to the Minister, yeah.
Yeah.
So when the Minister for Aged Care, Ms Annika Wells, visited Tasmania recently, how much time did she spend on the West Coast?
Well, I don't have access to Minister's diary, but I do know that she spent a few days there and she was in a number of aged care facilities.
Can you take that on notice as to how much time she spent on the West Coast rather than having a pie eating competition with the member for Lyons?
Well, you can have your political shot, but I think you'd be hard-pressed to find a harder working minister that has the energy that I don't seem to be able to find. And compare her to Senator Colbeck. I mean, if we want to have a chat about it, let's compare No, well,
we're talking
you
about the
open
current
this up.
minister is what I've just asked. I didn't say anything about Senator Colbeck. I'm
no,
very
you
sorry.
didn't.
I didn't.
No,
the reason
you didn't
because
for a reason.
we're talking about the current budget that we're looking at.
Look, we've all been getting along very nicely tonight. You had a political potshot about a very hard-working minister who is spending more time in aged care facilities, understanding the issues and working on solutions to fix them.
She was the one who put it all over Facebook.
Senator Askew, do you have a question to
any
direct
other
to the Minister?
that I can recall, certainly in the last 9 years of your government. So have your shot,
Senator
but
Askew.
Minister Wells gets on and actually does the job and delivers, which is why we are making such significant progress in aged care.
Senator Askew.
I just said I'd finish my questions and the
Oh,
minister
I
kept
didn't.
going.
I didn't
That's
hear
why
you. I
said,
didn't
I'm
hear you
sorry,
say
I
it.
couldn't
Well,
understand
I had
where it was
to
going.
look. If you're going to come in and have a shot, I'm going to push back. Okay.
That's fine.
Otherwise, we can all
That's
stay
what you're
nice
here
and we
for.
can get out of here at 11.
We are getting out of here at 11. Senator Ruston.
Didn't we extend it to 12?
Thank you. Chair, I've just got a few questions around the practicalities of the implementation of the Fair Work Commission pay rise. Is that best directed to you, Ms Stratford? So I'm just keen to understand, so is this funding to be provided to aged care providers? Well, so first of all, the government has stated that it's fully funding the pay rise. I think we had this discussion last time and government's on the public record as saying that. So how is this pay rise to be funded? Is the funding going to go via the ANAC tool?
That's right, Senator. For residential aged care,
Yes.
the intention will be that it would flow through the ANAC model for Commonwealth Home Support Program that's funded through a grant. So we would amend the grant to include that. We've got a number of programs that are also grant funded, so we would do the same thing. And home care is, remind me, that is through, I think, amending the indexation for the home care, which is done, which will be done on 1 July.
Okay, so in terms of how you calculate what it is that's going to be added to each of these particular instruments, that is the mechanism by which the Commonwealth provides funding for these services and providers, is it going to be, well, do you have information around how that's actually going to happen? I mean, I'm sure it's probably quite complicated. I'm happy for you to provide it to me on notice.
Emma Gleeson, Assistant Secretary, Market and Workforce Division. The approach we're taking in general is really to look at average labour costs across the sector and across the different programs as a base to which to apply the increase, and that would include both wages and on costs within that uplift.
Okay, so you confirmed that on costs are included, full on costs are included?
That's right.
So in the case of an operation that's receiving funding, whether it be residential, home support packages, etc., how do you determine the wage percentage on that? Because clearly, if you went to each and every provider, they would be able to provide you with their wage bill, and it'd be a fairly simple calculation to add 15% to that. Clearly, that's not the mechanism why you're doing. You're saying you're averaging it out. So I'm interested to understand how you're actually going to provide an equity proposition that is not going to penalise those providers that are currently paying, and many of them are paying well above award wage. Others are struggling and not able to. How are you going to manage that? Because, I mean, it seems unfair that if somebody's already paying more, that they're only going to get a base amount, whereas somebody who isn't paying now is going to get the same amount. So, I mean, how are you working that out so that there's an equity proposition?
Well, I mean, as using residential aged care as an example, what we want to do is use the ANAC model, which has already been established as a way of distributing funding. So that takes into account characteristics of the residential aged care facility, so the nature of the residents in the care of that service and their level of acuity and the care minutes that are required to be delivered for that service. And then once we factor in the wage increase, that would, match up to the needs of that particular residential aged care service.
But, I mean, what happens to a facility that's paying above and delivering above? Because, I mean, if you're basing it on the ANAC model, on the care minutes that have been mandated, that's great. Hopefully they all reach that level. But what about those that are above it? They are
that's why we're proposing to use average labour costs, because that actually factors in already the fact that some are paying already above award.
Yep. Was the decision for the 15% to be divided into a tranche of 10 and a tranche of 5 a decision of government, or was it based on a recommendation of the department?
The government took the decision.
That was a decision of government. Thank you very much. Okay. All right. Well, I might just, if I could indulge a small business or a small operator in a local community in South Australia. Is anybody here would be aware of an organisation called Wheatfields Residential Care in a small town called Freeling?
Sorry, could you say that again?
Wheatfields Residential Care in Freeling in South Australia.
No, I don't think so, Senator.
Okay. It's a small residential facility. It has 53 residents. It resides in a town of a population of 2,688. It's more than 15 kilometres away from a town with 15,000 people. Up until the 15th of September 2022, it was classified as an MMM5. And so they had predicated all of their budgeting and preparations for the forthcoming year on the basis of them being an MMM5. On the 15th of September 2022, they were advised by email from your department that they were now classified as an MMM3. The response, which gave them exactly 15 days in which to change their entire operation to take into account for the fact that they had lost a significant amount of funding. At that time, the facility sought, by writing to the agency, for the determination to be reviewed, and gave evidence as to why they believe that they were still an MMM5, in that they certainly didn't meet the criteria of or 4 or below. And to date, they remain frustrated as to the fact that they have not been given any reason, apart from apparent change in data of the 2019 census. So given that, and I can show you this lovely little map here, it's this little dot in the middle of here around all MMM5, for some weird reason a dot in the middle of the MMM5 region is MMM3 for the first time, and despite the response being received from the Residential Care Funding Reform Branch that says any changes to classifications would be given at least 6 months' notice, these people were given 2 weeks. So could I ask that this matter be taken?
We'll have to take it on notice. The Triple M regions are regularly updated, but they're a department-wide classification, so we'll need to liaise with some of our colleagues to find out what the update is, and we'll need to chase down the issue about the notice. We don't have a briefing, neither Mark or I have a briefing on that particular provider with us, but we'll chase it down, Senator.
Consider it referred.
Thank you very much. I'm sorry it took me having to bring it here to do so.
Had you raised it before, or?
This has been raised several times with the government. It's the first time that I've raised it, and it was probably as much out of desperation because they're going to have to close if that's what the determination, the actual determination is. Can I just quickly, before I hand over to somebody else, just seek some quick clarification in relation to a document published on the Department of Health's website last Friday, Care Minutes 24/7 Registered Nurse Requirements Guide, health.gov.au. In the government, in the document, it states that $5.4 billion over 4 years was provided to providers as part of the 2022 ANAC funding, and that it goes on to state that an additional $1.9 billion was allocated for 22-23 to increase average care minutes from 200 to 215. I'm just seeking, was the funding that was added, so it's 1.9 and 0.8 and 1.1 billion over the forwards, was that additional $3 billion, I'm assuming, is in addition to the 5.4?
Yes, it is.
Yep.
Yes, it is.
Yep, great. Is there someone can direct me to where I can find these in the budget papers?
Well, they were measures announced. The 2.4 billion for increasing to 24/7 coverage for RNs from 1 July and 215 minutes of care from October 23 were election commitments of the government, and they were documented in the budget papers in the usual way.
If there be some, I mean, I'm not asking you to do it now, Mr. Hartland, but if you could just give me the page number, because I have scoured them and I cannot work it out. Yeah.
What in the measures document, like BP2, or?
I've looked through a whole heap of the budget documents, so I can't find it.
So, Senator, is it in the budget papers?
Yep.
The budget papers sums it up at 2.5 billion for 24/7 and 215.
Yep.
The 1.9 is for 215,
yep.
and there's about 500,000 for 24/7, roughly.
500 million.
Okay, all right, I'll go and try it again.
500 million, sorry.
Okay.
Yeah.
All right, I'll go and have another go, and if I fail, I shall come back.
We could see if we
to
can
you.
find the reference to BP2.
Yeah. I was just trying to add it all up. And
It'll be in the measures document under health and aged care.
Yeah, and just finally, I'm probably going to you, Minister. In terms of the amount of money that's been will be required to meet the pay rise, do you have any indication of the cost of the pay rise in 2022-23 for the 10%? Or is that not?
Yes, we are working through that. It'll be reflected. Well, we've put our submission in. We'll wait for the Commission to reach their determination about, on how they see the 15% being allocated, and I would imagine it'll be reflected in the budget.
Thank you. Look forward to seeing what that is. And just quickly, in relation to supported home reform, I understand there was over 520 submissions received on public submissions in relation to the discussion paper. Is that correct?
Yes, that is correct. 528.
528. Well, there you go. Pretty close. And am I also correct in stating that the government has given a guarantee that in the transfer or the change and the amalgamation into the supported home program, they're given a commitment that nobody will be worse off?
I think the Minister has talked about that, yes.
And that's still the case?
The final arrangements haven't been finalised, but it's very usual for these big policy proposals to have grandfathering arrangements.
Okay. I've got one question. Just finally, last question, promise. Does the government intend to publish David Tune's preliminary report of the Aged Care Quality and Safety Commission's independent capability review.
It's a nod from Mr. Lai.
Can't record a nod.
Yes, Senator.
Thank you very much. I did say to Senator Rennick that I would give him the call at 1:15 if the chair would so indulge me. He promised 5 minutes.
Yeah, I'm happy to swap. Senator Rennick, you can have the call. Then Senator Pratt needs to place some questions. It's going to come back to Senator Rice and then back to you. But when you said that was your last question.
Yeah, no. I promise I won't open my mouth.
Oh, so you're ready to go to sport?
I'm ready to go to sport
okay.
when
That's
you
what I
are.
was just seeking to clarify, if you meant that block or something else. So Senator Rennick, you have the call.
Hi guys, how you going? I just want to confirm, did the Australian government ban the prescription of the antibiotic azithromycin for COVID patients throughout 2020? Is that correct?
Not to my knowledge, Senator. I mean, that's probably not really relevant in the aged care outcome.
Well, it's just that it's older people that generally get given antibiotics for bacterial pneumonia, that's all.
Yeah, azithromycin. I'm not aware of any banning of it for COVID patients. But I can take it on notice and investigate, but I'm not aware.
Because I've got the National COVID-19 Clinical Evidence Task Force, is that?
The Evidence Task Force may have made a recommendation. They've made lots of recommendations about, but there's no banning.
They have no power to
Yeah, okay. No, I just wanted to, I wasn't sure what exactly.
TGA, yeah.
That's
but
fine.
The Clinical Evidence Task Force was asked to give and did excellent work during that period to give some clinical guidance as the
Yeah,
name,
sure. Because in their
suggests.
document, they've not recommended it for patients with COVID. I just wanted
Not
to
recommended is different from banning.
Yeah, okay. No, that's good to know. And then the last question is, I asked you previously in estimates for the numbers on the reduction in hospitalisation and deaths from vaccinated and unvaccinated cohort.
Yes.
You gave me figures from December the 15th onwards, so presumably for the Omicron variant, December the 15th onwards, 2021. You had an unvaccinated death rate of people who caught COVID of 32.2%. And were you aware that's 40% higher than the 23% death rate for over 70-year-olds from the Alpha variant? And if so, how do you reconcile the fact that you said that the Alpha variant, well, Omicron wasn't as severe as Alpha, the Alpha variant?
Sorry, Senator, that's a bit hard to follow at 10:30 at night when we're talking about aged care. I'll take that on notice.
Okay, well, for over 70-year-olds, and most of the deaths were in aged care for over 70-year-olds, so it's relevant to the portfolio.
Yeah. I think Senator Rennick, if the officials indicated he needs to take it on notice, he's up to do that. So unless you had a different question.
Well, the point is that you're saying the death rate for Omicron for unvaccinated people over 70 is 40% higher than the death rate for unvaccinated people with Alpha.
Senator, as I said, I'll take that on notice. What I have actually said in the past, and I'm happy to update to the 15th of January 2023, is during the Omicron era, from 15 December until 2021 to 15 January 2023, the proportion of cases who have died is more than 36 times higher in unvaccinated compared with fully vaccinated up-to-date people between the age of 16 to 49, 41 times higher, not percent, times higher in people aged 50 to 69 years, and over 19 times higher in people aged 70 and over.
Yeah,
that's Australian data from our own records.
Yeah, they're relative percentages. I'd like to see all those numbers, because last time you just gave me relative percentages.
Yep. Well, I'll take that on
My point
notice.
is,
Yeah.
your numbers don't have credibility, because you've said that the Omicron variant isn't as severe as the Alpha variant, but the figures that you gave me for the Omicron variant were 40% higher for the over 70-year-old unvaccinated. So take it on notice, but
take
that's...
it on notice, yeah.
You know, can you justify those numbers, because they don't make any sense?
I can justify, and I will do so on notice. Thank you, Senator.
Okay, thank you.
Yeah.
Thank you, Senators. Senator Pratt just wanted to place some questions on notice, and then I'm coming to you, Senator Rice.
Thank you very much. Can I ask, please, for the department to advise us how many visits to aged care facilities have been made by the previous Minister for Aged Care, Senator Richard Colbeck, in the previous Parliament? And if that's not possible, please tell us how many visit briefs you've prepared for the former Minister in the previous Parliament. Well, we've just got, I think it's fair to have this information on the record, and I'm just going to ask the question straight up. I'd also ask in that context, how many visit briefs have been prepared for Minister Wells and how many visits she has made. In particular, how many visits were made to regional and rural Australia, MM2 and above locations.
Not regional.
If possible, please, in answering Senator Colbeck's my questions about his visits, it would be great to have that broken down into 2019, 2020, 2021 and 2022, please.
I think that
I'm happy for that to be taken on notice.
Yeah. Thank you. Is the department happy to take that on notice? Yep, great. Okay, Senator Rice, you have the call.
Quickly, Richard, I've got to whip through these things. I'll try and be quick, and if you could be quick, that would be great. A couple of follow-up questions on the star rating still. Sorry, having just left the table. Is it correct that a home can receive 3 stars for compliance, even if there is a direction from the Aged Care and Quality and Safety Commissioner to revise a plan for continuous improvement?
Yes, that's correct. But only in circumstances where it's a minor non-conformance and there's no risks to care recipients at the service.
Okay. Can you perhaps take on notice what that would mean? What sort of issues that minor non-conformance would mean?
Yes.
Okay. All right, I'll move on from there. I want to move to home care. So first of all, just with just some background about local councils who have exited the Commonwealth Home Support Program. And basically, either if you've got the stats, that would be great, of how many councils have exited the Commonwealth Home Support Program in the last 3 years, and how many local councils used to be providers, how many people have been impacted. If you haven't got it, take it on notice.
We have some stats about councils that have fully or partially relinquished their contracts. All have been replaced by alternative providers, but there have been some transition issues which are well known with some handovers. But there's no, well, I'll let Mr. Herald elaborate. So in 21-22, there were 13 councils that partially relinquished their contracts and 24 councils that fully relinquished their contracts. And do you want to, we are talking through, we are working with councils now and, well, all providers about the next set of contracts, and there are 5 councils that have indicated so far that that they're going to partially relinquish their contracts, and 17 councils that are intending to fully relinquish their contracts.
How many councils before these exits? How many councils did we used to have providing CHSP program contracts?
Senator Russell Herald, Home Support Operations Branch. Just to clarify a comment from Mr. Hartland, we've had 12 confirmations of councils partially or fully exiting or coming up. Another 10 have suggested they may, but are still considering it and are subject to a council resolution.
That makes sense. Yeah.
Go on.
Sorry. In terms of the overall number of councils, as at about 6 months ago, that was sitting at about 170 odd, 174. Obviously, it's moving around, but subject to the current process in play for the current extension process, we would still expect there to be around about 150 local councils across the country within CHSP.
So just one more point.
Those numbers don't add up, because to me that the numbers that Dr. Hartland just mentioned, that was something like 59 councils that were either partially or fully relinquishing over either this year or last year or this year.
Yes, sorry, Senator. So we've had these are the ones that have relinquished partially, but the numbers as at 30 June next year, that will be within the system, will be about 174. So if you backtrack that, we would have had about 200 and something councils as of 12 18 months ago.
So the 174 is what you'll be left with, and 2 years ago it was 264.
Yeah, in that
so.
order. Yeah, in that order.
And how about 5 years ago? How many would you have had?
Well, 5 years ago, Senator, CHSP didn't really exist.
Oh, well, when 3 years ago, whenever.
I don't have a record before 2020-21, which was when...
Don't worry.
Just one more point. I mean, it's not directly related to you. Well, it is directly related to the question. Councils are about half of the providers that we see wishing to change out of their contracts. So the 22 councils that we were talking about, in all 39 providers thinking about relinquishing their contract. So it's not a problem or an issue that's only related
restricted
to
to
councils.
councils. So how are we going then with replacing those services with other providers?
So obviously the ones that happened come 30 June last year, we've replaced all of those. Of the ones that...
All of them? So there are none where there are gaps? I mean,
they were all replaced. There were some issues, as Ms Hartland mentioned.
Yeah, so the ones on the Mornington Peninsula, which I know were a massive problem 12 months ago.
Yeah, they were, and that's been resolved. Extra capacity has been put into Mornington Peninsula. It took a bit of time to replace the workforce, but that has been resolved. We are working through the process at the moment to transition out the councils who have said that they are relinquishing shortly by 30 June this year. Those selection processes are underway and the transition processes are moving.
Okay, and you are confident that there aren't going to be any gaps and people left without home care services because of that?
The issues that were experienced last year were very isolated to a couple of councils. We have made adjustments to our processes to minimise the chance of that happening again.
Okay, all right. I might put some more questions on notice for just the detailed stats. So in terms of the proposed changes to home care, are we still plan to have the new system in place, which was delayed for a year, so it's now mid-24? Is that still on track for that?
Senator, that was the original Royal Commission timetable, 1 July 24. Which is the target date.
Okay.
Yeah.
And is it still planned to proceed with a fee-for-service model to replace the current CHSP block-funded model?
We are working through the final design features of the model with government at the moment. They're considering the issues that we've identified in the consultation, and they'll make decisions about what the final funding model is.
Okay, and what's the timeline, particularly given that are needed by the home care providers and individuals to transition? What timelines are you looking at, and what sort of forward planning are you going to give to organisations through that transition?
Mr Morgan will be able to talk to you about our consultation and information arrangements, but we're working to be able to provide details to the sector about how the funding system will work post-budget.
Okay, so quite shortly then?
That's right.
All right, and it's still, okay. All right. Has any work been done by the department to consider back to residential aged care, considering developing a government provider of last resort model for those areas where the market coverage is, market coverage doesn't exist? I've had multiple people contacting me, as I know others do here, with regional and rural areas where there's just, places are closed down and there's just no provision of aged care.
Senator, I think we've talked about this at St Estans before. We're doing some work in areas where we have thin markets. The example probably that we most often use is in Bombala, in New South Wales, and we don't have a Commonwealth provider of last resort as such, but we have state, you'd be aware, state services where there's often a hospital and aged care facility together.
Yes,
And-
which often aren't very good quality aged care. It's much more a hospital environment than a aged care environment, than a home environment.
Well, I mean, I think that's probably true in some circumstances, Senator, but that equally some of those facilities are much loved by people who, you know...
Look, I mean,
used
just
to that.
cutting to the chase because I haven't got much time. So in terms of a model of a government provider of high quality aged care rather than, you know, a wing of the local hospital, is there any work going on in the department?
Well, I think
for that?
I would just point to that the model of working with state governments as a potential future model. And if you think about capital improvements or new facilities, using that model, I think there's an opportunity to kind of think about a contemporary design that works, that doesn't necessarily resemble a hospital ward, but that still might draw its workforce from a combined state government, Commonwealth government pool. So, or our funding.
So it would be
with state government.
it would be a joint, basically, state and
Well, it might
federal
be a state
government.
government-run facility, but drawing on aged care, Commonwealth aged care funding, but the staff might also work in a hospital setting or a primary care setting.
Could you take on notice providing me with any information that the work that you're doing in the department with regards to that model? Okay. Capping of fees was a welcome improvement. What are you doing with monitoring fee changes and ensuring the capping of fees isn't being utilised by some providers as a way of increasing package and care management fees? We're having heard that some providers are increasing their fees by up to 33%.
We might need to pause on that 33% figure, but just to go to your first question, Ms Atkinson's area regulatory monitor the fees that are published on My Aged Care.
Yeah, that's all right. So Julia Atkinson, Acting Assistant Secretary in the Home and Residential Division. So as you'll know, the measure, the change came into effect in January this year, so we're about 6 weeks in on that change being official. So our job at the moment is to keep an eye on what's happening with the data and identify if we see anything that doesn't seem quite right. We've acknowledged that the implementation timeframes for this were a little bit truncated, and so we haven't seen an immediate drop to the cap by all providers, but we are monitoring that closely and working with providers to understand what's going on and what information they need from us to make sure that they get in line with those requirements.
And will there be any public reporting of that?
We regularly report on median prices in the sector, so that will pick up, the next report for that will pick up the situation post the capping measure. Yeah.
Okay. A constituent has come to me concerned about someone who's managing their own home care package, but not, and basically with the increase in minimum wages, not getting an increase in their package to cope with the increase in wages that they're having to pay out. So I'm just wondering what steps are being taken for people who are self-managing to ensure that they can still access the support they need with the increase in wages.
Well, the indexation factor for home care applies to all home care packages, whether they're self-managed or not. It's one of the WCI indexations, so it indirectly affects the minimum wages. There's been public commentary about the impact on the July 2022 indexation figure. So that index cannot sometimes reflect the costs in the system is one of the reasons why we're looking at getting the Independent Hospital and Aged Care Pricing Authority to advise on prices in the sector rather than use the WCI
so you agree
index.
that for people who are self-managing in particular, that their costs are going up, and so it means that they can't get the level of care that they used to get?
I wouldn't necessarily accept that without understanding the detail of the case.
Perhaps I'll send
it's
you
a
the detail
package
of the
that
case.
can.
Is it correct that ACAT teams don't assess someone who is in palliative care?
No.
It's not. Okay. Well, I've certainly got an example of somebody who was told that they refused to be placed on a waiting list for an ACAT assessment because they're under a palliative care team. So you'd say that's not...
No, we're happy to look at that, Senator.
Okay, I'll give you the details of that. All right. How much time have I got?
Well, you can fill the eyes of your colleagues. It's,
Okay. Look, I will put on notice, but I would have really loved to have had some discussion about COVID across aged care facilities and looking at the facilities that are doing well compared with the facilities that aren't doing so well. But look, I will put some, just generally, how is the department using the information from facilities that have got good infection control to help them lift the performance of the facilities that haven't? Probably perhaps my simple question to end is it true that in terms of deaths, COVID deaths in aged care facilities, that they're not evenly spread across the whole sector, are they? There'd be some facilities that have got a lot more than others.
Senator, I think we have some intelligence about, certainly around facilities that have had multiple outbreaks, and I think where you're going is right. We probably can provide you on notice some of the factors that we see that contribute to the success or otherwise of a facility battling COVID. I'm not sure that that extends to deaths, but we could certainly provide something to you on notice to give you a sense of that.
Yep, okay. And ventilation was one that was particularly raised with me, but obviously there's a range of other...
I'm not sure the ventilation's one,
control.
but we're happy to give you the things that we can see are material.
Okay, thank you. Thanks very much.
Thanks, Senator Russ, for your efficiency.
Very quickly, something to the question on notice taken from Senator Pratt.
If you want to play something on notice,
so just where we've got the breakdown in regard to visits to nursing homes over the last 3 years, can we also give us a figure of the number of percentage of nursing homes that were either in lockdown or requesting that only family or very limited visitations were provided? So just add that as part of the question on notice to give some clarity and some reality to the request. It's a witch hunt.
Could I put another question on notice with regard to serious incident notifications and for a breakdown of reportable incidents received in each category of serious incidents?
Anyone else like anything on notice? Pies consumed?
Well, we can count them on Facebook.
Okay, we are at the end of aged care. Thank you, officials. I am dismissing outcome 3. Thank you for your attendance and your participation in estimates today. I would now like to welcome officials from outcome 4, sport and recreation, to come to the table, please. Senator Ruston, I'll just give you an indication. We were thinking Senator Roberts may come with questions. He's not here now, but otherwise I understand you're the only one with questions. So
good.
I'm going to be really quick.
You can go. I'm going to go. See you another day.
Happy travels. How long are you getting to bed? About 4 hours?
On the plane.
You really did pull a short straw, didn't you?
Yeah.
Sport always does.
Sport always
Actually,
gets a short straw.
I'm going to do you a great favour. It's not a favour for the Minister or for the Secretary, but I'm going to request that next time at estimates that you guys get a better time slot. So now I'm hoping you're going to give me really good answers to my questions.
We try.
Yeah, you've got the call. Okay. Actually, you forgot to request them. So, but anyway, you have the call.
Look, I'm just interested to just unpack a little bit around the infrastructure funding for the Olympic Games in 2032 and the Paralympic Games that are going to be held in Brisbane, and around the urgency around getting on with the infrastructure deal between the Commonwealth and the state of Queensland. So I believe that the Prime Minister and Premier Palaszczuk are making an announcement tomorrow around funding for the Olympic and Paralympic Games. So I'm keen to understand, is that announcement around a 50-50 funding split to be confirmed? And it's something that we've been talking about for quite some time. Are we expecting that we are actually going to get some movement on the funding agreement between the Commonwealth and the Queensland Government tomorrow?
I think you'll know what my answer will be. I mean, that's a matter for the Prime Minister to announce. I would say you've been talking about it for quite a while. When you were in government, you didn't make any provision for it. So we've been working through the detail of responsibly of how we manage that, and I'll leave it for the Prime Minister to make suitable announcements. It's also a matter really probably for the infrastructure portfolio and not the sports and rec. Yeah.
Well, it certainly has a significant impact on this portfolio because, of course, we have a lot of interest in making sure that our elite athletes have got fabulous places for them to compete.
Which is why we've done the work, since you didn't provide any provision for your commitment of 50-50.
Well, certainly that commitment of 50-50, but going to that, one of the conditions of that 50-50 commitment under the previous government was the establishment of a joint infrastructure facility. And just keen to understand whether it's the understanding of the department that oversight in relation to the expenditure of infrastructure funding is going to go through Infrastructure Australia as it would normally do, or whether there's an intention to establish a joint infrastructure authority, which was previously part of the conditions of the funding agreement that was being negotiated.
Conditions of the funding agreement with no funding.
I said that was being negotiated. Well, it's very hard to know because at this stage we thought we had a $1 billion upgrade to the Gabba, and somehow it's ended up being $5.2 billion.
It's just funny that you call it a funding agreement that had no funding in it.
It was being negotiated.
Yeah. So, negotiated without any funding. It's a matter for infrastructure, questions around infrastructure, and I'll leave matters pertaining to any announcement to be made at the time that is appropriate.
Okay, so can I then ask the officials? The Queensland Government announced via its master plan, its Olympic Games master plan, that it was intending to make substantial upgrades to 8 existing venues and build 6 new venues. Does the department have any role in determining the appropriateness of those particular venues for the delivery of the sport at the Olympic Games and the Paralympic Games?
Senator Charles Swan, Chief Operating Officer, but formerly looked after sport as of 1 February, no longer. It'll be my colleague Blair Excel, but actually it's the same answer in infrastructure. It's their infrastructure matters and are being managed by the infrastructure department, and those discussions and negotiations will be worked through by our infrastructure colleagues.
Yeah, I think my question was particularly to the point of, obviously the infrastructure department builds the infrastructure, but clearly I would have thought that as the representative of the sport side of the Games, that you would have some interest in the appropriateness of the development of the venues for the delivery of the sport, as opposed to obviously negotiating and managing the contract of the building of the facility.
The government will work across portfolios in the delivery of...
No, but my question was around asking what role this department had in relation to that sporting component of it.
Well, I think we will have to revisit this in May.
Yeah, and it's also it was also interesting, and I'm quite happy to provide this for you, Minister. But when a number of these questions were asked in infrastructure, they told us to come and ask them here. So it's got to be one or the other, I would assume.
I'm sure we can have a more productive discussion in May.
Yeah. Well, let's hope so. Well, let's hope that we can have a productive discussion tomorrow afternoon after the Premier and Premier Palaszczuk have made the announcement. So one of the other things I was just wondering in relation to the sporting aspect of this is that it's understood that the Brisbane Live Entertainment Arena complex is being proposed to be turned into the temporary pool for the swimming. And in terms of the legacy benefit, we talk a lot about the legacy benefit of sport, of this runway that goes through to 2032 and the 10+10, etc. I'm just wondering whether the department has a view about doing a temporary, dropping a swimming pool in the middle of a live entertainment arena for the purposes of the Olympic Games is actually providing the kind of legacy outcomes that I thought we were trying to provide by the investment in these games for all Australia going forward.
There's a lot of speculation there, Senator Ruston.
Okay, so we're not dropping a pool in the middle of the arena?
Well, I think we can have a much more productive discussion on this in May.
Okay. So I suppose just finally in relation to this particular issue, are we confident, and maybe Minister you can answer this, that the Queensland Government is is not seeking to use Commonwealth funds for their own pet projects, and that we are really delivering the best possible outcome that we can for that legacy that I know that you and I and many others in this place are really seeking to achieve by the Olympic
Well, we're
Games.
confident that working with the Queensland Government, we can deliver a very good outcome for the Olympics and Paralympics. We choose to work with them.
That's great. Well, I look forward to it, and I look forward to hopefully tomorrow afternoon having some detail around what our commitment is. I'm not sure whether this is the right place to ask. If we don't have the right people here, I'll put these questions on notice in relation to the announcement today by the AIS for the boosting of funding for the Commonwealth.
So AIS were not invited
Okay.
tonight.
So would you prefer
I
me to
haven't
put them
seen
on
that.
notice?
Yep.
Yeah, no, they just made an announcement. I was just, it was quite a significant announcement of $17 million to netball, squash and bowls in preparation for the Victorian Games, the Commonwealth Games in 2026. And I was just interested to understand why netball, squash and lawn bowls were the ones that had been selected for this $17 million. Do you have any
That would go from their high performance funding scheme that they have a regular appropriation for that. And they
but
make
why them? Why now? Why, sports that are not dual Commonwealth Olympic sports? But if you think it would be better for me to direct it to them, I'm more than happy to do that. And on that basis, after sitting here all day, you can now go home. If the chair will. Okay, off you go. I'm leaving.
Thank you, officials. We have now exhausted questions for sport. Thank you for sticking around so late. Am I meant to say something? That does conclude today's hearing. Thank you to all witnesses who appeared, Secretary and all of your officials, Hansard and Broadcasting, who we really put to work today for their service and assistance. I remind senators that the committee has agreed that any written questions on notice should be lodged with the Secretariat by Friday, 24 February 2023, and that answers to questions on notice are due by 31 March 2023. The committee stands adjourned. Drive safe, fly safe. See you soon.
Thank you very much, Chair.